Very good morning to all of you. A very good morning to all of you. I welcome you all once again to the CME YUVAFOGSI 2020 organized by Obs and Gynae Society of Northern India. It's my proud privilege to welcome you for the first day of CME of this conference. On behalf of organizing committee, I welcome you again to all this first day of the CME. I hope you all had a wonderful academic feast yesterday. So after successful completion of this workshop yesterday, we will like to move ahead with the next obstetric challenges of the obstetrics. So we'll start the this first part of the CME with the morbidities associated with pregnancy. We will elaborate upon the prevention of these morbidities and how to manage these morbidities in pregnancy and how to manage pregnancy with the morbidities. So this was the initial part of our CME. The later part of the CME will also include the preventing the preventable situations like PT, thromboprophylaxis, how to prevent thromboprophylaxis, to give thromboprophylaxis, infections and PTH. So CME has been structured to include these important things, how to prevent them. And we will also include debates on various controversial issues like how to and when to induce isolated oligohydramnios and how to put surplus in situations of cervical incontinence. And this part of the CME on the first day will have a formal inauguration also that will be followed by presidential oration, and that will be on preconceptual care, a new concept relevant to high and critical care in obstetrics. After the inauguration, we will again have a very interesting session on panel discussion on aneuploidy screening and with a very big session on burden and prevention of stillbirth. And we have a very international faculty also in that session. So with these words, I welcome you all again to the first day of CME of YUVAFOGSI 2020, organized by Obs and Gynae Society of Northern India. So may I take this opportunity now to introduce my chairpersons of the first day of the CME of first session. Avinash, may I have the slide, please? Yeah. I welcome Dr. Sebanti. She is a consultant gynecologist at Kolkata. She has been a former associate professor at same medical college. She has many awards and honors to her credit. She has been a chairperson in quiz committees in FOGSI 18 to 20. I welcome you, ma'am. Dr. Anita Rajoria, she is HOD at Sardar Vallabhbhai Patel Hospital and College at Delhi. She has many publications and awards and honor to her credit. She has been a former vice president of Gynae Forum, Southwest Delhi. And I welcome you, ma'am. Dr. Lajja Devi Goel, she is a professor and head at AIIMS Bhatinda. She has more than 50 publications to her credit. She has many awards also. She has a special interest in high-risk pregnancy. She has been awarded as for the service of young in FOGSI 2018. Welcome you, Dr. Lajja. Dr. Itambra, she has been a alumni of PGI. She is now a senior consultant at Cloud9 Hospital. She is a very keen academician and she is very high interest in social ops and gynecology. She is a convener. She has been a convener of Club 35 program, and at present she is an executive member of IMS Chandigarh chapter. So I welcome you all, ma'am. I will request all of you to introduce the speakers, and please, I will request all of you to please stick to the time as we have a formal inauguration decided on very right time. Thank you very much. I will request chairperson to introduce first. Dr. Sebanti, please.
Yeah. Can I have the slide, please? Good morning. Thank you for inviting me as a chairperson to this preventing the preventable.
Can we can't listen you. Can we have a more volume, louder? Can you speak
I'm
louder?
increasing. I'm increasing. Can you hear me now?
Yes.
No, ma'am.
Yes, audible, ma'am.
She is audible.
She's audible.
It's full volume now.
Ma'am, she's audible. You're audible.
Yeah. So good morning and thank you.
You're
Thanks.
not audible.
How is it? Am I audible to everybody and not to you, Meenakshi?
Ma'am, Meenakshi, maybe your sound volume is down.
No,
Avinash, you are absolutely not audible.
Please increase your volume in your laptop.
Meenakshi, you increase the volume in your laptop.
No, my volume is okay, but still you are not okay. It's fine. Up.
Okay, so thank you. Good morning, and thank you very much for inviting me as a chairperson to this session of Preventing the Preventable. May I have the privilege to introduce the first speaker. Her topic is antibiotic prophylaxis in obstetrics. The first speaker is Dr. Meenakshi Singh. She's an associate professor of departments of Obgyn in Lady Hardinge Medical College, New Delhi. She has got a number of major achievements in her life. She's a life member of AOGD, NARCHI, DGHS. She is trained in POCQI. She's a national level mentor for Lakshya. She's a co-editor of NARCHI and a clinical secretary of AOGD. She is also the trainer and fellow in minimal excessive surgery in diploma in gynae. She has got a number of awards to her credit. She has got various publications, and her specific field of interest is high-risk pregnancy and infertility. So welcome, Meenakshi, to your session, and let us hear you speak on antibiotic prophylaxis in obstetrics.
Thank you so much, ma'am, for the introduction. I'll just share my screen.
Avinash, please stop this background music. No, it is running.
Maybe your platform is. Have you logged in from another platform?
No, there is no music in the background. It's okay.
Ma'am, I'll call you. Ma'am, Meenakshi, I'll call you.
There is background music.
Avinash, please give this.
Yeah, now it's okay. Again, the music is coming in the background.
Is my screen shared?
No, ma'am, please share again.
What's the problem? Any problem in screen sharing?
Yes, left. Maybe technical. Ma'am, I'll call her. Yes. Your slide is visible, ma'am.
Okay, thank you so much.
Please go to slideshow, Meenakshi.
Yes, ma'am. I'm just doing it. Is it now visible as slideshow?
Yes,
Okay.
yes.
Fine.
Okay, so good morning, everyone. And I would just start up with a lot of thanks to the organizers for giving me this platform to give my talk. So I would just start up without wasting my time. So my topic is antibiotic prophylaxis in obstetrics. And I would start with the explanation regarding the need of introducing this topic and talking so much about this topic. So as we know, the bacterial infections around the time of childbirth, they account for about 1/10 of the global burden of maternal death. And the sepsis accounting because of this is the direct cause of maternal mortality even in high resource countries, and is responsible for long-term disabilities to the mother, such as chronic pelvic pain and obstruction of the fallopian tubes, leading to secondary infertility. So much of maternal morbidity resulting because of this peripartum infections in the mother. Along with it, associated is estimation of around 1 million newborn deaths annually. So we can imagine what is the need of discussing this topic right now. Now, the most common intervention which we have found for preventing this morbidity and mortality in the mothers and newborns is the introduction of prophylactic antibiotics. But nothing comes without any cost. So this prophylactic antibiotic is again a double-edged sword. So appropriate guidance for health professionals and the policymakers on the introduction of these antibiotics, the type of antibiotics, the time of antibiotics, the number of antibiotics which we are introducing in the name of prophylactic antibiotics is very important, because at the same time, we need to prevent the emergence of the resistant bacterial strains and prevent the most dreaded antibiotic resistance. So there are factors which are associated with the increased risk of maternal peripartum infections. The factors may be pre-existing maternal conditions like maternal obesity, maternal malnutrition, uncontrolled blood sugars, severe anemia, bacterial vaginosis, and group B streptococcus infections, although not much prevalent in our low resource countries, but we still don't know the exact prevalence. Then there may be factors which are spontaneous or provider initiated. Conditions during labor and delivery, such as prolonged rupture of membranes or unnecessary multiple pervaginal examinations, manual removal of placenta, and the most important being the cesarean section. Now, cesarean section is, So what are the goals of prophylactic antibiotic in pregnancy? We have set the goals of prophylactic antibiotic in obstetrics as to prevent the infection. It is not to cure or treat a disease. It is just for prevention of an anticipated infection in certain circumstances. It should have a therapeutic tissue level at the time when the microbial contamination is expected, and adequate serum and tissue levels should be present before an incision is made in case of a surgical intervention. And the therapeutic levels, they should be maintained throughout the surgery as well as for a few hours after the intervention is over. So there are prerequisites for this prophylactic antibiotic which we give. They must be administered before the potential exposure. They should be usually for a short duration, less than 24 hours. So the long duration of action should not be very long. Delaying the administration by even a few hours will reduce or it will eliminate the benefit which we are anticipating with this prophylactic antibiotic. So what should be the choice of this prophylactic antibiotic? It should be an ideal agent of choice with a low incidence of adverse effects. It may have minimal side effects, but not so as to have major side effects. It should be long-acting. It should be inexpensive, easily available at our resource setting. It should be narrowly focused on likely bacterial pathogens which we are anticipating in that particular situation. It should not be that we choose a broader spectrum antibiotic, which is actually effective against every possible pathogen. It should be effective against the pathogen which is most likely to be encountered in that particular situation. Now, apart from this prophylactic antibiotic, which I will be talking upon, depending upon the circumstances, the baseline or the foundation on which this prophylactic antibiotic will actually be effective is following prevention of maternal peripartum infections. So there are certain, there are certain guidelines laid upon by WHO for prevention of these infections. It is not just introduction of the prophylactic antibiotics. So they have recommended that no routine perineal or pubic shaving should be done prior to a vaginal birth. No unnecessary PV examinations should be done. And infection prevention strategies, including proper hand washing, proper wearing of the personal protective equipments, and maintaining strict asepsis is the foundation of all this infection prevention. And regarding the routine vaginal cleansing with a chlorhexidine with minimal alcohol content solutions during labor for the purpose of preventing infectious morbidities is not recommended. Even during cesarean sections, it is local hospital policies few would prefer, but otherwise there is no recommendation of vaginal cleansing before the cesarean section. So I would be discussing different scenarios in obstetrics one by one for the prophylactic antibiotics according to the situation. So now the most important one is the cesarean section. So antibiotic prophylaxis for patients undergoing cesarean delivery is very important. And as we know that cesarean delivery is the single most important risk factor for peripartum infection. So the rationale here for antibiotic prophylaxis is in order to reduce the risk of surgical site infections. And antibiotic prophylaxis is recommended for cesarean deliveries unless the patient is already receiving some type of antibiotic regimen for particular situation. For example, a patient is having chorioamnitis, we suspect chorioamnitis, we have already started her on ampicillin and gentamicin injections. Then now if she lands up into cesarean section, there is no need of giving antibiotic prophylaxis as such for cesarean section. She may continue on the same antibiotic which she was put on. Now, there are different database of systematic reviews that have supported antibiotic prophylaxis during cesarean section. And there are observational studies, secondary analysis of observational study of 13 centers. And all these studies have supported repeatedly that antibiotic prophylaxis at the time of cesarean deliveries have significantly reduced the risk of postpartum endometritis and wound infection. Now, what should be the timing of antibiotic prophylaxis? Whenever we plan a cesarean section for elective cesarean, the prophylaxis should be administered within 30 to 60 minutes. Now, this time is variable. Somewhere it is 60 minutes, somewhere it is 30 minutes. So we have arbitrarily fixed a time of 30 to 60 minutes before the incision, before the skin incision. But in case it's an emergent cesarean section, we don't get so much of time to arrange. The prophylaxis should be administered as soon as possible after the incision is made. Different classes of antibiotics, which one to use for cesarean prophylaxis. Several studies have been quoted and they have compared basically the two broader groups, penicillin and cephalosporin, and they concluded that both of the antibiotic group, they have comparable results. So what is recommended by different bodies, they have summed upon that antibiotics effective against the gram-positive, gram-negative, and some anaerobic bacteria should be used for antibiotic prophylaxis for cesarean section. So we can use IV cefuroxime 1.5 gram start, IV cefazolin 1 gram start, IV coamoxiclov 1.2 gram single dose for BMI less than 30. And if the patient is heavyweight, BMI more than 30, then IV coamoxiclav 1.2 gram along with IV amoxicillin 1 gram should be used. In cases where the patient is allergic to penicillin and cephalosporin groups, then a single dose combination of clindamycin and aminoglycoside like gentamicin or amikacin can be used. Now, single dose versus multi-dose there are multiple studies, and the international studies, they have concluded upon that the single dose therapy is preferable because it reduces the cost, the potential toxicity, and it is as effective as multi-dose. So we agree upon the single dose. Now, need of additional dose of antibiotic for a patient undergoing cesarean section, an additional intraoperative dose of the same antibiotic which we chose for the pre-incisional prophylaxis should be used if your surgery is prolonged for more than 3 to 4 hours. Actually, it depends upon the half-life of the antibiotic chosen. Plus, in case a patient has undergone excessive blood loss more than 1500 ml, then also you give an additional dose of the same antibiotic which we chose. Now, in cases of emergency section, it has been recommended that we should be using injection azithromycin 500 milligram infusion over 1 hour. It is added upon with the chosen antibiotic for emergency cesareans in patients with PT-PROM, the preterm PROM, or PROM over 4 hours, or the patient is operated after she has undergone active labor. Now coming to the antibiotic prophylaxis for GBS Group B streptococcus in women for vaginal delivery. So for group B streptococcus, if the patient is undergoing cesarean section, it is not recommended for an additional antibiotic. You can go on with the prophylactic antibiotic as per the policy for cesarean section. But in case the patient has been planned for vaginal delivery, there are particular indications. They are clinical situation-based risk factors which have been chosen as indications, because as of now in our setting, we are not screening the women for GB. So the indications remain previous baby with early or late onset invasive GBS infection, or GBS colonization is detected even incidentally or by intentional testing of vaginal or penile specimen, GBS bacteriuria or infection in the current pregnancy. Universal antenatal screening of GBS is not recommended, and there are guidelines in RCOG which have supported that women with GBS detected in previous pregnancy, they should be offered the choice of testing or a bacteriological screening for GBS at 35 to 37 weeks, or at least 3 to 5 days before the anticipated delivery date. So additional intrapartum prophylaxis, antibiotic prophylaxis for GBS is not required for a woman undergoing cesarean delivery or a woman already receiving treatment with the broad spectrum antibiotics for fever in labor or suspected chorioamnitis. The rationale for prophylaxis for GBS is to prevent early onset neonatal group B streptococcal disease in the baby. So the first choice remains IV benzyl penicillin 3 gram start dose, and then followed by 1.5 gram 4 hourly until the patient delivers. And the dosing should start at least 4 hours prior to the anticipated delivery. Or we can give injection ampicillin 2 gram IV, initial dose followed by the 1 gram IV 4 to 6 hourly till delivery. For penicillin allergic patients, in case it's a non-severe allergy, cephalosporin can be used. And in case patient is severely allergic to penicillin, then vancomycin can be used 1 gram every 12 hours till the patient delivers. For vaginal delivery, all the bodies, including ICMR for India, antibiotics are not routinely recommended. It is just for GBS prophylaxis in the suspected women where you don't know the GBS status. So as for Indian setup, we actually don't know the GBS status. We are not doing screening for GBS. So there are guidelines that for the following indications, they may be given GBS prophylaxis, like established preterm labor in a patient less than 37 weeks, prolonged rupture of membranes of more than 18 hours, patient having fever during labor or chorioamnitis, history of previous baby with GBS infection if she has recalls, and bladder or kidney infection due to group B streptococcus. So these are the conditions where we give antibiotics. Otherwise, for vaginal delivery, they are not routinely recommended, but still, personally, I would feel that it depends on the particular hospital setting and their microbiological surveillance that they plan for prophylactic antibiotic they want to give or not. For operative vaginal delivery, again, there is a dilemma. Many guidelines, they do not suggest any additional antibiotic, but RCOG recommends for a patient having operative vaginal delivery, coamaxiclov 1.2 gram single dose, and for BMI more than 30, again, they say to add upon IV amoxicillin 1 gram single dose. And as an alternative for allergic patients, we can use IV clindamycin 1.2 gram plus IV gentamicin 5 milligram per kg body weight as single start dose. Now for patients with PROM at term, so rupture of membranes at term, again, a routine antibiotic prophylaxis is not recommended. It is just the antibiotic prophylaxis given for the indications for covering GBS positive patients or in suspected GBS infection, like a patient with prolonged rupture of membranes or fever during labor. For preterm labor with intact membranes, routine antibiotic prophylaxis is not recommended. And again, the indications remain the same to cover GBS in cases of GBS positive, if we know the status, and if we don't know the status, then in patients with prolonged rupture of membranes or fever during labor. The important thing to note is that antibiotic prophylaxis in cases of preterm labor with intact membranes, it does not intend to prolong the pregnancy. So we do not give antibiotic for the purpose of prolonging pregnancy in cases of preterm labor with intact membranes. If a patient with PT-PROM has undergone labor and now she is in preterm labor, then again she needs antibiotics as per the GBS prophylaxis guidelines. For preterm rupture of membranes, preterm pre-labor rupture of membranes, the rationale here to give a intrapartum antibiotic prophylaxis is to prolong pregnancy, to reduce maternal and neonatal infection and preterm associated neonatal morbidity. So here, what is recommended? Amoxicillin 1 gram 8 hourly or erythromycin stearate 250 milligrams 6 hourly for 7 days. For feasibility of the patient for easy oral intake, they have also recommended that instead of erythromycin, we can use per oral azithromycin that comes with a single dosing once a day, 500 milligram for 7 days. So these are given until the woman is in established labor or for 7 days, whichever period is sooner. Another recommendation by NICE is giving injection ampicillin 2 gram IV followed by 1 gram 4 to 6 hourly for 48 hours. And then we can switch over to the oral regimen of oral amoxi 500 milligram 500 milligram 6 hourly for 5 days plus erythromycin 333 milligram for 7 days. If erythromycin 333 milligram is not available, we can even use erythromycin stearate 250 milligram, but then it has to be used 6 hourly instead of 8 hourly. In cases of manual removal of placenta, if we do MRP during a cesarean section, there is no need of any additional antimicrobial prophylaxis. The one we have chosen for prophylaxis for cesarean delivery is more than enough. In case we do MRP following a vaginal delivery, then IV coamoxiclav 1.2 grams single dose for BMI less than 30, and for BMI more than 30 patients, IV coamoxiclav 1.2 gram plus an additional dose of IV amoxicillin 1 gram start dose is recommended. And as an alternative to allergic patients to penicillin, we can use IV clindamycin 1.2 gram plus IV gentamicin 5 milligram per kg body weight start dose. Now coming to the antibiotic prophylaxis for patients undergoing repair of 3rd or 4th degree lacerations. Now here the rationale is to reduce the risk of perineal wound infection. We don't want post-operative wound dehiscence or any type of wound discharge. So the spectrum to be covered should be gram-positive Staph aureus and gram-negative Enterobacteriaceae. So the drugs recommended here for prophylaxis is a single dose of 2nd generation cephalosporin or IV coamoxiclav 1.2 grams single dose, or again the alternative may be IV clindamycin plus IV gentamicin. The thing to note is wherever we are talking about antibiotic prophylaxis and we come for cephalosporins, we are generally avoiding the 3rd and 4th generation cephalosporins. We prefer giving 1st and 2nd generation cephalosporins because they are effective. They are having less of side effects, and plus we want to save the emergence of the drug resistance at the same time. Regarding the rescue cervical cerclage, here the rationale is to prevent the ascending infection from the vaginal flora to the exposed endometrium. So the organism to be covered is the vaginal flora. An antibiotic for prophylaxis is injection ampicillin 2 gram single dose or IV coamoxiclav 1.2 gram single dose. For evacuation of retained products of conception. Now here, the rationale is to reduce the risk of upper genital tract infection. We don't want any further morbidity because of pelvic inflammatory disease in future. So it should cover chlamydia, gonorrhea, and few anaerobes. So here we prefer IV coamoxiclav 1.2 gram single dose. As an alternative, we can use IV metronidazole 500 milligram single dose along with per oral doxycycline 200 gram. Or we can use azithromycin 1 gram oral plus metronidazole 800 milligram oral at the time of the procedure. And it needs not be repeated. Now, regarding the antibiotic prophylaxis for prevention of bacterial endocarditis at the time of delivery, it is recommended that infective endocarditis prophylaxis is not routinely recommended for a woman with acquired or congenital structural heart disease for either vaginal or cesarean delivery in the absence of infection. We go on for as a usual vaginal or cesarean delivery prophylactic recommendations. Primarily, if the patient is undergoing some dental procedures with the manipulation of the gingival region or perforation of the oral mucosa or the periapical region of teeth, then only they recommend antibiotic prophylaxis for infective endocarditis. In addition to that, AHA and American College of Cardiology, they recommend prophylactic antibiotic therapy for vaginal delivery in the patients with cyanotic cardiac disease or the patients having prosthetic valve insertion. So what antibiotic prophylaxis is recommended for prevention of bacterial endocarditis at the time of delivery is injection ampicillin 2 gram or cefazolin or ceftriaxone 1 gram. Or in cases of penicillin allergy, cefazolin, ceftriaxone 1 gram or clindamycin 600 milligram. Or we can use a single oral start dose of amoxicillin 2 gram. In cases where we suspect enterococcus, then we can use injection vancomycin 12 hourly 1 gram.
The time is running short, Meenakshi.
Yeah, sure. I'm just about to finish. Routine MRSC antibiotic prophylaxis is not recommended because we don't do a routine screening for our patient for MRSC colonization. But in the population obstetric patients where we are knowing that there is MRSC colonization, then we may consider adding upon a prophylactic dose, single dose of vancomycin 1 gram at the start. Now, antibiotic prophylaxis is not recommended for amniocentesis, for manual removal of placenta during cesarean section, for a routine prophylaxis before or immediately after giving episiotomy, for uncomplicated vaginal delivery, and in women with meconium stain amniotic fluid. So to conclude upon, I would say that one size cannot fit all. So we cannot have a generalized guidelines for all the hospital settings. And there is need for antibiotic stewardship program at all healthcare setups to be established, a microbiological surveillance time to time for individual hospital settings, and policy of prophylactic antibiotics. They should be customized accordingly to the setup. Continuous quality improvement and quality assurance checks on the antibiotics as well as the microbiological flora, reinforcement of WHO measures for infection prevention. So in the end, I would say that timely and appropriate prophylactic antibiotic in obstetrics should be adhered to in order to knock down sepsis-related maternal and neonatal morbidity and mortality. Thank you so much for your patient listening.
Thank you very much for your speech. May I hand over the session to the next chairperson to introduce the next speaker.
Thank you, Dr. Sebanti. It is my proud privilege to introduce Dr. Arihan Jain. He is Assistant Professor, Department of Internal Medicine, Clinical Hematology Unit, PGIM, Chandigarh. And he is DM Clinical Hematology, Fellow of Indian Society of Hematology and Blood Transfusion. He is a National IAP Quiz Awardee. He has got 40 plus publications to his credit. His field of interest is malignant and benign hematology, especially regarding thrombotic and bleeding disorders, leukemias, myeloproliferative neoplasm, hematopoietic stem cell transplant, etc. So he'll be talking on thromboprophylaxis and obstetrics. Beware, take care. Regarding introduction of the subject, we all know that venous thromboembolism is a leading cause of maternal morbidity and mortality. So all women should undergo a documented assessment of risk factors for VTE in early pregnancy or pre-pregnancy. And we must understand that risk assessment should be repeated if the woman is admitted to hospital for some reason or other, or especially in intrapartum and postpartum phase. So at present, current guidelines are varying in their directions and details, but all strategies at present, they rely on risk factor assessment and institution of thromboprophylaxis as and when required as per guidelines. So over to you, Dr. Arihan. Is Dr. Arihan around? Yeah.
Thank you, ma'am. Am I audible clearly?
Yes, you are audible.
Let me share my screen. Is my screen visible?
Yeah, make it slideshow, yeah. Yes, we can see it.
So, first of all, I thank the organizers for giving me this opportunity to talk to our obstetric colleagues on this important and often, I would say, overlooked aspect of obstetric care, which is thromboprophylaxis. And the organizers have given it a title, Beware, Take Care. So first of all, I would like to start with the definition. So in the medical dictionary and in most trials which have been done on thromboprophylaxis, the definition used, it includes all the modalities which would help in avoiding blood clots or thrombosis, as we call it. This would include medications such as heparin, low molecular weight heparin, or blood thinners, other blood thinners, oral blood thinners, the use of physical measures such as graduated compression stockings or sequential compression devices, sometimes IVC filters, and also the lifestyle measures like ensuring a good mobility and hydration, the impact of which is often difficult to measure, but they are equally important. So the next, before we move on further, we need to be aware of certain terms which would be used in most of my rest of the part of presentation, and are also used whenever we talk of thrombosis. So whenever we have a VTE, we have to understand whether it was provoked or unprovoked deep vein thrombosis, or we know VTE, which we call. So unprovoked DVT is one when there is no identifiable provoking environmental event which is evident, and the provoked ones are the ones which are caused by a known event. They can be transient major risk factors, which include any surgery which lasts for more than 30 minutes, or a hospitalization or immobilization for more than 3 days, or cesarean section. The transient minor risk factors such as less than 3 days of hospitalization, less than 3 days of immobility, even pregnancy is often classified as a transient minor risk factor. Persistent risk factors such as the comorbid conditions like a malignancy or an inflammatory bowel disease, which would resolve ultimately, and irreversible risk factors, which are the inherited thrombophilias and sometimes the end stage cancer or chronic heart failure. So why do we need to talk of thromboprophylaxis in obstetric care? Well, there are certain immediate risks which ma'am just alluded to, but I would give numbers to that. First of all, venous thrombosis complicates approximately every one in 1,000 deliveries. The incidence is 5 times the normal age-matched population females during the antepartum period, and it is 60 times during the postpartum period. And the postpartum period is having a higher risk because the number of days are shorter. The increased risk postpartum persists until 12 weeks, but it is greatest in the first 6 weeks after delivery. And that is why most of the time when we talk of postpartum thromboprophylaxis, we mean 6 weeks after delivery. And the diagnosis and prevention and treatment of VT in pregnancy must consider both maternal and fetal well-being. So basically, there is little data actually from India, and I could come across only 2 or 3 studies. So the overall in India, 0.1% of pregnant women would present with VT, and this is a tertiary care setting. In my guess, the actual incidence would be much higher. The VT accounts for 3.75% of maternal mortality in tertiary care settings in India, and this figure is approximately 3 times in Western countries, in United States actually, to be very specific. So what drives this increased risk of thrombosis during pregnancy? Well, we all know the famous varicose triad. So during pregnancy, obviously, we have the first component is the stasis. The stasis, I need not tell to this audience why there is venous stasis, the progesterone, the gravid uterus, the reduced mobility, the vascular damage, which happens often at the time of delivery, or which is operative or assisted. And then we all know the hypercoagulable blood, which is because of the upregulation of procoagulant factors, which is actually, as we read, that it is a natural defense mechanism to prevent PPH. But all these factors are present, and that is why the increased risk of VTE during pregnancy is there. And that is the reason why we are talking of thromboprophylaxis. One thing to note is that most of the VTE events which occur during pregnancy happen on the left lower limb, and so 85% of them would happen in the left lower limb, and that is why we have the famous left rule to diagnose or to suspect VTE in pregnancy. And often they are confined only to the pelvic veins, and sometimes if we do the distal Doppler, the results may be negative, so we need to be very vigilant about those. So so now we come to the question that whom should we assess for thromboprophylaxis and when should we assess. So as in the introduction ma'am just said, that all pregnant women, whenever they are coming to the clinic as they conceive, or even for the antenatal planning, the obstetrician need to assess them whether this patient would need a thromboprophylaxis or not. And it should be done at the time of booking. It should be repeated during any hospital admission during pregnancy, and again it should be repeated postpartum. So next question is what all to assess when we, which would help us guide to offer thromboprophylaxis to the pregnant woman or not. So to start from first things first, we need to actually begin with the past history of VT, if that patient is having or not. A good family history, particularly if she had any first degree relatives of age less than 40 years who had a venous thromboembolic event. Then of course the comorbidities, diabetes, obesity, smoking and addictions. Obstetric history, I'm sure anyways would be taken, the parity status, the pregnancy status, and which trimester the woman is. Besides, we also need to explore what would be the patient preference, what is the social support in the Indian settings, what is the financial support, and what would be our likely plan for termination and peripartum management in the case, because this is what will help us to choose the right thromboprophylaxis modality. So whenever we are talking of thromboprophylaxis, practically the non-pharmacological methods are not efficacious in most cases in isolation, and they have to be used in conjunction with the pharmacological prophylaxis. So practically whenever we are talking of thromboprophylaxis, we are talking of the blood thinners or the drugs which we will be using. So this is the list of the options which are available. Obviously, so we have to consider the placental transmissibility of the drug, and if we are talking of a postpartum state, then whether it is secreted in the breast milk or not. So when these factors are considered, the green signal is only for unfractionated heparin and low molecular weight heparin, while vitamin K antagonists would be contraindicated in most situations, except for even in the second and third trimester, except when there is a case of mechanical heart valves. DOACs again have been shown, the newer oral anticoagulants, rivaroxaban, apixaban, which have now actually replaced most other anticoagulants in the non-pregnant setting, but in the both antepartum and postpartum period, DOACs cannot be given. Fondaparinux, again, there is little data, so it is actually no. And danaperoid, rarely it is safe, but it is used only when we have heparin-induced thrombocytopenia. So practically, it is either low molecular weight heparin or unfractionated heparin in most cases as the choice of anticoagulation. So amongst these two, how to choose? So low molecular weight heparin is the preferred agent because it causes less of osteoporosis. The incidence is 0.04% versus 1% in 1 to 2% in unfractionated heparin. There is less of heparin-induced thrombocytopenia, so we don't need to monitor the platelet counts every week. And it has a once daily dosing when we are using the prophylactic regime. The advantages of unfractionated heparin would be a rapid reversal and obviously the low cost. Then certain things, the interference with epidural anesthesia and skin allergies would be common probably, and the bleeding risk would be common to both the agents. But in most cases, and it would be low molecular weight heparin which would be used. So what guides the, as ma'am told, that it is the risk which will guide the decision to offer a thromboprophylaxis. So basically, we have to understand that the case fatality rates for major bleeding and a VTV event are similar in pregnancy. So, so the decision to offer thromboprophylaxis should be when the risk of VT exceeds the risk of major bleeding with anticoagulation. So with anticoagulation, the risk of major bleeding is 0.4 to 1.5%. And the universal VT risk in any, if we talk of an unselected population of pregnant individuals, the universal VT risk is 0.05%. So, so the universal AP antepartum postpartum prophylaxis is likely to cause more harm than good, and therefore it is not recommended. And therefore, in the most guidelines would say that if the antepartum risk exceeds more than 1% or is between 1 to 3%, and the postpartum risk of VT is more than 1%, that would justify the case for offering the low molecular weight heparin prophylaxis to pregnant women. So next comes, what are these risk factors? So there are certain factors which operate both in the antepartum and postpartum period, such as the inherited thrombophilias, the previous history of VT, a high BMI, antepartum immobilization, or a combination of these. Certain risk factors which would only operate antepartum often are the assisted reproduction techniques and smoking. And then there are certain risk factors which operate only in the postpartum period, such as PPH, such as puerperal sepsis, IUGR, preeclampsia, and an emergency cesarean section. So then there can be other risk factors which are there. So whenever we are assessing the patient, we have to take in account all these risk factors to decide. So what is the, I would start with the commonly encountered clinical risk factors in the obstetric setting, and I would just enumerate. So what are the hazard ratios which have been proven in the various studies? So immobility more than 1 week with a BMI more than 25, the hazard ratio for a VT is 62 as compared to normal individual. And similarly, ARTs, spontaneous twins, antepartum hemorrhage, smoking, weight gain less than 7 kgs, receipt of blood transfusion, sickle cell disease, use of ARTs, weight gain more than 21 kgs. And all these are risk factors which have preeclampsia, hyperemesis, smoking. All these risk factors have a significant hazard ratio of a VT as compared to normal individual. So, so when to thromboprophylax for these clinical risk factors? Well, there is, while these are known to be risk factors, but the efficacy in these settings of thromboprophylaxis, there is very little data to guide. So the current recommendations are that for women with no or one clinical risk factor, you can actually omit antepartum or postpartum thromboprophylaxis. While for women with more than risk factors, you have to individualize the decision. The British and Swedish have come up with very nice thrombosis risk calculators, which are available online, and you just feed the patient data and they would guide you whether that woman would need a thromboprophylaxis or not. Then coming to the very usual scenario, which is a cesarean section, whether to thromboprophylax or not. So it is not a routine for all C-sects. For a single additional risk factors, whenever we get one additional, which would mean actually 2 risk factors, then you need to use a thromboprophylaxis, which is often pharmacologic. When there are multiple additional risk factors, you need to use both pharmacologic as well as mechanical thromboprophylaxis, and the duration would be, if it is a very high risk, then the duration would be actually for 4 to 6 weeks, while in other settings, in clinical risk factors, it would only last till the patient is hospitalized. So if there is a previous VT event, again, if the previous VT event was provoked by a non-hormonal risk factor, the risk of recurrent VT would be only 1%, and that is why you don't need to thromboprophylax antepartum. While if it was a pregnancy-associated VT or an unprovoked VT, the risk is 3 to 6%, and that is why you would actually need to thromboprophylax these individuals who had a previous VT. So this is a simple flow diagram. Antepartum period, any unprovoked VT previously, or a VT event which was provoked by estrogen or pregnancy, they would need both antepartum and postpartum prophylaxis. While if the previous VT event was provoked by a non-hormonal transient risk factor, such as a fracture of lower limb or a major surgery, then only postpartum prophylaxis is indicated. So one thing we should understand that 50% of individuals, actually, when we investigate the cause for VT, we would not be able to identify the risk factor, and actually these are the individuals who would actually be classified as unprovoked VT. So prior VT, as I already told, antepartum, if it was an unprovoked, you need to prophylax. And if it was pregnancy related or estrogen related, you have to prophylax throughout the pregnancy. And postpartum, all women you need to prophylax who had a prior VT. Then coming to the often, which is a sort of there is always a confusion regarding what to do with inherited thrombophilias. So we have to understand that not all thrombophilias are same, and there are validated, so different thrombophilias have a different risk. So amongst these, it is the antithrombin 3 deficiency and a homozygous or a compound heterozygote factor laden who have a significant hazard ratio, and it is only in these conditions that thromboprophylaxis would be indicated in the absence of a prior VT event. So then the question often asked, and this is a common consult which we get in our hematology clinic from obstetric side, whether to do a thrombophilia workup or not. Basically, we have to understand the prevalence, the population prevalence is in Asians is only 0.4% for most of the thrombophilias. Prothrombin gene mutation, again, the PGI data suggests that it is not prevalent in northern Indian population, while there is some data coming from Vellore which says that in Indian population there is some 1% incidence in the VT population of this mutation. Protein C, protein S, you don't need to actually, the prevalence is very, very low. So basically APLA, again, in patients of VT, it is quite common. So we need to check for it if the patient had a VT. So when to test, basically we need to understand that at the time of VT event, there is no role of testing. So we have to actually identify the goal of testing, and only when it is going to determine our decision. So in unprovoked VT, anyways, we have to thromboprophylax. So all those individuals need not be tested for thrombophilia. It is only when there is a family history of VT in age less than 40 and the woman is planning for a pregnancy. In those cases, we actually need to screen them for thrombophilia, so that if they test positive for 83 or a compound factor 5 lead-in, then they would need to be on thromboprophylaxis. So this is kind of a flow chart from the American Society of Hematology recommendations. So for women who do not have a personal history of VT, for all these, for heterozygous factor 5 lead-in, protein C, protein S, you don't need antepartum thromboprophylaxis. While antithrombin 3 deficiency, you definitely needed both antepartum and postpartum. And this recommendation is based on the more than 1% access risk that I previously talked about. Again, homozygous prothrombin gene, there would be and combined thrombophilias would need prophylaxis both the times. And for certain of these, you need to give only postpartum prophylaxis. Although the evidence for all these is more of an expert opinion rather than a randomized trial. Obstetric APLA often, so we need to understand that the risk of VT in obstetric APLA has been almost zero in most of the cases. So if there is a previous VT event, you need to thromboprophylax. If there is no previous VT in a patient who had an obstetric APLA, you don't need an antepartum prophylaxis unless there are additional risk factors. But in postpartum, you can offer them thromboprophylaxis if they have a high titer of APLA antibody or if their lupus anticoagulant is positive. So
Dr. Arihant, I am afraid you will have to wind up. Please hurry up.
Yeah. So what is the optimal dose of low molecular weight heparin in pregnancy? See, so actually no one knows the optimal dose, and there is a famous high-low study which is looking at it. So the optimal dose for prophylactic heparin is, I would just talk about enoxaparin. It is 40 milligram once a day, irrespective of the weight. How to reverse it? We all know that protamine can be used. It is more effective in conventional heparin and less effective in enoxaparin. How to monitor patients on low molecular weight heparin? For pregnant women who are on therapeutic or prophylactic low molecular weight heparin, most guidelines suggest against the routine monitoring of anti-10A levels because the exact levels which are required are actually not established. So in the absence of benefit, there is no role of anti-10A monitoring. Then coming to the part how to terminate the pregnancy in patients who are on thromboprophylaxis. Well, if they are on prophylactic dose, the preferred mode would be a spontaneous delivery, and the woman should be instructed to stop the anticoagulant as soon as they notice their first signs of labor, such as contractions or broken membranes. Scheduled delivery can be offered in women where we are contemplating a neuraxial anesthesia. Again, emergency cesarean section, you need a 12-hour gap before neuraxial anesthesia. And if you can't give that gap, then you actually have to give a GA rather than a neuraxial anesthesia. So postpartum management, 12 to 24 hours after the prophylactic dose, we can resume low molecular weight heparin, and vitamin K antagonist warfarin is safe during breastfeeding, and that can be reinstituted 1 day after starting low molecular weight heparin to target an INR of 2. So preconceptional management, obviously NOACs and VKs need to be shifted to low molecular weight heparin. However, if a woman has conceived on NOAC or VK, you need not terminate the pregnancy. Actually, you can just switch it to low molecular weight heparin unless there has been a very significant exposure which is lasting beyond 12 weeks. In that case, you need to discuss with the family. So there have been Cochrane meta-analysis which show that we are actually performing very poorly on the thromboprophylaxis front, and this is a very preventable cause of maternal mortality. And so we need to address this issue from a healthcare provider system perspective. And so we can improvise by giving regular human alerts, computer alerts, these grand rounds, meetings such as this, which can actually sensitize the obstetricians regarding the importance of thromboprophylaxis and prevent the maternal mortality and morbidity. So what I have not covered is the ART and the OHS in this topic, and the future priorities of research would be exploring the DOACs and fondaparinux safety, and basically also at this forum, I would like to say that there is a need to formulate national guidelines which are suited to Indian population on this front. So the take-home messages: thromboprophylaxis, why we need it? Because it is an important risk, important cause of maternal mortality. When do we offer prophylaxis? When we know that the thrombotic risk is more than the bleeding risk. Whom do we offer? I have already enlisted, and in most cases it is low molecular weight heparin in antepartum period. VKS can be used in postpartum period. So these are my references, basically ASH update for pregnancy, the RCOG guidelines, and the Canadian and ACCP guidelines. And a happy Easter to all of you. Thank you.
Thank you, Dr. Arihan, for covering the topic so comprehensively. Of course, the time was short, and but you were discussing it so beautifully. The future is there. We have to somehow find ways to decrease risk factors of VTE. So I hope the questions will be taken and at the end of the session, all the sessions. So
Yes.
Dr. Arihan, hope you will stay back for any queries to be answered regarding that. So over to my next co-chair, Dr. Laja, for introducing Dr. Anju. Ma'am, you have to unmute yourself.
Good morning, everybody. I'm very thankful to the organizers for giving me this opportunity to be here this session. So I'll be introducing the speaker for the next topic, that is postpartum hemorrhage: predict, prevent, and prepare. The speaker is Dr. Anju Agarwal. She is a professor in the Department of Obstetrics and Gynae, King George Medical University, Lucknow. Madam is past chairperson of North Zone Indian Society of Perinatology and Reproductive Biology, and she is also past president of the same society. She has participated as an expert in the development of GOI national guidelines on calcium supplementation, deworming, GDM and hypothyroidism in pregnancy, and EMOC curriculum. Madam is a recipient of FIGO Fellowship and Award of Excellence on Teachers' Day. Her area of interest is high-risk pregnancy and infertility. And there was a message from the organizers that this topic has been already discussed vastly yesterday. So she asked the madam to be brief on the topic. So over to Dr. Anju, please. Madam, please unmute yourself.
Thank you so much.
Unmute again.
Ma'am, unmute yourself.
Yeah, am I audible now?
Yes, ma'am.
I must congratulate the North Zone team on organizing such an excellent conference. Yes, I attended the workshop yesterday and I'll keep myself to the point. Is my screen visible?
Yes, ma'am.
So I'll be talking on postpartum hemorrhage, how to predict, prepare, and prevent. Now, why do we need to worry about this? In spite of nature making so many arrangements so that the women are able to bear the loss at intrapartum and postpartum periods, but it continues to affect almost 5 in 1,000 deliveries. And it is a major contributor of maternal mortality. As you can see, it is contributing to almost 1/4 of the maternal deaths. And the other thing which we are really worried about, that it can lead to death within 2 hours. So we have very little time to intervene. So we need to concentrate on prevention and prediction. And that is what is important. It is largely preventable, and if we are quick, we can manage it successfully. So how do we go about predicting PPH? The RCOG says risk factors for PPH may be present antenatally or in labor, and these risk factors must be known to all practitioners, and they must be identified at the appropriate time. And women with risk factors must be encouraged to deliver in the centers with transfusion facilities. The risk factors which have been commonly identified, we all know multiple pregnancy, you can see the odds ratio, and they all have a odds ratio of about 3 to 5. Previous history of postpartum hemorrhage, preeclampsia, fetal macrosomia, failure to progress in the second stage of labor, a prolonged third stage, retained placenta. A very important cause which we are seeing more and more nowadays is a placenta accreta syndrome, and the use of general anesthesia at the time of delivery. They all contribute to postpartum hemorrhage. Other predictive tools which have been recently proposed have been identified. Pre-delivery, lower mean platelet volume values may be used to predict PPH. This has been recently published in the Journal of Maternal Fetal Neonatal Medicine in August 2020. And they found that the prepartum MPV, a cutoff of 10.95 femtoliters was identified, had a high area under curve for predicting PPH with a specificity of 81% and a sensitivity of 69%. But definitely it needs to be replicated in further studies before it can become in universal usage. Besides this, the use of radiomics is important for the accurate detection of placenta accreta syndrome. And this is particularly important not for the full-blown incretas and the percretas, which are easier to identify, but the minor degrees of placenta accreta syndrome, which we detect peroperatively and then which lead to bleeding. And a study has been conducted where they did an ultrasound measurement of intrauterine contents 30 to 45 minutes after delivery, and they found it to be well correlated with detection of smaller amounts of PPH. Larger amounts, yes, we know they are all bleeding. But when we look at this systematic review of these predictive tools, we find that none of the prediction tools are ready for clinical use. And development and robust validation of PPH prediction tools application to the general obstetric population is required. Only 3 PPH risk prediction tools out of all reviewed were found to have potential for clinical use, but they also required robust external validation. So with prediction comes the need for preparation, which is very important. If we don't prepare, we are preparing to fail. One of the major preparations which we need to do is treat anemia. Anemia is widely prevalent in our country, and treating anemia is similar to the airbags in our cars. They are preparing us for the accident of postpartum hemorrhage. So we need to monitor the hemoglobin regularly during the antenatal period. We must ensure that the woman takes iron pills regularly as advised, with proper counseling that she should not take the iron with the calcium tablets, because many times this counseling is missing in our antenatal care. We must ensure hemoglobin is at least 11 g% at delivery, and as and when required, we must give parenteral iron and blood transfusion. Besides this, other things which we can do for preparing our facility is to train our service providers in triage, ensure that the proper PPH trays are made with all the equipments required, including intrauterine balloon tamponade, NASG. We organize regular drills so that everyone is sure what they are supposed to do when they detect PPH or when a patient or PPH is coming in. Equally important is debriefing after every event, whether it be a drill or it be a real life event. Debriefing is not for the purpose of attaching blame, but we need to identify what are the lacunae and how we can tide over these lacunae and improve our performance. Very important is to encourage all our antenatal women and their families for blood donation so that we have adequate blood as and when required. And the next step is preventing PPH. We have the tools, we need to know how and when to use them. So most important is active management of third stage of labor, which is important to reduce the blood loss in the normal third stage, to shorten the duration of the third stage, and to reduce the occurrence of PPH. The single most important intervention in this is the administration of uterotonic, for which it is recommended that oxytocin 10 international units intramuscularly must be given immediately after delivery of fetus, that is within 1 minute of delivery of fetus after ruling out a second twin. The other two components, controlled contraction and uterine massage. Uterine massage to a large extent has been done away with and is only recommended when you are observing excessive bleeding. Controlled contraction is advocated. Again, it is not as important as the administration of uterotonic. We need to remember that giving of the uterotonic should not interfere with the delayed cord clamping, which is very important. So oxytocin, as I have said, is a drug of first choice for the administration of for the AMTSL. Misoprostol given in a dose of 400 to 600 micrograms orally may be appropriate in settings where skilled provider is not available to give the oxytocin or oxytocin is not available. Here you will see that the dose of misoprostol is as recommended by WHO is slightly lower because they say 400 micrograms given orally. Oral administration is more acceptable to the parturient woman. Secondly, 400 micrograms is equally effective and it is associated with lesser side effects. Injectable prostaglandins like carboprost are not recommended for active management of third stage of labor. Now, why does WHO give these statements? For misoprostol, they found it to have similar desirable effects as oxytocin, but it was less effective for reducing severe postpartum hemorrhage, that is a loss of 1000 ml or more. And to the extent of, there were 7 more cases of severe PPH per 1000 women treated as compared to oxytocin. And that is why they continue to advise oxytocin as a drug of first choice. The second important thing about misoprostol is that it causes more undesirable effects as compared to oxytocin, which we all know it causes nausea, vomiting, shivering, fever, and diarrhea. For carboprost, it has been seen it is not beneficial for the substantive priority outcomes, that is severe PPH more than 1000 ml, need of blood transfusion, and need of use of additional uterotonics. It is only having a 39% risk reduction of PPH of more than 500 ml. So the benefit is much less as compared to the other oxytocics. And also it is associated with a higher risk of diarrhea with numbers needed to harm of as low as 6. So out of 6 women, 1 will have a severe diarrhea. So carboprost is not to be used, and out of the others, oxytocin is the first. What about ergometrin or centometrin, which we were using previously? There's no clear evidence of any difference in desirable effects between ergometrin, centometrin, and oxytocin when they are used for PPH prevention, but women are more likely to experience side effects in the form of nausea, vomiting, headache, hypertension, and diarrhea with ergometrin. The most important thing is that ergometrin may be dangerous in women in whom there is hypertension, which has been missed or it has not been screened, which is a very common condition in our setup. And that is why we should be very careful when we are using ergometrin. And it is preferable that we use it only for treatment of PPH rather than for prevention of PPH. Carbetocin is a new player in the field. It is a longer acting oxytocin derivative and it is as effective as oxytocin. And in fact, the Canadian guidelines recommend that carbetocin 100 micrograms should be given as an intravenous bolus over 1 minute for the prevention of PPH in elective cesarean deliveries. But the major deterrent is that it is much more expensive as compared to PPH. And that is why most of the guidelines are not recommending it for routine use. Tranexamic acid has a definite role. A Cochrane review has seen that blood loss greater than 400 ml was less common in women who received tranexamic acid after vaginal birth or cesarean section in the dose of 1 gram or 0.5 gram intravenously. A recent placebo-controlled trial has also found IV tranexamic acid to significantly reduce blood loss at cesarean section. So it has a role in prevention as well as treatment of postpartum hemorrhage. There are certain natural methods to which we must pay attention. Initiation of breastfeeding as soon as possible after delivery is very important because it leads to better mother-child bonding and release of oxytocin, which helps the uterus to contract and controls the amount of bleeding. Other interventions to avoid PPH, we must ensure a skilled birth attendant at the time of delivery. The use of partogram must be encouraged to make sure that the woman does not go into prolonged and obstructed labor. Asepsis must be ensured because again, infection is a common cause of PPH, particularly secondary PPH. Unnecessary induction and augmentation must be avoided, and it must be ensured that there are regular audits of induction and augmentation, and the indication for the same must be documented properly. The head delivery must be controlled to prevent tears. Fundal pressure, we all know, should not be given. And once we are preventing, but we should be very alert for the early diagnosis of PPH. Traditionally, it is defined as a loss of more than 500 ml of blood, but again, the quantification of blood loss is very variable from person to person, and visual quantification is often underestimated. Accurate quantification may be done using a brass bead drape, but again, they are not universally available. So we need to be very alert. We should not wait for shock to develop. Any bleeding, which is a continuous trickling or leading to any degree of tachycardia or hypotension, is significant. And we must remember that anemic and preeclamptic women are more likely to collapse even with a small blood loss. So management, I don't think I will go into that. We need to remember the acronym hemostasis, help, assess the ABC and resuscitate, look at the etiology, massage the uterus, give an oxytocin, shift to OT, look for tissue trauma and give tamponade if required, apply compression sutures, do a systematic devascularization if required, interventional radiology, and lastly, subtotal or total hysterectomy. So hopefully we don't need all of them. The PPH bundle is a very important method which helps you to remember the things. So as a first response, quickly give IV fluids, uterotonics, tranexamic acid, and massage. Give the supportive, look for any lacerations, empty the bladder and the uterus. If still PPH is continuing, we need to go in for bimanual uterine compression or aortic compression, while in the meanwhile give a intrauterine balloon tamponade and apply the anti-shock garment. And we require the supportive measures of blood transfusion and, if required, referral to a higher center. Always remember PPH, the woman comes in quite well and suddenly she has a major PPH and either becomes low or expires. The chances of litigation are high. So we need to counsel the attendants at every stage, including about the risk factors, the need for blood arrangement. The documentation must be good and complete, and always we need to be empathetic. We can improve the outcomes by organizing well-defined teams, which include an obstetrician, anesthetist, and support staff, regular drills, and regular audit. So being prepared and having a team effort is the backbone of our success. So remember, prevention is always better than cure, and we need to be prepared for PPH in every case. And at all times, time is of essence because death may occur as early as 2 hours after delivery. So we need to be alert, have a high index of suspicion, and remember, oxytocin is the drug of choice for prevention and treatment of PPH. So thank you very much. Let us all join hands because every mother is important, and let us join hands to prevent PPH. Thank you.
Thank you, Dr. Anju, for wonderful presentation on the prevention and prediction of PPH. Thank you very much, ma'am. You have beautifully summarized the topic.
Thank you.
Thank you.
Now we move to the good afternoon. Hello.
Yes, Bharti, yes.
Hello.
Yes, we can hear.
Yes, am I audible? Good morning all.
Yes.
Now as we are already running short of the time, so now we move to the next topic, that is confusion to clarity. And definitely we are going to learn about the 3 most important topic: hypertension, preterm labor, and recurrent pregnancy loss. And let us learn from our speakers that they are so difficult to handle, but how the treatment in such patients can be minimized. So may I have the honor of inviting the chairperson for this session, Dr. Jaya Chaturvedi, Dr. Meenakshi Rohila, Dr. Dilpreet Sandhu, and Dr. Ruby Bhatia. Dr. Jaya Chaturvedi, may I have a CV, please? Madam is a professor and head of the department, AIMS Rishikesh. Dr. Meenakshi Rohila, Madam is professor in the Department of Obstetrics and Gynae, PGI Chandigarh. Dr. Dilpreet Sandhu is a professor in the Department of PGI Chandigarh. And Dr. Ruby Bhatia is head of the department and professor, Maulana Medical College, Ambala. So now we begin with the next session, confusion to clarity.
Good morning, everyone.
Good morning.
Thank you, Dr. Bharti, for the kind introduction. We are at the beginning of our second session, and this is a very important session as far as obstetric morbidity and mortality is concerned. And I am happy to invite Professor Sukumar Barekh, who is professor and head at Eye Care Institute of Medical Sciences and Research, Haldia, West Bengal. Sir is recipient of many awards and achievements, and he is recipient of CL Zaveri Prize of Foxy, Dr. M. Kochar Award, AICC RCOG, Chairman of ISOPAR. He is past Joint Secretary, Bengal Obstetric and Gynecological Society, member of National Guideline Development Group on PCOS. He is peer reviewer of many international and national journals, and associate editor of Indian Journal of Perinatology and Reproductive Biology. He is having many research paper and publication in his credit, and now he is going to talk on optimizing outcome in hypertensive disorders of pregnancy. Welcome on the dais, sir. The stage is yours, sir.
Thank you very much for your kind introduction. It's a real pleasure. Can you hear me?
Yes, sir.
It's a real pleasure to participate in this conference well organized by PGI Chandigarh, my own alma mater. this is the session on confusion to clarity. In 15 minutes, I have to clear the confusion of hypertensive disorders of pregnancy, which has not been cleared over decades or centuries. The introduction suggests that optimization means something to make better, and the outcome means that something at the end of the result that or the getting some consequence of some procedure. In hypertensive disorders of pregnancy, we'll divide into two groups. One is predict and prevent, and then manage this condition. For last 7 or 8 years, this has been the classification adapted from ACC, the task force, which suggests there are two basic groups. Somebody who has hypertension before 20 weeks, that means some chronic hypertension or renal disease. And there is a group where there is preeclampsia, gestational hypertension, or chronic hypertension superimposed with preeclampsia. Now, if we summarize the whole thing, then the talk will be divided into two parts. One is managing chronic hypertension with pregnancy. And the second group, the commonest group, is the gestational hypertension or preeclampsia group, where we have to prevent it if we can and manage it effectively. So if you look at the chronic hypertension, the very important thing, if somebody is hypertensive before the pregnancy, she should have an assessment by the physician. There is a need for changing the antihypertensive if it is necessary, and for us to start folic acid and to have a good control so that she can start the pregnancy in an optimal condition. We know that if she is on ACE inhibitor or ARBs, we should stop that one because that can cause known congenital anomalies. Similarly, we should stop thiazide or thiazide-like diuretics, and we should stop or we should target the blood pressure around or below 135 by 85. And we should know that we should nowadays, we should control or consider labetalol. If labetalol is not suitable, then nifedipine is the second choice. And this is the age-old methyl dopa. If both the things, very small group where both labetalol and nifedipine are not suitable, in that case we can start methyl dopa. But as you know that it takes longer time to action, and there are some side effects, and that is one of the reasons why methyl dopa has lost its glory. And at the current moment, the choice has shifted from methyl dopa to levodopa or nifedipine. And in this group also, where there is a chronic hypertension, we should start low-dose aspirin 75 to 150 milligram once daily from 12 weeks onwards. If we move from the chronic hypertension to the preeclampsia, there are three important things. One, can we prevent it? And this is the area, there is a huge study going on for ages. And you know that every student or everybody who is doing obstetrics are thinking someday they will discover something and have the award of the plaque, as we see in this Chicago laying-in hospital. In the primary prevention, at the current moment, the only thing which stands is dietary calcium, particularly those who are in the low calcium intake group. In the secondary prevention, at the current moment, there is a risk scoring system, that means clinical risk scoring, followed by the low-dose aspirin. And there are many algorithm-based prediction of the biochemical prediction is coming up. Along with also there is algorithms are there. And in that group, if there is a high risk group, then we can start with the low-dose aspirin. And in the tertiary prevention, we know there is Maxal is there. So in the risk scoring system, we know that these are the high risk factors. If somebody has got the previous hypertensive disease during pregnancy, or chronic kidney disease, systemic lupus erythematosus, or antiphospholipid syndrome, or somebody has got type 1 or type 2 diabetes, or somebody has got chronic hypertension, will be classified as high risk group as the history. And in the medium risk group, if somebody has got more than one medium risk, like first pregnancy, or the age is 40 or older, the interval of the pregnancy is more than 10 years, or the heavier body mass index, or there is a family history or multiple pregnancy. So if there is a combination, is a first pregnancy and there is a multiple pregnancy, yes, we should start low dose aspirin. This is an interesting study published, which is ASPI trial, published in New England Journal of Medicine in August 2017, clearly promotes that if we start low-dose aspirin in the high-risk group of preterm preeclampsia, there is a lower incidence of diagnosis than placebo. So it is important to do the risk factor by some means and to start the aspirin in the appropriate group. If we move from the prevention, prediction, and prevention to the management of preeclampsia, eclampsia, we are benefited by the several things. That you have to consider appropriate antihypertensive. We have to consider the appropriate anticonvulsant. We have to think about corticosteroid in the appropriate time. Needless to say, the maternal monitoring is important, along with the fetal monitoring. We have to consider which patient need to be cared in HDU or intensive care unit. We have to think about delivery in the appropriate time and the neonatal care and the postnatal care. We are very fortunate that we have got antihypertensive, as we mentioned earlier, the labetalol, particularly the intravenous if it is necessary, oral nifedipine is there, and if it is necessary, we have to go for intravenous hydralazine, but most of the time it is okay with these two, labetalol and nifedipine. About the antihyperconvulsant, we are very fortunate that at the current moment there is only one which stands tall, is magnesium sulfate, which has been clearly demonstrated in the collaborative eclampsia trial. And I must take the privilege or the proud of remembering two colleagues of mine in PGI. One is Professor Anil Bhalla, and second one is Professor Narayan Jana, who has contributed significantly in the management of eclampsia. And this is a paper which is published in International Journal of Gynecology and Obstetrics, having the experience of low-dose magnesium sulfate in the management of eclampsia over a decade. And they clearly, Professor Jana group has clearly demonstrated that low-dose regime is safe, effective, particularly in the lightweight women like which are there in our country. So this is a very well-tried, good, well-designed trial over nearly 3,000 eclamptic patients. Ladies and gentlemen, we have to consider the corticosteroid for lung maturity, particularly if you are thinking about delivering preterm. And needless to say, the fetal monitoring stands a very good thing. If somebody admitted with severe preeclampsia or severe gestational hypertension should have a CTG done at the time of admission. And if we think about conservative management, then appropriate growth scan, amniotic fluid volume index, and the umbilical artery Doppler will guide us that which is the time appropriate for delivering the baby. Second important thing is repeat CTG is necessary if there is a change in fetal movement, if there is vaginal bleeding, abdominal pain, or deterioration of the maternal condition. In that case, we have to think about repeating the CTG so that we should decide the time of delivery. We obstetricians always think about when to deliver, and always there is a not a dilemma. Is it too early to deliver this baby, or is it too late? And that is the dilemma we have to sort out by considering different conditions of the mother, the fetal condition, and to judge whether to deliver the baby by cesarean section or induction of labor. But the mode will depend on the severity and depends on two important things. What is the clinical condition of the mother and the fetus, and what is the woman's preference will guide us whether you should go for induction of labor or should go for cesarean section. So finally, ladies and gentlemen, we are very fortunate today. Remembering 30 years back in PGI Chandigarh, we don't have an effective antihypertensive. Neither you know which one is the effective anticonvulsant. Dear friends, the younger colleague, you are very fortunate. We have powerful, effective antihypertensive today. You don't have any confusion about the anticonvulsant. Only thing you have to think about whether to go for the low dose Maxal or not. You have got an effective fetal monitoring tools, and also you have got ultrasonography, which includes the biometry and Doppler, along with the cardiotocography to see what is the climate and what is the weather to determine what is the time to deliver this baby. We have got better laboratory facilities today. So liver function test, the complete hemogram is available within few hours, even within an hour. And we are very fortunate. This mother can be sent to intensive care facilities, which is improved enormously in today, so that the whole thing can be improved very significantly. But whatever improvement has happened, the man behind the machine is very, very important. So that is the reason in managing managing hypertensive disorders of pregnancy, it is very important to be very vigilant. There is a judicious use of all the facilities, but dear friends, it should not be too much, neither it should be too little. So effective management will have a better outcome, and gradually we have moved from many confusions to clarity, but in hypertensive disorders of pregnancy, still few confusions are there, and we need enormous research to lead towards real clarity. Thank you very much for your kind attention.
Thank you, sir. Wonderful and on-time presentation.
Thank you.
It is really very important that men behind the machine should be very vigilant. And that is the wonderful message conveyed with your presentation to all of us. Thank you so much, sir.
Thank you.
I think question and answer will take in the end. And I want Dr. Dilpreet to introduce next speaker.
Thank you.
Thank you, sir.
Good morning, everyone. First of all, I thank organizers for having me here. We are all aware that preterm birth is a major cause of infant morbidity and mortality. And most of the known risk factors are not modifiable. To understand the disease pathology, its progression in a better way, now we are moving on to the advanced molecular techniques to analyze the biomarkers in the maternal tissues. To speak on this important topic, it's my proud privilege to invite Dr. Ashima Taneja, Professor and Head of the Department of Obstetrics and Gynecology, DMC Ludhiana, and a recipient of Dr. R.D. Pandit Award. She has more than 20 years of teaching experience and trained in genetics, IUI, IVF, and laparoscopy. She's organizing chairperson of yearly quarterly meet of Northern Chapter of Obs and Gynae Society of India and MRCOG Part 1 2015. She's core member of WHO Task Force on Safe Abortion and FOGSI National Task Force of COVID-19 in Pregnancy. I invite you, Dr. Ashima, to speak on this important topic.
Thank you for your kind words. I would like to congratulate Dr. Vinita and team for this excellent conference. Let me just share my screen. Is it visible? The slides are visible?
No, ma'am, not yet.
Not yet.
Share again.
Ma'am, is your presentation on?
Yes, it's on. Not able to share.
Just share the screen then, ma'am.
I'm doing that, but it's just give me a moment.
The person you have called is speaking to someone else.
Can somebody guide me?
Yes, ma'am.
Avinash, please.
Yes, ma'am. Ma'am, click on the share screen button.
Yes, I've already done that.
And then any window open?
The desktop is coming. The white.
Yes, then click on your click on your presentation.
Presentation is already there in the background, but it's not sharing.
Ma'am, is it open, ma'am? Is it open?
Yes, it's open.
Ma'am, close the presentation, then again open it.
Okay, okay. Sam, come fast, please. Come fast. Okay, I'm again opening everything.
Okay. And now again click on share screen.
Share screen, yes.
And then is it showing? Desktop.
Video.
It's not share. Either share. Is it visible?
Yes, yes. Now it's visible.
All right.
Ma'am, do it on slideshow.
Right, I'll do that. Yeah.
Yeah, perfect.
Just. Yeah, sorry for the technical problem.
So we will request you to please be, fast, and we have to reach on the time with the inauguration in each hall.
Sure, sure. So the topic for today is metabolomics in preterm labor. So it's a novel approach. As we already know, preterm labor is almost the incidence is 10%. And if we look at this chart, India is just topping on this preterm births. And we have to decrease these preterm births to decrease the childbirth mortality and morbidity. So preterm labor, we all know, whenever there are contractions and cervical changes before 37 weeks, it's a preterm labor. And causes are multifactorial. So if we have to predict, we have to be very accurate with the cause of the preterm labor. And we know along with this, there are associated uterine distension, hemorrhage, stress, autoimmune factors, infection, inflammation, environment, behavioral, and socioeconomic factors. And they are all leading to a complex pathophysiology by causing inflammation and release of interleukin factors, tumor necrosis factor, decidual hemorrhage causing release of interleukins and thrombin, maternal fetal endocrine activation leading to CRH and leading to surfactant proteins and phospholipids, uterine overdistension releasing to the hormones and the prostaglandins, and finally leading to a preterm delivery. So if we can understand this complex pathway, we can lead to some good predictive test. Currently, we have a test which is called the transvaginal measurement of cervical length. And if it is short, we give progesterone to prevent a preterm labor. But we do not have studies on cervical remodeling, which causes the shortening of the cervical length. So the clinical test we have is the cervical shortening. It has a sensitivity of only 33 to 36%. We can measure cervicovaginal fetal fibronectin levels with a sensitivity of 46%. So to summarize, we do not have a good test for a prevention. If we cannot do a prediction, we cannot prevent. So what do we lead to? So now we have metabolomics in preterm labor. So what it is? So it is a part of biology. So genomics, they study DNA. Transcriptomics, they study mRNA. Proteomics, they study proteins. And metabolomics, they study the metabolites. So if we see what is this, metabolomics is the method that we are going to measure small molecules which are called metabolites. And where do we find them? They are in the tissues, they are in biofluid, and they are called metabolome. So if we can study these markers in tissue, plasma, or amniotic fluid, we can reach to a conclusion. And what are the techniques? How are we going to measure them? We have HNMR, proton nuclear magnetic resonance. We have chromatographic methods, gas or liquid chromatography. And the sources, as already I have told you, we have the amniotic fluid, blood, plasma, cord blood. And these have already been reflected in various studies. This is a study of 2013, where maternal fetal medicine pointed out that we could do some biomarkers in all the sources enlisted before. But what are the metabolites we are going to study? So it's a big spectrum. It could be histidine, it could be steroids, it could be bile acids, it could be fatty acids. So how to study such a big spectrum? So there was a study in Metabolites 2019. They said if we can study the 4 metabolites, prostaglandins, vitamin D and derivatives, fatty acids and metabolites, bile acids and the other acids. If we can study these 4 in the plasma, we might be able to predict something. So we need a biomarker, not a panel. We just need a specific biomarker which can predict preterm labor so that we can do a prevention. So far, we do not have any ideal method or an ideal or an accurate biomarker, biological marker. So we have some studies from 2019 which were reflected in Cochrane and PubMed, and there was another study in 2018. So a summary of these 2 studies is highlighted as now, that they studied the fatty acids in plasma. The fatty acids could be saturated or unsaturated. Unsaturated include omega-9, 6, omega-3. So what is their role? Another thing is arachidonic acid. So there's a phospholipase activity which breaks down these fatty acids into further metabolites. And if we measure them in plasma, we can find out what is happening. Similarly, in lipid group, we have lysophosphatidyl and the other derivatives, which are broken by phospholipase A2 activities and their level increase. So this is the study reflected that fatty acid metabolism, all these metabolites increase in preterm labor, and we can measure them in plasma. Then there was a study which suggested that we could measure progesterone. We know progesterone is released from corpus luteum, and whenever there's a preterm labor, the progesterone levels are lower. So if we can estimate the progesterone levels, we can reach to a conclusion. So we know in cholestasis of pregnancy, bile acids are increased and related acids are also increased. And if we measure them in plasma, we can predict preterm labor. This was reflected in the study that is available at 2020 PubMed. We know that vitamin D deficiency is linked to preterm labor. So the plasma estimation of vitamin D during pregnancy can tell us about the preterm labor. There were various studies which estimated some metabolites in amniotic fluid. So in amniotic fluid, they studied the carbohydrate levels, the amino acids, the bile acids, allantoin, creatinine, and myoinositol. And this is the reference study. So they found the carbohydrates were decreased in the amniotic fluid. And amino acids, they had a variable response. They are linked to a spontaneous preterm delivery because of the dearrangement of the placental function. So there are some amino acids which increase, like tyrosine, and some decrease, like alanine. So estimation in amniotic fluid will give us some clue. So these are the reference tables. They also studied allantoin in the placental tissue. It is also a marker of oxidative stress and has been linked to preterm labor. Another is a psychoactive substance, anandamide. So patients who are consuming this, it gets gathered, it gets accumulated in amnion and choriodecidual tissue. And we can estimate from the placental tissue amniotic fluid at the time of cesarean section, and it is known to increase at the time of preterm labor. So after we have done all these studies, can we really apply it in the real life? So there are some discrepancies in this study. So now we have various studies which have estimated these metabolites in blood, amniotic fluid, urine, cervicovaginal fluid. So we do not have a constant study which has estimated on plasma and compared it, or amniotic fluid and compared it. That means we don't have good studies. And all these studies, they estimated at a different gestational age. Some did at 15 weeks, some did at 20 weeks. So the gestational age was not constant in all the studies we have available with us. Then the population group, whether it was a singleton pregnancy, it was a multiple pregnancy, whether there was a pre-labor rupture of membranes. So that is not known. So that is a bias factor in all the studies. And the sample size in all the studies was just 100. And we have limited studies. And when we talk of the methodology, so some were doing with the mass spectroscopy, some did liquid chromatography, some did gas chromatography. So there was not a uniform method by which everything was estimated. And another study highlighted that if patients are close to the environment where they were exposed, suppose a patient was close to an industrial area where the environmental exposure was more and was compared to other person who was away from that industry. So it means that the proximal metabolites are present in larger quantities than the distal exposures. So that was also one of the bias. And when we are studying these metabolites, the final aim is that we have to give a healthy baby, and we do not know whether these metabolites are doing anything to the baby. So we have limited studies on the fetal aspect. So what do we conclude from all this? That it is definitely a novel way that you estimate biological markers and predict preterm labor, but the plasma is very reassuring, but amniotic fluid appears to be invasive. So it is possible that we estimate at least prostaglandins, fatty acids, vitamin D, and bile acids so that we can predict preterm labor. But we need a robust data to document all this. But in a nutshell, if we have to say whether the biofluids should be used for this prediction and prevention, it is yes. Thank you.
Thanks, Dr. Ashima, for such a nice talk and keeping time limit also in mind. Thank you so much. Now we move on to next. I request my madam, my teacher, Dr. Ruby Bhatia, to kindly invite the next speaker.
Hello, doctor. Good morning, all. My hardcore thanks to Dr. Vanita Suri and team for making me part of YUVAFOGSI. As we all know, recurrent pregnancy loss remains the most frustrating area in reproductive medicine. There are only very few evidence-based diagnosis and management strategies. Today we have Dr. Aparna Sharma, additional professor from AIIMS, New Delhi. She has many awards to her credit, and she has a special interest in fetal medicine with expertise in fetal interventions, with a number of publications in various international reviewed journals. Over to Dr. Aparna for management of recurrent pregnancy loss.
So, can you hear me? Am I audible?
Yes.
You are.
And my screen is visible?
Yes.
Yes. So, a very good morning to all of you, and thank you, Dr. Ruby Bhatia ma'am, and really thank you, Dr. Vanita Suri ma'am and team, for making me a part of this. And recurrent pregnancy loss, as ma'am said, is really a very frustrating problem. So I would really stick So let us start by trying to quickly define what is RPL, the prevalence, the causes, the evidence-based tests, the chances of recurrence, and what is the treatment. So when we try to define recurrent pregnancy loss, we would try to define it as earlier as 3 or more consecutive losses. But the general belief is that if there are 2 or more pregnancy losses, we will not wait for the third loss to start investigation. So Eschrey says that if there are 2 or more losses which are defined by serum or urine pregnancy test which is positive, so biochemical pregnancy tests should also be considered, but do not include confirmed ectopic or molar pregnancy. And this is the 2020 definition of committee opinion of ASRM, which defines as 2 or more pregnancy loss. How common is it? 1 loss is 15%, 2 or more is 2%, and 3 consecutive losses 1%. So although not very common, but when it does occur to us, it is very, very frustrating. So primary RPL is when they never had any previous viable pregnancy, and secondary RPL is when there was a previous pregnancy followed by consecutive losses. Then we come across the situation, what could be the causes of these pregnancy losses? So evidence-based cause is anatomic, when there is a uterine malformation, genetic, when there could be some karyotypic abnormalities or a translocation in the parents, immunological, APLA, or endocrine, or any infections or others. If you look at the etiology, it is anatomic, is seen in 10 to 15%, genetic in 3 to 5%, immunological in 15 to 20%, but majorly it remains idiopathic. Best accepted unambiguous causes is only 3: uterine, antiphospholipid antibody, parental karyotypic abnormality. So I will stick to 3 in the next 15 minutes or so. So most common unambiguous known cause of recurrent pregnancy loss is antiphospholipid antibody, and I will deal with this in some detail. So we know that antiphospholipid antibody is characterized by arteriovenous thrombosis along with lab of relevant antiphospholipid antibodies, and the clinical criteria plus which is characterized by arterial or venous thrombosis or pregnancy related morbidity which is unexplained miscarriage more than 10 weeks of a formed fetus, or a premature birth before 34 weeks, or more than 3 unexplained consecutive miscarriage less than 10 weeks, along with lab criteria which is lupus anticoagulant, anticardiolipin antibodies, anti-beta-2 glycoprotein. So if these 3 features, any of them is present, this is the lab criteria, along with or without thrombosis, then this is the clinical criteria, along with 1 lab criteria, then that would be antiphospholipid antibody. This thing. Now, recommendation for testing, it is a strong recommendation for testing, and it is recommended that the time interval for testing of LAC and after a pregnancy loss is not known. However, the confirmation of a result after 12 weeks is necessary. Earlier it was 6 weeks, but now it is 12 weeks. So we need 2 results at an interval of 12 weeks. High risk factors for APLA is LAC and double positivity in triple positivity. If it is isolated ACL or anti-beta-2, it is a low risk factor. Now, there is a bit of a difference between prophylactic versus therapeutic anticoagulation when we know that it is antiphospholipid antibody positive. Now, if there is a prior thrombosis, then we have to give therapeutic anticoagulation. If there is no prior thrombosis, then we give prophylactic anticoagulation. And we know that the dose of prophylactic anticoagulation is enoxaparin that we give subcutaneous OD, while if it is therapeutic anticoagulation, we give enoxaparin subcutaneous BD. Interestingly, there is a bit of difference in the kind of APS based on early or late fetal losses, or whether if it is only preterm delivery based on uteroplacental insufficiency. Now, if it is the APS based on fetal losses of more than 10 weeks gestation, single, or more plus low molecular weight heparin along with postpartum molecular weight heparin, more in this particular case. If the morphology is only consistent with placenta
I think we have lost her connection.
Yes, ma'am. I'm just calling. Just a minute.
Dr. Aparna, can you? Hello.
I'll call her. I don't.
Okay, fine.
She's joining. She's joining in a minute. She's joining in a minute.
Okay. Ma'am, may I request Dr. Ruby to please give you some concluding remarks about the talk till she joins. Ma'am, please unmute yourself. Dr. Ruby, please. Please unmute, ma'am.
Dr. Ruby, unmute kariye. Yeah.
Yes. Hello.
Yes, ma'am, you are audible.
So, in all cases of recurrent pregnancy loss, it is very, very important to reassure the couple, not only the patient, but I think the couple, and to evaluate for all causes, mainly anatomic and autoimmune causes. They are very, very important, especially APLA, and we should go for all the three lupus coagulant and beta-2 glycoprotein and anticardiolipin, and repeat it after 12 weeks. We should be very clear. And this antepartum prophylaxis with ecosprin and low molecular weight heparin, this should never be given unless the patient is APLA positive. Not in every case. We see many of the patients who in field that where they are giving it without documenting APLA twice. Yes, uterine malformations must be ruled out, at least with 3D transvaginal ultrasound or MRI. That's very important before we make a diagnosis, because that remains a very important cause. Yes, again, in many, many cases, it can be unexplained, and where we should reassure them that in 30%, even if she doesn't take any treatment, the results are going to be that she is going to have a live baby. And I will like Dr. Meenakshi to add on, since she's heading the high-risk unit.
Thank you very much, Dr. Ruby.
Dr. Aparna joins.
Thank you, Dr. Thank you very much, Dr. Ruby. I think we need to wind up this session. I'm sorry, and I thank all of the chairpersons to. I mean, I'm really thankful to them that they spare their time and share their experience and knowledge with us. My apologies to Dr. Aparna also, as we are running short of time. As she can't join, we need to start the next session. Thank you very much, all.
Thank you. Thank you all. Thank you all.
May I request Avinash to please just display the slides of chairpersons of the next session? Yeah, thank you. I take the opportunity to introduce the next chairpersons of the next session. Dr. Sunita Goel, she is professor and former head of Department of Obs and Gynae at Christian Medical College and Hospital. I welcome you, ma'am. I hope she has joined.
I'm there. Thank you.
Yeah, thank you, ma'am. Dr. Seema Chopra, she's additional professor at PGI Chandigarh. She has a very special interest in medico-surgical disorders in pregnancy and laparoscopy. I welcome you, Dr. Seema. Dr. Abha Singh, she is director professor and unit head at Department of Obs and Gynae at Lady Hardinge Medical College and SSK Hospital, New Delhi. Welcome, ma'am. Dr. Jyoti Malik, she is medical superintendent of JJ Institute of Medical Sciences at Bahadurgarh. I welcome all of the chairpersons, and I will request all of you to please introduce speakers and please restrict to be on time. Thank you very much. Dr. Sunita, please introduce Japleen and.
Yes. Yes. Good morning, all. Thank you for having me here in this conference. Our first speaker today for the topic, isolated oligohydramnios near term. It's a big dilemma whether we should go for induction or just observation if everything else is normal. So I will invite Dr. Japleen Kaur. She's Assistant Professor, Department of OB-GYN, Dr. B.R. Ambedkar Institute of Medical Sciences, SAS Nagar, Punjab. And she has lots of awards to her credit, and she has 16 papers in national and international journals and contributed many book chapters. Her field of interests are reproductive endocrinology, infertility, high-risk obstetrics, surgery, preventive oncology. Dr. Japleen, please.
Thank you for the kind introduction, ma'am. And at first, I would like to thank Dr. Vanita Suri and all the organizers for this opportunity. Without further ado, I'll start. I'm sharing my screen. Are my slides visible?
Yes.
Yes.
Yes, ma'am. I'm audible, right?
Yes, ma'am.
Okay, thank you. So isolated oligohydramnios near term, whether to induce or not. First of all, just a brief introduction. Oligo is basically ultrasound suggestive of an AFI less than equal to 5 centimeters or a single vertical pocket less than equal to 2 centimeters. It is called isolated when it is associated with an appropriate fetal biometry and there are no associated structural or chromosomal abnormalities, no history of any maternal infection or illness or leaking to explain that oligoamnios. And the incidence is 0.5 to 5% in different studies. So the importance to differentiate an uncomplicated from a complicated or an isolated oligo is that if there is an associated cause, like a fetal growth restriction or hypertension or rupture of membranes, the management is easier as it is guided by the primary cause. So the issue remains whether the isolated oligo is to be induced or not. And again, the challenge here is that the isolated may not actually be isolated. Plus, it may be a surrogate marker of some underlying placental perfusion problems because the pathogenesis of isolated oligo is also believed to be underlying decreased placental perfusion and hypoxemia, which is leading to a decreased generation of fetal urine. So we think that the fetus is affected, even if we are not able to see anything else. And the ultrasound is also insensitive in diagnosing growth restriction. So some cases of IO may actually have an underlying fetal growth restriction, which we have not been able to pick up. And we need to see whether this isolated oligoamnios gives rise to any adverse perinatal outcomes. So there is this meta-analysis in 2016 in which they saw that yes, isolated oligoamnios patients were more likely to have emergency cesarean delivery for fetal distress, admission to NICU, and infants with MAS. This is just representing the same data. So what are the managements when we know that somebody has isolated oligoamnios? We know that we have to go for a stringent fetal monitoring with NST, biophysical profile, AFI repeatedly, and plus minus the umbilical artery Doppler venometry. And whether we induce or not, depending upon the fetal distress, or we go up to term or have a conservative management. In some cases, we may even need to go for elective cesarean section. So in Korea, they did a study in which they asked a lot of their respondents, how did they manage their patients of isolated oligoamnios? So what we can see here is they were asked these questions. Is a case of isolated oligoamnios in third trimester an indication for induction of labor? 70% said yes. And when they were asked whether induction of labor reduces the adverse perinatal outcomes, again 74% said yes. Similarly, a study in 2009 in which 221 respondents of Society of Maternal Fetal Medicine, even they, 96% had said that yes, isolated oligo was an indication for induction of labor. Now, what can help us decide when do we induce? So there may be some role of Doppler velocimetry, although it is not 100% established in isolated oligoamnios as much as it is in fetal growth restriction. But still, some people have from studies defined that an intervention may be avoided in isolated oligo when the Doppler indices are normal. And now coming to this meta-analysis in 2016, isolated oligo at term as an indication for labor induction. Again, they were not able to show that either induction has a definite role or not. So the evidence does not really support or defy routine labor induction in this setting, and still high quality data are needed. This was in 2016. The only RCT of 2005 was a very small RCT in which they actually randomized patients into two groups of expectant management versus induction. But it was a very small study of about 54 patients. The randomization was done at 40 weeks, which is almost like everyone got expectant management, right? This is the latest study now in 2020, a retrospective cohort only, although not an RCT, in 1191 term singletons, in which they induced these either at early term or waited till full term, that is 39 weeks. And they found that the rates of meconium stained amniotic fluid LICA was higher if the induction was done later, that is in expectant management, and again increased risks of cesarean sections as late as the pregnancy was carried on. So labor induction of IO at early term is a better thing, and it reduces the risks without increasing the risks of neonatal adverse outcomes. And coming finally to the guidelines and recommendations, the latest 2019 ACOG committee opinion also says that oligoamnios, which is isolated or otherwise uncomplicated, diagnosed as an SDP less than 2 centimeters, should be induced at late preterm or early term, that is 36 to 37 plus 6 weeks. So my take-home message from this is that isolated oligoamnios near term, yes, it should be induced, but we should individualize, keeping these points in mind, that using a criteria of single deepest pocket less than 2 centimeters is better, as proven in Cochrane systematic reviews also. We must make every effort to confirm that it is isolated and there are no underlying causes like PROM or fetal growth restriction or any anomalies, so a good congenital malformation scan. We must discuss the risks and benefits of the intervention versus expectant management with the patient, and early term, that is near 37 weeks, is better than the late preterm or later term. And here there may be a role of umbilical artery Doppler to guide our timing. Then we must do a careful Bishop score assessment and use judiciously the cervical ripening agents so that unnecessarily patients do not land up in the cesarean sections. Thank you.
Yeah, thank you, Dr. Japlin. So we would like to, I think, now take up the next speaker. Can we have the CV of the next speaker so we can then compare the two? Yeah. So
good morning, ma'am.
Yeah. Good morning, everybody. So on behalf of NODZone YUVAFOGSI, I would like to welcome everybody on this platform and thank the organizers, Dr. Vanita and all the team for giving us this opportunity. On behalf of all the chairpersons, I would like to thank each one. So here we have Dr. Namrata. She is Associate Professor at King George's, Lucknow. And she has been accredited from Fetal Medicine Foundation, UK, for fetal scans. And she has got a few good awards from FOGSI, Dr. Usha Krishna Award, Dr. Jagdishwari Mishra Award, and Dr. Krishna Mukherjee Medal for the best paper published in Journal of UP Chapter of Obs and Gynae, and has 25 publications. So over to Dr. Namrata, and what you now, can you put your view, please?
Good morning, everybody. Thank you very much for giving me this opportunity to speak in this wide platform of NODZone YUVAFOGSI. So I'll be sharing
video on, Namrata. Please put your video on if you.
Your slides are not visible.
Yeah.
You please
I'm just sharing
share the screen.
I'm just sharing.
Yeah. Yeah, it is okay. Now you can put it on full screen. Yeah, that's
it visible now?
Good, good. Yes.
So I'll be speaking on, as Dr. Japlin has very nicely spoken about the her points about that isolated oligohydramnios should be induced. I'll be speaking that we don't have enough evidences that should be induced. So very quickly, just to revise, oligohydramnios defined as AFI less than 5 centimeters or deepest vertical pocket less than 2 centimeters. It is a risk factor for adverse fetal outcome. It is an indicator of possible presence of maternal or fetal comorbidities, and identification of oligohydramnios usually mandates a close fetal surveillance that we all know. Now, causes can be acute and chronic. We are not bothered because if there are causes, then we have to induce, but there is an entity called as isolated oligohydramnios, which means that there is oligohydramnios without any fetal structural chromosomal abnormalities, without any fetal growth restriction, without intrauterine infection, and in absence of any known maternal disease. Now, what is the incidence? 0.5 to 5%. And when it is diagnosed near term or term, it is a solid indication for labor induction as of now. We all know that, because we believe that it is associated with the increased incidence of adverse perinatal outcome, possibly as a result of cord compression or uteroplacental insufficiency or meconium stained amniotic fluid. But why are we bothered so much to induce or deliver? As an attempt to reduce the incidence of these outcomes just enumerated, but do we have evidence for that? Enough evidence? Those reports which we talked about since the year 1999, these reports basically elucidate the association between oligohydramnios and the perinatal outcome, but they were a lot of heterogeneity, and most of these studies also included fetuses with structural anomalies, with growth restriction, with post-maturity syndrome, as well as mothers who have numerous medical conditions. And so they are not like the newer researchers, they were not that reliable. So we had a doubt whether the observed association between the perinatal outcome actually reflect the sequelae of these comorbidities, or whether they are direct result of the amniotic fluid volume itself. And therefore, we have a very questionable justification for the common practice of labor induction near-term pregnancies in presence of isolated oligohydramnios related to an otherwise low-risk pregnancy. But still, it is a strong indication for labor induction in most of the institutions, and that is why we need to think about it. Now, what are the challenges? We do have challenges. Challenges like the poor subjective definition. A definitive diagnosis for the amniotic fluid volume requires an invasive procedure, and that is not practical. And we depend upon AFI, which is it's not that sensitive. And then we have lack of resources at many places, so that we are confident that the pregnancy is actually a low risk one. We have differences at places where we can screen the pregnancies, and obviously difficulties to monitor the pregnancies, and that makes us more reluctant not to take a chance. So then what is the evidence? Whether induction of labor in near-term pregnancies is superior than conservative management, or whether induction of isolated oligohydramnios actually increases the rates of perinatal morbidity and mortality. We have to think upon that. So going back to the year 1999, when Chauhan et al. Did the first meta-analysis to see an association between the AFI and perinatal outcome, and these authors, they confirmed that oligohydramnios to be associated with significant risk of cesarean delivery for fetal distress and low risk growth. But gradually, more studies came into effect. And then previously, 1999 ACOG bulletin did said that we have a lack of convincing data to support in absence of other risk factors to induce or not induce. That led to a lot of brainstorming, a lot of new studies. We have very few RCTs, only one RCT is identifiable, that is 2005. It was to evaluate maternal and neonatal outcomes in uncomplicated pregnancies with oligohydramnios at term. And 26 women were taken only, 40 weeks completed pregnancies, and 28 women were given to induction of labor group, and 26 to conservative management group. The primary outcome was the mode of delivery, and the primary neonatal outcome was the cord pH and Apgar score. And they did not find, this RCT did not find any difference in maternal or neonatal outcome. Gradually, newer studies came. In 2013, we had study which was a review. And again, this study, it was not clear that it is associated with any neonatal adverse outcome, actually. And then we had a survey of perinatologists. What did they feel? So majority of these perinatologists, when they were inquired, they did say that, yes, we are going for induction. Actually, nobody was aware what is the evidence. Majority of them, they were not aware whether to do or not to do. And those who were aware were dubious about what is the evidence. Now, studies did came whether near term before 37 weeks did we have to do induction or not. Again, it was associated with numerous cases of iatrogenic prematurity and its consequences. Then we had a meta-analysis 2016 finally. This meta-analysis included 12 studies, although only one RCT. And this meta-analysis also said that in isolated oligohydramnios in term pregnancies is significantly associated with higher rate of induction of labor and higher rates of cesarean section. And also because of this sequelae, there were higher rates of low Apgar score and ICU admission, but there was no difference in cord pH difference between the study group or the control group. Then we had a newer study in 2020. It's a very recent study, which included a very large data group from 2011 to 2019, where singleton pregnancies between 36 weeks to 40 weeks were divided into two groups, study group and control group, one with isolated oligohydramnios on conservative management, the other one with induction. And they realized that induction of labor at 36 weeks or after among isolated oligohydramnios gestation were associated with an adverse neonatal outcome as compared to no induction group. Indian studies also speak the same story. We have a study from Med Hospital, although very few Indian study, and they have also realized that we have a very high cesarean rate if we induce the pregnancy just because of isolated oligohydramnios at near term. Cesarean section rates were very high, and there were no differences in the fetal outcomes. So what consequences we feel after induction in near term for us isolated oligohydramnios? These pregnancies which are induced, they have a high intervention rate as compared to those pregnancies which are left a bit destined to their normal delivery, or destined to their actual delivery time, that is if they're left for conservative management with a close follow-up. These pregnancies which are induced, they have several fetal and neonatal parameters that are compromised. Even if we take all the rigorous attempt to exclude all the high-risk pregnancies, even that they have numerous fetal and neonatal parameters which are affected. There is no clear evidence to support the benefits of labor induction as far as short and long-term neonatal outcomes are considered. It is a very strong reason that we land up in iatrogenic prematurity, and we know that prematurity is again detrimental for short-term as well as long-term neonatal outcome, starting from transient tachypnea of newborn to the asthma of the baby. Then labor induction increases the use of cesarean delivery, and there is almost a revolt nowadays to cut down the cesarean section rate. Labor induction in women who have cesarean may increase the chances of repeat cesarean section and gradually increase the rates of morbidly adherent placentas. Then finally, we realize that there is no evidence clearly to support. Isolated oligohydramnios near term is associated with significantly high rate of medical interventions because of our anticipation and increased rates of cesarean section. It is also associated with several important adverse neonatal outcomes like low Apgar score or an ICU admission, even in the absence of any high-risk characteristic just because of our intervention. There is simply no evidence to support routine labor induction in this setting. But we require a high-quality data because we're aware that we have just one RCT. And then what can be done? Obviously, we need more RCTs. Can something be better than AFI? If we start relying more on the DVP, maybe we have less subjective variation and we have less cases where we feel that the likelihood is actually less. And of course, we need to have a vigilant fetal monitoring and frequent follow-up so that we are confident that we are monitoring the babies and so that we can take a daring decision to follow up with the
You have to wind up, Dr. Namrata. Okay, yeah, you have done. Right. Thank you so much, Dr. Namrata. Now, Dr. Japlin, what do you have to say? What Dr. Namrata has countered you. So we have 3 minutes for this discussion.
Yeah, ma'am. Can I share one of my slides again?
Yeah, please.
Excuse me, Dr. Jyoti. Was somebody supposed to say for the motion and somebody was supposed to say against the motion?
Yes, ma'am. One was, I think, for induction and the other was not inducing. It was like that.
So both have said the same thing, that they're not sure whether induction has to be done or cesarean has to be done.
So that is what they have
the motion or against the motion.
Yes, Dr.
Yes, ma'am. I'll just present my final slide. I'll just present my final slide. What the evidence says.
You can go ahead.
What the evidence says, when we don't have good evidence, we go to guidelines, and when we don't get good guidelines, sometimes we see the practice patterns. So the evidence, yes, in isolated oligo is associated with adverse perinatal outcomes. This is clear. And we know the challenges that we may not always be able to, everyone doesn't have the same expertise. When I am saying isolated, it may not be isolated. A good fetal medicine expert might find some congenital anomaly or might find some fetal growth restriction, which maybe I have missed. And possibility of underlying placental insufficiency as the cause of that oligo. क्योंकि कुछ तो कम हुआ, कुछ तो flow कम हुआ, that oligo developed the fetal urine decrease. Although still, yes, no, not the good. Evidence is not good enough to either support or refute. This was what the 2016 meta-analysis concluded. Then come the guidelines in 2019. The ACOG says that yes, you use the criteria of single deepest vertical pocket, and you do the IOL between 36 to 37 plus 6 weeks or later whenever you diagnose. And again, they say that you consider steroid. If you plan the delivery less than 37 weeks, then to decrease the chances of prematurity and associated problems, you can use steroids. And then coming to the practice patterns, we have seen that in 2009 also, the fetal medicine specialists, 221 respondents, they were in favor of induction, although they were not sure whether it improves or not. But still, in the Korean study in 2019 also, 70% were sure that yes, once you find isolated oligoamnios, you should induce, and 74% also saying that they firmly believe also that it decreases the prematurity, the adverse perinatal outcomes. And again, what ma'am has said, that labor induction per se increases cesarean rates, that's not true. Multiple analyses have now shown that if you have used good cervical ripening agents, you can easily reduce your cesarean rates, which you think are due to induction alone. Even this meta-analysis in 2016 said that the high induction rates alone were not responsible for the increased cesarean rates. And it was especially the ones due to the decreased, the non-reassuring fetal heart rate patterns. And actually the fetus must be compromised, which is leading to the cesarean rates and not the inductions per se. So over to you, Dr. Namrata.
Yes, I believe the evidences do have such recommendations, but at the same time, they also say that most of the studies are not following the DVP thing. Most of the studies are if AFI is taken into consideration, we need more data. Even the guideline has mentions along with the recommendations that still it is not, the level of evidence is not that good, and we need more RCTs.
Ma'am, my only question is that out of the 36 participants here, who all will not be doing induction for the isolated oligoamnios, the next patient that you see? Do we really have the heart to leave a patient like that at term? I'm talking about term.
So that is the debate, that induction does actually, we have to be very careful doing NSTs, Dopplers, and we have to have a good cervical ripening agent. Otherwise, the interventional or the cesarean section rates would definitely increase if
and
we
especially, ma'am, when it is near term. Especially when it is near term.
And in fact, both the evidences are telling us that the cesarean, the neonatal outcomes definitely is that there are adverse outcomes. Even Dr. Japlin, you have mentioned that, and Dr. Namrata also is mentioning that even if we wait, if we don't induce also, the outcomes increases, the adverse outcomes. So, ma'am, I think, can we go on to the...
I just want to add Dr. Jyoti, thank you very much, Dr. Jyoti, for these concluding remarks. I would request the next chairperson to please introduce the speakers.
Thank you, ma'am.
Right, thank you.
Good morning, everyone. I hereby welcome Dr. Ajay Agarwal to present his next lecture. And he is a laparoscopist, MD from PJ, and he is a diploma in relation. He was awarded Endoscopic Surgeon of the Year Award for 2019. Dr. Ajay, please.
Hello. Yeah, good morning, ma'am. Thank you for kind introduction, and I'm thankful to Vanita Suri ma'am for inviting me for the conference. And now I'm going to share about the abdominal surplus. So my topic of debate is about the abdominal surplus versus venous surplus.
Your slides are not visible, Ajay. Slides are not visible.
I started sharing it, ma'am. Already started sharing it.
Now it is visible.
Now it is visible?
Yeah, yes.
Yeah, fine. So I will just go through my slides very, very fast. Yeah, right. So see, cervical incompetence and mid-trimestral loss is a highly stressful condition for the patient, which lead to emotional breakdown. And moreover, the uncertainty about the future outcome because of the recurrence of the this incompetence makes it more and more difficult for the patient. Now, in the era of the uterine transplant, when we are already doing uterine transplant to achieve a baby, where minimum 4 laparotomies are required, like transplant surgery in donor recipient, IVF, LSCS, and then hysterectomy, we are still not talking about abdominal surclas because of the possible complications, which are roughly 2 to 3%. And but if we are well versed with the possible side effects and complications, considering the higher success rate of the abdominal surclas, I think we should give an option of abdominal surclas to the patient, like when we are giving option of the vaginal surclas. Now, 3 types of the surclas we already know. Now, this is the abdominal surclas, the point of the abdominal surclas, where we put the tape at the cervicoischemic junction. Now, according to the guideline, we talk about ACOG, RCOG, and Canadian Obsgynae Society. All of them, they agree on the indication of abdominal surclas about 2 things. One is when there is previously failed vaginal surclas. If you compare these patients for the next pregnancy, you put up abdominal surclas or vaginal surclas, abdominal surclas has higher success rate and better neonatal outcome. Second indication is when it is it is not possible to put a vaginal surclas in these kind of patients because of severely shortened cervix, maybe congenital or maybe after surgery like trachelectomy. Now, what is the advantage of abdominal surclas? Because it is put at the higher level, which is anatomically more correct, and the chances of infection is very less because the foreign body is not exposed in the vagina, and suture migration chances is very less. So that's why the results are better. Now, abdominal surclas, if we compare to the vaginal surclas, the only thing we have to go for cesarean section. It is technically more demanding, but you can learn it over the time period, and it is highly effective. It has higher success rate compared to vaginal surclas, and the best thing, it can be left in situ after cesarean section, and next pregnancy can be planned with same tape. We don't have to remove the tape and then again in the hope of the vaginal delivery, because vaginal delivery is possible after vaginal surclas. It is not always mandatory, because in the current scenario in primary gravida also the cesarean section rate is 15 to 25%. Now, world stat, 90% of the pregnancy are successful after abdominal surclas, and there is different kind of studies have already been done where the success rate of abdominal surclas is shown from 80 to 100%, but of the vaginal surclas almost 70 to 80%. Now, even in cases of previously failed vaginal surclas, there are different studies. Again, they show the better neonatal outcome, 6% versus 12%, and 10% versus 38% when we compare the abdominal surclas to the laparoscopic surclas. These are the adverse outcome I'm talking about. Positive outcome is approximately in 90% of the cases. Now, there is one of the biggest study having more than 600 patients with cervical insufficiency, where it was compared between the laparoscopic surclas interval and during pregnancy, similarly Shirodkar and McDonald stitch, and the outcome was that intraoperative blood loss, operative duration, and post-op hospital stay among different methods were comparable. Laparoscopic surclas showed better effectiveness in terms of total pregnancy week, term birth rate, and take-home baby rate, etc. Preconceptional or post-conception surclas seem to have no statistical significant difference, and preconception surgery is obviously better because it shortens the duration of post-op hospital stay significantly, and there is lesser complication rate. Now, gray areas where we still need to work is when we are talking about the persist pregnancy, like when patient has conceived after 10 years and then she has incompetence, or IVF pregnancy when patient has incompetence earlier and now again she is planning for embryo transfer. Considering her to be a case of incompetence, whether we would like to go for the best one, we will give her the option of abdominal surclas or not. So these are the gray area we need to discuss. Then there are the patient of PCOS patient who are at high risk of bad neonatal outcome because they are at high risk of developing incompetence. Then those cases we want to discuss where there is no cervical length left to put a vaginal tape. And so basically we have to individualize the treatment. It is not always about following the guideline only, that it has to be put only in previously failed vaginal surclas. Now, what are the major concern for abdominal surclas? Why we are reluctant to offer abdominal surclas to a patient? Because most of the gynecologists, like we are not having much of knowledge about abdominal surclas. Surgical training is compromised. We don't know how to counsel the patient. The most important part when you are talking about the surclas patient, you always have to confirm whether it is actually incompetence or it is associated with preterm labor. And then very important, how to handle the possible complications. Like we are having this thing in mind, if we put a abdominal tape, the fertility outcome will be compromised. We won't be able to do IVI or IVF embryo transfer, but it happens because menses, patient resume with menses normally. We are not, we are just applying a stitch. We are not obliterating the cavity. Then suction evacuation can be done up to 12 weeks of pregnancy easily. Then rupture of membrane, just in case happens, we have to counsel the patient, we have to open the tape, and then we have to deliver. Similarly, if there is fetal demise, again we have to open the tape. If there is preterm labor, we have to manage well in time, otherwise we will end up having bucket handle tear of the cervix or erosion or uterine rupture. So all these things we have to learn. Once we have learned it, your outcome of the abdominal cerclage will be almost 90 to 100%, because most of the complication, like 5 to 10% or 15% of the complication associated with abdominal cerclage, but because they were not well managed in time. So thanks a lot. That was all about my presentation. Hello.
Yeah, thank you, Dr. Agarwal. Thank you.
Thank you, ma'am.
I'll request Dr. Abha to please introduce Dr. Bhavna.
First, I'd like to thank the organizers for giving me this opportunity. And I'd like to invite Dr. Bhavna to speak. She is an assistant professor in the Department of Reproductive Medicine, IGMIS, Patna. And her major achievements are that she's in the quiz committee of FOGSI and POHES. She has some awards also, like National Scholarship Award and winner of Usha Krishna Award and Kiran Gupta Memorial Award. So I like Dr. Bhavna to go on with the topic of cervical incompetence. Whether she wants abdominal or vaginal, she has to stress on one of the mode of. You can put yourself on full screen.
Yes, ma'am. Thank you so much, ma'am, for the kind introduction. First of all, I pay my regard to all my teachers sitting there. Very good morning, ma'am. Today's topic of debate is cervical cerclage, whether to go for transabdominal or transvaginal, and I'm completely in favor of transvaginal. Now, not going into the details of cervical insufficiency definition, we know that the various indications are related to either history, ultrasound indicated cerclage, or rescue cerclage, as per the RCOG guidelines also. Now, question arises whether to go for abdominal one or vaginal. As per the RCOG GTG guideline number 60, vaginal cerclage has a number of benefits over abdominal cerclage. First of all, it is much simpler, so less surgically challenging and much easier to perform. It causes a much lesser morbidity to the patient, much lesser bleeding. It can be conducted as a daycare procedure, so less operative stay of the patient. There's no chances of injury to uterine artery and much easier to cut the suture also. Now, this was a recent study published in 2018, which analyzed the effectiveness of transvaginal cervical cerclage in singleton pregnancies. And the authors concluded that transvaginal cervical cerclage is definitely an effective and safe technique in prolonging the gestational age and improving the obstetric outcomes in pregnancies with cervical incompetence. Now, we know the types of vaginal surgeries, the McDonald and Shirodkar, so I'm not going into the details of it. The limitation where my friend Dr. Ajay pointed out the role of abdominal cerclage was that in cases of extensive cervical laceration where the cervical length left behind for vaginal cerclage, we go for transabdominal cerclage. And the other thing was in the failure of previous cases of vaginal cerclage. But even these can be taken care of by transvaginal route, because many of the studies in the literature is full of studies showing that there is an option of transvaginal cervicoisthmic cerclage placement by means of polypropylene tape or sling surgery. This was a study published in 2006, which showed that it can be considered as a very good alternative to a transabdominal cerclage with much less invasive technique and much lesser rate of complication. A similar study was published in 2011, in which it was seen that in the women who had previous failed McDonald cerclage as well as absent or very less portio vaginalis of the cervix were taken up for transvaginal cervicoisthmic cerclage placement, and it was found that the overall neonatal survival rate was as high as 94%, and the median gestational age of delivery was around 37 weeks. So why to go for transabdominal cerclage when we have a lesser invasive technique with much less operative morbidity, much less complication rate with similar results? So I am completely in favor of transvaginal. Now you can see this study was published in 2017 in European Journal of Obstetrics and Gynecology, in which fertility and pregnancy outcomes after transvaginal cervicoisthmic cerclage was compared, and it was seen that the neonatal survival rate was around 90 to 95%. And out of 33 patients who desired a second pregnancy, the cerclage was left behind, and 29 of those patients had spontaneous pregnancy. And then again, the neonatal survival rate was quite high, around 96 to 98%, which is much comparable to the abdominal cerclage. Because Dr. Ajay pointed out that one of the problem was that the cerclage has to be removed in transvaginal and replaced in the next pregnancy. This can be taken care of if we are placing a cervicoistomic suture through the transvaginal route. So the cervicoistomic cerclage by the technique of Fernandez can be considered instead of transabdominal, with much satisfactory results regarding the neonatal survival. Another similar study has been published in 2018 with the same results, that transvaginal cervicoistomic sutures are much effective for patients with history of recurrent pregnancy losses, even in cases of failure of previous cerclage. Now, this paper was published recently in 2017, which compared the transvaginal and transabdominal approach by a retrospective cohort study. And the authors concluded that both had a similar result as far as the efficacy is concerned, as far as the neonatal survival is concerned, as far as the mean gestational age is concerned. But the transvaginal has an edge because the cerclage has lesser morbidity and lesser complication rate as compared to transabdominal. So again, if you have a similar results with lesser complication, you will obviously go for transvaginal route. Now, Maverick trial states that it was the only randomized control trial which has compared the transabdominal and transvaginal cerclage, and people quote this usually for the more efficacious results of the transabdominal route. But in this, only 39 patients had transabdominal cerclage, 39 had the high vaginal cerclage, and 33 had low vaginal cerclage. It was found that rates of preterm delivery were much lower in women with transabdominal cerclage. But we are not seeing the several limitations of the Maverick trial. First of all, the number of patients recruited were too small to come to any valid conclusion about which route is better. Then the randomization was itself defective and biased, and as it was affected by the preferences and beliefs of the clinicians. So if the randomization is biased, the entire study's result goes into doubt. Accurate screening data was not collected, the trial was underpowered, and it was not able to analyze the complications related to transabdominal cerclage. So how can they conclude that transabdominal is better than transvaginal as far as the results are concerned? Now, what are the limitations of abdominal cerclage? Increased risk of bleeding, there is more chances of bladder and bowel injury, anesthesia-related complications. You are going for laparotomy or laparoscopy, both during the time of placement of cerclage and for removal. Moreover, you have to go for cesarean section once you place a transabdominal cerclage. So the rate of complication as quoted by the RCOG is as high as 3.4%, while for vaginal it quotes 0%. Moreover, abdominal cerclage can never be used as a rescue cerclage because you have to place either a preconceptional period or in the early gestation up to maximum 14 weeks. So in rescue cerclage, it has no role. It carries the added risk of intraoperative hemorrhage of damaging the uterine veins once you place the band between the bifurcation of uterine artery. And what if the patient goes into suffering with delayed miscarriage or fetal death? Then what option you are left with? Either you will go for hysterectomy, or you have to go for laparotomy or laparoscopy to again open the suture. You may land up into hysterectomy or cesarean section. Few surgeons say that they can open the suture via posterior colpotomy incision, which needs a lot of expertise, and there are high probability the uterine artery or vein may get lacerated during the procedure. So the take-home message is cervical cerclage should be preferred in recurrent mid-trimestral losses, but definitely vaginal cerclage is a better and much easier option with much lesser complication rate than abdominal cerclage. Abdominal cerclage has got very limited role, except in selected cases of extensive cervical surgery and previous failed vaginal cerclage. And here also we again have the option of the transvaginal route placement of cervicoistomic suture by means of polypropylene sling, which I have already mentioned. The literature is extensive literature is there, and still individualization of the management strategy as per patient's profile should be considered. Thank you.
Yeah, I think, thank you, Dr. Bhavna. Now, Dr. Ajay, you have to put up your points.
Yeah, ma'am, that was an excellent presentation by Dr. Bhavna. So I would like to highlight 2 or 3 points. One, I knew it that Madam will be mentioning about Merrily trial that done by Merrily et al. So it was about the comparison between the transvaginal versus transabdominal cervicoistomic suture. Now, if you go through the trial properly, it has a very, very big bias in the form of that abdominal circulars was done in maximum of the patient who were pregnant. It was pregnant circulars in the majority of the patient, trans-abdominal route. But in trans-isthmic, that through the vaginal route, it was majority of the patient were actually non-pregnant. So first thing was this. Second thing, in trans-abdominal circulars, I don't know what was their technique, but almost 20% of the patient, they had intrauterine demise within 3 days after the surgery. Even before the patient, all those patients, they got discharged from the hospital. So the outcome of the trans-abdominal versus trans-cervical, they have shown that 70% efficacy in both groups. Now, if you compare in those both groups, actually 20% had IUD in trans-abdominal group. So that is somehow ruled out. It is not a failure of the circular step. You have to understand the concept. It is not the failure of the circular step. It is failure of the technique. It could be vaginal or it could be abdominal also, because IUD was done, and they have already mentioned clearly in the end, in the conclusion, that it can be considered that abdominal circulars, our technique could be having some kind of fault. Second thing, they had laparotomy done in all of the cases. But now what we are doing is laparoscopy, that makes it much, much easier for the patient. Recovery is very fast. And obviously handling of the uterus and all organs are very, very less. Right. So second thing is about the timing. Madam mentioned rescue circulars cannot be done, and it is had to be done up to 14 weeks. There are enough data, enough YouTube videos, enough articles about this circulars, abdominal circulars have been done up to 20 week, even 24 week also. And rescue circulars, even in failed vaginal circulars in the current pregnancy, has also been tried with a good positive outcome.
Yeah, Dr. Bhavna.
Thank you, ma'am. Thank you, Dr. Ajay. Actually, you quoted only about the shortcoming of one comparison study between the transvaginal and the transabdominal cervicoisthmic sutures. But there are several studies, and in all of them, there was no such IUDs or something like that. I'm not quoting about the number of IUDs or what happened and the timing. But the point is, if you have you can do the same procedure by transvaginal route with much lesser complication rate, with much lesser surgical expertise. You're saying that no, it is very difficult. Oh, definitely everyone is not having that access to so much surgeries and the laparoscopic surgeries and laparoscopic abdominal circulars, and the rate of complication is definitely higher as compared to vaginal route. So if you can do the same procedure by vaginal route, why not to go for vaginal route? Because the rates of complications are less. Moreover, you were pointing out that the suture has to be removed and then again it has to be placed. This is one of the shortcoming of the vaginal route. But in this case, when you place a cervical isthmic suture, you can leave it behind if the patient desires a second pregnancy. So then again, the same advantage of the abdominal circulars. Advantages in vaginal circulars is much, much more than abdominal circulars. You have to agree about it. Only limited role which every guideline mentions is that when the portion of the cervical length is much less to place a suture from below. So then you can go for abdominal circulars, and laparoscopic abdominal circulars is still in its the studies are coming up, and the people have to get training and to learn the procedure and to avoid the complications. So why to go for so much? You may learn a new thing, but you do not have to forget the previous ways in which can tackle the same problem.
You have to win because you are here to fight out and आपको समझना पड़ेगा कि हाँ थोड़ा सा तो Dr. Bhavna has an edge over you.
See, cervicoisthmic circulars, if we talk about vaginally we talk
you
about.
Also mentioned about what is the best route for IVF pregnancy. See, I am into reproductive medicine. I'm doing IVF daily. So see, for IVF patient, if you are anticipating IVF pregnancy is not for previous multiple losses or previous mid-trimester losses. It is there is problem in conception. Then you go for IVF. You're not going for IVF for patients
and you went for IVF and then patient had cervical incontinence. There was no time to put a circular.
I agree. You feel that there is on ultrasound finding you have a decreased cervical length. You want to place a cervical circular. Why not to go for transvaginal?
Cervical length is not an
efficacy rate is almost similar. Sorry, Dr. Ajay, I won't agree on this.
Length is not a criteria to put a
You
tape.
have to give them more time, say maybe after inauguration to discuss all these things.
Yes. Ma'am,
So,
I request
both have
Dr.
put their points very well.
I should thank you all, ma'am. It was a great opportunity, and Ajay is my batchmate.
Yeah.
Yeah, so you
That's
can
why,
find
yeah.
out at a later stage now. Okay.
I wanted to say both of them are alumni of PGI, and
It is a proud privilege to be part of PGI again today and witness all my teachers witnessing the today's program. And I really pay my regard to all my teachers. You all have done a
Okay,
lot.
so
for
we
me.
can thank you. Thank you, both of you, Ajay and Bhavna. Now we can proceed to the third one.
Thank you, ma'am.
Thank you, ma'am.
So, we have
Yes,
Dr.
ma'am. Please introduce.
Seema Chopra, ma'am can introduce Dr. Venus if Dr. Seema is there. Otherwise,
Who is going to introduce?
ma'am, Dr. Seema Chopra is also the chairperson.
Okay, I can't see her. That is why I'm saying her. Okay.
Yeah.
Okay.
Yeah, ma'am, she's there, ma'am. She's there.
Okay.
No, ma'am can introduce. It's all right. She
Yeah.
was introducing her.
Yeah, ma'am. Please go ahead, ma'am.
Let ma'am introduce. Dr. Abha, please introduce.
No, Dr. Seema, you go ahead.
All right. Okay.
No, you go ahead. I already introduced one of them. Yeah.
Another point of debate is cesarean myomectomy. It is very tempting to go ahead with the surgery when this myomectomy during cesarean section, if you think it is coming into the incision line or it is a subserosal fibroid. But let us say what our speakers have to say about this. Dr. Venus Bansal, please.
Yeah, am I audible?
Yes, ma'am.
Yeah, good morning, everyone. First of all, I would like to say thank you to organizers of YUVAFOGSI for giving me this opportunity. So I will start my talk. I am going to speak in favor of cesarean myomectomy, and my colleague, Dr. Nidhi, is going to speak against it. So we will try to come to a conclusion in this YUVAFOGSI platform. We are what we repeatedly do, and excellence then is not an act but a habit. So slowly, I think we have to convert ourselves with an open mind and keeping an option of cesarean myomectomy, making it an excellence and slowly making it a habit. So the extent of problem is rising. It is rising because girls are planning their conceptions in a late age, and there is rising incidence of cesarean. So as cesareans are more, so cesarean myomectomy dilemmas are more. The incidences of myoma in pregnancy is 1.6 to 10.7% in different books and the data. And it is the most controversial issue that what to be done with it, because there is no consensus yet, there are no guidelines yet, and there has been certain meta-analysis, but no RCT yet. So in total, 10 to 30% of pregnancy develop some kind of complication, which is not a part of this particular debate today. Evidence is coming quite in favor of benefits of cesarean myomectomy. When we were the postgraduates, then we were told that, oh, we are doing a cesarean, never, ever touch the fibroid, it is going to bleed like anything. But things are changing now, the scenarios are changing now, and why they are changing, that is what we are going to see. The first question that one should ask to oneself while dealing with a cesarean patient having a fibroid is whether this patient is ever going to need a fibroid removal. And if the answer is yes, then we can proceed with how it can be done in the most beneficial way to the patient, and then we can avoid one more laparotomy later on in her life, laparotomy or laparoscopy. So there can be certain potential indications like pain, pelvic pain, myoma more than 5 centimeters, single myoma, anteriorly located, pedunculated, and degenerative, and it can be a patient desire per se. Potential contraindication, patient nearing menopause. Patient is having atonic PPH or atonic uterus during the cesarean section, multiple myomas. We can't reach all of them, posteriorly located, asymptomatic. Patient is having coagulopathy or there is a history of any uterine rupture. So we are going to take this history prior to taking up the call for the cesarean myomectomy. There has been meta-analysis done in 2013, 2017, and now the recent one is by journal pre-approved, that was done by Dr. Manu Goyal et al. In 2020. She's from AIMS. They have reviewed 249 studies, 17 were included in this particular study, and the analysis one done. So these are the parameters in which we are going to take pros as well as the cons. The fall in hemoglobin, need of blood transfusion, operative time, hospital stay, incidence of hemorrhage, and the post-operative complications. To my surprise, the mean change in hemoglobin was very less. It was only 0.2 gram per cent, which is less in cesarean section. However, it came out to be statistically significant with the random effect model as well as with the fixed effect model. But it was not clinically significant in both the models. So there was no clinically significant hemoglobin change in these cases in which cesarean myomectomy was planned. Recommendation grade, however, say it is a low grade evidence for the loss of hemoglobin or loss of blood. How we can tackle it? Like I have said that there are certain techniques that we can just do to avoid this whatever fall we are having. We can even reduce it further if we use intramyometrial carbetocin, if we use intramyometrial vasopressin, and we use tourniquet. We can use high dose of oxytocin, electrocautery. There can be certain suture technique like use sutures horizontally placed, or they can be baseball locking, or they can be a purse string sutures, that is myomectomy, which is done with the purse string sutures. So these are certain things that can help us to reduce this loss and should be in the training pattern of our postgraduate students and the people who are practicing, like practicing gynecologists, that if we plan to do it, what can we do to reduce this particular loss from the fibroid? Then we have to take a call on which route. Earlier, there was only one route which was thought of, that was serosal myomectomy, but now endometrial myomectomy is taking up, which is another way of taking out a fibroid, which has advantage that you don't need to give another hysterectomy scar. You do not need to suture the endometrium if it is less than 3 centimeter. And we can proceed with the same incision that we have even for the cesarean per se. Concern for these cases is the adhesions. In serosal myomectomy, adhesions are almost the same. Rather, I will say little less if the cesarean and the myomectomy are done in the different settings, because 2 laparotomies will be done then. And in the endometrial myomectomy, there has been the chapter which I'm going to refer here, in which saline infusion sonography was done. Saline infusion sonography was done after endometrial myomectomy. And it has shown that there was no adhesion after 40 days of endometrial myomectomy was done. Need of blood transfusion has a statistically significant increase, but it is same if we compare the cesarean alone and the myomectomy later on. If we combine and if we compare cesarean myomectomy, then it is not statistically significant that it is going to need a blood transfusion more than the cesarean alone patients. Whether a patient is going to need a cesarean myomectomy or the patient is not going to need a cesarean myomectomy, a large fibroid undergoing a cesarean, we are definitely going to alert our blood bank. So blood is anyway going to be ready for this patient as an obstetric training per se. The mean operative time was significantly more in the CM group because ultimately we are adding one surgery. But how we have to compare it? The time difference is much less than the time needed for the next laparotomy. So ultimately, time is in our favor. Blood loss we can tackle with the different techniques of usage. Blood transfusion is already needed in many cases in which there is a fibroid. So post-operative complications have come not very statistically significant in any of the meta-analysis that has been done when it was compared with the cesarean section alone group. Hospital stay, there was no statistically significant difference was found in the same. Future obstetric performance, future pregnancy outcome was not affected by the cesarean myomectomy, and it was in 2 more studies, that was in 2001 and 2008 by the authors as mentioned. So from my side, the take-home message is going to be that cesarean myomectomy provides the benefit of 2 surgery in 1 laparotomy, avoiding the risk of a repeated anesthesia and a repeat re-laparotomy. Medical options are very short-term treatment, so ultimately surgical treatment remains the mainstay. If the patient will be needing any time removal of that fibroid, cesarean myomectomy is not a bad idea, provided we are going to take a balanced decision for that. In low resource setting, it saves the cost of second surgery, and decision of myomectomy should be approached with caution by evaluating the numbers, the size, the approximation, the uterine incision, operative decision with the patient, hemoglobin, expected course of fibroid progression in the future life. Cesarean myomectomy is generally considered a safe in cases of anterior, as I have already put, but in the cases in which we find that it is posterior, but it will be needing, I think we should evaluate per on table, and I will be little pro towards removal of those fibroid if the patient is pre-operatively well worked up. So here what I wanted to add on is that if we have given the option to the patient pre-operatively, if we have prepared ourselves pre-operatively and the arrangements have been made accordingly, we can change the decision per-operatively from cesarean myomectomy to simple cesarean. But we usually are not able to convert from cesarean to cesarean myomectomy if it is not coming in the incision line. So always think pro to taking two surgeries together. If we will
Dr.
not be able to, then we can always take a call.
Dr. Venus, I think we will have to stop. We have to, because
yes, ma'am. My last slide, please. Science is cumulative, and the apprentice of the next generation can undo the master of the last. Thank you.
Thank you so much. Thank you. So can we quickly address Dr. Nidhi Bansal? So because already 11:30 we have the inauguration, and we have only 5-7 minutes for the speaker. So can I quickly introduce our next speaker, Dr. Nidhi Jindal, who's Assistant Professor, Department of Obs and Gynae, Shimla, Indira Gandhi Medical College, and she has various publications, a bronze medal in post-graduation, socially active, secured first rank in Indian Menopausal Society practitioner exams, and her field of interest is high risk. So over to Dr. Nidhi. Now you can start your screen share, and you have to exactly 7 minutes.
Okay, ma'am. Thank you so much, ma'am. First of all, my regards to my esteemed teachers, and this is actually a prestige for me to invite it as a faculty. So I will be discussing in short about cesarean myomectomy, when not to do actually. So coming fastly to the fibroids, all we know that the most common benign tumors of the uterus are fibroids, and prevalence as discussed by Dr. Venus, they can be as high as up to 10.7%. And this prevalence has seen a recent surge in recent years because of the delay in women's childbearing age, increased use of conception because of ART techniques, and definitely improvement of diagnostic techniques like resolution of ultrasound machines, which can pick up even the smaller fibroids during pregnancy also. So if we talk about the pattern of growth of these fibroids during pregnancy, this has been seen that majority of them, they exhibit a negligible change during pregnancy, while 20 to 30% they tend to increase during pregnancy, and even 8 to 27% they may even decrease also during pregnancy. Now, if we talk about their size, then large fibroids, that is more than 5 centimeters, they generally increase more in size, while small fibroids, they remain same in size. So what were the beliefs till date regarding cesarean myomectomy? Cesarean myomectomy, it was first described in literature by Bonis in 1914, and that was quite very early. But surprisingly, there was no mention of cesarean myomectomy in literature for over a century. In fact, it was discouraged in the literature. And the reasons for its discouragement were there was fear of intractable hemorrhage, need of peripartum hysterectomy, increased perioperative morbidity to the patient, and need of multiple transfusions. So now the confusion arises, what is the current scenario now? As discussed by Dr. Venus, that more and more studies are coming in favor of doing myomectomy at the time of cesarean, which is now a new concept. But the question arises, if it has to be done, does it need to be done in universally on all patients, or it is a total contraindication? Or there are any specific situations where we should not do it? So before we come to the deciding factors when not to do, all my fellow clinicians should know their Hippocratic dictum, that is primum non nocere. That is, first, let us not do any harm to the patient. That if we are not well versed with the surgery, we should not make any harm to the patient as a clinician. So deciding factors can be location, size, and number of fibroids. Their relation to the placental attachment is a very important deciding factor. Then relation to major vessels and other pelvic organs. Expertise of surgeon definitely remains the mainstay. Then institutional setup and availability of blood and blood products is also important. So if we discuss them in a bit of details, the fibroids like cervical, broad ligament fibroids, they have an increased chances of injury to ureter, bladder, and major vessels. As we all know that vasculature is very congested in pregnancy because of hormonal changes. So definitely the chances of bleeding increases. Cornal fibroids, they have a risk of intractable hemorrhage. We are always, being obstetrician, we are scared of cornal bleeding always. Then posteriorly located fibroids, we know that there are chances of more bleeding, as well as they are difficult to repair also. So I would like to bring a clinical scenario in your knowledge. This was a patient which was referred to us recently in labor 38 plus 2 weeks primary with a diagnosed case of cervical fibroid. So when we did the ultrasound, we found that it was a FIGO stage 5 fibroid in lower uterine segment and extending to cervix. Though the fibroid on picture doesn't look very big, but it was overriding bed of left-sided uterine artery, both descending and ascending branches. Then the HB of the women was 8.6 grams and she was in labor. So we decided not to go, the patient landed up in cesarean because of the indications, and we decided not to go for cesarean myomectomy because of the obvious reasons as seen in the picture. Then another concern is regarding abnormal presentation after cesarean myomectomy is area of concern, both in terms of location as well as myometrial invasion. It has been seen that there is increased risk of placenta previa and accreta after cesarean myomectomy. Then comes the assessment of scar quality, which we cannot do at the hysterectomy site if cesarean myomectomy has been done along with. And it is doubtful whether uterus is capable to withstand subsequent pregnancies and deliveries without problems related to muscle healing. Then myoma recurrence. This is another issue of concern, and I would like to bring to your notice that as we have discussed that myomas may also decrease in size. So small myomas at times they become indistinct due to hormonal changes during pregnancy, and we tend to miss them during cesarean myomectomy. After a few months, the women lands up with symptoms, and the entire exercise of doing cesarean myomectomy, taking so much of risk, giving transfusion remains futile, and you have to go for the second laparotomy. Akkad et al. In a publication in 2018, they have reported an incidence of 8.4% of recurrence after cases of cesarean myomectomy. So hemorrhage, as discussed earlier also, this remains a major risk, and the incidence has been reported in the literature as high as 35%. And this hemorrhage can further require reoperations, re-laparotomies, need of arterial embolizations or ligation, blood transfusion, and even postpartum hysterectomy, leading to increased perioperative morbidity of the lady. So from literature review, I could sum up that myoma size, if it is more than 5 centimeter, fetal weight, if it is more than 4 kgs, and maternal age, if it is more than 40 years. These are independent risk factors for the increased intraoperative bleeding during cesarean myomectomy because of various their underlying reasons, and complications as discussed by Dr. Venus also, these stays the same and definitely they occur. Intraoperative bleeding, postoperative fever, blood transfusion, and prolonged hospital stay are the early complications. We at times we have to put drains to the patients after cesarean myomectomy, so that is definitely going to increase prolonged hospital stay and postoperative fever also. Then late complications, adhesion formations, Asherman syndromes, abnormal placental insertions, and uterine ruptures in next pregnancy. Asherman syndrome can be a dreaded problem, and as Dr. Venus discussed that endometrial myomectomy is a new thing nowadays, but I would like to not to appreciate it much because it can lead to, Dr. Kriplani and all have published a paper in 2018, and they have actually condemned the technique because it can lead to high risk of Asherman syndrome because of compromise the quality of endometrium. So if I summarize from whole of the literature, my suggestion is this, that if a woman is having aged more than 40 years, she is having multiple myomas, or myomas are coronally located, posteriorly located, or cervical and broad ligament fibroids, asymptomatic, very small myomas, and a woman is having tendency to bleed, then we should avoid, in fact, we should not do cesarean myomectomy in such patients. So coming to the conclusion and the take home message, my message is this, that as we all know, there are no standard and established guidelines for indications and contraindications of cesarean myomectomy. So a clinician should himself or herself should decide and patient should be counseled accordingly. And to clarify this area more, we need more midterm and long-term trials in this area, and risk versus benefit of cesarean myomectomy should be re-evaluated. Thank you.
Yeah, thank you, Dr. V. 1 minute for Dr. Venus, please.
Yeah, I would like to just disagree on one point, that all the studies says that there is no much difference in the hospital stay and the post-op complication in the group in which cesarean myomectomy and the cesarean was done alone. Secondly, only one case in the last RCT was there in which re-laparotomy was done. Otherwise, most of the cases they stood the procedure very well. So definitely I agree with Dr. Nidhi, and I congratulate you for a very nice presentation. That cervical fibroid, broad ligament fibroid, we have to step back in such cases. But still, the take home will be consult the patient pro, tell them certain decisions will be on table. This is what I believe is going to be the take home message.
Right. Thank you so much. Dr. Smita ma'am, please conclude. Dr. Abha ma'am, Dr. Smita ma'am can say, and then Dr.
Very nice debates we had on all the three topics. So I think the take home message for all of us is that every patient has to be individualized. When there are controversies, there are no uniform rules. So every patient has to be individualized. We should see which patient will benefit from which procedure, whether it is putting a transabdominal cerclage or vaginal cerclage, whether it is doing a cesarean myomectomy or not to do it, or whether to induce a isolated oligo at term or not to induce. So every patient has to be individualized. That is where our experience, our expertise will come in, and everything should be discussed with patient beforehand. All the pros and cons, which all we have discussed in this session. So all this needs to be passed on to the patients. Nowadays, patients are the ones who take decision, ultimately. You have to tell them what are the advantages of this procedure, what are the disadvantages, and many a time they are also into our decision making. So I would say that thank you very much for having us here. It was an excellent session. All the speakers were very good. They did a lot of research work, and we really enjoyed it. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Thank you.
Thank you. It was a nice session, and our speakers, they had spoken very nicely. They had done their research, and expertise is required. And the younger lot should know that they should not take the decision on their own. They should show the patient or consult a senior person with them. And every surgery has their own complications. So they should know how to deal with the complications also before they go in for newer things which are coming up. So cesarean myomectomy, how many people have done? They may not have done. So don't start alone. You can take the help of your senior person, and then you can think about it. And choosing the patient, the indications is very, very important. So it should not be a blanket rule that any fibroid you have to remove it during cesarean section. Same thing is for other surgeries also. Thank you so much.
Thank you.
I know you are running
Thank
short
you
of
so
time.
much. Yeah, wonderful. It was absolutely amazing session. We on behalf of all the chairpersons, I would like to thank you, and would like to congratulate Vanita. Yeah,
all everybody on the screen.
Ma'am, it was amazing, amazing. Thank you so much for making us a part of it, and we are really proud of the North Zone YUVAFOGSI being part of it.
On the screen.
Thank you, ma'am.
Screen.
Thank you very much, ma'am. Dr. Jyoti, Dr. Sunita, Dr. Abha Singh, Dr. Seema. Good morning, Dr. Chandravati, ma'am. Good morning, Dr. Vanita Suri. Good morning, Dr. Umesh Jindal. Ma'am, sorry, we are just running short of time, but actually the hall B is running with the talk. So, I mean, we can just wait for some time. We're just waiting for the talk to end.
So that means we managed the time very nicely. The chairpersons of this.
We rushed.
I'm sorry, ma'am. I need to interrupt to some speakers, but I had to manage. But actually, the speaker who's in Hall B, he has joined internationally. So we just have to wait for 5 minutes. Thank you, ma'am. Thank you very much for waiting.
So, Dr. Sunita, you can also give your more comments.
We can keep on discussion also, ma'am. We can keep on discussion.
We can keep ourselves busy.
So now I think if Dr. Venus, we had interrupted her very.
Yes, Venus, you can continue.
In between, so.
Ma'am, I have also finished. That was my last slide only, but I can just repeat the take-home message because we have time here. So one thing that I would like to say is that we should be now, as the blanket cover earlier, we used to say that no fibroid should be touched during the cesarean. Now the dictum should be that assess, pre-inform, prepare pre-operatively, take the call during the surgery, see the number of the fibroid, see the site of the fibroid, see the approximation to the uterine incision, see the pre-operative discussion, look for the consents and detailed consents with the patient, pre-operative discussion, as Dr. Sunita ma'am has also said that at times, rather most of the times patient is equally involved in the discussion for these cases. Then see for the pre-operative hemoglobin, if we are operating on an already low HB patient, anemic patient, then it is not a good idea to add on to a removal of fibroid if it is not coming in our way. Then expectant course, if patient is nearing menopause, like as Dr. Nidhi has said that IVF is increasing, so 40 plus pregnancies are increasing, and she will go in a menopause in a quick while, and this fibroid is small. We may just leave it alone, because many fibroid, they are asymptomatic, and menopause is a cure factor. And surgical techniques should be told to the postgraduate, because we have learned it now over the time by attending the conferences, listening to other speakers, listening to the seniors, and now and so few we have created by ourselves. But now the surgical techniques and hemostatic options of cesarean myomectomy should be a part of a regular postgraduate training schedule. This is what only this line was left from my slide. That's all.
You were mentioning about intra-op use of vasopressin, syntocinon, and something. One more thing that you'd mentioned.
Oxytocin, ma'am, IV oxytocin and IV oxytocin
intramyometrial, what?
In the uterus oxytocin and the IV oxytocin. But tranexamic acid
How much
can also be given.
How much oxytocin? How much oxytocin?
Dr. Jyoti, you're saying something?
I was just asking the amount of oxytocin that you are injecting in the myometrium. Vasopressin and all, we understand the dilution and the amount.
There is the chapter that I have mentioned as a reference. In that, they have written that 5-unit diluted can be used directly in the myometrium. I am not using it. I have not personally used it. It was a reference only. We use a little higher dose, like 20 units, and we use in the IV, and we give it for next 24 hours. This is what we are doing. And another thing that we usually add is a tranexamic acid that we are giving the patient during the surgery, and then 24 hours post-operatively. These are the two most common things that we are doing for our patients.
Right. So we have Professor Dr. Chandravati ma'am also. I can see ma'am. Namaskar. And could we have your comments on if you have heard the debate, if you were there, if you on
part of it, I heard it, and at certain points I do agree, because taking a decision about myomectomy to cesarean needs to be very, very careful decision, and I don't think there is any hurry or there is need to embark on some things where you can be in problem. I will tell you, I was not a very experienced surgeon, and I was doing a cesarean, and there were 3 small fibroids, and I was tempted to take out those fibroids. This is what gave me a good lesson for my life, and I took out those fibroids. It was all right, but I could not stop the bleeding from those fibroid beds. In spite of all my efforts, all my stitches, every effort, at the end, my only alternative left was with me to do a hysterectomy. So that gave me a lesson that one has to be very, very careful. Sometimes it's got pedunculated. You feel that there's hardly any vessels crossing, and it's a big pedunculated fibroid. Easily you can take it out while doing cesarean. If it is in the anterior part of the uterus, somewhere easily you can take out. But to embark for surgery on difficult situations, as I heard, I do agree that we should be very, very careful and take decisions very carefully with all the facilities available for other improving the situations.
Excuse me, can seniors like Dr. Meenakshi and Dr. Abha can throw some light on this cesarean myomectomy, ma'am, like regarding your experience from PGI and all, ma'am? I mean, we have a long data from PGI, must be having, we must be having.
Dr. Chandravati, thank you very much.
PGI में तो बहुत करते हैं hysterectomy, अलका तो बहुत करती थी myomectomy cesarean के साथ. Yeah, but they have facility, 10 blood आ जाए, 12 blood आ जाए. You have all those facilities over there. You can easily do it. But most
no, ma'am. Actually, we do not have this practice to do cesarean myomectomy during cesarean. We do not have this routine protocol.
Yeah.
You are absolutely right. It should be a very careful decision, and maybe if the small fibroid coming into your incision line, that you can think of. Otherwise, it's a really
you to take it out. You can't do anything.
Yes, I fully agree with madam that it has to be a very careful decision, and unnecessary. You should not fiddle it out with this, because this fibroid may disappear also after the pregnancy.
No, they shrink in size.
Yes, yes.
Shrink in
I
size
fully
after
agree with ma'am. Ma'am, Dr. Abha Singh, yes, ma'am.
Yes. So as I was earlier saying also that this myomectomy during cesarean section is full of thorns. So you should not prick them unnecessarily. So if you earlier our dictum was don't touch the capsule of the fibroid because it is all avascular area, and if you touch the capsule, you may land up doing a myomectomy. So don't touch the capsule, be away from it. And after delivery, the size of the fibroids is likely to shrink. And if you require doing a myomectomy later on, you can do it after 6 weeks. There's no problem with that. Only thing is, you will again leave, say there were two fibroids, one was bigger in size, the other was smaller. So bigger you've removed, smaller you've left. And then there are chances that there will be recurrence of the fibroids. So again, you will say you've removed the myoma, but again, it has grown. So again, you should not touch the fibroid unless it is really essential. And you should have blood in hand, so many blood in hand, and you should inform the patient earlier before you take up the patient for cesarean that you may land up doing a myomectomy also during cesarean section, because as Dr. Chandravati rightly said that this patient may land up with instead of myomectomy into a hysterectomy, and then the patient will sue you that you had taken consent for doing a cesarean section, not a hysterectomy. So we have to be very careful with litigations these days also. Thank you.
Thank you.
Yes, sir. Yeah, Dr. Jyoti ma'am, please speak.
No, I was just saying that because we have heard this debate, we have many youngsters here logged in, and we have the PGs, postgraduates and things. So we should not feel that because we have debated that cesarean hysterectomy should be done, we start embarking on it. As Professor Chandravati ma'am has said, we have to be very, very careful. How many of us have removed and been assisted doing a cesarean myomectomy? So we cannot just take it very casually. So that is something very important that we have to keep in mind. Under guidance, when indicated, when we have taken a consent beforehand, when we have blood, then only, otherwise we can just leave it like that rather than putting ourselves into trouble. So that is it, I think.
Yeah, the most important thing is rather than directly embarking on the cesarean myomectomy, first thing that we should embark right now is the decision that it should be in the training schedule. Which one to look for, which one to remove. But yes, definitely we can go for it. But that is what we are saying, that pre-operative things, discussions, preparations, because we should be more well-versed. We will keep on doing it on daily basis. We will know which fibroid we can touch and which fibroid we have to.
And one more thing I would like to add, ma'am, a surgeon who is thinking of doing cesarean myomectomy, first he or she should be well versed with the interval myomectomies also, because even interval myomectomies, they demand expertise. So they should have done well number of myomectomies before going for cesarean myomectomies, if even they want to do so.
Nidhi, I would like to share an experience here since we have the time.
Yes,
I remember when I was a junior consultant, I was doing a elective cesarean section, although I was knowing that the fibroid is in the lower segment, but it was slightly on the laterally placed. So Dr. Sindar was also, supervising me. So I thought she was a young primary gravida. I thought it's better to go give a lower uterine incision. So I tried to put an incision. Try to not to go to give the incision over the fibroid, but still when I took out the baby, the incision was over the fibroid, and that cavity probably opened. Although we could do this cesarean, we could take out the baby and we could do suturing also, but finally probably the cavity was opened. We took out the fibroid also because it was already open, but it led to an infection so bad that it led to a fistula formation, and it was she has to undergo for a repeat surgery for that. Do you remember that?
I was senior resident in your unit only.
Oh, that's so nice of you. So why didn't you share that?
Ma'am, because I was in, I know, even remember, ma'am, I went for the file also, and Dr. Angren was with you as the primary surgeon.
I remember.
Jasneet, ma'am, patient's name was Jasneet. I remember her.
Actually, as Dr. Chandravati said, that was also a lesson to me that, I mean, if it is a lower segment fibroid, it's better to go upper segment. Don't try to be so.
Exactly, ma'am.
Okay, then,
Or you
I think we can finish off this session. Thank you very much. I think the chairperson of the next inauguration function has already logged in. Thank you very much, everyone. Ma'am, Dr. Chandravati, and please keep on video on.
Thank you.
Good morning and namaste to everyone gathered here today. It is with great pride that we welcome you all to North Zone YUVAFOGSI version 2020, being held under the aegis of Federation of Obstetricians of Gynecologists of India, FOGSI. We are immensely grateful to everyone who has accepted our invitation to be a part of this elite event. The theme of the conference is Optimizing Perinatal Health. It is our privilege to invite Dr. Vanita Suri ma'am, Chairperson, YUVAFOGSI 2020, to deliver the welcome address for the conference. Ma'am is Professor and Head of the Department of Obstetrics and Gynecology at PGI-MER, Chandigarh, an institute of national importance. She has been President, Obstetrics and Gynecological Society of Northern India during 2015 to 2016. She is President of the Association of Gynecologic Oncologists of India, the Chandigarh chapter. Ma'am has been Program Director for ICMR and WHO Collaborating Center. She heads many research projects. Ma'am, it is an honor for us to invite you for the welcome address.
Good morning to all. Today is a great day as we have gathered here to inaugurate the much-awaited event YUVAFOGSI North Zone version 2020 after wading through deep waters of COVID pandemic. A moment of unimaginable joy is what a mother feels when a newborn is placed in her arms. A joy every mother should have the right to experience. But for many pregnant women in India, this may not happen as the moment of birth is often frightening. It's estimated that approximately 46% of maternal deaths and over 40% stillbirths take place on the day of the delivery. Quality of care is increasingly recognized as a critical aspect of care around labor and delivery and in the immediate postnatal period. Keeping this in mind, the theme of our conference is Optimizing Perinatal Health. And who could be better than Dr. Vinod Paul as chief guest for this inaugural function, who's an eminent pediatrician and a strategic planner. Dr. Paul has been a member of the faculty at the AIIMS New Delhi and head of the Department of Pediatrics for several years. He is a full-time member in Niti Aayog, where he is in charge of the health and nutrition vertical. He has contributed towards formulating the Poshan Abhiyan and the Ayushman Bharat Yojana of the Government of India. He served as the chairman of the Board of Governors of the National Medical Council of India from 2018 to 2020. In the wake of the COVID-19 pandemic, Dr. Paul chairs the National Task Force on COVID-19 and the Empowered Group on Medical Emergency Management Plan. He also serves as chairman of the National Expert Group on Vaccine Administration for COVID-19. He is a member of the steering committee of Global Every Newborn Action Plan also. A well-known researcher and public health exponent, Dr. Paul has over 350 publications to his credit and is a recipient of the prestigious Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research by ICMR and Public Health Champions Award by WHO. Dr. Paul was conferred the prestigious Ehsan Dogramasi Family Health Foundation Prize at the World Health Assembly in 2018 in recognition of his service in the field of family health. Other than his professional achievements, his personal attributes like gentleness and simplicity are exemplary. So, ladies and gentlemen, here we have with us a brilliant academician and inspiring leader. I feel extreme joy and honor in welcoming you, sir, to this forum and would seek your blessings for this conference. PGI has been a collaborating center for WHO for more than 4 decades and has enjoyed special privilege of working on many projects from WHO, and we are grateful to this organization. One such project named Stillbirth Registry and Surveillance was initiated as a collaborative effort by WHO CRO and PGI Chandigarh in 2011. This area needed attention as we didn't have any data in spite of very high stillbirth rate. Dr. Neena Raina was instrumental in starting this project in a big way, and under her guidance, we are working on 7 offshoots of this subject. Not to forget, in terms of positive impact, this work has brought India on the global map. Dr. Raina, who is a PGI alumna, is working as Senior Advisor, Maternal, Newborn, Child, Adolescent Health and Aging at the WHO Regional Office for Southeast Asia. She has been working at the WHO for more than 2 decades. As a public health expert, she has worked in the areas of reproductive, maternal, newborn, child, and adolescent health, healthy aging, violence against women, and immunizations for the past 40 years. She has published about 200 articles. She is a trailblazer and a dynamic leader. In addition, she is a good friend and a very affectionate person. Dr. Neena, I feel immense pleasure in welcoming you as the guest of honor to this conference. The Federation of Obstetric and Gynecological Societies of India, FOGSI, is a professional organization representing practitioners of obstetrics and gynecology in India, with more than 200 member societies and over 25,000 individual members spread over the length and breadth of the country. I am overwhelmed with happiness and gratitude in welcoming the stalwarts of FOGSI, the President, Dr. Alpesh Gandhi, Vice President, Dr. Ragini Agarwal, and Secretary General, Dr. Jaydeep Tank. Dr. Alpesh Gandhi has been a practicing gynecologist for 27 years. He is a high-risk pregnancy expert, critical care in obstetrics expert, and hospital management expert. Dr. Gandhi is a resource person for preparing guidelines of establishment of obstetric, HTU, and ICUs for Government of India and for their operationalization also. His book on principles of critical care in obstetrics is available in more than 5,000 world-renowned medical libraries, published by an international publisher and translated in Chinese and Spanish language. He has received many awards and delivered countless orations. He has a magical gift of converting challenges into opportunities. Last year was the most challenging year for any organization, and Dr. Alpesh has left no stone unturned in bringing in a new culture of webinars that has revolutionized the existing system. He has been on his toes throughout his tenure and has taken FOGSI to new heights. I feel humbled and grateful in welcoming you to this forum, sir. Dr. Ragini Agarwal is the Clinical Director of Obstetrics and Gynecology and Minimal Access Surgery, Head Department of Cosmetic Gynecology and Pelvic Reconstructive Surgery at Pratiksha Hospital, Gurgaon, and she is Director of AA Derma Science and Dr. Ragini's Advanced Clinic for Women's Health. She is the founder president of many associations. Actually, it was Dr. Ragini who requested and inspired us to hold this conference and has been helping us unconditionally in organizing. Dr. Ragini, I express my thanks and welcome you to your own conference. No chair can function without a good secretary. Dr. Jaydeep Tank is the consultant, Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF, co-founder Esperanza Healthcare Private Limited, Program Director and member of board of Profert IVF. He is visiting consultant for IVF at 15 IVF centers. He has been an integral part of several technical advisory groups and committees of the Government of India. He was instrumental in drafting the proposal for FIGO, which has resulted in a grant of $13 million for a 10-country project. And he is the technical lead for this project. He is currently working on developing a proposal for a 6-country project on menstrual hygiene in Asian countries for the YUVAFOGSI. Dr. Jaydeep Tank, the Secretary General FOGSI, is a methodical person with orderly mind and sweet disposition. I extend my warm welcome to Dr. Jaydeep. I would like to extend my cheerful welcome to Dr. Umesh, our co-chairperson, and Dr. Subhash Saha, the organizing secretary. I would like to take this opportunity to thank my co-organizers, and faculty members for their immense help and support. गुरु गोबिंद दो खड़े काके लागू पाए, बलिहारी गुरु आपने जिस गोबिंद दियो मिलाए. We are incomplete without our teachers. YUVAFOGSI is a concept based on mentor-student relationship and combination of old wisdom and young energy for the advancement of knowledge and technology. This is a beautiful concept. I am deeply honored in welcoming all my esteemed teachers, seniors, and colleagues to this conference. Now is my turn to welcome the Yuvas of this group. I extend my hearty welcome to all the young doctors, young-looking doctors, and young at heart doctors. Students are our future torchbearers. I express my cordial welcome to the young, brilliant minds who will be next up to light the way forward. Ladies and gentlemen, I once again welcome each one of you and hope that these 3 days of knowledge sharing will empower you with the skills of a good doctor. Thank you.
यार होस्ट ने रोक. Thank you very much, ma'am, for your welcome address. It was full of warmth and gratitude. Now I would like to request Dr. Umesh Jindal, ma'am, Joint Chairperson, North Zone YUVAFOGSI 2020, to join us and deliver the welcome address for the conference. Ma'am is Founder Secretary for Greater Chandigarh Chapter of the Indian Fertility Society, IFS. She is a pioneer of ART in the region and is Director at Jindal IVF Chandigarh. She was Vice President of IFS for the years 2013 to 2015. She has held many important offices in regional and national societies. Ma'am has been organizing secretary in many large national conferences, ISAR 2007, Fertivision 2008, FertiProtect 2019, and Fertivision 2020. Ma'am, we request you to join us on the stage and introduce past President Dr. Nandita Palshetkar and President-elect Dr. Shanta Kumari. Over to you, ma'am.
Thank you, dear. Dr. Paul, Member Niti Aayog, Dr. Reina, Advisor Child and Adolescent Health WHO, Dr. Alpesh Gandhi, President FOGSI 2020, Dr. Ragini, Vice President North Zone, Dr. Jaideep Tang, Secretary General FOGSI, and my dear friend, Professor Vanita Suri and Professor Saha. I am very happy to be part of this YUVAFOGSI conference. I have been given a very pleasant duty to introduce two of my very good friends, Dr. Nandita and Dr. Shanta Kumari. Dr. Shanta Kumari, a very dynamic personality. She is President-elect FOGSI 2021, and we look forward to a forward-looking FOGSI under your guidance, ma'am. Senior Consultant Obs and Gynae and Laparoscopic Surgeon, Yashoda Hospitals, Hyderabad. She has been very active in FOGSI for many years, and she is a member of FIGO working group on VAW from 2015 to 2021. Currently, she is also still a member of working group. She was also chairperson of ICOG 2018, Secretary ICOG 2015 to 17, Vice President FOGSI in 2013, Secretary TCOG 2017 to 19, IH Managing Committee 15 to 19, and Chairperson FOGSI Committee from 8 to 10. She has received many awards, which include an honorary fellowship from the Royal College of UK in 2018, FRCPI from the Royal College of Physicians of Ireland, National Corresponding Editor of Jogi, and many Young Scientist Award and CL Javeri Award. She has been active in social fields also, and she initiated a project named Dhira, a socio-medical campaign to eliminate violence against women. Welcome, ma'am. And the Nandita, a very bubbly and very active president, FOGSI. She is a director of 9 Bloom IVF centers in India, and she's a professor of OB/GYN in DY Patil Medical College, Navi Mumbai. She was President Foxy in 1920 and still President of AMOGS 20 to 22. She has been past President of MOGS 2016, former President of IH in 17, former Vice President of ISAR in 2020, and former Chairman of MSIR in 16-18. She has also been awarded FRCOG honorary by the Royal College of the UK, and she has several books, more than 150 chapters, 60 orations, numerous achievements. She is a recipient of Bharat Gaurav Award at House of Commons in 2014, recipient of IMA Award for contributions towards medical field 2019, and recipient of IMA Empowered Women Award, Women Super Achiever Award in 2019, and recipient of Frost and Sullivan Best Practice Awards in IVF in 2030. I welcome you to the conference, Dr. Nandita, and your presence always makes sessions lively and very informative. Over to you, Rini.
Thank you, ma'am, for your very kind words. We are grateful to you for addressing us. Moving forward, India is a land of traditions, and in our tradition, it is believed that Goddess Saraswati endows humans with the powers of speech, wisdom, and learning. Ma Saraswati has 4 hands representing 4 aspects of human personality in learning, which are mind, intellect, alertness, and ego. To invoke her blessings, doctors from PGI-MER will be reciting Saraswati Vandana. I cordially invite Dr. Snigdha, Dr. Paromita, Dr. Shivani, and Dr. Aishwarya for the same. And I would like to invite all the folksy and ICOG office bearers to kindly join us for the Saraswati Vandana and lamp lighting ceremony. Thank you to the team for the very melodious and warm Saraswati Vandana. We just got a message that Dr. Vinod Paul sir won't be able to join us today due to an unavoidable urgent work, and he would be joining us later. Moving forwards, I would now like to invite on the dais Dr. Ragini Agarwal ma'am to say a few words with us. Ma'am is Vice President FOGSI 2020. She is founder Gurgaon Obs and Gynae Society, founder President Association of Obstetricians and Gynecologists of Haryana, founder President Elect Aesthetic and Regenerative Society India, founder Committee Chairperson Aesthetics Health of the Indian Menopause Society, President Indian Academy of the Cosmetic Dermatology and Gynecology. Apart from these, ma'am holds eminent positions in various obstetric and gynecological societies pan-India. Ma'am, please join us.
Hello. Hello.
Yes, ma'am.
Yeah.
Welcome, ma'am.
So, very good morning to all of you. Dignitaries on virtual dais and off the dais. With blessings of Mahakal, it is my proud privilege to welcome you all as Vice President in charge of North Zone YUVAFOGSI 2020, which has become 2021 as a virtual conference between 2 to 4 April for this academic feast organized by North India Society OBGYN under the Premier Academic Institute of India, Postgraduate Institute Chandigarh, under able guidance of Professor Suri and the great academician Dr. Umesh Jindal and team Dr. Saha and Dr. Bharti Joshi and others. I am thankful to FOGSI and our visionary president, Dr. Alpesh Gandhi, for giving me this opportunity to bring out.
Ma'am, could you please on your video?
Okay. To bring out this academic program to justify your precious time for all 3 days, the delegates and the faculty which has joined here, and we are all deliberating a very, very important topic, that is the perinatal optimization. We all know that our goal in the obstetrics is giving a good, healthy baby and healthy mother at the end. And this topic is very apt. Why I have chosen PGI, that PGI is a center from WHO, associated center for the stillbirth for many, many decades. And I'm very happy to see all the program which is given by the PGI Chandigarh and the Madam Suri and the renowned faculty. It is excellent. So I am very sure that all of you will take some pearl of wisdom which will help the society and our women for a good outcome. My all co-VPs, FOGSI office bearers, Dr. Shanta Kumari, incoming president, Dr. Nandita, immediate past president, ICOG, they are always there to bring the good academics and increase our work, good work with the society. So this conference is dedicated to all mothers and all fetus who are not able to get the justice. So in future, with this type of the deliberation, we are going to improve our outcome and having more of the happy mothers and the happy society. So with this word, I again welcome you all and thank you being with us for 3 days, making it as a grand success. Together, we can make a difference. Jai FOGSI, Jai Hind.
Thank you very much, ma'am. We are grateful to you for your kind words and your warm address. Now we invite Dr. Jaideep Tank Sir, Secretary General FOGSI 2020, to kindly join us and share a few words with us. Apart from his position as Secretary General FOGSI 2020, Sir has been immediate past President, Mumbai Obstetrics and Gynecological Society, MOGS, Chair, International Federation of Obstetrics and Gynecology, FIGO Committee for Safe Abortion, Deputy Secretary, Asia Oceania Federation of Obstetrics and Gynecology, AOFOG. Sir has been Chair, Publication and Newsletter Committee of the AOFOG, Chair Reproductive Endocrinology and Infertility Committee, AOFOG, ex-chairman MTP Committee, FOGSI, from 2004 to 2009. He has been Vice President, Forum for Enhancement of Quality in Healthcare. He was awarded FRCOG honoris causa in 2020 by the Royal College of Obstetricians and Gynecologists. Over to you, sir.
Thank you. Thank you very much for that very kind and generous introduction. And let me first begin, of course, by thanking the ONG Society of North India and all the wonderful organizers for taking all the efforts to put this conference together. I understand that it has been greatly supported by the Vice President in charge of the conference, Dr. Ragini Agarwal, and our very dynamic President, none other than Dr. Alpesh Gandhi. I'm delighted to see all the office bearers, past, present, incoming, outgoing, who have joined this inauguration. And I thank very much the organizers for putting all this together. I must mention the chairpersons, Dr. Vanita Suri and Dr. Umesh Jindal, the co-chairpersons, Dr. Alka Saigal, Dr. Mangla Dogra, the organizing secretary, Dr. Saha, the joint organizing secretary, Dr. Rashmi, Dr. Meenakshi, and Dr. Bharti Joshi, who has been coordinating personally with me for all kinds of issues. There is a very large executive committee for the conference, and I thank each and every one of them for putting this together. I very much appreciate the theme of the conference and the fact that the organizing committee has taken to heart the words Yuva, because if you will see the program, you will realize that indeed Yuvas form the bulk of the program, and that really is what the YUVAFOGSI conferences were devised for. So congratulations and all the best for the conferences. But I think this conference is already a huge success, and many, many congratulations to all of you. On behalf of FOGSI, particularly, I would very much like to thank you. You know, sometimes I wonder why people put in the hard work that they do to organize all these kind of conferences. We are all doing it on an honorary basis. And I think the only conclusion that I can draw is that people love FOGSI, people love their local societies, and they want to do something to demonstrate that love and affection they have, not only for FOGSI and their society, but also for women's health in their country. So thank you very much again, and I look forward to the rest of the proceedings. Thank you.
Thank you very much, sir. We are thankful to you for your kind and enlightening words. I would now kindly request Dr. Shanta Kumari ma'am, President-elect FOGSI 2021, to join us and say a few words with us. Ma'am is Senior Consultant OBGYN at Yashoda Hospitals, Hyderabad. She was Vice President of FOGSI in 2013, Chairperson FOGSI ICOG 2018, Secretary ICOG 2015 to 17, Member FIGO Group on VAW from 2015 to 2021, Vice President FOGSI 2013, Secretary TCOGS 2015 to 19, IAGE Member Committee Member 2015 to 19, and Chairperson MNNRC FOGSI Committee 2008 to 2010. She has been a recipient of many esteemed awards, including CL Jhaveri Award, Young Scientist Award, and FRCOG Honoris Causa by UK in 2018. Ma'am has been an instrumental person in organizing many national OBG conferences under the aegis of FOGSI. Ma'am, it is an honor for us to welcome you. Please join us.
Thank you very much. Dear friends and colleagues, it's indeed a pleasure to be here today with all of you. And I wish all the delegates who have joined, all the FOGSians who have joined this webinar, a very warm, happy good morning. I'm sure all of us were thinking that we have put behind us the pandemic last year and we were happy with the vaccinations. But we know now the situation demands that we take care of ourselves even now. So as our dynamic president, Dr. Alpesh Gandhi, had envisaged and themed safety for all FOGSians in 2020. So friends, it's still time that all of us adhere to the theme of FOGSI, safety first, of yourselves and then the patients. So please take care of yourselves, use masks, face shields in spite of being vaccinated when you're taking care of women's health. So I think we need to congratulate each and every member of FOGSI for the dynamic work you have done. It's because of the hard work put by each and every one of us that we have actually seen these days where the maternal mortality and morbidity has reduced tremendously, and we are still on the way forward. And let's hope that we will meet the SDG goal very soon. And Dr. Jaideep was very happily wondering why Foxians are very keen to do Foxy conferences. You're right, Jaideep. People look forward to being a part of Foxy by participating and organizing conferences that makes them feel a part of the organization. We have understood how much important it was to have this person-to-person contact when we missed meeting each other the last year because of the pandemic. And Foxy has kept itself very active in the academic front by organizing so many webinar, online conferences, and all the whole team, Dr. Alpesh and all the vice presidents, Dr. Ragini and the other 4 vice presidents of the administrative team, Dr. Jaideep, Tank, Dr. Madhuri, Suvarna, Parikshit, everyone have been very, very active. And we have seen that Foxy has organized tremendous number of online CMEs and webinars. And that has kept us actually together. And this year we were very fortunate that the last month we have witnessed the first physical hybrid congress of Dr. Alpesh, the Vizag YUVAFOGSI South Zone, organized by Dr. Radha and the team, which was a fantastic conference. We had about 600 people who had attended the Congress in person and more than 1100 people who had actually joined online. So congratulations, Dr. Alpesh and Dr. Radha, for the wonderful YUVAFOGSI South Zone. And when I was there, Jaideep and me, we felt so much alive. So I think, Jaideep, that gives you an answer why we are so crazy to do the conferences. We need to connect with each other. And this is a way forward. Let's hope that good times come back and we will be able to meet in person in the near future. And I wish all the delegates and happy, I think, learning or updating your skills, or more than that, it's a camaraderie and feel good factor when you are actually listening to so many good speakers and faculty. Thank you very much. Wish you all the best, Dr. Ragini and team.
Thank you very much, ma'am, for your inspiring and kind words. Now we kindly request Dr. Nandita Palshetkar, ma'am, to please join us and share her thoughts with us. Ma'am is Professor OBGYN at D.Y. Patil Medical College, Navi, Mumbai, and is an esteemed infertility expert, a director of multiple 9 Bloom IVF centers. Ma'am has been President Foxy 2019-20, President MOGS 2016, President IAG 2017, and Vice President ISA 2020. She is currently President EMOGS 2020 to 2022. Ma'am is an exceptional orator, having delivered more than 60 orations and more than 1,000 talks, and is a recipient of many, many esteemed awards. Ma'am, please join us.
Thank you. Thank you very much. At the onset, I really want to congratulate Alpesh, Ragini, Jaideep, Dr. Vanita, Umesh, and Dr. Saha. I think it's fantastic that you could actually conduct this North Zone YUVAFOGSI, and thank you for inviting me here. I think today the youth are really, really very, very important part of our being. They are mainly our workforce, our influencers, and this energy, I feel, needs to be properly channelized. In fact, last year as a Foxy president, I involved youth in every activity. I think the mentoring which we do for our young doctors, for even the adolescent girls, I think Alpesh has done a lot of programs for adolescent girls, and Foxy has focused on adolescent girls, and these adolescent girls actually become mothers. And this mentoring that we do to the youngsters is very, very important, because, when I was a young student, I was mentored, and today here I am. And that is what we need to do, is give equal opportunities to the youngsters and give them the skills to come up. And I think the Yuva is such a important part of our being. So what I personally believe, since this is a Yuva Congress, and I think I agree with Shanta and Jaideep and everybody, and that especially Ragini, she calls up every time and she says, you have to join. I love her enthusiasm. Is that we are missing the fellowship. We definitely are missing each other, and we want to be with each other. But I think this is a crisis. This this is the second wave that has come, and we need to remain safe. We need to tide over this crisis, and I'm sure we will get over it quickly. Our infrastructure is stretched to its limit, so we need to take care of that. And friends, I would just like to end by saying that we cannot build our future on the youth. What we need to do is we need to build our youth. And I think these are conferences, the YUVA conferences, where we focus on the youth, is something that gives us an opportunity to do that. So thank you very much, and all the best to everybody for a wonderful program. And thank you for inviting me here.
Thank you very much, ma'am. We are indebted to you for sharing your vision with us. I would now request Dr. Alpesh Gandhi, sir, to share a few words with us. Sir is President FOGSI 2020. He has been Vice President FOGSI 2013, Governing Council Member of ICOG 2016-17, Chairperson Practical Obstetric Committee FOGSI 2009 to 2011, Vice President of the Justosis India Chapter, past President Ahmedabad Obs and Gynae Society during 2007 to 2008 and 2003-2004, past Joint Convener and Treasurer of the SOJOG. He is National Coordinator, Emergency Obstetric Care, EMOC Program of the Government of India and FOGSI. Over to you, sir.
Thank you very much for the kind words, generous introduction. Today's chief guest, Dr. Vinod Paul, Member Niti Aayog, Guest of Honor, Dr. Neena, Senior Advisor WHO, Guest of Honor, very supporting, very kind Dr. Kansanta Kumari, Guest of Honor, always helping, smiling Dr. Nandita, Dr. Ragini Agrawal, Vice President, Northern YUVAFOGSI Conference, Chairperson, great teacher, Dr. Vanita Suri, Dr. Umesh Jindal, and Secretary, Dr. Saha, Dr. Bharti, and all the team members of Northern YUVAFOGSI Conference, dear delegates. At the beginning, I would like to congratulate the organizers of Northern YUVAFOGSI Conference for the excellent scientific program, for the hard work, for good number of registration, meticulous planning, prestigious institute, as Dr. Ragini has mentioned, PGI Chandigarh is always well known for its high standard of academics. So I congratulate all of you to continue the high standard of academics in this conference and for the great teamwork. Pregnancy is a time of great happiness and joy for all expectant parents. Experiencing a stillbirth or a death of a baby or a preterm delivery in the final stage of pregnancy or during labor or soon after delivery is a silent tragedy for mothers, fathers, and families. It is estimated that 2.7 million neonatal deaths and 2.6 million stillbirths every year across the world. And India is one of the countries having highest incidence of stillbirth. Most of these losses are preventable with high quality, evidence-based intervention, delivered before and during pregnancy, during labor and childbirth, and in the crucial hours and days after birth. It is said that 46% of maternal mortality and neonatal mortality occurs during labor or immediately after labor, in the labor room or immediately after labor. Most stillbirths and half of the neonatal deaths do not receive a birth certificate or are not registered. By counting the number of stillbirths, neonatal deaths, gathering information on where and why these deaths occurred, and also by trying to understand the underlying contributing causes and avoidable factors. Healthcare providers and policymakers can help to prevent future deaths and grief for parents. Nothing is as frightening or heartbreaking for a new mother than watching a baby in a glass incubator, connected to multiple tubes and wires, all because it was born too soon. A low birth weight baby provides an unrivaled challenge to the best of neonatologists to try to have it not just survive but also thrive. Again, preterm birth is the leading cause of neonatal death and death for children below 5 years of age worldwide. But again, unfortunately, India is having the highest number of preterm birth in the world with 3.5 million preterm births. 3/4 of these deaths could be prevented with current cost-effective interventions. Simple measures like steroid given to mothers likely to deliver preterm baby, early initiation of breastfeeding. It is said only 50% of mothers give breastfeeding in first hour after delivery. So early initiation of breastfeeding, kangaroo care can be very helpful and can save many neonatal deaths. As obstetricians, we have a chance to prevent this heartbreak, predicting patients who are at the risk of preterm or IUGR babies, observing minutely for the subtle early signs that can be reversed in time, counseling the patients so that the importance of these early measures is understood and compliance is achieved, managing cases that have already crossed beyond the early stages, and then bringing these fetuses safely to term. This is the essence of the management of an preterm baby, low birth weight baby, and this is what this conference aims to tackle. The theme for this conference is optimizing perinatal health. There are 3 principles of success: hard work, perseverance, and importantly, teamwork. Because no one gets there alone, no one knows this better than us physicians, who constantly rely on a team of dedicated professionals to achieve successful outcomes. And for this, the trilogy of obstetrician, ultrasonologist, and neonatologist, pediatricians are the ones that come together often in the management of a pregnant patient all the way through to delivery. We are working as one unit for the project Milan and for the project Lux capacity building MOU of FOGSI with UNICEF. FOGSI's courses on critical care in obstetrics recognized by a few reputed universities. Our country has now more than 300 obstetric HDU and ICU, and within a year or two, we will have 500 obstetric HDU and ICU. Now, this HDU ICU need expert who can run this obstetric HDU ICU, and therefore we need a course, fellowship course on critical care in obstetrics. Being a prestigious premium institute, I request PGI Chandigarh to start the FOGSI recognized fellowship course if possible on critical care in obstetrics. 4 or 5 universities across India have already joined this course and started this course. It is said that knowledge share is knowledge squared. The unique conference is an attempt to do just that, so that at the end of the day, we together are able to give a mother a healthy outcome of a pregnancy with safe motherhood and healthy baby. It is time to make every baby count and prevent future tragedies by learning from and effectively responding to preventable deaths. We wish to start FOGSI's registry on stillbirth, and we wish to publish advocacy statements on perinatal asphyxia and preventable neonatal deaths. At present, we are working on FOGSI's registry on stillbirth, and it is nearly ready. This year, the theme of FOGSI is safety first for Indian women and FOGSians. And I once again congratulate North Zone YUVAFOGSI organizers for working for this theme. I also would like to thank all of you for working this theme during this critical time, difficult time, uncertain time of COVID-19, and continuing good academic work good social work, and continuing essential health services. Uh, as Dr. Santa Kumari and Dr. Nandita has mentioned, this is the second wave, and we all are very much worried for the safety of all of you. Please take vaccination. I hope by this time all of you must have vaccinated, but if you have not taken it, please take it. Please take care of yourself, your staff, your family members. We wish safety to all of you, and once again, I congratulate North Zone YUVAFOGSI organizers for this excellent conference and excellent execution and good gathering. I wish all of you happy learning. Once again, I wish safety to all of you. Thank you very much for giving me this opportunity of sharing my views. Thank you.
Thank you, sir, for the very enlightening address. Thank you for sparing your valuable time for us. I would like to request Dr. Neena Raina ma'am to kindly join us and share her words with us. Ma'am is Senior Advisor, Maternal, Newborn, Child, Adolescent Health and Aging at WHO Regional Office for Southeast Asia. She has worked in WHO as Coordinator Health Through Life and course and Regional Advisor, Child and Adolescent Health and Development. She has been working in WHO for the last 22 years. Please join us, ma'am.
Good afternoon, namaste everyone, and I bring greetings from WHO Regional Office for Southeast Asia region. Dr. Vinita Suri, who is a friend as well as a very dynamic person who has not only taken as a WHO Collaborating Center many roles, but also has organized this meeting. When I heard this, title, Foxy Yuva, because Dr. Alpesh Gandhi, who is here, welcome sir, has done so much of work in adolescent health. I thought it is related to adolescent health. But when I realized that it is for the young people, who are Foxy members, it's a very innovative idea. Congratulations to all of you who have really put it all together. I'll also like to welcome Dr. Ragini Agarwal, Dr. Jaideep Tank, Dr. Umesh Chindal, Dr. Saha, Dr. Shanta, Dr. Nandita. I see stalwarts here. I'm missing Dr. Vinod Paul, who is not only a big champion of perinatal health. I remember that to bring newborn health and perinatal health on the global scene, not only in India, he has really played a very important role. And I thought that he'll be here today to listen to all of you, to be able to really put some policy changes, because he's in that position. But I'm sure that you will be sharing the recordings and the gist of this with him so that a lot can be done. I see the, stillbirth, as Dr. Alpesh mentioned, anyone who really becomes pregnant looks forward to a healthy baby. Either it ends up, it ends up as a stillborn, or a mother loses within the first week or the first month. And we know that now, out of the total under 5 mortality, the major contribution is coming from neonatal mortality. Or she ends up with the birth defects. And I think as WHO Collaborating Center, under the able leadership of Dr. Vinita Suri and Dr. Neelam Agarwal, Dr. Bharti Joshi, Dr. Bharti Sharma, they have established a wonderful stillbirth registry. It's a surveillance, it's an active web-based surveillance. And we have 2 coordinating centers in India, PGI as well as Safdarjung Hospital, which has taken Delhi hospitals, and PGI has taken a lot of hospitals from North India. We want to expand, and we have been able to expand it to other countries with the help of our WHO Collaborating Center in PGI. They also monitor quality. So I see that a good start has been made, but perinatal health, which is the theme, optimizing perinatal health of this conference, has never been so much of importance because it has always fallen in between the cracks. Stillbirth is the responsibility of OBGY, and early neonatal death, which is the first 7 days, is the responsibility of the pediatrician. The moment the baby is delivered, if it is alive, kicking, it's handed over. And then it's the responsibility of the pediatrician. And I see that this perinatal health, which you have taken as a theme, brings it all together. I like to highlight some very disturbing figures. Globally, we lose 2 million, which is 20 lakhs babies to being born as stillbirth. We lose similar numbers to neonatal deaths. There has been a very drastic reductions in mortality, especially newborn mortality, 62% reduction in Southeast Asia region. But then stillbirth rate of reduction has been slow. And if you look at the sustainable development goals, you will see that stillbirth target is not there for 2030. We have newborn mortality reduction target of less than 12 per 1,000 live births, but we do not have a stillbirth reduction target. But let's not be disheartened with it. We have a stillbirth reduction target as part of the Every Newborn Action Plan and UN Secretary General's Global Strategy on Every Woman, Child and Adolescents. And there also it is less than 12 per 1,000 births. In India and in many countries, we are far from it. But something which is very interesting, that 6 countries of our Southeast Asia region out of 11 have already achieved a stillbirth reduction target. And there are 5 countries which have achieved already before 2030, they have achieved the newborn mortality reduction target. So what I want to bring home the point that it's doable. We can do it. We are losing, and we are now. I pose couple of challenges. As WHO defines, early stillbirth is 22 weeks of gestation. If that is not available, birth weight of 500 grams, length of less than or equal, more than or equal 25 centimeters, and then it is late stillbirth, which is 28 weeks of gestation. And we did, a kind of a survey to really find out what is the situation in most of the countries of our region. And it's interesting that many countries, every country is defining stillbirth cutoff point differently. So I think the first major challenge for all of us when we report on stillbirth is that how do we define stillbirth? Do we take 20 weeks? Do we take 22 weeks? Do we take 24 weeks? Do we take 28 weeks? And I think for standardization, for late stillbirths, I think 22 weeks some countries have taken and 28 weeks other countries have taken. So I think first is when we think of counting. So the first challenge is these numbers are not counted. The second is when they are counted, everybody is using different definitions. So we can't really compare apples with pears, and we can't really say that how much is the burden of the problem. So it's unheard, hidden tragedy, which is happening across most of the countries of our region, which is not even getting fully reported. So this is where we are in terms of the magnitude. Now, the second is, when does it happen? Is it intrapartum? Is it antepartum? And we know that in India, 59% of the still, which is almost 60%, are intrapartum deaths. It intrigues me most of the time that if a woman has already gone to a hospital, there is no reason that she should be losing her baby. And we see that our surveillance, which is a web-based surveillance as part of our newborn birth defect surveillance, the stillbirth surveillance, the platform which we have created, where most of the countries are reporting data, we find that most of the stillbirths are happening during intrapartum period across. Then the next lot of debate happens on fresh stillbirth versus macerated stillbirth. So that's another issue which comes in when we are defining the stillbirths in different parts. So we know how much is the magnitude, I would say approximately. What we are seeing is the tip of the iceberg, because most of the stillbirths don't get reported. We know when they happen, and we also understand why they happen. And now we have ICD-10 classification, which is very, very clear. which takes into account different maternal factors as well as neonatal factors or fetal factors into consideration. And in PGI as well as in other places where there are about 20 hospitals in India which are doing good quality surveillance of stillbirth, which is hospital-based surveillance, active surveillance, where they're clearly telling us, yes, there are, they're using ICD-PM for classification. So where do these stillbirths happen? In India, I think the deliveries have now got to 78% institutional delivery. And it really bothers me because, for example, another country, Indonesia, where deliveries have increased, but the proportionate decline in mortality has not happened. So equity, mother's age, education, geographical, urban versus rural, poor versus rich, all these factors, equity issues are definitely there. So we need to map, we need to count, we need to map where are these happening, where are the pockets where maximum number of stillbirths and early neonatal deaths are happening, which is less than a week, if we want to really address this issue. We know that there are evidence-based interventions which exist. WHO has really provided the list of evidence-based interventions which can be used during intrapartum, antepartum period, and their calculated effect also is available, but the coverage is very low. If you have evidence-based intervention, like antenatal care, 4 visits is only 51%. Half of the women are not even getting to 4 visits, whereas 2016 WHO came up with the recommendation that it should be 8 visits because there is now very strong evidence that it is the last trimester where the quality of antenatal care is extremely important. And that's where we lose. Women just don't even notice that there is the fetus is not moving, there is antepartum death. And they come to the hospital very late. And there's very little that all of you can do about it. So we need to really see that most of the countries, including India, have already put this evidence-based intervention as part of their package, antenatal care, intrapartum, and so on. But the coverages are very, very dismal. And I think unless we get to the 90% coverage, we'll not see the impact of these interventions. So what can we do all together, Foxy, UVA, and IC, because most of the young leaders, the future leaders of Foxy are connected. So what can we do? I think, first of all, raise voice, create awareness, advocate for it. Your voice is heard. And I think not only Foxy, but every country where there are OBGY societies, including South Asia Federation, Asia Pacific Federation, your voices are very strong and they are heard by the ministry, they are heard by the policymakers. Raise voice, create awareness, advocate. My second message is you can only do advocacy and you can raise voice and create awareness if you have numbers right. And my second request is that please count the numbers and report. I think measurement is extremely important. There is a lot now. Neonatal mortality has been reported. There was time when me and Dr. Vinod Paul in early 1980s were working together to raise awareness on. We always used to say M is big, C is small as part of MCH program of Government of India. And then we started within the C, newborn is missing. So I think we have been able to get to the stage where neonatal mortality rate has been started to be reported for the last almost more than a decade. But stillbirth doesn't come. So I think count numbers, measure. If you don't measure, it doesn't get done. Nobody will believe you if you have not systematically counted the numbers and also investigated these stillbirths to get to the cause. And you can demand health system strengthening. The third, I would say my message would be support bereavement care. I think normally for us, at times, these just remain numbers. We say 2 million, 100,000, 300,000. But for a mother or for a parent, for a family who have lost a baby, either as a newborn, early newborn death, or as a stillbirth, is a big, big challenge, is a big problem. They go through a lot of grief, and I think that's the time we need to support them. And we know by evidence that after the stillbirth or early newborn death, the woman becomes pregnant very, very soon because she really wants to get over that grief. So I think bereavement care is extremely important. That's where PGI, Dr. Neelam, under the guidance of Dr. Vinita and Dr. Bharti, have done wonderful work on bereavement care. Strengthen health system. And I said, if you don't count, you don't get to the cause, why it happened, what was missing. You can't really ask for strengthening of the health system. And I would say essential newborn care, preterm care, intrapartum care, emergency obstetric care all are very, very important issues to address. Equity, we need to map what are the pockets. It can't be one size fit all. We need to really define within India which are the pockets which are contributing to the maximum numbers, which are the states, and within the states, what are the districts which are contributing to maximum number of stillbirths and early newborn deaths, and address those and put in more resources there rather than giving equal amount of resources to everyone where problem is not so grave. And lastly, I would like to say that quality of care matters a lot. And I would say point of care quality improvement is extremely important. We have trained large number of people as WHO, and recently we have finished a training of, now there are about 100 people who have been trained across countries on maternal death surveillance and response, and there is a guidance on perinatal death surveillance and response. Surveillance is active surveillance, and response comes what to do. And in response, I think quality of care is extremely important. We may get to the numbers, okay, 51% are getting antenatal care, but the quality of antenatal care, if that is not good, we are not going to see any change in the outcomes, even if we get to 90% coverage. There are 3 countries already, Maldives, Sri Lanka, Bhutan, who have already get to the decided and they are implementing 8 antenatal care visits. So let's not get to the numbers. I think it's very, very important that numbers are increased to 8 at a policy level. And there is enough evidence to state that India has not done. And you can, sort of be a good advocate for it. So to improve the quality of care and also the quantity, the number of antenatal care visits. There are places in urban areas amongst the elite. It get to even 15, 20 visits. But when, when we get to the rural areas, the woman has not even got one antenatal care visit. So, or a contact. So I think that's very, very important for us. So I would like to say that join hands. This is an excellent initiative. This kind of opportunity will not come again. This is the time that we need to really focus on getting all the people together to advocate for stillbirths and early neonatal deaths to optimize perinatal health. And most importantly, now that is a COVID time, Dr. Alpesh, under your guidance and leadership, we did work together on COVID in pregnancy. And there are many hospitals in India which are reporting on a regular basis. So there is a lot of things. And COVID, I think there is a very clear modeling and estimates which have been done. Because of this disruption of services, the indirect impact of COVID on survival of women, children, newborn have been greatly impacted. The number of deaths are going to increase. The gains which we made during Millennium Development Goals, and I saw that the countries were on track to get to Sustainable Development Goals of 2030, and I was very hopeful for India. But I think COVID has pulled us back by another 3-4 years. So I think we need to really make sure that the disruption in services is low. The access to services is given to women to prevent stillbirths. And believe in me, stillbirths have also increased during COVID time. This year, 2021, COVID is still not going to leave us. So we need to really make sure how do we reduce deaths, how do we reduce the indirect impact of COVID as well. I would like to again thank Dr. Vinita Suri, Dr. Alpesh, Dr. Ragini, Dr. Jindal, Dr. Shanta, who is going to take the torch ahead, Dr. Nandita, Dr. Saha, and of course, I'm missing, Dr. Paul, a great deal. I'm sure that under your leadership, you people have not only in perinatal health, but many other areas you have taken the lead. And now cervical cancer, again, our WHO Collaborating Center of Dr. Vinita Suri has trained large number of people from different countries. They used to come, I think those were the wonderful times in 2019 and 2018. They all used to come from different countries and went back with lots of praises for this center where the hands-on colposcopic trainings were given. And we are looking for our other WHO Collaborating Center. We have some funds available to be able to do HPV testing. So there's a lot of work which we can do together with FOGSI. And I look forward, I think this is a wonderful collaboration we have. There is not a single meeting of WHO CERO which I organize where FOGSI is not invited. And other OBGY, professional associations are not invited, because I have a great faith and trust that you people are the real advocate and the champions who can do wonders. And with that, I would like to thank all of you and wish you all the best with this wonderful conference. Thank you.
Thank you, Dr. Nina. Thank you, Dr. Nina, for appreciating FOGSI, for keeping faith in FOGSI, and for keeping FOGSI always in all your programs and meetings. Thank you very much for your concern for the stillbirths, and thank you very much for your clear message, 3-4 message for all of us and for YUVA as the guest of honor. As you have mentioned regarding YUVAFOGSI, I am happy to inform you that we have every year 4 YUVAFOGSI, one in each zone since last 20 years, where we invite more and more YUVA gynecologists, obstetricians to take the lead and as a faculty. And this year, just 2 weeks before, we had a wonderful, successful YUVAFOGSI conference at Visakhapatnam under the able leadership of our Vice President, Dr. Ramani Devi. And this again, one more successful YUVAFOGSI under the able leadership of Dr. Ragini Agrawal, where with the efforts of Dr. Vinita, Dr. Umesh, Dr. Saha, and Dr. Ragini, we can see a good number of YUVA delegates and YUVA faculties. So really, I would congratulate Dr. Ragini once again, Dr. Vanita, Dr. Umesh, Dr. Saha, and always Dr. Jaideep is there to see whether YUVAFOGSI are as per the protocols following, whether there is a good number of involvement of YUVA is there or not. So thank you, Dr. Jaideep. All the office bearers are working very hard for this YUVAFOGSI conferences, and I am sure in future we have 2 more YUVAFOGSI remaining, that is in East Zone and West Zone. And again, our Vice President will guide our organizers. So once again, thank you very much for your message and joining, and for your time as the guest of honor. Thank you very much.
Thank you, sir. Thank you, ma'am. I would now request Dr. Subhash Chandra Saha, sir, Organizing Secretary, YUVAFOGSI 2020, to deliver the vote of thanks. Sir is Professor, Department of Obstetrics and Gynecology at PGI-MER, Chandigarh. He is Secretary of Obstetrics and Gynecological Society of North India since 2018. He has been a recipient of many awards, including Indumati Jhaveri Prize. He was awarded the National Scholarship in 1976. He is a renowned expert in high-risk pregnancy and clinical RH immunized pregnancy. Welcome, sir.
Thank you, Dr. Rini. Respected guests of honor, FOGSI stalwarts, teachers, colleagues, and my students. It's my proud privilege to propose vote of thanks and express our gratitude on behalf of the organizing committee. We are extremely sorry and regret that our esteemed chief guest, Dr. Vinod Kumar Paul, could not attend at this moment, but he has left a message that he will be delivering his message sometime, anytime soon. We are proud to have Dr. Nina Raina, Senior Advisor from WHO, and we are all aware of her passion for maternal and child health. And our 3 important messages, that's what I gathered One is channelize the energy to reduce parental mortality urgently, improve the bereavement care, quality of care, and obviously to improve emergency obstetric services. I think these messages will leave an indelible impression on all young minds. We are very privileged to have with us stalwarts of YUVAFOGSI, present, past, and future. The present President, Dr. Alpesh Gandhi, Vice President, Dr. Ragini Agarwal, Secretary General, Dr. Jaideep Tank, Dr. Nandita Palsetkar, our past YUVAFOGSI President, Dr. Santa Kumari, our future President. We are all very happy to have you here at this moment, ma'am. Years after years, the leadership of YUVAFOGSI, through their untiring and selfless work, has strived to improve the obstetric and gynecological services in India. The leadership, even at this difficult time, will remain as a source of great inspiration for all of us. Now, I think Dr. Alpesh Gandhi has left one important message, that is starting critical care in PGI. I think that's a very important suggestion. Now, holding this conference against all odds at this difficult time was a part of our goal to improve the obstetric and gynecological services all over India. And leadership of YUVAFOGSI, since the inception of this conference, was always supportive and guided us with the timely advices. We thank all of our YUVAFOGSI bearers, especially Dr. Alpesh Gandhi and his team from bottom of my heart. Now, I come to two important pillars of this organizing committee, Professor Vanitha Suri and Dr. Umesh Jindal, for whom tons of thanks will be found wanting. Dr. Vanitha was there everywhere with a sharp acumen and years of experience, planning the scientific content, suggesting speakers, contacting people, and galvanizing the whole support staff into action and bringing this conference to a success. Dr. Umesh Jindal, in spite of being a very busy practitioner, was always there with a practical wisdom to guide us. Now, this conference is for young budding gynecologists, and you'll be happy to know that our young faculty colleagues, Dr. Bharti Joshi, Dr. Bharti Sharma, Dr. Pooja, Dr. Ashima, Dr. Sujata, Dr. Manisha, Dr. Snigdha, along with all junior and senior students, were the main persons behind the ground level work. I especially mentioned Dr. Bharti's name because she has been working incessantly for the last 2 years. Now, let me remind you here in this context that this young generation, as has been stressed by various speakers, which includes our residents and junior consultants, be it in PGI or outside, are in the forefront in our fight against this pandemic. Many of them have suffered from COVID infection, but undaunted, they're continuing their services for the good of humanity. May God bless them all. I shall be wanting in my duty if I do not acknowledge the supports we received from all quarters. Colleagues in private sector, in medical colleges, in and around Chandigarh, all were very, very helpful. Now, I'll especially mention Dr. Alka and a team from Government Hospital 32. They stood with us all the time, and thanks a lot. All our senior colleagues, especially Dr. Vanitha Jain, Dr. Prasad, Dr. Neelam, Dr. Rashmi, Dr. Minakshi, Dr. Shalini, Dr. Pikasha, Dr. Seema, Dr. Kajal Jain from Anesthesia, along with their junior colleagues, were the main architects of these wonderful workshops which we witnessed yesterday, and they're also behind this well thought out academic program. My deepest gratitude for each one of them. Now, speakers, either national or international, they are the main persons behind real success of a conference because we come here to learn. And it was very heartening to note that everyone participated very willingly, overcoming all odds and were ready to condone our many mistakes. Really, it was a very humbling experience for all of us. Our chairpersons too need special mention because they have a very important role to play by making presentations interactive. And I thank each and every one of them from bottom of my heart for their participation. I thank all the pharmaceutical companies who participated in this conference and helped us. Without their help, it would have been difficult to organize this conference at this difficult time. Now, this is a virtual conference and we had no experience whatsoever. We are completely dependent on professionals who are working behind the computer. Mr. Girish and his team from meetings and more have taken the responsibility. They're doing a good job and they deserve a big applause. Now, we also thank here the staff from telemedicine and our photography department who have been very, very helpful. Lastly, I'll say that this conference was to bridge the gap between past, present, and future. I take this opportunity to thank all my teachers, colleagues, students for their active participation. Thanks a lot.
Thank you, sir. We are very grateful to you for organizing this academic feast for YUVAFOGSians. We would now be taking this session to a close. I would request everyone to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We will now be moving forward with the presidential oration by Dr. Alpesh Gandhi, sir, on preconceptional care, a new concept relevant to high-end critical care in obstetrics. For this session, I would like to call upon my respected chairpersons, Dr. Chandravati ma'am. She is Professor Emeritus, Department of Obstetrics and Gynecology, KG Medical College, Lucknow, Proprietor Director, Krishna Medical Center, Lucknow. She is the Managing Trustee, Krishna Educational Foundation, Lucknow, Secretary, NGO Wheel, which is Women's Health Empowerment Education, Lucknow, and Patron of Indian College of Maternity and Child Health. She has been HOD of Obs and Gynae at KGMU. She has been Vice President FOGSI 2001-2002 and of UP Chapter Obs and Gynae, Lucknow, Governing Council member of the ICOG for 2 consecutive terms. She has been Peer Reviewer General Committee, ICOG, for 5 years. And she has organized more than 20 state, national, and international conferences. Welcome, ma'am.
Thank you very much. But the video is not working, so I do not know. Video फिर वहीं से बंद हो गया. हाँ, video वहीं से बंद हो गया.
Ma'am, click on start video. Click on start video.
फिर आ गया.
Okay, now.
ठीक है. Thank you very much. Yeah.
Thank you, ma'am. Next chairperson, Dr. Sadhna Gupta, ma'am. She is Director and Senior Consultant, Jeevan Jyoti Hospital and Medical Research Center, Advanced Infertility Center, Gorakhpur. She was the FOGSI representative to SAFOG in 2018-20, Vice President of FOGSI 2016, ICOG Governing Council member 2015 to 2020, Corresponding Editor, Journal of Obstetrics and Gynecology of India and SAFOG, Chairperson FOGSI Safe Motherhood Committee 2011 to 2014, FOGSI representative to WHO and UNFPA workshops. She's been the chairman of UP ISR chapter 2017 to 19 and founder president Gorakhpur chapter of ISO PARB 2020. She has been awarded the Best Research Paper Award in AICOG 4 times, 3 Korean Award for Best Scientific Paper, thrice DC Datta Prize for Best Folksy Publication, and Dr. Naval Kishore Gold Medal in MD and many gold medals in MBBS. She has been awarded by many national organizations for her humanitarian work, community service, and work for women's empowerment. Welcome, ma'am.
Thank you.
Next chairperson is Dr. Umesh Jindal, ma'am. She is Director Jindal IVF and Sons Memorial Nursing Home, Chandigarh. She is the organizing chairperson for North Zone YUVAFOGSI 2020. She is the founder of Chandigarh Obstetrics and Gynecology Society and Greater Chandigarh chapter of the IFS. She's been the vice president of IFS for the years 2013-15 and has held many important offices in regional and national societies. She's instrumental in starting a fellowship program in ART by the Indian Fertility Society. Ma'am is an accomplished speaker and has been invited as faculty member for many national, international, and regional conferences. She has delivered numerous lectures and chaired multiple scientific sessions. She has presented her research work at many scientific conferences in India and abroad. She is an icon in the dissemination of medical knowledge in this region. Welcome, ma'am. And the last person is Dr. Ashok Kumar, sir. He is Director, Professor and Head, Department of Obstetrics and Gynecology, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. He has been Secretary-elect ICOG 2021-2022. He has been the editorial board member for Indian Journal of Medical Research and Archives of Gynecology and Obstetrics. He published research papers in more than 120 indexed and more than 80 non-indexed journals. He's edited 5 books and contributed many chapters in books, conducted 12 research projects of ICMR and UGC. Sir has a special interest in maternal health, especially medical disorders and in high-risk pregnancies. It is my honor to welcome you all. I would request Dr. Chandra.
Can I start the?
Yes, ma'am. Chandravati, ma'am, to please introduce the topic.
So at the outset, I must first congratulate organizing team of this North Zone YUVAFOGSI for choosing wonderful topic, optimizing perinatal health, and having me as a faculty as to chair an oration, which is very, very relevant to this topic. And the oration topic of preconception care, a new concept in high and critical care in obstetrics by none other than Dr. Alpesh Gandhi, the president. I wanted to take this opportunity to talk about Alpesh because this was the star, was born at Lucknow conference, and seeing his progress, it always gives me immense pleasure to see him doing so much wonderful work. We all know that a new WHO report shows that preconception care has a positive impact on maternal and child health outcomes. Preconception care is provisional of biomedical, behavioral, and social health interventions to women and couples before the conception occurs. It aims at improving their health status and reducing the behavioral and individual factors that contribute to poor maternal and child health outcomes. Its ultimate aim is to improve maternal and child health in both the short and long term. So our aim today, what we have been talking is to bring down the maternal mortality, neonatal mortality, have babies who are not born too premature, not born small for date. So Dr. Alpesh, the whole stage is for you. I'm anxious to listen to your oration because I know you always bring out wonderful points for us to remember.
Thank you, Madam Chandravati ji. I'm happy to listen that you are happy to see the work as the President Foxy have done. And with your blessings at Lucknow, we started our tenure. So I'm happy to listen these words. At the beginning, I would like to thank Dr. Professor Vanita ji, Dr. Umesh, Dr. Saha, and Dr. Ragini Agrawal for awarding me the oration and for honoring me. Can you see my slides?
Yeah, yes, sir.
Yes, yes.
Okay, thank you. Thank you. I'm going to speak on a topic, preconceptional care, counseling, medicine, recent concept, relevance to high-risk pregnancy. Namaste. I bring greetings from Foxy. A very good afternoon to all of you. In 2000, 189 nations made a promise to free their people from extreme poverty and multiple deprivations. And this pledge was known as MDG to be achieved by 2015. And as per MDG, India was required to reduce maternal mortality rate to 109 by 2015. To achieve this, during those days, our priority was to bring more and more pregnant women to the hospital for safe delivery, because hospital delivery rate was only 27% in 1998 in India. Several schemes were introduced in India, but Janni Suraksha Yojana has brought revolution in Indian obstetrics. Because of the scheme, the hospital delivery rate has been increased to 84% in 2015, which was 38% in 2005. And with this pace of improvement in maternal mortality rate in India, every year it was improved by 15 and 20. So we were expecting that we would be able to achieve MDG goal by 2015. But after 2011, as here we can see, in 2011 it was 178, and in 2015 we had reached to 162. So after 2011, the pace in the improvement of maternal mortality rate in our country was stopped. Why this observation? Why the progress in maternal mortality rate stopped? This was because of the lack of quality obstetric healthcare in our institutes, in our hospitals. India is one of the countries having highest incidence of PPH, preeclampsia, eclampsia, diabetes, IUGR, prematurity, septicemia, and so many pregnancy-related complications across the world. But the sad part is the case fatality rate is significantly high in these complications. Again, why these observations? This is because of lack of quality obstetric healthcare in our institutions and our hospitals. Now 85% of women are delivering at hospital. Now they are reaching to the hospital. Our doctors are available. They are dedicated. They are experienced. Even though our mothers were dying, this is just because of lack of quality obstetric healthcare in India. And as per WHO, the near miss case incidences can be as high as 8.23% in India. So because of the lots of advocacy from Foxy, at the end, government, we have a good, good news is that we have guidelines on obstetric HDU and ICU, which was published in March 2016, and then operational guidelines were published in 2017. And now we have more than 300 obstetric HDU, ICU functioning in medical colleges in many and some of the district hospital across India. And now again, second revolution has occurred in Indian obstetrics. And now again, with this, in 6 states, the maternal mortality rate we have reached to SDG goal, and in 10 to 11 states we have reached below 100, and we are now again expecting that we would be able to achieve SDG goal for India quite well ahead of time before 2030. By narrating this history of Indian obstetrics, my intention is, initially it was thought that we would be able to reduce maternal mortality and fetal mortality if patient delivers at hospital. Of course, there was significant improvement in maternal mortality rate, but we could not reach to desirable level. Then we thought that good emergency obstetric care will bring a maternal mortality rate down, and we will be able to achieve the MDG goal. But again, we were not able to achieve MDG goal. And then we realized the importance of good quality obstetric healthcare as obstetric HDU ICU as the vital backup once critical complication occurs. And now we are thinking that we would be able to achieve MDG and SDG goal. But as the professional organization, as the policy makers, and as the women health caretaker, we should look ahead. now we should think how we can make India, how we can make maternal mortality rate India equal to developed world, because in developed world it is less than 20 or 30. So our next target, our next aim is to reach to bring our maternal mortality below 20 to 30. And for that, now we realize that we have come to further realize that the base prenatal and quality care will still not be adequate to reduce the mortality and morbidity in several certain situations where women enter into pregnancy with pre-existing some conditions for bad obstetric outcome, and for those conditions, for taking care, for preventing them from becoming critically ill, for preventing them from making the pregnancy high risk, we need to take care of those women from the preconceptional period, and thus we arrived at a significant concept of periconceptional and preconceptional care and medicine. This is about the genesis of and importance of the preconceptional care. As Dr. Madam Chandravati ji has mentioned, it is a new developing branch of obstetrics. We can say it's a preventive obstetrics of primary kind, and it requires more insights into patient history and examination, and to promote health of women before conception in order to reduce preventable adverse pregnancy outcomes. It refers to intervention that aim to identify, modify biomedical, behavioral, social risk to pregnant woman and her baby before and immediately after conception occurs, as we all know that prevention is always better than cure. And WHO has also realized its importance and has developed a package of preconceptional care intervention and published in 2012. At this point of time, I would like to bring to all of you a kind notice to all of you about few eye openers why preconceptional care is required, is important. 4 out of 10 women report that their pregnancies are unplanned, and so essential health intervention is too late in 40% of pregnancies. Perinatal deaths are 50% higher among babies born to mothers less than 20 years, and we all know that India is one of the countries having highest incidence of early marriages and early pregnancies. Up to 10% of pregnancies among women with untreated gonococcal infection results in perinatal death, and up to 30%, 35% of pregnancies among women with untreated gonococcal infection result in low birth weight infants. And again, India is one of the countries having high incidence of gonococcal infection. Maternal undernutrition and iron deficiency anemia are one of the major risk factors, and we all know that 52% of pregnant women are anemic, which account for at least 20 to 30% of maternal deaths directly or indirectly through cardiac failure, preeclampsia, antepartum hemorrhage, postpartum hemorrhage, sepsis, and many other complications. Female genital mutilation increases the risk of stillbirth and neonatal death by 15 to 55%. In the absence of intervention, rates of HIV transmission from mother to child are between 15 to 45% or significantly high, very, very high vertical transmission if interventions are not done. And if intervention is done, the rate decreases to below 1%, we can say nearly zero. And pregnancy is absolute or relative contraindication in many conditions like severe mitral stenosis, pulmonary hypertension, chronic uncontrolled hypertension, uncontrolled diabetes mellitus, type 2 diabetes, and many other such conditions. India, with 5,92,000 stillbirths out of 27 million babies born every year, accounted for 22.6% of global burden of stillbirth, and having the highest number of stillbirth as per the Lancet. So we need to discuss this with expectant mothers, and we need to take corrective measures. We need to correct the deficiencies. We need to correct the possible cause for the stillbirth before second pregnancy and during preconception period. We should make strategies, plans for prevention of the recurrent stillbirths, which is the neglected tragedy. Similarly, as I have mentioned, India is the country having the highest number of preterm birth, 3.5 million preterm birth every year, and we all know that so many immediate, short-term and long-term complications of preterm birth, and it is the #1 cause for neonatal mortality. And again here, if you look at this table, then interesting table, that if mother has first preterm delivery, then the possibility of second preterm delivery is 17.2%. And if she is having both previous two deliveries are preterm, then this risk increases to 28.4%. That means we need to discuss with this with mother and her family. That possibility is significantly high, very, very high, that you will have, you may have preterm delivery, and we need to discuss and we need to take preventive measures if possible for saving this pregnancy. It's a big major public health problem, and it accounts for 43% of the all neonatal deaths in India. And so I would like to discuss few cases how preconceptional care could have been save those pregnancies or mothers. I am not interested in for those cases when discussing antenatal management or intrapartum management, because our today's aim of discussion is preconceptional care. A 23-year primey in 37 weeks of pregnancy admitted with dyspnea. She was diagnosed to have rheumatic heart disease, severe mitral stenosis before conception. After admission, she was treated with diuretics, verapamil, and oral penicillin. Cardiology reference was done, echocardiography was performed, and it was found that she was having severe mitral stenosis and suitable for balloon mitral valvotomy. She went into CCF, remained in failure despite treatment, and delivered a healthy baby after cesarean section. Was ventilated overnight. She was stable for 24 hours, but developed refractory pulmonary edema and succumbed 2 days after cesarean section. What could have been done to save her during preconception period? A cardiology reference during preconceptional period, maternal echocardiography could have been advised and performed preconceptionally during the early pregnancy. If ejection fraction is found to be less than 30%, pregnancy carries a significantly high maternal mortality rate. Nearly 60 to 70% of the mothers are dying if ejection fraction is less than 30%. Such pregnancy we cannot allow to continue. Such pregnancies should be terminated. Mothers should undergo balloon mitral valvotomy. After balloon mitral valvotomy, again she should be advised for cardiologist reference and maternal echocardiography. And if her echocardiography shows that ejection fraction is more than 45 or 50%, then we can allow this mother to have the pregnancy. A 24 years gravida 2 presented with right heart failure at 25th week. Past history of primary pulmonary hypertension 3 years earlier, and was advised termination of pregnancy. First pregnancy was terminated at 3 months on advice of cardiologist. Was again advised MTP at 5 weeks of present pregnancy, but she opted to continue at her own risk. Antenatal visits were regular. She went into spontaneous labor, delivered vaginally, developed fever on day 3, breathlessness on day 4, chest pain on day 8, pulmonary embolism was suspected, was put on parenteral heparin and failed to improve and died on postpartum day 9. Pulmonary hypertension constitutes a contraindication to pregnancy. Any symptoms of chest pain on exertion or syncope may be a manifestation of pulmonary hypertension. We should not neglect such minor symptoms, and we should always be high suspicious. Pulmonary artery pressure may be estimated during using non-invasive echocardiography testing. High suspicious cardiology reference, maternal echocardiography, and MTP probably would have saved her life. So, 3 important aspects of preconceptional care when woman is having cardiac problem. We should try to identify if any pre-existing cardiac problem is there or not during preconception period. We should try to evaluate the severity of this cardiac condition as the risk factors in relation to the expected hemodynamic changes of pregnancy. We should try to identify whether she requires any intervention or not, and if she requires any intervention, then we should offer this intervention. For some women, pregnancy may worsen their cardiac condition and functional capacity, and this has to be kept in mind during preconceptional period. Otherwise, she will become a high-risk pregnancy, critically ill, and probably she may lose her life also. There are certain absolute contraindications, there are certain relative contraindications with this potential risk. I will not go in detail of this, but we should try to evaluate We should try to identify, find out whether she is having any such absolute contraindication or relative contraindications during preconceptional period before she becomes conceived. When patient is having chronic hypertension, the potential risk of pregnancy labor delivery should be discussed with the patient and her family members in the preconceptional period. We should discuss that this is a high risk pregnancy, can develop complications, may require frequent investigation, may require admission in obstetric HDU, may require monitoring for follow-up of the patient. We should discuss all possible complications of all these requirements during the preconceptional period. For example, the patient may require hemodynamic monitoring in obstetric HDU, ICU, in intensive care units. We should try to control pre-existing hypertension. We should try to modify or optimize the drugs required if required. If she is on atenolol or ACE inhibitors, we need to change it to the other alternative antihypertensive drugs. If she is on warfarin, then it is to be changed as it is teratogenic if given in the first trimester. We should anticipate and discuss the possible complications like early onset of preeclampsia, eclampsia, IUGR, and many other complications to mother and her family members. A 40 years primary with BMI 35 was admitted at 38 weeks with pain in abdomen. She had regular antenatal checkups. She had a cesarean section for fetal distress under spinal anesthesia. No antenatal intranatal complication. On day 4th, post-operative day, patient became dyspneic. She was given steroids. Bronchodilator was shifted to ICU. By the time she was in shock, she was intubated and put on ventilator. But within 20 minutes of onset of symptoms, patient was declared dead. The final diagnosis which was declared was pulmonary embolism. We all know that high BMI is a high-risk condition. High BMI can lead to hypertension, gestational diabetes, thrombosis, pulmonary embolism, and many complications. We should discuss during preconception period that these are the risk factors. She may require additional investigations. She may require many precautions. She may require longer time of thromboprophylaxis. We should discuss all this. We should educate mother and family members, and particularly if we should also try to advise to reduce her weight during preconception period. Patients with BMI more than 35 kilogram with any comorbidities such as diabetes or cardiac problems should be offered bariatric surgery. Weight loss after bariatric surgery may reduce the risk of complication. Of course, we need to delay pregnancy for 1 year after bariatric surgery, as this is the phase of rapid weight loss and nutritional deficiencies. So we should advise in such cases during preconception period for weight loss, and we should continue, we should give for a longer time thromboprophylaxis in such cases. A patient of 27 years came with history of 4 months of amenorrhea with SLE mid-trimester. MTP was performed. Patient was discharged from the hospital on the same day. This is a routine practice to discharge patient of MTP within a few hours. She developed intracranial hemorrhage 5 days after MTP, followed by coma and death. Available history show that she was having active SLE, and we know that when patient is having active SLE, active lupus, there is a possibility of flare-up in 15 to 65% during pregnancy, and not only during pregnancy, even after MTP. Also, a post-termination higher dose of prednisolone could have probably more appropriate for her. She was requiring a longer duration admission in obstetric HDU ICU to keep the patient in hospital under close watch on her hematological and immunological parameters until it becomes normal. Then only she should be discharged, and she was required higher dose of prednisolone. Probably this could have saved her life. So all this possible risk, possible management aspect should be discussed during preconceptional period, and we should advise her not to have pregnancy within 6 months because chances of flare increases if it is active SLE. 27 years old patient with grade 2 abortion, 1 non-case of diabetes, and was on oral hypoglycemic agents. First pregnancy was DNA was performed at 8 weeks because of missed abortion, and this time she came directly at 22 weeks with FBF 150, PP2BS 220. Sonography was advised. A lethal cardiac anomaly was identified. Baby delivered with a cardiac anomaly and died within a few hours. So we all know that when HbA1c is less than 7%, congenital anomalies risk approaches to general population, but when it is more than 10 or 11, it corresponds to a risk of fetal anomalies as high as 25%. When HbA1c is more than 10 or 11, out of every one fetus will have serious congenital anomalies. So we should try to control diabetes mellitus in the preconceptional period, and this is interesting table where different studies are projected. Here, a comparison of congenital anomalies incidence was done in diabetes mellitus with preconceptional care and without preconceptional care, and it was found that with preconceptional care and medicine and management, incidence of congenital anomalies was between 0 to 2.5%, whereas without preconceptional care, it has increased from 4.2 to 12%, nearly 4 to 5 times more possibility of congenital anomalies if preconceptional care, counseling, and medicine is not done in diabetes mellitus cases. So we should try to evaluate medical history, obstetrical history, should try to know the duration, type of diabetes, whether any acute complications is there or not, whether she is having any chronic complications like retinopathy, nephropathy is there or not, whether she is on any management of diabetes mellitus, whether the use of glucose lowering agents are there or not, whether glucose monitoring she is knowing or not. We should try to know about her physical activity, nutrition. All these things should be evaluated during the preconceptional period if she is having diabetes mellitus. A 27-year-old patient, gravida 3, abortion 2, previous 1 abortion at 8 weeks, 1 MTP at 18 weeks of congenital cardiac anomalies. This time patient came directly at 7.5 months. Sonography was performed and she was having big open spina bifida in lumbar region. And we all know that the importance of folic acid, vitamin B12, vitamin B6 for the programming of healthy life and healthy baby. And we know that in India there is a 28 to 30% deficiency. There is a 20 to 30% of mothers are having deficiency of folic acid, vitamin B12 and B6. So this is the time where we can correct this deficiency during preconceptional period. Hyperhomocystinemia can lead to 7.7-fold risk of preeclampsia and 3-fold increased risk for abruptcy of placenta. And so this is the time for correction of improper diet, premature birth, low birth weight, inability to breastfeed, deformed babies, complication at birth, depression. So many complications can occur because of diet, improper diet and nutritional deficiencies. So this is a time where we can do correction of this deficiency and we can advise for proper diet during the preconception period. And again, this is the time to know the vaccination status, particularly MMR, Tdap, HBsAg, varicella, influenza, hepatitis B and C. Incidence is 10 times more incidence than the HIV. So we should be very much cautious about all these viral infections. And if she has not taken rubella vaccine or not protected, then we should give these vaccines to mother for the protection of all these diseases and possible complications. We should try to evaluate whether she is having any history or not. So particularly if she is chronic smoker or tobacco use, then it can lead to problem with the placenta, premature delivery may occur, sudden infant death syndrome may occur, or she may have, baby may have cleft lip or cleft palate. Similarly, now it is said that in India, the incidence of alcohol consumption in women is increasing. Now it is believed that 15% of Indian women are consuming alcohol, and this is a very high incidence and which can lead to many complications, including fetal alcohol spectrum disorder, where a fetus baby may have hyperactive behavior or difficulty with attention, may have poor memory, may have learning disability, may have speech delay or intelligent low IQ. So many complications can occur if mother is consuming alcohol. And sometimes if she is having anti-epileptic drugs, then we should counsel with the patient about the risk. We should try to balance the risk of seizure and the risk of these medicines. And at the end, I would also like to bring the that the effects of pollution and toxins are severe on pregnancy and on future generation. This is the time that we should include this in our curriculum, in our textbook of undergraduate and postgraduates. And unfortunately, India, if we look at the world, then 10 cities having the highest incidence of air pollution and toxins. 5 to 7 cities are from India. It can lead to air pollution and toxins can lead to miscarriage, birth defects, low birth weight, stillbirth, childhood cancer, thyroid dysfunction, attention deficit hyperactive disorders, cognitive impairment, sudden infant death, asthma, earlier onset of Alzheimer, Parkinsonism, premature aging, so many complications it can lead. So we should advise our patients women during preconception period to avoid visiting areas where air quality index is high. She should stay at home when the air quality index is very high. She should avoid active and passive cigarette smoking, avoid cosmetics. She should avoid noisy places, avoid living near to sewage incinerators or crematoriums or chemical manufacturing plants. She should avoid vaporizing during open air cooking with food, and she should use exhaust fan in the kitchens to reduce air pollution from indoor cooking. We need to advise, we need to educate our women about the bad effects of pollution, toxins on pregnancy and future generation. So preconceptional care has 7 integral components. Physical assessment of a couple should be done. Identification of the risk factor related to pregnancy should be done. Laboratory investigations of a couple should be done. Vaccinations should be programmed. Counseling regarding pregnancy risk, severity of the possible complication, management options should be done. Monitoring and correction of the nutritional status is important, and initiation of intervention if required when possible to provide optimum pregnancy outcome is very, very important. This is the risk factors, and we should try to evaluate if woman is having any of these risk factor during preconception period, because these are the high risk factors in which if mother is having these risk factors before pregnancy, then there is a possibility that this mother will become, this pregnancy will be high risk and this mother may become critically ill. Similarly, this investigation we should offer to both the partners, wife and husband, and this is the period window of opportunity to address all these issues and to know the status, nutritional status, vaccination status, genetic status. It's again a very big topic I have not addressed because it is a separate lecture. Environmental health status, infertility, fertility, subfertility status, female genital mutilation, sexually transmitted infections, interpersonal violence, again a significant thing, mental health, and particularly in this COVID time, we have witnessed that the incidence of violence and mental health problem increases a lot. HIV status, tobacco use, psychoactive substance use, all this should be addressed, try to identify whether if she is having any of this. And this is an opportunity for psychosexual counseling to understand and to educate her about the personal hygiene. If she is planning for second pregnancy, then during preconception period, we can educate her for the use of contraception, lactation, family planning measures. This is an opportunity, and as Madam has mentioned, as Dr. Neena has also mentioned, our guest of honor, that preconceptional care has very, very positive impact on her perinatal health outcomes. It can reduce maternal mortality, it can reduce child mortality, it reduces birth defects, reduces low birth weight, macrosomia, preterm birth, neonatal hypoglycemia. It reduces mental retardation. It reduces childhood cancer, hypothyroidism, vertical transmission of HIV. It reduces congenital infections, anomalies. It reduces underweight and stunting in children. It reduces breastfeeding problems. Just by using this window of opportunity, we can save many complications and we can bring the perinatal or good perinatal outcome. We understand this, that we are very busy in our routine practice. So there are so many patients in our antenatal OPD, and that is why we should have a separate dedicated preconceptional clinics, at least in all the medical colleges, so that this at least once a week, this preconceptional clinics should run in all the medical colleges, so that our residents doctors will also be benefited. They will know the importance of preconceptional care, as well as our mothers will also be benefited, because in our routine busy OPD, it is not possible to discuss all this aspect with all the mothers, all the women. We cannot do justice to these women, and therefore this special dedicated preconceptional clinics, many such clinics we require, like preventive oncology, preventive obstetrics, like preconceptional care for HIV and STDs, and for adolescent healthcare clinic. So at least every day we should have one dedicated such specialized clinic for our patients, so that special focus attention can be given to those women, because our aim is we all are working day and night for the upliftment of women's healthcare in India. Previously, the paradigm was healthy mothers are required for healthy babies, but now it has changed to healthy women are required for the healthy mothers, so that we can have healthy babies. So paradigm has been changed, and now we should also concentrate, we should also focus on preconceptional period to make healthy women. We should try this from adolescent age, teenage age, and then during the preconceptional period, premarital age, and then the preconceptional period for healthy woman and healthy mother and healthy babies. And this is the checklist we are going to upload on our website. And this is last thing is, this is a multi-speciality approach is required, because some of these women may have some renal problem or cardiac problem or neurological problem where we require endocrinal problem where we require support of all this speciality. So this is a preconceptional clinics are basically a multi-speciality approach clinics. And at the end, today more and more often pregnancies are possible after treatment of gynecological, surgical, and fertility conditions, but the preconceptional aspects, which is the preventive obstetrics of these circumstances, have often been underestimated or forgotten or neglected or ignored, even today, in their importance for overall good outcome. Time has come to rectify this situation, and Foxy, who can take lead to correct this, to rectify this situation? I think Foxy and all of us should take this lead to rectify this situation. Preconceptional counseling, care management would have made a difference to so many such cases, so many such mothers. It is the need of the hour. Preconceptional care involves wide range of situations. The dream is to be able to address them in each and every patient, but the challenge lies in getting these women to come to us on time and providing them adequate time and motivation. Every health visit by a woman at reproductive age should be used to make her aware about the need of preconceptional care, because our ultimate aim is improved maternal and child health outcome in both the short term and long term. It is said that if quality obstetric healthcare is provided in time, then 80% of mothers, it means 2,40,000 women could have been saved in the world every year. But at the same time, now it is the time to see that why she should have high risk pregnancy, why she should become critically ill. Can we do anything to prevent her from becoming critically ill? And preconceptional and periconceptional evaluation, counseling, and intervention play a significant role to prevent later intensive care admission and complications for many such women. If we can reduce the number of critically ill pregnant women in the world and high risk pregnancy in the world, this would be the best service to the mankind and woman of and the woman. We did not come to fear the future, we came here to save it. And Benjamin Franklin declared that by failing to prepare, you are preparing to fail. We should try, we should utilize this period of preconceptional time period for preparing pregnancy. A big section of society in our country is still unreached and underprivileged, deprived of benefits of healthcare. And some of the benefits are very simple benefits like preconceptional care, which is the preventive obstetrics we all can perform. We do not require a separate special training. We do not require a special gazettes for preconceptional care. We do not require technology or specialization for this. And we cannot allow our mothers deprived of benefits of such simple things of preventive obstetrics. Thank you very much for giving me this opportunity. Let us work together for FOGSI theme 2020 for safety first for Indian women and FOGSians. And probably preconceptional care is, I think, is one of the measure for the safety of our Indian women. Let us work together to achieve SDG goal before 2030, and let us target to achieve it by 2025. Thank you very much for this honor, for patient hearing, for giving me this opportunity to share my views on this very important topic. Thanks a lot. Thank you.
Dr. Alpesh, it was excellent oration, and it really reveals and alerted to the fact that all critical illness, the root lies in the prevention and the previous health status as well as the previous health records. Thank you very much. Actually, the today's obstetrics and the future medicine will be the social obstetrics and the preventive obstetrics. And you have very like laid the path for the FOGSI, that how we should work together, and as it is YUVAFOGSI, and we so many times think that our heroic measures is satisfying, very difficult thing is satisfying, but you have proved that very correctly, that future is for prevention and it is for SDG goals. So the accessibility and the equity is to be there, and we require knowledge, alertness, and most last and not the least, our willingness to do the best. So for Yuvas, it is prevention, it is preventive strategy, it is reaching to all, develop your skill, develop multidisciplinary approach, build your team, and provide best care to our women and children. Thank you very much, Dr. Alpesh. It was wonder to listen. It was feet to ears, and a very encouraging oration. Thank you very much. I invite my co-chairperson for their concluding, for their experience and the remarks.
मैंने तो तारीफ पहले ही कर दी थी, सो सुनने से पहले, because I knew the product what was going to come. It was wonderful oration. Thoroughly enjoyed the whole thing. Thank you.
Dr. Alpesh, I think you have raised a very important point, which I think that prenatal care can only take care of the problems which arise during pregnancy, but obviously it cannot take care of the problems which were there before pregnancy. And the major outcome of pregnancy for the mother and the baby depends on the problems which were pre-existing. And when we have to have that target area, we have to have the shift to shift our focus from prenatal care to the healthy woman. And only then we can achieve our target of having a healthy mother and a healthy baby and reducing all the morbidity and mortality indices. You have highlighted many areas where we can definitely work, right from minor problems like anemia, borderline diabetes, obesity, and other things, to major problems like heart disease and other life-threatening issues. And genetics is one area where I think a lot of now scope is there in the genetics, and a lot of perinatal mortality and neonatal morbidity and mortality can be prevented. Diseases, common diseases like thalassemia. I mean, this is one simple area where prenatal preconception counseling and treatment can definitely prevent the birth of major children having major thalassemia. So there's a lot of scope for preconceptional care and counseling and these clinics. I congratulate you for picking up this very important topic and highlighting the issues. And I would go by the FOGSI and to raise this as a program and run it successfully. Thank you very much, Dr. Alpesh.
Thank you, madam. Thank you. Dr. Ashok Kumar, you are muted.
Yes, good morning, good afternoon. Am I audible? Yes. Yeah. Thank you. First of all, Dr. Alpesh Gandhi, as usual, your oration was very informative, and I think everyone was bound to his or her chair to listen to you and got a lot of information. As you have rightly told, yes, prenatal care is the like it is very important, and you know, from our younger days we have learned that timely and regular antenatal and prenatal care is required for the benefit of our mothers and to provide them a healthy life in future and to prevent maternal mortality. And with the modern advances and modern technology, you know, all the diseases can be really prevented or can be diagnosed at an early stage, like preeclampsia. You can predict, you can treat at early stage. For GDM, you can look for macrosomia, you can plan the management. All those things are there. So I think prenatal care is very important, and you rightly highlighted the need of prenatal care and the new concept and the new things which have added in this era. So thank you very much, sir, as a President Foxy, for your innovative work also. And in the end, I would like to thank YUVAFOGSI team also for giving us this opportunity to chair this session. And thanks my co-chairpersons. Thank you very much.
Thank you very much, all the respected chairpersons, for your comments and appreciation and agreement with the need of preconceptional care and preconceptional clinics. And I hope your delegates will be benefited, and if with our joint efforts, if we can have preconceptional clinics in more and more medical colleges, it will be a great service from our side to the mothers of India. And at the end, I would like to thank Professor Dr. Vanita ji, Dr. Umesh Jindal, Dr. Saha, and our Vice President Ragini Agrawal for awarding me this oration and giving me this platform for this honor and giving me this opportunity to share my views, to convey something to all our delegates. Thank you. Thank you so much.
On behalf of all the chairpersons and the organizing committee, I would like to thank all the chairpersons and Dr. Alpesh for this wonderful oration. And with that, I think we can close the session. Thank you very much.
Thank you, ma'am. Prasanna, you are muted.
Heading to the next session. Good afternoon, everybody. Next session is panel discussion on aneuploidy screening, which is supposed to be held at 1 p.m. to 2:30 p.m. Sorry for the delay. Now I'm going to introduce and invite our chairpersons, Dr. Saha, Dr. Pragna Mishra, and Dr. Meenakshi Lallar. Introducing Dr. Saha. Sir is a professor and Department of Obstetrics and Gynecology, PGMR, Chandigarh, and he is the Secretary of Obstetrics and Gynecology of North India since 2018. He has many publications in indexed journals, more than 60, and he's received many awards. And he is doing pioneering work in IUTs and RH isoimmunizations and robotics. And his field of interest is fetal medicine and robotics. And introducing the second chairperson, Dr. Pragna Mishra. Hello. Ma'am is a renowned gynecologist in Patna, Bihar, and she is specialized in colposcopy and infertility and fetal medicine, active member of various societies and associations, and office bearer in BOGS and FOGSI. She received many more awards, George Mahoney Award and CL Jhaveri Award and Jagdeshwari Award. And introducing the third chairperson, Dr. Meenakshi. She had completed her DM in medical genetics SGPGL Lucknow, and now she is working as a clinical geneticist in prime imaging and prenatal diagnostic Chandigarh. She is the ex-consultant in Department of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. She received many gold medalist and best paper oral awards, and she has so many research papers, more than 30. And she is an active member of Indian Academy of Medical Genetics and Society of Fetal Medicine. Now I would like to invite Dr. Saha and Dr. Pragna Mishra to introduce the moderators.
It's my pleasure to introduce Dr. Mandakini. She has got illustrious career. I won't go to how many awards she has received, but all I can say that I have seen her material rise right from the beginning. She was resident here, and right from the beginning, she was a single-minded person, meticulous, strong-willed, and yes, single-handedly, she has developed the Maternal and Fetal Medicine Center in SGPGI. It was almost from the scratch. She is almost a self-trained fetal medicine specialist. She is both has an MD in gynecology as well as an MD DM generics. So that's a rare combination. We are very glad that Dr. Mandakini is with us, and many times we have to contact her to get her advice, and she's always ready to help us. Dr. Mandakini, please.
Thank you, sir, for that very nice introduction. And if Dr. Shreyasi can be introduced, then we can start.
Now I invite Dr. Pragna Mishra ma'am to introduce Dr. Shreyasi Sharma.
Yeah, thank you. Can I have Dr. Shreyasi's CV displayed on the screen? At the outset, I would like to thank North Zone YUVAFOGSI, especially Dr. Saha, Dr. Vinita Suri. Apologize if I'm missing names, for having involved me in your conference, first of all. And I can see a young moderator in front of me, Dr. Shreyasi, and she's senior consultant in fetal medicine, and it is at Cloud9 Hospital, Gurgaon, and she has won several awards and given several presentations and has had so many publications. It would be helpful if we had her CV displayed on the screen, but I'm sure that Dr. Shreyasi has a lot of credentials, and she's really going to make this panel discussion quite enlightening, along with Dr. Mandakini Pradhan. And we are all looking forward to this panel on aneuploidy screening.
Thank you for the kind introduction, ma'am. Again, at the outset, I would say that I'm extremely thankful, and there's a lot of gratitude to the organizing committee of the YUVAFOGSI. I have my mentor sitting right in front, so that is a matter of immense pride and honor, I would say. So without much ado, we will introduce our esteemed panelists before we go on to the discussion. If I could have their CVs displayed, please. Or else probably I can take the help of...
With this, we can introduce Dr. Shreyasi. It's already displayed.
So Dr. Sumitra is an associate professor and senior specialist in Vardhaman Mahavir College and Safdarjung Hospital. And Dr. Ritika Bajaj, she is a consultant obstetrics and fetal medicine at Jindal IVF and Sant Memorial Hospital, Chandigarh. Dr. Navya is a senior consultant at fetal medicine at Apollo Hospital, Hyderabad. Dr. Smita Pawar, she is a consultant fetal medicine at Cloud9 Hospital, Mumbai. Dr. Sangeeta Khattar, she is a consultant medical genetics at Jindal IVF Sant Memorial Hospital, Chandigarh. And I'm sure that all of them have multiple credentials to their credit. So without much ado, we'll probably start with the presentation. So if I may be please allowed to share my screen.
Yes, ma'am. Sure.
Actually, this is lunch time, and those who have already taken lunch must be drowsy, and those who have not taken lunch must be hypoglycemic and drowsy. So anyway, so this is the time frame, and we must stick to our time and have a wonderful discussion regarding this burning topic.
Yes, so we will have
Shreyasi will be presenting these cases, and let's start discussing. Dr. Shreyasi.
Yeah. Sure. So just to make it crisp and the smooth flow, we will discuss with one panelist at one point of time. So the first case is we'll be discussing it with Dr. Smita. We have a lady who gets pregnant and she's 28-year-old. She has a spontaneous conception and she comes to our clinic at 12 weeks. So Dr. Smita, our question is, what is the aneuploidy screening you would offer and how would you counsel? What is the ideal time you would perform a first trimester combined screening? And is there any rationale behind the timing that we rarely talk about? Dr. Smita, please.
Hi, Dr. Shreyasi. Good afternoon, everyone. I hope you're able to see and hear me. Yeah. Okay. At the onset, I would just like to thank the YUVAFOGSI North Zone Committee for this opportunity and to be part of this panel discussion. So coming back to this case, this is a primary gravida, looks low risk, 28 years age, 12 weeks gestation. This would be the ideal time to counsel this couple regarding the various screening tests which are available for screening for aneuploidies, mainly trisomy 21, 18, and 13, because these constitute about 60 to 70% of the chromosomal abnormalities which are found in the fetus. So this would be the ideal time to counsel them about the various tests which are available, what we are testing for, why we are testing for it, why do they need the test, and what is a screening test? Basically, what answers are we going to get from this test? What is the detection rate of the test? And once we get the outcome, whether it is going to be low risk, intermediate risk, or high risk, what are we going to do about it? What diagnostic tests are available to further confirm our findings? So this is the time when we do the pre-test counseling. So this is the pre-test counseling, educating them about all the various screening tests which are available and why it is better to do this screening test early, like in the first trimester itself, so that we detect these aneuploidies early on in pregnancy. So the ideal time, of course, would be in the first trimester itself, and we would go for the combined screening test. Combined screening includes the NT scan as well as the dual marker as in the PAPA and the beta HCG levels. And this is done between the 11th week of pregnancy to 13 weeks, 6 days. If you have to take it in the CRL, then it is 45 millimeter CRL to 84, because a mother might come to you exactly at 11 weeks and the CRL might be 41, 42. So it is better to take the CRL as our guiding point. So CRL between 45 to 84. And why do we take this 11 to 13 weeks, 6 days? Is because before 11 weeks, if we try to do the scan, there are two things. One, after the screening test, we will not have a diagnostic test to do because the chorionic villus sampling is done only after 11 weeks of pregnancy. So we will, so that's why we do it after 11 weeks. And also the fetal anatomy is better visualized after the 11 weeks or better at, around 12 weeks. Before that, we will not be able to comment on the fetal anatomy much. And why not after 84 millimeters? Because it has been seen that after 13 weeks, 6 days, the sonolucent area behind the neck or the NT, it reduces. And also after 14 weeks, the fetus, they tend to go vertical, they go in a standing position, making the NT scan more technically challenging to be done. So that is why the timing has been decided as between 11 weeks and 13 weeks, 6 days.
That is great, Dr. Smita. So you've correctly summarized that this is the time that we would do. The rationale behind the timing, non-availability of a diagnostic test before 11 weeks and after 13 weeks, 6 days, difficulty in requiring an NT and the NT not being as sensitive a marker. Then the correct thing is, of course, there is a pre-test counseling that is required where we give the various options. So would you want to elaborate what are the criteria that we really need to meet when we acquire a CRL image? And how should it be done?
Yeah, so here on the screen, I'm seeing a very perfect CRL image. So the CRL, while capturing the CRL, we have to make sure that there's a perfect mid-sagittal section of the whole fetus. The image is sufficiently magnified to around 60 to 80%. And you are able to completely identify the crown and the rump. You should be able to see the echogenic tip of the nasal bone, and it should be in line or above the level of the anterior abdominal wall. The fetus should be in a neutral position, like in this case, and there should be a pocket of fluid between the fetal chin and the chest. So like this fetus, the axis of the CRL should be 0 to 30 degrees to the horizontal. So it should not be, you cannot take a vertical image. So, and the calipers should be placed end to end from the crown to the rump. So this is an ideal CRL as you have shown in the image.
So right, so we have the CRL now. Next, what are the important aspects in the history you would want to record when the patient comes with this profile?
So
before you move on to the combined screening.
Yes, so the combined screening, when we are doing a combined screening, there are many variables which affect our findings. Of course, first of all is the mother's age, because we know as the age increases, the inherent risk for the mother to have a Down's baby will increase. So a woman who will come to us at an age of 25 might have a risk of 1 in 1,000 to a mother who comes at 35 who will have a inherent risk of 1 in 250. So the risk will increase. So maternal age. Then whether she has a previous history of having a Down's baby or a chromosomally abnormal baby. Again, that would increase her risk by 1%. If it is a translocation in the parents, then more. And then, of course, as you have put it on the slide, there are many variables which will affect our biochemical markers, like the mother's weight. If she is obese or if she has high BMI, then because of dilution of the analytes, the PAPA level might come low and you might have a false high report of Down syndrome, false positive report. Also, diabetes mellitus in the mother, smoking, then the type of conception, whether it's an IVF conception, whether it's a donor egg, that is very, very important. And whether it's multiple pregnancies, it is single pregnancies, and of course the ethnicity, because the levels will again differ in different ethnic groups. So these we have to properly mention while we are ordering the biochemical markers.
So as Dr. Smita has correctly pointed out, filling up the form is very important while you're sending the patient for a double marker test, because all these variables will actually tweak the final results and make the entire screening less sensitive. So now in this patient, what are the ultrasound markers you would want to see? Now that we have seen the history, we have a fair idea that she has come to us in the correct timing. What are the things you would want to see on the ultrasound?
So on the ultrasound, of course, once we have documented a correct CRL, after that, and we have confirmed that dates are correct. So dating is very important. After that, the single most important measurement is our neutral translucency, which should be taken in a standardized way. And if you take only the neutral translucency measurement, you will be able to detect around 70% of cases of Down syndrome. Like the detection rate would be around 70% with only NT measurement, 70 to 75. But if you also see additional markers like the nasal bone, the ductus venosus flow, the A wave and the PI of the ductus venosus, and the tricuspid regurgitation, then you can improve the sensitivity to around 85% without the dual marker. So you can improve the sensitivity to around 85% with a false positive rate of 5%. So the additional markers are also very important to tell us whether this mother is low risk or will come in the intermediate or the high risk. So these are the markers which I would like to see.
So could you please more elaborate, like you rightly mentioned, that there are certain prerequisites which are required for NT measurement in an image, and to fulfill them is extremely important. That kind of quality control is extremely important to actually have a good screening. So if you could just elaborate on what exactly comprises, what are the components required as a prerequisite for acquiring the NT image?
Yeah, so again, the image in front of me is a perfect NT image. If you can see, this is a perfect mid-sagittal section of the fetal head and the upper thorax. The image is adequately magnified so that around 75% of the screen is composed only of the head and the fetal thorax. The nasal bone should be clearly seen, the tip of the skin, the tip of the nasal bone, that should be seen, the palate and the chin. And you have to make sure that the fetus is in a neutral position, again, with the fluid pocket in between the fetal neck and the chin. Because if the fetus is in a flexed position, you might take a false low NT. And if it is it's hyperextended, then it can be a false high. Also, the echogenic lines of behind the fetal neck should be clearly visible, and the skin should be differentiated from the amnion. So that would be best document. If you see the fetal jump, you will be able to differentiate between the skin and the amnion. And then the correct placement of the calipers. So the calipers have to be placed on the echogenic lines. Like the crossbars should not come inside the the blood zone. They should be correctly placed on the echogenic line to measure. And then at least 3 measurements should be taken, and it should be measured in the widest part of the fetal neck. So that is how the NT image has to be taken.
That is great. Dr. Shreyasi, we move on because we have 48 minutes left. So
I think for the nasal bone assessment, it's the same criteria only.
Same criteria, yeah.
So next case we can.
So I'll quickly just cover it up. The components of double marker have already been covered, and we just have to interpret in the meaning of multiple of median, because that makes it gestational independent. So the mom value will actually tell how close the patient value is to the median value of that pregnancy. So for this particular patient, when we did the scan, the nucleotranslucency was well within the normal range. The PAPI and beta HCG mom are highlighted. The next step is actually to calculate the risk, including both these, the double marker and the ultrasound. And as we see that against a background risk, we have of 1 in 333, the adjusted risk is 1 in 3,386. So Dr. Smita, how would you counsel? It's probably just reassurance and follow up as a low risk. Anything?
Yes, we move on.
Right. So we'll move on to the next case, and Dr. Sumitra would be discussing that with us. This is a 28-year-old second gravida who has one living issue. She came to us at 18 weeks of pregnancy, and then she has had no screening before, no double marker, no ultrasound. There's no other significant history as well. How would you want to proceed, and how would you want to counsel this patient? And Dr. Sumitra. Do we have Dr. Sumitra?
Yes, thank you. Am I audible?
Yes, indeed.
At the outset, I thank Professor Vanita and the entire team, Dr. Bharti, for this very kind invitation to join this endeavor. So moving on, Dr. Shreyasi, so she's a case where she's coming to us at 18 weeks and no screening has been done in the first trimester. So I think Dr. Smita has already, made my job easier, that even in the second trimester, if a lady comes in who's not had any prior screening, of course, I would again, go through the same pre-test counseling. And I would, of course, have to tell her that, what is her initial risk, the a priori risk of carrying an aneuploidy fetus, why we can offer her the screening, what is the disease, pathology, what is the inheritance, and of course, the whole gamut of pretest counseling, that if the screen comes out to be positive, then, what else we can offer to her, and if it comes out to be negative. So there are 4 biomarkers which are, tested in the maternal blood. And these biomarkers are the result comes in as moms. So the mom values are in relation to the values that would otherwise be in general population with euploid fetuses. So whenever we actually look at a quadruple marker report, it's very important that don't just look at the risk, also look at the mom values, because they also give you some additional information other than the risk for aneuploidy also. And there are certain cutoffs for these moms, like if I may look at the beta HCG and the dimeric inhibin A, then a mom of 2 or more would be taken as significant. And for the ones which are lower, like the AFP and the unconjugated estradiol, it would be say 0.73 or 0.75, and lesser than that would be significant. So important is to look at the mom values too. And then, of course, the initial risk, which was 1:877, which was the a priori risk because of her age. And then the final risk, which we are able to recalculate and give, which is the patient-specific risk for that fetus to have trisomy 21 at term, would be 1:3498, which is again a low risk, Dr. Shreyasi. So I think we can also again reassure her.
Dr. Sumitra, the patient has come to you in this COVID time, 18 weeks. She never had any antenatal visit beforehand. So everybody should remember that we should not forget our antenatal checkup and antenatal, the routine things that is to be done. Second thing is, would you like to do an ultrasound? You yourself are an expert in ultrasound. Would you like to do ultrasound on the day of visit of this patient?
Definitely, ma'am. We would
yes.
discuss
So
that.
we do an ultrasound, have a look at it. There may be anencephaly. She has never visited.
Right.
So all of us must have come across this situation that there may be malformation in the baby. Then our subsequent management changes, and is and anything else you need to look into in the ultrasound.
Yes,
is pointed out.
I would just like to add, ma'am, that there are patients who have also Googled and come to us, and there are times when they ask about the NIPT. And so I think we can also discuss that with them. There are some who want to know about this and want to opt for it, and we really have to tell them and discuss with them that that is a test which doesn't really apply as a screening for a low risk population, because the
Great.
value is lower. And so that also I think I should be able to discuss with this lady. And as ma'am very clearly said, that on the same day, of course, I should have a basic ultrasound there, right there, to be to be able to assess the biometry as well as the structural, if at all if there are any obvious structural defects. But very important is that I should be able to look at the genetic sonogram. Now, what is a genetic sonogram? So genetic sonograms tells us about the risk that this fetus may be carrying an aneuploidy. So how is it different from the structural defects? Well, structural defect is something when you put your probe, you are able to immediately see there is a holoprosencephaly, there is a spina bifida, so there is an AVST. But soft markers are something which when we assess in a genetic sonogram, and they are to be looked into. We have to actually specifically look for these markers. Like you have to go in and you have to measure the ventricle. You have to go in and you have to measure the nuchal fold thickness. You have to bring your gain down and you're looking at an EICF or trying to look at an echogenic bowel. So these are markers which we have to assess. And in fact, we should be assessing all of them. So there is an entire list, and we should be looking at all the markers because individually they carry a underlying risk of their association with the aneuploidy. So that is known as a likelihood ratio. So what is a likelihood ratio? It is basically a ratio between a fetus which is aneuploid and is having the same soft marker to a fetus which is euploid and is also carrying the same soft marker. So what is the risk to this fetus if it is carrying a certain soft marker or certain soft markers? There may be more than one. So it is one thing is important to look for all of them and differentiate them, like as I said, from structural malformation. So they are not diagnostic, they are basically markers which tell you about the risk of aneuploidy and which each of them carry a likelihood ratio. So I think the Agatha clause, thank you, Dr. Shreyasi. So this again has made our lives easier, tells us about the likelihood ratio of each marker. So there are certain markers which carry a higher association with trisomy 21, these being the the echogenic bowel, the increased NFT, the ventriculomegaly, ARSA, the absent nasal bone. And there are certain, of course, which have a lower risk. So the likelihood ratios are there. What we need to do is we look into each of these and we assess if they are present. Then the likelihood ratio is multiplied. So it is positive, it is multiplied. And they have a very important benefit that if they are absent, they reduce the risk. So we are looking at all the markers and they are absent. In fact, there are no soft markers, then the risk is reduced almost 7.7-fold. So it is important that we look at each of them, and accordingly, the positive ones we multiply and the negative ones we divide. So we then arrive at a final diagnosis, a final risk. We do have certain calculators. I think Dr. Shreyasi, so the
very correctly stated, Dr. Sumitra. These are the markers which are there in the current context, and as she rightly pointed out, these are not abnormalities, these are just normal variants which indicate that there can be a genetic disease. What I wish to there's just one point I wish to highlight more, that in the current scenario, these are the markers over which we do risk calculation. A choroid plexus cyst is actually not a part of this entire gamut. So when we saw this, we saw there are no ultrasound markers, and what would be the next step? So as Dr. Sumitra was rightly saying, that we have to look at the likelihood ratios, and there is a way, a combined likelihood ratio is actually calculated by combining the positive likelihood ratio of the given marker, and it is multiplied by the negative likelihood ratio of all other markers. That is how we finally come to a digit which is actually the combined likelihood ratio. So once we have that, we have softwares, but even from this paper only, there is an appendix which is freely available online, and one can actually calculate those risks online. So for this patient, we found there was no marker. The quadruple, as you said, was low risk, and then we saw the adjusted risk was 1 in 2,000. So what is the basis? Like you correctly said, it's the likelihood ratio. And this is the addendum that is there with the paper that has been published in the White Journal. So you can actually see, this is a drop-down menu. You can mention that all these markers are absent. You can have a combined likelihood ratio. And all you have to do is have a background risk. Just divide the background risk with the likelihood ratio, combined likelihood ratio, and you will get the adjusted risk in case you do not have access to softwares.
Yeah, there are other softwares also, like on perinatology, you have that Aura, that
Yes,
ultrasound risk assessment. So one can use whichever software they can access, and or they can do the mathematical calculation. So also it becomes a bit tedious. And
yes. That's what it will become like. Like the patient will just be looking at us while we are calculating.
Well, this is very easy. You can use the Excel by Agatha-Claus. And I would also like to just add that the soft marker also has another value. Like, so maybe the risk for aneuploidy is low. You have a mild ventriculomegaly and you find that, well, the risk was low, or you have a echogenic bowel. But then there are other additional aspects to the markers also, like maybe an echogenic bowel, then you would want to, look into the cystic fibrosis, or you would want to look into some GI obstruction. Or you have a raised NFT, then you would look into fetal anemia and maybe do things like that. So I just wanted to add that aspect also. But otherwise, in this case, of course, it was simply low risk. So reassurance and sharing with her that again, that post-test counseling, that your test is low risk. However, the detection rate is 8%, and there is still a 5% false positive associated with it. And
yeah, that's great. Let's move on.
Yeah, sure.
So we'll discuss the third case with Dr. Smita again. So this one is a 29-year-old low-risk primary gravida who comes to our clinic, spontaneous conception. She again comes at 12 weeks. And she has been referred with an ultrasound which has been done elsewhere. And the CRL is 77 and the nuchal translucency has been reported as 2.7 mm. The patient is in a dilemma. At some centers, she's been told that this is an increased nuchal translucency. So right now, when the patient comes to you, how would you want to proceed and how would you want to counsel this patient?
So again,
can we move on, Dr. Shreyasi? Let's move on to the this thing, because we have already discussed this initial situation.
So initial situation we have discussed. My question is that, is the NT high and do we have a cutoff for the NT? How would you want to go about it?
Yes, so NT can only be seen in context with the CRL. So unless we know the CRL, so we have to plot the CRL and then put the NT. You cannot have an arbitrary one value and say that this NT value is high. Unless the value is more than 2.8, which is more than 95% for even 84 millimeters of fetus. So 2.7, we will plot against the CRL, which is 77, you said. And we'll see how much is the risk coming. Yeah, so this is well within the range. It is coming around, less than 95th centile. So this baby is, according to scan, it is low risk. And when we add the dual marker, the combined risk is coming as 1 in 2,800. So again, we can just reassure the mother. So CRL is important.
Yeah, so the take-home message is NT has to be interpreted with regards to CRL. Yeah. And even at an 84 mm, the 94th centile for NT is 2.8. So at any given gestation during the time, an NT above 2.8 would be a high NT.
Yes, that's a great point, that NT more than 2.8. And usually in our routine clinical practice, we tend to forget that 2.8. So everybody to remember or practically utilize NT more than 3, advise a prenatally invasive testing rather than asking for a NIPT or this thing, needs little amount of counseling. Yeah, so remember NT more than 3.
Moving on to the next case we'll discuss with Dr. Navya. So Dr. Navya, we have a 36-year-old primary gravida who comes to us at 18 weeks period of gestation. Again, due to the COVID time, she has no first trimester screening. She did not have access to hospital. She was homebound. So then she comes to you, you offer a quadruple marker, and these are the values of quadruple marker which you feel they are low risk. What is the next step you would say?
Because first of all, hello to everyone. I thank you for being a part of this North Zone YUVAFOGSI and being in my alma mater. And thanks to Dr. Saha sir, who being inspired to do the fetal medicine, and to all my professors and Vanita Suri ma'am. And so coming to the case, she is 18 weeks now, and she's 36 years old primary, because she doesn't have any first trimester
No,
screening.
this is the
And she has all
ultrasound that is.
ultrasound.
Just a
Yes,
minute.
she has
It's the
missed.
ultrasound that is shown over here. You are finding this.
Yes,
In that one
and
is
she
2:44.
had a quadruple test at least done, shows a low risk. And now in the ultrasound, there is a absent nasal bone in this, I could see, because it is a mid-sagittal view which shows a right view to take a nasal bone, and there is an absent nasal bone. And with a low risk in a quadruple, I would try to combine this two, because obviously the combining of this genetic sonogram and the quadruple markers will give a higher sensitivity of around 90%, because she has missed her first trimester. So I
So
can see
once
after combining, like the risk is around
So
1 in
after
54.
combine, yes. So against a background risk of 1 in 435, the risk is now 1 in 54. So how would you counsel the patient, and how would you proceed?
Now she is definitely in the high risk category, because the risk of 1 in 154 is a high risk. Anything less than 1 in 250, higher than 1 in 250 is considered as the high risk category, and for which I would definitely, because as already mentioned, the meta-analysis in 2013 by Agatha Colas, which is the absent nasal bone as an isolated marker, is a increase of 6-fold risk for the calculation, and it also shown that it is 6.58. So it is a very strongest and major marker for especially for trisomy 21. So I would suggest for the patient, even if the combined risk has come as a low risk, this being the strongest marker, I would suggest for an invasive testing.
So the patient did opt for invasive testing, and we have the result in front of us. The patient was carrying a baby with trisomy 21. So I think Dr. Navya has correctly highlighted that this is one marker which has the highest as an isolated marker, highest likelihood ratio. So even like you said, that if there is an absent nasal bone, even if the quadruple marker is low risk, when we combine both, it is not possible. Mostly we will end up getting a high risk only. So Dr. Navya, very quickly we'll discuss another soft marker with you. Could you please explain this image, and what are we trying to see over here?
Yeah, I can see we are trying to trace down ARSA in the ultrasound. The first image shows a normal, how a right subclavian artery should go beneath the clavicle. It is just above the three vessel trachea view. And the second image shows there is a presence of ARSA. So as we have seen in already previous table, that ARSA is also one of the soft tissue marker for the second trimester screening. And it also has it is one of the strongest individual marker with a likelihood ratio of around 3 along with other markers. So, but as taking as an isolated marker with other soft tissue markers, I don't know whether she's having complete ultrasound done.
So yeah.
Other markers.
So 36-year-old priming gravida, no biochemical screening. Only marker that we have been able to identify on her ultrasound is an aberrant right subclavian artery. Like you correctly mentioned. Dr. Navya, it seems we have in a way lost you. Now you are.
Am I audible?
Yeah, now you are. Now you
what
are.
What about the ultrasound findings? Other than
Other than ARSA, there is nothing else.
Yes.
ARSA is there as an isolated marker that we've been able to find on the ultrasound. So, like you correctly said, that the combined likelihood ratio of ARSA is 3.9. And when we did the risk calculation of this pregnancy, it was again coming in 1 in 100. She opted for an invasive testing. And again, this baby tested as trisomy 21. These are just
so every
two
time
facts
the
about...
combined risk is very important. Right.
Yeah. So
just
a few facts about...
And the mark.
And these are a few facts about aberrant right subclavian artery. If you would want to speak something about it, Dr. Navya. Dr. Navya, am I audible to you?
Hello. Am I audible?
Yeah, Dr. Navya, you're audible. If you just want to recapitulate on how would you counsel the patient who has an ARSA, and just a take-home brief message?
Yes, isolated ARSA, as I said, it's a prevalence of around 1 to 2%. And as an isolated marker, it is benign. It doesn't have a the invasive testing offering only on isolated ARSA is debatable. So when ARSA is present along with other cardiac markers, which is usually associated with ARSA, and if there is any other soft tissue second trimester markers, we have to definitely offer a invasive testing for the patient. That will be logical.
So basically risk calculation by the mathematical model, and based upon the facts that there is a prevalence of Down syndrome in 23.6%, and it's there in euploid fetuses as well. So we just have to calculate the risk based upon the mathematical model and accordingly counsel the patient.
If it is in the same 36-year-old primary, already the background risk is on the higher side. So we have to see whether the detailed ultrasound and also see for whether any other markers are present or not, and then accordingly we have to counsel the patient for this.
Great, Dr. Navya, thank you. We would now be discussing the next case with Dr. Sangeeta. Dr. Sangeeta, do we have her here?
Yeah, good afternoon, everybody.
Hi, Dr. Sangeeta. So, Dr. Sangeeta, we have for you a 34-year-old primary gravida who comes to our clinic at 12 weeks, 3 days of pregnancy. There is no significant past or family history. She's been referred with an increased nuchal translucency. The CRL is 59.2 and the NT is 2.6. How do you proceed further?
So I would like to thank everybody for giving me this kind opportunity. So as patient has come to me with increased NT, first of all, I will try to see how are the images and whether it has been done by a certified FMF certified or experienced sonographer, and we try to view the images whether they are according to the FMF protocol or not, and then I will try to plot the NT against CRL in a NT graph, whether it is coming over 95th to 99th centile or more than 99th centile. Now in this picture I can see this is coming above 95th centile, and maybe between 95th and 99th centile it's not crossing 99th centile, so I'll take it as 95th to 99th centile. And I will try to check any other malformations are reported or not in the ultrasound. So depending upon that, I will consult the patient.
So in the ultrasound, there was no other marker, no other structural malformation. Whatever we could see in the heart also looked absolutely fine. How would you counsel the patient? What are the implications of an increased NT? And how would you take it further?
So as we are dealing with this NT 95th to 99th centile, in these cases, usually we get 4 to 5% chances of chromosomal anomalies, and they can be associated with structural anomalies, and mainly the cardiac anomalies are most common with increased NT. And these patients can have adverse pregnancy outcomes in terms of IUDs, miscarriages, and newborn with neurodevelopmental delays. So we have to think about this and counsel the patient regarding all these points.
So if you would like to highlight that the patient falls in this range where the abnormal karyotype would be there in 3 to 5% and fetal death in 1% and cardiac defects in 2 to 5%, while a normal healthy live baby could be there in 93%. So that can be a part of this counseling, and this has been taken from the Fetal Medicine Foundation. So this can be there in everybody's clinics. It just makes the counseling very easy for the patient. Yeah. So since the patient was referred, already the patient was having a double marker where the PAPE was 0.6 MOM and Vita HCG was 1.9 MOM. When we combine both against a background risk of 1 in 325, the adjusted risk was 1 in 1238. So what would you like to do more? The situation is we have an increased NT above 95th centile and the combined risk is still low. And how would you counsel and go further?
So even if the dual marker is showing low risk, but in case of increased NT, we should take this into account and always offer invasive testing to patient in every case, because NT has many more implications except for these trisomy 21, 18 and 13, and more of microarray abnormalities, submicroscopic deletions and duplication syndromes, and single gene disorders also in many cases. So I would like to offer patient with the invasive testing and their limitations, their benefits, their risk, and we'll explain everything.
So as Dr. Sangeeta rightly mentioned, we should, in this scenario, opt for an invasive testing. The patient did opt for that, and we can see the result. It was actually a trisomy 21. I would also like Dr. Mandakini to comment on it. Often people want to do an NIPS in this scenario, and mostly all fetal medicine people will keep on saying no, reiterating the fact that irrespective of whatever is the combined risk, if there is an increased NT, please go ahead and do an invasive testing. Dr. Mandakini, would you please like to add?
No. Increase NT, please look for first is invasive testing. But everybody should know that if you are sending for QA-PCR or only for face, then that is not sufficient.
Yes.
What these days we are seeing is the amniocentesis has been done, and the test that has been done is FISH for chromosome 21, which is very, very inadequate. So you must know that for FISH, you will order for chromosome 21, 18, 13, or what all you are suspecting in your ultrasound. So mostly it is chromosome 21, but then simultaneously karyotype, we should not forget that it is the gold standard. So always it has to be karyotype along with the FISH. And next, coming up in the block is microarray. So any patient who has an increased NT, first cause is chromosomal abnormality. Second cause, Dr. Sangeeta already told that it could be cardiac defect. So you need to have a very good look at the fetal heart. The third thing is single gene disorder or genetic syndrome. And the most common genetic syndrome is Noonan syndrome, which cannot be picked up even by a microarray. Hence, a counseling to the couple that our test may increase as long as we find a defect. So once we find a defect, then we stop there. But then we counsel them beforehand so that we can extend this testing in the fetal sample that we have obtained. And we should not go ahead and do multiple pricks. Please, everybody who are listening to me, please refrain from doing one amnio for FISH, second amnio for karyotype, third amnio for microarray. I have come across such patient and by different people. So please refrain from at least doing this. Preserve those sample. It can be done, utilized for the further testing.
So as Dr.
Mandakini, invasive testing, no in between.
So I think Dr. Mandakini is trying to say that always have a DNA stored with you. So you would always want the DNA to be stored in case we want to do any other testing or a clinical exome. We move on to the next case. This one we would discuss with Dr. Ritika. Dr. Ritika, do we have you here?
Hello, Dr. Shreyasi.
Hi, Dr. Ritika. So Dr. Ritika, here is an ultrasound image in front of you. And what do these findings reflect, or what is your take from these this image? How would you want to explain it?
Yeah, at the outset, I would like to thank the organizers for having me on this platform. So I think Dr. Shreyasi has already pointed out with an arrow also. So these are two fetuses. It's a twin pregnancy, and we can see the T sign at the insertion of the intertwin membrane. So we know that it's a monochorionic twin pregnancy.
So this is one spectrum, and would you like to explain this also, because we'll go on to the aneuploidy screening in all these scenarios. So before moving there, just explain the ultrasound findings which differentiate between a monochorionic and a dichorionic twin pregnancy.
So again, we can see two fetuses in this slide, and we can see the lambda sign at the intertwin membrane insertion or attachment. So this suggests a dichorionic twin pregnancy. And chorionicity should be well established before 14 weeks of gestation. So I think anybody who's doing a first trimester ultrasound should establish chorionicity. After 14 weeks, the accuracy decreases, and it has implications for the entire pregnancy till delivery if we are not able to establish a correct chorionicity for that patient.
That's a great message. Doctor, can you repeat that same thing? If somebody is doing a first trimester ultrasound, finding a twin gestation, please mention about chorionicity. Even if you do not do any aneuploidy screening, do not do NT, nothing, you don't do anything. You write two fetuses and please do a chorionicity, whether monochorionic or dichorionic. Right. That's probably should be the message.
Yeah, very right. So what would be the best screening modality in twins? Please address both. How do we do it in a monochorionic twins?
Sorry. Sorry to
Sure.
interpret in between. The clock has jumped from 20 to 9. So we are left with 9 minutes. Okay.
Ma'am, this case will be finished within 9 minutes.
Yeah.
You are
Okay,
totally
great.
building up the pace for us.
Yeah. Okay.
So if Dr. Ritika could quickly tell what do we do in dichorionic and monochorionic twin pregnancy?
Yeah, so just like a singleton pregnancy, a combined first trimester screening is the best way to go, even in twin pregnancies. And I think we should put it across clearly, even in twins, combined first trimester screening is the best way to test. And this involves a combination of maternal age, your NT-NB scan, and a dual test. So you will give the lab the complete details. They will know the maternal age. They should know whether it's a monochorionic or a dichorionic twin pregnancy. They will calculate the free beta HCG and PAPA levels. However, this difference in reporting is that in a monochorionic twin, we know that most of the monochorionic twin pregnancies are monozygotic. So both the fetuses, unless and until it's an exceptional case, they will have the same genetic component. So in a monochorionic twin pregnancy, the risk is assigned to the entire pregnancy. So both the fetuses have the same risk of having Down syndrome. However, in dichorionic twin pregnancies, it is different. So 90% of your dichorionic twins are dizygotic. So they have different genetic components. So each fetus has a separate risk of having Down syndrome. So you can have a dichorionic twin pregnancy where one fetus has trisomy 21 and the other does not. So your screening will actually give a risk according to each fetus. So the free beta HCG and the PAPA levels remain the same while calculating risk for both fetuses. But in dichorionic twins, individual NT measurements are used to give a fetus-specific risk. So if one fetus has an NT of 1.3 and the other has a NT of 1.8 at the same CRL, their risks will be different. In a monochorionic twin pregnancy, the lab will calculate the mean NT. So they will calculate the mean of NT of both the fetuses and give a combined risk or a similar risk to both the fetuses.
So as very correctly stated, Dr. Ritika, so is there any role of a triple or a quadruple marker or second trimester screening in these particular scenarios?
So triple test, I think, is kind of obsolete in most places in India. So yes. Quadruple test, if the patient has completely missed the first trimester screening and she's coming to us at around 16, 17 weeks with an early anomaly scan, we do discuss it. If she has no dual test, we do discuss it, but we do tell her that the sensitivity and the detection rate for trisomy 21 is much lower. And the false positive rates also tend to be higher. So you can go, or you can just go with a very good quality anomaly scan with the
best thing to do over here is a combined first trimester screening. The quadruple marker has a very limited benefit in such scenarios because the detection rate falls drastically in case of twins. So it would not be much informative here. So very quickly, another scenario that there's a 34-year-old primary gravida who comes to us at 12 weeks, a DCDA twin pregnancy and a vanishing twin. How would you go ahead about it, and what screening would you do?
So we will reassess her previous ultrasound images. So we need to know whether the vanishing twin, it was an empty gestational sac or some fetal pole was seen in it. In an empty gestational sac, I think there was this wonderful paper by the Nicolaitis group long time back, and they found out that in an empty gestational sac, you can calculate the risk similar to a singleton pregnancy. The free beta HCG levels, they fall very quickly after the demise, and the PAPA levels are not much varied. So you can calculate the risk and you can do a combined first trimester screening. If a fetal node is there, then the free beta HCG levels, they fall and they are in a singleton range, but the PAPA levels tend to persist for a longer period of time. So the thing here is that if you do a combined first trimester screening in a vanishing twin, you have a higher chance of getting a false negative report. So your PAPA levels are higher, so it can actually mask the Down syndrome levels that you might get. So that is important. So there are some people who look at the timing of demise and they calculate risk accordingly. So there are some centers, or there are some people who call us and they ask that if it's been more than 4 weeks since the fetal demise, so now can we calculate it? So we generally suggest that to avoid confusions, because that screening, the sensitivity is falling significantly. If you do before 4 weeks, your sensitivity is around 81%, so around 75%. After 4 weeks, it's 81%. So we just say that you let it rest. because we've had to perform amniocentesis in several such cases where even in vanishing twins, a combined first trimester screening is done. You get these reports and then you can't counsel the patient because they then eventually end up with an amniocentesis. So with the vanishing twin, we only go by an ultrasound if there was a fetal pole seen. Even NIPT should not be suggested in these pregnancies because the cell-free DNA from the demised fetus has been known to persist for as long as 15 weeks after the demise. So again, NIPT is out of the question. If a fetal node was seen, even dual test. So you only go by an ultrasound-based screening.
Very rightly stated, Dr. Ritika. The only thing we have to see is whether it's an empty gestational sac or there is a fetal node, and accordingly we can take a call, because when there is a fetal node, then our biochemical screening actually goes haywire and we cannot rely on the result. Very quickly, another scenario: you are working in an IVF center. You must have come across this scenario a lot. There's a primea gravida who comes to you at 12 weeks, IVF conception. Initially, there was a trichorionic triamniotic pregnancy. She underwent fetal reduction at 11 weeks. Can dual marker will be done for her?
No.
So again, there is extremely low sensitivity of biochemical screening over here. So again, this would be only an ultrasound-based risk assessment. So if we have to summarize multiple pregnancy, then Dr. Ritika, what do you have to say? That combined first trimester screening is the best bet. Then there's a limited role of second trimester biochemistry, and in cases where there is a fetal reduction that has been done, or fetal pole is still visible in case of a vanished twin, again, biochemistry has no role over there, and ultrasound-based risk assessment has to be done. I would want Dr. Mandakini to add to it and conclude this session, because I think we have managed to be on time. Thanks to Dr. Mandakini's making us keep up with the pace, and she has been an inspiration and a guiding light for many, both Dr. Saha, Dr. Vanita Suri. I think they have in a way inspired a whole lot of generation. So ma'am, a few words from you before we conclude.
No. It was, I got inspiration from Dr. Vanita or Dr. Saha. I have worked under them and have inspired lot of qualities from PGI Chandigarh. So I always tell that whatever I am is because of PGI Chandigarh. So anyway, so to have what we have not discussed about screening is NIPT.
Yes.
So what are the indications anyone can take up? What are the indications of doing a NIPT? If a patient is willing to do whatever you want to advise, he will go by it. So let's say, what are the indications of doing an NIPT? The current, anyone?
Dr. Navya, you can take it. Dr. Sangeeta?
One point, I think, ma'am, NIPT should be part of the contingent screen. No, we shouldn't really be doing it for everybody.
Yes.
In the low risk population.
Second, Dr. Navya?
Yes, NIPT can be given as an option for any patient after 10 weeks of pregnancy. So it can be given, but
can be given to any patient. Dr. Smita?
Yes, ma'am. Actually, the ACORD guidelines now say that NIPT should be offered to all, even low-risk mothers. It should be offered, like they should be aware that a test like this is available. But again, dual marker gives us a lot of other information. So it is not an replacement for a dual marker.
Which ACOG guideline you are
obviously?
Ma'am, the 2020 ACOG guidelines say that even low-risk mothers,
it
all
says
mothers
that the information about it should be given. As of now, what we are talking about is, what we are working on is, as a general practitioner, everybody should go away with this idea that there are certain indication of doing an NIPT, and that is a maternal age more than 35 at the time of delivery. Second is previous history of Down syndrome, which is trisomy 21. Second is if she is a carrier, one of the parent is a carrier of chromosome involving chromosome 21. So these are few indication of offering NIPT, definitely going ahead and doing an NIPT. Rest, what this says that you need to give all these options, like contraception is a basket, cafeteria approach.
Exactly.
Similarly, you need to do this. Second thing I would like to highlight is, we need to look into more important things like screening for thalassemia, rather than concentrating on aneuploidy screening, though this whole scenario was aneuploidy screening, but we should not forget our routine antenatal testing and more common things. So this is an optional test, optional screening test for a pregnant woman. And as an obstetrician, we need to tell to them, and please should not forget it, and that there is a screening test available and it can be screened. Such condition can be screened.
Dr. Mandakini, one more thing I would want you to highlight, which is again a common scenario that everybody comes across. What do we do when there is a no call on NIPS? So ma'am, just briefly, if you can recapitulate that.
Yeah, that's regarding no call, we need to tell them beforehand that 6% of samples can be no call, and specifically if the maternal weight is more. And there are guidelines which says that more than 70 kg, you should not go ahead and do a non-invasive prenatal testing. So, but then there is no definite guideline accepted by all. So it is more maternal weight, you tend to get less amount of fetal DNA, and hence the test will be no call. There are two thoughts regarding no call. You do a repeat testing or you go ahead and do a invasive testing. The latest guideline says that you go ahead and do a invasive testing if your first sample says that no call. And this information needs to be given to the couple beforehand, even before doing an IPT. So what we are trying to come up is, as a guide, the information sheet that can be printed in the local language and can be given to the patient. Okay, thank you.
So, great, ma'am. Thank you to all the panelists. Thanks to Dr. Mandakini.
Thank you. Thank to Dr. Shreyasi. She has got all the effort to make all these slides. And I thoroughly enjoyed this panel. Great panelists.
And one sentiment and spirit I think that we all share, who all have post-graduated from PGI, I think we owe it all to PGI. We owe it all to Dr. Saha and Dr. Vinita Suri and all the consultants there. I think I totally agree in spirit and in sentiment with Dr. Mandakini over there. Okay, I think we'll close this session now.
Thank you.
Thank you.
Thank you, Dr. Shreyasi and Dr. Mandakini. It's a pleasure to have you here.
Thank you,
now,
sir.
May I ask my co-chairpersons to ask any questions to any of them?
No questions, but I would just like to make some comments regarding the panel.
Dr. Pragya, will you please ask?
Yeah. I think I'm audible, right?
Yes.
So I said no questions, but just some comments at the end of the panel. It was a wonderfully dealt panel, having been moderated by Dr. Mandakini Pradhan and Dr. Shreyashi Sharma. And the first case, Dr. Smita dealt it very well, where one thing that she highlighted, that if a patient comes slightly early, then her NT may not be, her CRL may be less than 45, then it may not be the right time to request for the biochemical markers. Then in case 2, Dr. Sumitra, she again, you highlighted the importance of looking at the individual mom values. So that was one take-home message from the second case. And from case 3, one was that which Dr. Smita dealt very nicely, regarding that NT should be interpreted against a CRL. Just don't go by the individual value. Then in case 4, which was dealt by Dr. Navya, regarding absent nasal bone and ARSA, that because these in itself have a very high risk of aneuploidy, and it may be good to go for an invasive testing. Then in case 5, which was dealt by Dr. Sangeeta with input from Dr. Mandakini Pradhan, and that was regarding implications of increased NT, where Dr. Mandakini Pradhan highlighted that if it's very high, go for an invasive testing, don't just leave it, because, as in that case, the combined risk was low, and actually looking at the PAP-A values, PAP-A was low. So in that case, it would be better to go for an invasive testing. And case 6, which Dr. Ritika dealt, this was regarding aneuploidy screen in twin pregnancy. Quadruple marker is not sensitive. And she also mentioned that really we should not go for a triple marker because it's something which is obsolete these days. And then finally, we talked about fetal reduction in IVF pregnancies, where biochemical screening is not at all sensitive. And last but not the least, with the concluding, facts about NIPT, which Dr. Mandakini dealt wonderfully. So I think
you summarized very well.
Yeah. Thank you so much. Yeah. So once again, I thank the team North Zone YUVAFOGSI for having involved me as an expert for this panel discussion. I thoroughly enjoyed it, and I think I'm more knowledgeable with all the expert moderators and the knowledgeable panelists in the panel. Thank you so much.
Thank you.
Thank you. Thank you all, and thank you all the panelists.
Thank you, everybody. Now we are heading to the next session of today's, that is optimizing the perinatal outcome in gestational diabetes. Now I'm going to introduce our beloved chairpersons, Dr. Rakhi Singh ma'am and Dr. Archana Verma ma'am and Dr. Kiran Agarwal ma'am. Introducing Dr. Rakhi Singh ma'am. She is the well-known renowned gynecologist in India. Her present position is director and IVF specialist in Abalone Clinic in Noida. She has completed her diploma in reproductive medicine and embryology and advanced laparoscopy and hysteroscopy from Germany, Kiel University. She was invited for more than 300 national and international conferences, and she is the chairperson of ISAR and YUVAFOGSI Award. And she is the present chairperson of Endocrinology Committee of FOGSI 2020 and 22. And she has written multiple chapters in various books on topics including fibroids management in IUI. And introducing the next chairperson, Dr. Archana Verma. She is the renowned gynecologist from UP. She is the Vice President-elect FOGSI 2021. And she is actively involving and passionate about creating awareness on women health. She is the organizing secretary of North Zone YUVAFOGSI 2016. And she is the winner of Indian Book Award and President FOGSI and Best Committee Appreciation Award. And she has received Governor Appreciation Award for Menstrual Hygiene. And she has received Appreciation Award from CRPF Director for Health Programs in 2019. Introducing the third chairperson of the session, Dr. Kiran Agarwal. She is the Director, Professor, Obs Gynae, Lady Haddon Medical College. And she is the President of Indian Menopausal Society, Delhi chapter. She is the chairperson, Adolescent Committee, AOGD, and member of Adolescent Health Committee, FOGSI. Now, I would like to introduce speaker of the session, Dr. Preeti Kumar, and giving the session to Dr. Archana Verma. Hello.
Hello, I think Dr. Rakhi
Agarwal, ma'am. Sorry.
Dr. Rakhi Singh.
Thank you, dear, for inviting me to introduce well-known Dr. Preeti Kumar. I am Dr. Rakhi Singh, Chairperson of Endocrinology Committee of FOGSI. Dr. Preeti has done widespread amount of work in FOGSI, and she is known for working hard. And we've seen wonderfully done 2020 AICOG under her guidance also. At present, she is the Chairperson of Safe Motherhood Committee of FOGSI, and a fellow member along with me, and she's a core member for the Prevention of Violence Against Women Cell of FOGSI from 2018 to 2020, Director of Sunflower Medical Center at Lucknow. She's been the organizing secretary, and under her able guidance, we've seen her working very nicely, and the lovely AICOG which was conducted at Lucknow. An appreciation award she's received, and for execution of AICOG 2020. She's been the organizing secretary of 2019 Lucknow, organizing secretary of 25th Annual Conference UP chapter. She is being the vice president of Lucknow at present for the Lucknow OB-GYN Society. She's been delivered many lectures all over, and also the oration she has given during the APCOG 2018 at Prayagraj. She is been working very closely with Manyata, and we all of us have known and seen her working. Today, I'm presenting to you Dr. Preeti Kumar, who's going to do justice to the topic and deliver the academic feast for all of us.
Thank you so much, Rakhi, for that kind and generous introduction. At the outset, I would like to thank the team, North Zone YUVAFOGSI, the organizing chairperson, Dr. Vanita Suri, and of course, Dr. Umesh Jindal. Gratitude to the organizing secretary, Dr. S.C. Saha, sir. And I would like to especially mention Meenakshi Rohila. She had been so kind and considerate in calling me again and again for this North Zone YUVAFOGSI. So nice of you, Dr. Meenakshi, and I really want to congratulate you for a wonderful the workshop that was conducted yesterday, and I attended the entire workshop. So before I start my session, I would like to again congratulate the team of North Zone YUVAFOGSI, because this conference had been a successful conference and we have been hearing all the deliberations right in the morning. We do gratitude.
If I just may take a minute, Dr. Preeti, we
Yeah,
have
please.
our expert here,
Yeah,
Dr.
please.
Shanta Jain, for the session.
Yeah,
I just introduce you. I'm sorry for the intervention.
it's okay.
And it's my privilege to introduce Dr. Shanta Jain. And what great moment rather for me to introduce your own teacher and mentor. Dr. Jain, a postgraduate from PGI Chandigarh, that's the association, and she herself is a teacher of teachers. She is the founder of the Delhi Gynae Endoscopic Society, has received, I think she needs no introduction. And that's why she said that just introduce me as a teacher. And she's taking forward the role of all doctors in the National Medical Commission and is hell-bent on teaching the doctors about the medical legal significance. A surgeon par excellence, a teacher of teachers, and I think way forward ahead in all spheres of life. Dr. Shanta Jain, I think you may please continue. Dr. Preeti.
Yeah, thank you, Dr. Kiran. Really, we admire and appreciate the efforts what Dr. Sharda Jain has put in for the women's health and for the doctor community, and we really salute you, ma'am, for all your endeavors. So I like to, with the due permission of the chairpersons, the esteemed chairperson, Dr. Archana Verma ji, Dr. Rakhi, and Dr. Kiran, and of course the experts, Dr. Sharda Jain, who I would be happy to have her comments at the end of the presentation. So I would like to share my presentation. Now, is it visible?
Yeah.
Yeah, thank you so much. So I've been given the responsibility to speak on the topic optimizing the perinatal outcome in gestational diabetes. And this topic is very close to my heart. And I would like to also share some of my experiences, which I have faced in the past in one of the projects that I have done in Jharkhand about the practices, what we are doing for diagnosing gestational diabetes mellitus. So the scope of presentation would be defining hyperglycemia in pregnancy. Of course, the periconceptional counseling and care, which has been very nicely covered by Dr. Alpesh Gandhi, President Foxy, in the oration. Definitely the diagnosis of GDM, which is again a dilemma and a lot of controversies in how to diagnose GDM, maternal and fetal complications, antenatal care, management of hyperglycemia, and when and how to deliver, and postpartum follow-up. I have put these points because they all directly or indirectly affect the perinatal outcome. So when we talk about the definition, the gestational diabetes mellitus is carbohydrate intolerance with recognition or onset during pregnancy, irrespective of the treatment with diet or insulin, whether or not the condition persists after delivery. So FIGO has given this definition as hyperglycemia in pregnancy, which can be a pre-GDM, which is diagnosed for the first time in the pregnancy, or it can be gestational diabetes per se. So when a pregnant woman becomes a diabetic, she may face many problems related to diabetes and also related to pregnancy. So any of the complications in the mother will indirectly affect the perinatal outcome. So in the diabetes complications, we are all aware of diabetic ketoacidosis, which is very common when the patients are on insulin or type 1 diabetes mellitus. Then certain obstetric complications like miscarriage, premature birth, pregnancy-induced hypertension, polyhydramnios, maternal distress, and there can be complications in labor like prolonged labor, shoulder dystocia, perineal injuries, and many of these complications can directly or indirectly affect the perinatal outcome. Then there can be fetal problems. We have been talking about the aneuploidies in the last session. The pregnant patients who are pre-GDM have higher chances of having the chromosomal abnormalities, but GDM per se doesn't have those chances of having the chromosomal abnormalities. So let us see this case where the opportunities was missed. This lady she delivered the first baby when she was 22 years of age, and the weight of the baby was 3.9 kgs. And after 11 years, she again became pregnant, and she reported at 12 weeks with a BMI of 30 kg and the single step test showed the value of 248, and HbA1c was 8.8. Now, when we were hearing Dr. Alpesh Gandhi, he said that 40% of the pregnancies are unintended, and where we lack is the preconception counseling and care, which plays a very, very important role. And therefore, the early testing makes a very important place when we talk about reducing the maternal and the fetal complications. So a lot has been discussed in the oration, but I would really like to point out that the HbA1c level, if the patient is diabetic, should be maintained below 6.5 or 6, and a fasting value of less than 95 and the postprandial less than 40. Then again, I would like to emphasize here that there are recent publications where they have mentioned that the diabetes has been linked with thyroid dysfunctions. So even if you have done the thyroid study in the first visit, even if you diagnose a GDM in the later part of the pregnancy, it is always advisable to go ahead with a repeat testing of thyroid. Then rest of the things we are all aware, and the folic acid supplementation definitely is very important. Now, it is also very important to understand that the patient is a case of pre-GDM or it's a case of gestational diabetes mellitus, because the patients, the pregnant women who are pre-GDM will have not many problems, and there are serious implications if the pregnant woman is pre-GDM. But if the pregnant woman is GDM, there are more of anthropometric metabolic disorders rather than organ or behavioral disorders. So these are the recommendations that have been put in by the government of India, and we all endorse. The FOGSI also talks about it. The FIGO has also given the recommendations for low resource setting that yes, the single step OGTT non-fasting is good enough for diagnosing the gestational diabetes mellitus, and the values above 140 should be considered as positive value. Now, just to mention this, we had done a Vistrit project in Jharkhand. It's a pilot project which we did in under the USAID. It was supported by IP Global, and we did a survey. Just try to find out whether they were aware of the single step test or what tests they were just doing. This was a survey which was done in the private sector. The survey showed that most of the gynecologists were aware of the single step test, but they were doing a random test. So the knowledge was there, the practice was missing in those centers. So we try to inculcate the single step test procedure doing OGTT, and we try to train the healthcare workers and the doctors. And now they are doing a single step test and a lot of pickups of gestational diabetes mellitus patients. Now, the government of India guidelines clearly say that you have to do the first testing at the first visit, and the second testing should be done at 24 to 28 weeks. But if you have the opportunity and if you can do, the third testing should also be done at the 32 weeks of gestation. Now, this chart is again very important because what we say is the values in the pregnancy should be below 120, but we should not omit the values between 120 to 139 because these are the patients that have a high risk of developing gestational diabetes mellitus. So if you have a value somewhere between 120 to 139, those are the pregnant women where they need to be counseled because they are the pregnant women who have a very, very high chance of developing gestational diabetes later on. Again, I would like to emphasize that the values beyond 200 are the pregnant women who have most likely are pre-GDM, and they should be considered as pre-GDM, and the values between 140 and 199 should be considered as gestational diabetes mellitus. Then most of the prescriptions we find HbA1c as the monitoring tool for the glycemic index. But I must tell you the HbA1c has a limited value when we talk about the gestational diabetes. It is not at all a useful tool for monitoring the sugar control during pregnancy. It can be one of the important tool when you find high sugars in the first trimester, where you really want to differentiate whether the patient is a case of pre-GDM, and you can just calculate the risk of having the congenital malformations. Again, I would like to emphasize that higher HbA1c levels are not an indication for termination of pregnancy, and they should be counseled regarding the risk of malformation, but they should not be counseled about the termination of pregnancy. Again, just highlighting this very important article, which has been recently published in New England Journal of Medicine in March 2021, because many of the centers, when we talk about the single step test, what Government of India has implemented, only 12 states in India are following the single step test, but most of the centers still have varied diagnostic procedures. Some are following IEDPSG guidelines, some are still following ACOG guidelines, double test. But this article, which has been done, it's a randomized trial which has been done in more than 22,000 pregnant women. And this randomized trial showed that one-step screening as compared to two-step screening doubled the incidence of diagnosis of gestational diabetes, but did not affect the risk of large for gestational age, adverse perinatal outcomes, primary cesarean section, and gestational hypertension. So there may be some more studies needed, whether are we over-diagnosing if we are following a single step test procedure. Now, coming to this case, Mrs. C, a 32-year-old primigravida, a diagnosed case of PCOS. She comes at 22 weeks, a high BMI of 35, her fasting values of 128, and the PP is 192. HbA1 is 9.2. What is the management protocol for this patient? But because you are definitely concerned about the maternal and perinatal outcomes. So what is the prognosis of the pregnancy and the future resolution of the diabetes? So whenever you talk about the antenatal management, you have to divide into obstetric management and the glycemic management. And again, as far as the glycemic management is concerned, you have to really find out whether this patient is a pre-GDM or she is a case of GDM. Now, when we talk about the management of hyperglycemia and pregnancy, the first two remain constant, that is medical nutrition therapy and physical exercise, irrespective of the oral hypoglycemics you are using, whether you're using an oral hypoglycemic drug or you're using insulin. Then weight chart is again very important, and I must emphasize here that whenever you have a pregnant woman, in the very first antenatal visit, you should mention about the weight of that pregnant woman, and just mention on that paper the expected weight gain in that pregnancy, because this is very important. If the pregnant women have a high BMI, then the weight gain has to be very less. So unless you have a pre-pregnancy weight gain, then only you will be able to calculate the weight gain, a total weight gain in pregnancy. So it is always advisable to mark on the prescription chart the expected weight gain in that pregnant women. So traditional management of hyperglycemia, we talk about diet, exercise, and insulin. Again, I want to emphasize there is no universal, uniform diet charts, because the diet patterns differ from part to part, in the region to region. South have different dietary habits, North have different dietary habits. So you have to just calculate or exchange the proportion of meals accordingly, and you have to have a diet counselor. Exercise again is important, and then insulin. So whenever you put a patient on MNT, again, there are certain important things that we need to understand in clinical practice, that MNT should be advised if you diagnose a GDM or a hyperglycemia in the first trimester. It is always advisable to put them on insulin, because you need a strict glycemic control. But whenever you are putting a patient on MNT, if you have a borderline hyperglycemia, maybe something between 140 to 199, the MNT is advised for 2 weeks. And after 2 weeks, you advise a 2-hour postprandial sugar. And these are recommendations of Government of India guidelines. And if these values are below 120, then monitor by 2-hour postprandial every month in second and third trimester. But if the values are more than 120, then you have to have the oral hypoglycemics or insulin. Definitely, the Government of India of guidelines also quote that metformin and insulin are both accepted management. Whenever the MNT fails, you can put them on metformin or insulin. Again, I want to emphasize that they have clearly mentioned that metformin should be added beyond 20 weeks of gestation, not before that. But insulin definitely is the best choice for managing hyperglycemia. Again, AD has given a recommendation, because a long debate was there whether you should continue metformin if the patient conceives on metformin. The ADA has given a clear recommendation in 2020 that if a patient conceives on metformin, then the metformin should be continued till first trimester, and then you have to stop this metformin because this is not going to be beneficial. Exercise, we all know about it. It should be a very, very important part of, because this controls the hyperglycemia. And this is a very important, the control of hyperglycemia is very important because it is linked to many of the complications in maternal during the pregnancy, and that can affect the perinatal outcome. So when to start insulin? Definitely a fasting value more than 90 or more than 120. Or if you diagnose a clear-cut case of diabetes, a fasting value of more than 125 and the postprandial value of more than 200, it is always advisable to put them on insulin rather than starting metformin. So when should the insulin be a first line? Whenever you diagnose GDM in the first trimester, try to put them on insulin. Whenever you diagnose you have obstetric problems, if the patients are on oral hypoglycemics, and even though if you're finding any of the obstetric complications, try to switch them on insulin, because even though the metabolic control is there, but if the patient is having, the pregnant woman is having obstetric complications, put them on insulin. If the fasting values are more than 25, or if the pregnant woman is intolerant to hypoglycemics. So again, the target values should be less than 90 and 120. Again, I have mentioned the approved insulin, but the government of India has recommended only NPH as the recommended insulin. They have not mentioned about the Lispro-Aspart, but we can use, depending on the status of the hyperglycemia. It's just a postprandial hyperglycemia. We can just add these analogs or short-acting insulins where they can very easily control these hyperglycemia. Then this is a very important paper. I would like everyone to just have a look on this. And because this paper has been published in 2019 by Dr. Shishia sir, that after 20 weeks of gestation, the fetus begins to swallow the amniotic fluid. The addition of placental transfer of glucose, ingested high glucose amniotic fluid, also stimulates the insulin secretion. So it's the smallest postprandial hyperglycemia, even of less than 1 hour, once a day in a mother, may produce fetal insulin stimulus through oral route for several hours together. So this is a very important, that means a small spike of hyperglycemia in a mother can stimulate the fetal pancreas for hours together because of the ingestion of the amniotic fluid. Then this is another entity what Dr. Shishia has mentioned in his paper regarding the fetal glucose steal syndrome, wherein the hyperinsulinic macrosomic fetus apparently helps to attenuate and normalize the maternal glucose despite poor maternal metabolic control. It provides an explanation why some mothers with fetus will have the characteristic of diabetic fetopathy, but apparently a good glycemic control. So this is again very, very important statement, the syndrome which has been mentioned by Dr. Shishia, that even if you have the normal metabolic control in the mother, you can have the diabetic fetopathy. The crux of this management is the fetus should not come to know that the mother is diabetic. If the fetus comes to know that the mother is diabetic, then the fetus will definitely be affected. So when we talk about the obstetric management, I've already talked, you have to see whether it's a pre-existing or it's a gestational diabetes. The antenatal care has been clearly mentioned by Government of India guidelines. You have to do an anatomical survey if it has been diagnosed before 20 weeks, and definitely a fetal echo is must in these patients if you have diagnosed GDM early, and then definitely a growth scan to rule out macrosomia, and there should be a gap of 3 weeks. Now, if the blood sugars are controlled on MNT, those patients can be considered, those pregnant women can be called on a regular antenatal visits. But if they are uncontrolled, definitely they have to be sent to the higher centers and monitor for abnormal fetal growth, macrosomia, or growth restriction if there is a vasculopathy or there is a preeclampsia, polyhydramnios at each antenatal visit. Then whenever needed, steroids can be given. The only thing is whenever the patients are on high insulin levels, you should admit these patients because the insulin dose is going to increase for another 4 to 5 days when you are putting these patients on steroids. So this is just a chart we have just summarized what all you have to do in the first trimester, second trimester, and third trimester. If the gestational diabetes is diagnosed beyond second trimester, then you have to just do the blood sugar levels and proteinuria and serial growth monitoring. But if it is diagnosed in the first trimester, then you have to just see if it is a pre-GDM, then you have to assess the end organs as well. Now, this I want to really highlight where we don't have the facility of doing uterine artery Dopplers, or we don't have the facility of doing the biochemical markers. This is again the HDP Gestosis India chapter has put in this score where they have given looking at the maternal characteristics, they have done the scoring, and if the score is more than 3, these patients can be easily put on, these are patients at risk of preeclampsia, and they can be put on low dose aspirin and high dose calcium. So this is a very easy chart. This can be followed, although not validated still, but still the lot of publications are there on this, and the India Gestosis chapter definitely supports and promotes this during this. And so I also find it very important and very useful putting these patients on aspirin just to reduce the incidence of. Now, this is a very neglected portion which we usually don't see. Now, born healthy studies are some of the studies which are being done by the government of Rajasthan, where every antenatal visit, they are doing the simple urine test. They are not doing culture, just a multi-reagent dipping test. They see the nitrite or they see the leukocyte esterase. If that is positive, the antibiotic should be given for 5 to 7 days. So asymptomatic bacteria is very, very common in GDM patients. And these patients have a high chance of going into preterm labor and also low birth weight. So these are the recommendations, what antibiotic you should give. Nitrofurantoin, definitely not in the third trimester. Amoxicillin and cephalosporins are drug of choice. And single dose, if you want to give, the Williams code that these are the single dose regimen, amoxicillin or ampicillin or cephalosporins, whichever you want to give. But asymptomatic bacteriuria should be tested in GDM patients at least 4 times during their pregnancy. Now, preterm, again, beta mimetics are contraindicated. We all know nifedipine is a drug of choice. Whenever these patients, maybe due to polyhydramnios or due to infections or whatever, they can go into preterm, then you have to use nifedipine rather than beta mimetics. Again, a little bit talk about the macrosomia, a very important concern. And we see these macrosomic babies despite the good sugar controls, but obstetricians still feel compelled to use ultrasound to guide obstetrical management of pregnancies complicated with diabetes, though we know that weight is has a very low sensitive index. The abdominal circumference is a only sensitive marker for diagnosing macrosomia. Coming quickly to the time of delivery, a well-controlled diabetes, a reassuring fetal condition, expected management, but not beyond 40 weeks. You should deliver these patients, the pregnant women at 40 weeks. Indications, you cannot have a uniform protocol depending on the fetal conditions, depending on the maternal condition. You have to decide about the mode of delivery. GDM per se is not an indication for cesarean section. It's only the obstetrical indications. So indications for early delivery, maybe if you have a previous stillbirth or a diabetic nephropathy or vasculopathy, a poor glycemic control, or you have a weight more than 4 kgs, then definitely elective cesarean is an option. So GDM on MNT, when and how to deliver. A good control MNT, GDM on MNT can be considered as a normal pregnant woman, and they should be left for normal vaginal delivery. Controlled on insulin, definitely 38 weeks, depending on the other risk factors. Again, vaginal route is preferred. So not only the cesarean that you have to do, again, cesarean should be the option only when there is a risk factor. When you have a high insulin, using high insulin, the sugars are not controlled, definitely you can deliver these babies early by cesarean section. Then you have to have it in a high center, and you need to have a good neonatal care when you deliver these patients. The sugars in the intrapartum period should be maintained at 110, because the higher sugar in the intrapartum period will again stimulate the pancreas. The baby will become hyperinsulinemic, and even after the delivery, they will immediately have hypoglycemia. So this is how we do the monitoring of sugar. I have really mentioned here in latent phase on MNT 6 hourly, on insulin 4 hourly, in active phase definitely on MNT 4 hourly, and if she's on insulin, then again depending on the level of the sugar, the timing of monitoring can be decided. So insulin requirement definitely in pregnancy is reduced, but if the patient is a type 1 or sugar levels are high, then you have to use insulin. And this is again a chart I have taken from Government of India guidelines, but they have used for the various values of blood sugar. They have used for 120 to 140, 4 units, and for 140 to 180, you have to give 6 units. And this is a rate they have mentioned in the Government of India and guidelines, and normal saline is the infusion. Again, few comments upon the shoulder dystocia, a very challenging task, a kind of a nightmare, but I really want to emphasize it needs expertise, it needs skilled birth attendant. But whenever you deal a patient of shoulder dystocia, there are certain things that you need to document, because you should be prepared for litigations, because this is very important. So you have to mention about the delivery of the head, how it was delivered, whether it was spontaneous or instrumental, the time of the delivery of the head, then who were the people who were called in the labor room for the help, then which procedures you opted for managing the shoulder dystocia, and also their order. What is the condition of the baby regarding the abscess, the injuries, the birth weight, and any other problem in the baby, and definitely the condition of the mother. So the documentation, if you're managing shoulder dystocia, is again very, very important. The neonatal care, they are more prone for hyperglycemia. All the newborn should receive the essential newborn care immediately. Early breastfeeding is advocated. None of the hypoglycemics are contraindicated. Whatever you're using, or metformin or insulin, you can give the breastfeeding as early as possible. They are prone for hyperglycemia, respiratory distress, conversions, and hypoglycemia. Then for hypoglycemia, it should be tested within 1 hour. And if 4 values are normal, then you can just leave that baby and ask the mother to feed the baby. But if the blood sugar, the baby is not able to feed, then expressed breast milk can be given. And if that is not possible, definitely a cow's milk can be given to the baby. The sugar value should be maintained above 45, but if the values are not maintained above 45 or they fall below 20, then they need a higher center care, and they should be immediately put on IV line. And the 10% dextrose or glucose is given depending on 2 ml per kg body weight. Breastfeeding is not only important immediately in the postpartum period, but it has been seen that it is protective against the hypertension, insulin resistance, and type 2 diabetes, and dyslipidemia and obesity in the child also. So this is very important, that the breastfeeding should be promoted. And these are the other clinical manifestations that we should look in a baby when the baby is born to a gestational diabetic mother. So this is again a very comprehensive chart of postnatal visits. You need to counsel them about the diet, exercise, weight reduction, contraception, GCT, and breastfeeding, because the perinatal outcome of a baby will also, you have to really you have to just look into those 2 generations, the mother and the child, in future as well. So quality statements I want to last put in is just diagnose GDM. Diagnose GDM as early as possible. Whichever test you are opting, you're opting GAI guidelines, you're opting IAD PSG criteria, or you're opting a double step test, whatever test you are doing, just diagnose GDM as early as possible, because we are not able to catch hold of those pregnant women in a preconception period. So let's break the cyclical perpetuation of diabetes. Let's break it. And thank you so much for patient hearing. Thank you so much, all the chairpersons, for your kind patience. And thank you, Dr. Sharda ma'am. We would be happy to have your comments for this talk.
Comment, or chairpersons want to make a comment? So as far as diabetes is concerned, I think, high time has come that we Indian gynecologists do not talk about the Western guidelines. A lot of work has been done. In fact, I will just quote that way back in 1973, I presented the first paper on gestational diabetes mellitus in API conference, and I said the incidence at PGI Chandigarh has been 17.5%, and they said, look who's talking. I said, look, I come from an institute where integrity of data is very, very important. And if today you are doubting what I'm presenting, tomorrow this is the reality. And I feel, it's a high time has come that we emphasize on screening and a single step screening. And very well highlighted by Dipsy, I don't have to repeat it. pregnancies are diabetogenic at the first visit. If you can't find it, repeat it in the second trimester. And if you still can't find it, in the third trimester. And you very well highlighted in case if the blood sugar levels PP is between just below 140. Then also these are the people who are sure they must have a screening in the second trimester and the third trimester, and then you will definitely pick it up. Secondly, all said and done, when it comes to management, gestational diabetes with DIPSI test, has a very high specificity, 98%. Whatever data comes in the Western time, I think, if anybody quotes Indian data and says that there was no change in perinatal mortality, there are no change in cesarean section, is all talking rubbish. You also know, I also know. I've been in this particular game for a very long time. The statistics coming pan-India is very difficult. But we found out, I think all people are sitting here, the stillbirth rate because of missing diabetes have really gone down. And euglycemia should be really the aim. And people like me go a step further, that even if there is a best euglycemia, then also in the last 4 weeks, you can have stillbirths. And that is why the fetal monitoring must get started at 32, 33 weeks. Simple methods. She does her counts, we get an NST done, and we must have a Doppler in the late part of it, so we come to know. Because we all know now, the Doppler comes before abnormality, and the NST will be picking it up later. But whenever we are talking, we should not talk that we are working in a top tertiary center. We should talk of the remotest areas where things can be done. And I think all said and done, आपके कहने से बहुत आसान है कि जी आप 20 हफ्ते से पहले metformin नहीं दीजिए. You take it from me, 99% of the doctors, Indian setting, थेरी में आके कभी कुछ भी बोले, वो आपकी मर्जी है. But the reality है कि metformin, in spite of that, it has not been cleared by the Drug Controller of India. It is the drug which people are using it because many people are using it, and we find that relatively it is safe. I definitely congratulate you when you highlighted when insulin has to be used. Very clear guidelines are there when insulin has to be used. The sophisticated insulins have been not advocated by ministry because the people in this country can't afford it. So, but I find, gestational diabetes, I can see in the last 45, 50 years of my experience is that stillbirth rate have really come down. Otherwise, we used to see, today we are seeing everything is okay. We kept the patient for cesarean section tomorrow, and you come in the morning, the stillbirth, the fetal heart is not there. But I think, it gives a wonderful opportunity to all gynecologists to counsel your patient. Look, if you don't change your things, if you don't find lifestyle changes, it is written on the wall that 2/3 will repeat in the next pregnancy, and 50% of you will have over diabetes. I think this particular thing, we have a wonderful opportunity, which we are not utilizing it at the moment. We should utilize it. And I think, in this particular country where nearly 1/3 of the population is diabetic, and 99% of heart attacks are because of the diabetes. So I think we must get obsessed about it. We should not talk, we are working in India and we talk only of the Western figures. That's not done. We should talk in the remotest area in UP, how are they going to manage it? And that should be our priority. So I feel screening is very important. Counseling at 6 weeks when you find out, she has come back to normal, the counseling is very important. And I feel, as you already said, that the baby should not know that my mother has diabetes. And that's very important, because this euglycemia is the thing. The practical experience, I can say that even if you've diagnosed gestational diabetes, 90% will sail through. They will not give a problem. एक बार पेशेंट को बताने की जरूरत है, मैडम ब्लड शुगर ज्यादा हो गए, फाट से फीट हो जाएगा, कुछ पता नहीं चलेगा आपको. And then she will see to it, and she will bring the chart every time you see her, and then the chart isn't good enough. And very rightly you have mentioned about it, that we should not, even if the best of the control, we should not fast expected date of delivery. If she's complicated, naturally you have to, or if she's on insulin, we have to terminate her early, depending upon the facility we have. बहुत आसान है कहना tertiary center में चले जाओ. Is it not possible? I'm talking of city of Delhi. मुझे मेरे लखनऊ में क्या होता मुझे नहीं मालूम. I have left Lucknow for a long time back. But मेरे लखनऊ में क्या था मुझे नहीं मालूम. But ये वाली बात बिल्कुल clear है. Maternity in the next 5 years or 10 years is going to come to general hospitals. It will go away from private practitioners. So we should think from that particular mindset that what is going to happen in the periphery. And we should talk the reality, what is doable, and not talk sitting in America. We should not compare ourselves with America. Thank you very much.
Thank you, Madam. Dr. Sharda, I just want to share my experience in the Jharkhand, where we trained 240 healthcare workers on the single-step test. Regarding the metformin, most of the doctors are still using metformin. That you have rightly pointed out.
Metformin के बारे में बताना चाहती हूँ, डॉक्टर साहब.
Yes, ma'am.
हमें दस्तखत जरूर लेने चाहिए कि this has not been cleared by the drug controller of India. But अगर आपके पास ये इसमें दस्तखत नहीं करोगे तो आपको इंसुलिन पे जाना पड़ेगा. उसके दस्तखत ले लो और काम करो. दस्तखत लेना बहुत जरूरी है.
And the second thing is, after this training is over, now the rates of the diabetic patients have increased in Jharkhand.
Oh, yes.
So we are still analyzing the data. Hopefully we'll present it in the next month. And the results are just drastic. Thank you, ma'am. Thank you so much.
I would like just to make a comment, Dr. Preeti. It was a very excellent presentation covering all the points. Only 2 comments that we should be counseling our patients, very important. And a comment that a DIPSI should be repeated at 32 weeks, number 2. And number 3, just a mention about the COVID times. As per our data from Lady Harding, we analyzed all our intrauterine deaths and stillbirths and distresses during the COVID. And you would be surprised that having more than 400 COVID positive patients, a substantial number, the bickering was taken by the diabetics. And howsoever we provided them all the opportunity for counseling and telemedicine and e-Sanjeevani and everything, I think the counseling, and with COVID again on the surge, the diabetic patients should be counseled and the telemedicine facility should be provided to them, so that the control is there and they reach the hospital in time.
Yes.
It was really sad to see them losing babies in the initial part of the COVID. That's all. A very well done presentation.
Thank you so much, Dr. Guru.
Thank you. One line from me also, and my salutes to Dr. Sharda Jain and dear Preeti. And really, one only thing is because this HIP or this GDM is such an, or diabetes is such a maximum #1 NCD nowadays in India, is topping the list, and because it is associated with so much of mortality, morbidity. And so it is now our moral duty to do the counseling and awareness, especially in the postpartum period, because till the majority of the patient, they get best of the best care during antenatal and immediately intrapartum care. And once they are discharged from the hospital, that is the point where the lifestyle modification and they are coming back, and the baby care they needs to manage it. And because we have to understand and we have to make it understand to them also, this is a slow motion disaster. So thank you, Preeti. Thank you for such a nice elaborate talk, and thank you, Madam Dr. Sharda Jain, for explaining.
Thank you, Archana ji. Thank you for your kind words.
एक मान से बद्रीनाथ वाला
Hello.
आराम से देख लेंगे यार.
Hello, good afternoon, everybody. I welcome you all to the next session, Breaking the Silence on the Stillbirth. Stillbirth is a nightmare for both mother as well as the obstetrician alike, and similar to the haunting silence and overwhelming emptiness associated around stillbirth. Similarly, this subject has also been a taboo and has never been mentioned in any of the health indicators. However, this silence is being broken in the last decade thanks to the Lancet series, 2 Lancet series. And now reduction of preventable stillbirths is a global priority. And bereavement care and involvement of these mothers who have had experienced a stillbirth and the families is another important aspect of this stillbirth care, as also mentioned today by our chief guest, Dr. Neena Rana, and our FOGSI president, Dr. Alpesh Gandhi. So this in this session eminent, enthusiastic, compassionate experts with immense experience in stillbirth care, and many of them have been involved in those Lancet Stillbirth series are present in the stillbirth session, and I'm sure you will gain from their experience. Dr. Tanvi, our senior resident, will now take over for conducting the session. And as we are already almost 80 minutes late, I will request all of you to please stick to the time. Thank you so much. Tanvi, to take over.
Good evening, everyone. Thank you, ma'am. Now I invite the chairpersons for the session. I'll be giving brief introduction. So for the first session, Dr. Vijay Kumar is the chairperson. He's Executive Director in Survival for Women and Children Foundation, Panchkula, retired from WHO as Director Honors and founded the Department of Community Medicine in PGI. Dr. Pramila Jindal, she is Medical Director, Jindal Women Care, Ludhiana, and was former professor and head of Department of Obs Gynae, DMCH, Ludhiana. Dr. Navneet Thakkar, she is professor in Obs Gynae, GMCH, Chandigarh, website chairperson, Indian Menopause Society. Dr. Rachna Chaudhary, professor in Department of Obs Gynae and Chief Medical Superintendent at LLRM Medical College, Meerut. I request Dr. Pramila Jindal and Dr. Rachna Chaudhary to take questions from the chat box and ask the respective speakers in the further sessions. And now I request Dr. Vijay Kumar to please invite Dr. Priya Karna for the talk. Thank you.
So please unmute. Vijay sir, you have to unmute yourself.
I hope I am audible now. Yes, am I audible?
Yes, sir, you're audible.
Yes,
Yes,
sir,
sir.
you're audible.
I'd like to make 3 points before I introduce Dr. Priya. One, stillbirth is a huge problem in India. In which we have lost, unfortunately, more than 2 lakh people. But the size of stillbirth is close to 3 times the deaths that we have experienced in our COVID pandemic. The second point that I like to make is that the solution for reduction in stillbirth are not easy. They are not just purely biological. We have to think of social, psychological, and behavioral components before we can discuss this problem in a meaningful way. There is silence from the point of view of policy. And as far as we are concerned, we at Swachh record close to 500 stillbirths every year, a rude reminder of the need to do something. Now, I don't want to go long. I have great pleasure in introducing Dr. Priya Karna, who I have known for quite some time. He is currently Technical Officer, Reproductive Health at WHO Country Office in India. It's difficult to summarize her major achievements because there are so many, but the one which I have picked up is the public health skills and data mining capacity, and the fact that she is looking at data to inform the policy. She has received a huge number of honors, awards, and has publications to her credit. Her field of interest is reproductive health and health policy. And I think health policy is going to be the driver of action on stillbirth, which is desperately needed. The silence on stillbirth must break, and as fast as possible. I have honor to introduce Dr. Priya Karna. Please, Dr. Priya Karna.
Good afternoon, everybody, and thank you so much. It is really an honor and privilege for me to be a part of this panel, particularly being introduced by Dr. Vijay Kumar, who has been inspiring and has really helped me personally to be able to present on this platform on stillbirths. I think keeping in time, without much ado, I will reserve my thanks for the end of the presentation. I'd like to begin with our conversation this afternoon, where I will be talking about the overview. I'll be presenting on the overview and the burden of stillbirths, both worldwide, and then hone in a little bit on how that burden, transforms or, adds burden in the Southeast Asia region as well as India. As Sir has very nicely introduced, but I'd like to just say that as a technical officer for reproductive health at WHO Country Office, I do manage the Samarth initiative, which is to strengthen health policy and provide direct programmatic support to Government of India for policy asks. In my presentation today, I'll be first talking about the burden of stillbirths. I want to just share that, we've moved on from a time where we talked about the Millennium Development Goals, which ended in 2015. We are now in the SDG era, which is the Sustainable Development Goals. The Sustainable Development Goals go beyond health targets, and they also incorporate social, developmental, as well as public health aspects, which are a very important part of reaching towards health targets. Unfortunately, as was the case in the Millennium Development and the Sustainable Development era, there are no dedicated targets for stillbirths. However, we were fortunate that many of the panelists that are there in this session, as well as stalwarts like Dr. Raina, Dr. Vijay Kumar, Dr. Neelam Agarwal that presented earlier, there is an Every Newborn Action Plan. It was endorsed by the 194 member states of WHO. And there is a stillbirth target, which runs in parallel to the SDGs, called the ENAP target, which is to reduce the stillbirth rate to 12 per 1,000 total births by 2030. In addition to reducing to a stillbirth below 12, the target also specifically says that there has to be an equitable approach towards achieving this target. And I'll talk about what that really means. But what happened was, because of this missing policy commitment from the MDG to SDG, as you can see in the graph, the progress towards the stillbirth reduction has been much lower. In the first bar that I've highlighted, as you can see, the red dots signify the average annual reduction in stillbirth rate, which is clearly visibly all across the board, whether it's Asia, Latin America, North Africa, even Europe and developed economies like the Americas. The stillbirth rate, the reduction rate, which is simply how much it reduces per year, is very low. It is also because, like Dr. Vijay Kumar said, it's something that is often missed out. People tend to focus a lot on perinatal mortality, maternal mortality, which has received its due, but I think it's time, and I'm so happy to say that we are here discussing stillbirths to really bring the focus on stillbirths. This is not so because of this miss in prioritization. Today there are about 2 million stillbirths globally, which is nearly 164,000 per month, almost one baby every 16 seconds. So you can imagine, in the time that we've had this discussion, how many stillborn babies were there all over the world. Most of these stillbirths, actually account for a lot of the perinatal mortality. So perinatal mortality, early, late, all of it, stillbirth actually accounts for nearly half of it. This burden is disproportionately borne by countries in Africa and Asia. In India alone, even though a lot of it is missed, India accounts for 1 out of the 5 stillbirths globally. which is a very, very high and significant number. We contribute to a large share of live births, but we also contribute to a much larger proportionate share towards stillbirths. In the last 2 decades, despite this burden, there has been progress that has been made. If you see in this map, you can see that countries in the Southeast Asia region, India, Bangladesh, Nepal, all have made progress. The region as a whole, collectively, which is a conglomeration of the 11 countries, experienced a 50% decline, which is quite significant. We halved the number of stillbirths. So you can imagine without focus, we were able to halve it. With focus, where we can reach. Just to give you a sort of numbers at where we are, in just the last 5 years, 600,000 stillbirths were prevented. And this is since the ENAP targets were set. So before the ENAP target in 2014, the reductions were much, much slower. Just these last just 5 years, despite the pandemic, has been able to bring significant focus and higher commitments from the government level to be able to prioritize and take action towards stillbirth reduction. If you see the SEER countries, the Southeast Asia region, which has 11 countries, you can see that across the board, all of our countries have made progress in the last 2 decades. India has made, I think, among the highest given its proportionate share, 53% reduction, which single-handedly brought down the stillbirth rate in the region. I think when the last publication was out and the last data was released for 2015, it looked like India will not be able to achieve the stillbirth target, and in turn, the region won't be able to achieve it. However, in the last 5 years, because of the prioritization, because of the actions that were taken by everybody, by the government, by WHO supporting, UN partners, and most importantly, professional organizations and professionals like all of y'all, this commitment has realized in saving so many lives. At present, as of this day, today, there are still about 492,000 stillbirths in the region, but this number has significantly reduced in terms of its number itself. Now, we must remember that overall burden in terms of number might be something else, but the stillbirth rate against which countries and their progress is measured might be different. So while it's very important to reduce the absolute number of stillbirth through the care that you can provide, it is also equally important that the stillbirth rate is brought down. It's primarily because countries are not assessed on the number of reduction, but really on the rate of reduction, that is the measure against which progress is measured globally. India, like I said, it has made very significant progress. In the last 2 decades, we've halved the number of stillbirth rates from 30 to 14 as of 2020. However, even with this reduction, there are still 340,000 stillbirths that occur every year in India. This is 70% of the regional share. Therefore, any progress that is made in India will automatically lead to progress, not only in the region, but also because India accounts for 18% of the global burden. It will bring down the world at large. I mean, in terms of the stillbirth reduction. So it's imperative, I would say it's absolutely important. And I think even with the COVID, you've seen that, when there is progress that is made in India, it automatically, as a spillover effect, affects everybody, not only the region, but also the world at large. I also want to highlight here that, like I said, the world committed to ENAP target of 12. However, Indian government and everybody here, I think a lot of academics here contributed to this commitment, that Indian government actually went one step ahead and formulated the India Every Newborn Action Plan, which actually aims to have a target of single digit. And this is just so much more, and it would mean so much more. This is in recognition that, simply bringing down the stillbirth rate might not be enough. The numbers are too high. So as you bring down the rate, India has to bring down its stillbirth rates to less than, single digits, basically. So today we are at 14, another, I would say 9 years more to go to bring it down by additional 5 points, which is quite significant if you see as to how that translates in numbers. That was about the burden and really what how much, what are the numbers of stillbirth. Let's look into a little bit of what are the prevention strategies, or what does the evidence say that can be done for stillbirth. I'd like to start first, just to take a step back and say, what does the definition of stillbirth mean as per WHO? If you start from the onset of pregnancy all the way to delivery, once 22 weeks of gestation are completed, or the birth weight is more than 500 grams, whichever is sooner, and in case either are not available, then a body length of more than 25 centimeter accounts for an early stillbirth. From 22 to 28 weeks, that's the period for early. 28 weeks is really when we take anything after 28 weeks, more than 1,000 grams, or body length more than 35 centimeters, qualifies as a stillbirth. I mean, technically it is early and late. However, so that there is international comparison, different countries, some have 20 weeks, 22 weeks, 24 weeks, etc. So for our international comparison, bearing, plus minus the way people measure across countries, we take 28 weeks as a cutoff for stillbirth. That's when we actually look at, so every other calculation, whether it's stillbirth rate, it's looking at numbers, it's looking at any strategy, effect size, everything starts at 28 weeks of gestation for international comparison. I'd like to also talk a little bit about antepartum and intrapartum stillbirths. Although they are often interchangeably noted as early and late, that is not accurate in terms of the definition. What antepartum stillbirths really mean are those that occur prior to labor. It could be early or late. However, intrapartum stillbirths are really the ones that occur after the onset of labor. This is important because when we look at prevention strategies, you'll get, I'm sure you already know, but I'd like to present on what this evidence and what is an internationally accepted standard and what that means in terms of prevention of stillbirths. If we look at intrapartum stillbirths, remember I said that anything that starts on or after the onset of labor, 3/5, that is 3 out of 5 stillbirths, they occur at the time of delivery or in facilities which are considered to be intrapartum. Now, there's a lot of evidence on the 3 delay model, etc., where people might take time to reach the facility. There might be delays in seeking care. However, given all of that information and evidence that we already know, we still see that about 60% of stillbirths are really intrapartum, and that is true for the Southeast Asia region. As you can see from the graph here, this is much higher than what the global evidence says. This is also highest in terms of how we compare, and even 10 points higher than the region in Africa. Remember that India accounts for 70% of this regional share. So you can imagine how high that number must be. I really want to take a moment here to point out what the previous speakers said. Madam talked very nicely about, you have to really think about the last mile. Think about the last person, the person who's least likely to receive services, and design public health strategies according to that. And that's really where we must remember. I mean, if one thing you can take away from my presentation today is that particularly in the periphery where there are health system challenges, where there are accessibility challenges, this is where the stillbirths are happening, and there is something that we can do about it. If we look at risk factors, they spread across the spectrum, whether it's antepartum, intrapartum, a lot of overlap, but consistently in our region, we find that advanced maternal age, infections, weight, diabetes, hypertension, all of this contributes to stillbirth. I do want to acknowledge the session by Dr. Preeti and the previous session on aneuploidy that really broke down, what that is, how do you identify it? And I really must reiterate that tackling things like diabetes.
Excuse me, Dr. Priya.
Yeah.
Can you hear me?
Yes.
Ma'am, the time is already up, please. Can you please hurry a little? Thank you.
Sure.
Thank
Sorry,
you.
I think I'm taking too much time. I hope my slides are available to everybody. I'll leave them with the organizer. So if you want to really go into the evidence, you can.
Yes, that will be very helpful. Thank you so much.
Sure. So before I'd like to take a moment to just show you that, there are all of this evidence that is there in the slides that you can look at, you can use, that is there and that is available for anybody who might be interested. Of course, at WHO, we are available to support, and we've had very good working relationship in the past. A very good example of that working relationship is really the stillbirth surveillance. PGI Chandigarh started it in 2014, 2019, and it was expanded. Dr. Vijay Kumar is here. Swachh does population-based surveillance together with WHO. That has really gone a long way in creating the evidence that is needed for stillbirths. Without going into a lot of these opportunities and others that may be there, I'd like to just take one moment here that COVID has disrupted services, and we know that there is additional burden or additional stillbirth that may have happened during this time. But when there are crises or other situations like this, there are also opportunities. Government of India has been pretty straightforward in setting up essential health services, and as WHO, we have supported in consultation with AIMS, PGI, and a lot of other centers in setting up the SCOPE study, which is to look at COVID and pregnancy outcomes, which includes stillbirths. I don't want to go into how much gain and things that we can make, but these slides would be readily available to you so that you're able to use them. Simply the message is that, that there are high impact interventions that go really at the periphery that can be done, that must be done in order to prevent and manage stillbirths. I'd like to leave you with this slide here and end my presentation. WHO has a lot of resources. We have a tutorial on the ICD classification on perinatal mortality to better look at stillbirths. We also have data sets that are readily available for analysis. If people are interested in looking at it through their PG or UG, etc., you can still go there. And then, of course, the Lancet series. I think that has really...
We're running very late. If we can wind it up fast.
That's all from my side. Thank you so much. I think that there is the movement is there, and I think as India, we can progress, and as WHO, we are happy to support and welcome this opportunity. And I really want to thank the organizers for having me here. Over to the organizers, I guess.
Thank you, Dr. Priya Karna. That was really enlightening talk. Now I request Dr. Navneet Thakkar to invite Dr. Nuzhat Aziz for the next talk.
Very good afternoon, everyone. It gives me great honor to introduce Dr. Nuzhat Aziz. She is the head of the Department of Obstetrics and Gynae and Telecare at Fernandez Hospital, Hyderabad, Telangana. Her field of interest is obstetrics and high-risk obstetrics. She has formed protocols, teaching, training, and prevention of stillbirths. I've got to know lately that she has done great work on this. So maternal morbidity reduction and even customized growth charts. So you know that stillbirth is an unspoken grief. And sometimes the cause is fetal growth restriction, and it is a missed cause sometimes. So on this area, our speaker will be giving us light, and her topic is fetal growth restriction, screening for better outcome, and she'll be throwing light on the GAP protocol. Dr. Nuzhat Aziz, please.
Thank you, Dr. Thakkar, and all the other chairpersons. A big thank you to the YUVAFOGSI team for inviting us. Can I share my screen? Yeah, thank you so much. Okay. Are you able to see my screen?
Yes, ma'am.
Yes.
Thank you. I just will put it up onto the...
We can put it on slideshow.
I will do that. So over the next 15 minutes, we are going to talk about, how the evolution of fetal growth restriction screening or SGS screening evolved in our institute. And my overview would be fetal growth restricted stillbirths, what proportion, how do we screen, what is the current evidence, and how does it help to put a system in place, especially if you have a big unit, and what has been our experience. The probable preventable stillbirth, if you take a look and you go into the research, then you find that a big proportion, maybe 1/4 of them, are FGR or SGR or placental factors that are there. And this is what we would be trying to kind of focus on. And just to introduce our hospital, it's a journey of 1948 to the current day. And we started as a 2-bed to a 300-bed story. We are a single specialty, that is obs and gyn and newborn care. And we do about 10,000 births annually. And I'm going to take you back to 2012 and give you a kind of a story. At that point of time, we had a stillbirth rate of somewhere around 8.7 per thousand. And I'm going to take more than 28 weeks. And this was here at the 61 stillbirths out of 7,200 kind of births that we had in that year. If we take a look at the stillbirth rate per thousand, and I go back to 2005, we were hovering around at this point. And we take 24 weeks and above, but then we do have a referred criteria. And anytime we would talk about it, and the team would say we have such huge number of referred population, and then we would never improve. So I removed the referred population and again started creating graphs to say that where do we stand. Were they antepartum or intrapartum, we would have on an average 1 to 2 intrapartum stillbirths, and we could reduce it down over a period of time. We were doing cardiotocography training, we were doing fetal blood sampling, and we had midwives over the journey. And if they were entirely antepartum stillbirths, how do we reduce our rates was the question. And I do understand that there is a session of ICD perinatal deaths classification, and I think that is the best currently. But just to maintain our graphs and uniformity of comparison, we have still been using recode classification. If we take a look, 27% were unexplained at that time, and 21% were SGO or FGR. That is how they were categorized at that time period. Now, if we take a look at this FGR stillbirths, then the question came, did we detect all of them in the antenatal period? And the answer was very sad that many of them were not, and many of them were in a good gestational age that we could. Just to give a little background again, we work as a team of around 60 doctors together. We have an electronic database. We had everything that was required for a good monitoring tool, and we should have had comparative stillbirth rates as the UK or any other unit that has 3 or 4. So we started our journey at this point of time, and we had very good fetal medicine unit with protocols backing us up. So the journey started 8 years ago when we approached the Perinatal Institute, because a lot of talk was going on reduction of stillbirths in UK, and we reached them and asked them whether you would like to help us. And the first question he asked is, what is your SGA detection rate? This was the first time that somebody had asked a question like this, and I really did not know how to answer it back. And I told him I would go back and just do a audit and get back to you. And it was very shameful believe me, we thought we would do good antenatal care. We were just on an average, 50% of the babies that were being categorized as birth as SGA were detected in the antenatal period. So this was a kind of a shock that came to us. The second question that they asked was, what is the tool that you are using to call it as SGA? Now we have multiple things available. What is it that you are choosing? It is for you to answer that question. But then we had a big study done, and in 2012, we published our neonatal centiles chart for Fernandez Hospital, which would be a South Indian population database, and we were using our own population centile chart. We did not have customized centiles, but if you take a look, and these are two of my colleagues, and I belong to a category that is given as a short one. So we do have tall mothers, and we do have a lot of cute mothers. So it is not that we are uniformly in a subset. So then we asked them whether we could have the customized centile or done for our population or our hospital data set. And in 2015, we were given the Indians ethnicity centiles along with our database for SGA and FGR detection rates. So what kind of screening protocol did you have? And we did not have a screening protocol which was uniform across the table. We thought everyone who places a hand on the abdomen of a woman was doing a good kind of a care. And we would use the ulnar border. And if somebody applied a little more force, it would look small. If they did not apply, it would look a little more, bigger baby. So what kind of a routine growth scan do you do? 34 weeks. After 34 weeks, how do you identify that the baby is not growing? Did not really have answers for this. Now, the logic behind detecting SGA is if you detect SGA, that is FGR detected, it has a very low stillbirth rate when compared to FGR, which has not been detected. So this is the logic that once you put on a surveillance protocol, we don't lose babies. So the growth assessment protocol was a training certificate that we got for the entire team, 100% certification they wanted. And the components are risk stratification for SGA in your population, standardization of symphysis fundal height measurement. We had to do multiple training sessions, customized charts, grow charts for plotting the symphysis fundal height as well as the estimated fetal weight. But we had to do plenty, almost an year or two we took to interpretation and training, and then auditing your rates. Now, by that time, the stillbirth prevention bundle had come, and we do have a session on that. But I would like to know that each one of you to know that we were doing this very patchy. We were not applying it uniformly to all. And a bundle is something that we have to apply it very uniformly across to every person, every defined population and time. So if a woman comes across at 11 weeks to your care, how is it that you are going to put it up? So we are taking the growth assessment protocol from the NICE guidelines as it is pretty well done, did not have the need to adapt it. Low risk population and high risk population, the risk factors, and a low risk population would be on symphysis fundal height, and the high risk would go across to. But what was happening was the risk factors were getting missed. So we had to get this chart into our electronic database, wherein if you tick over here, then you will get it over here as a risk factor, chronic hypertension, and which would come right on the dashboard, which would be visible at all times. So important it was that if there were no risk factors, then you would do a serial fundal height measurement. But if there were risk factors, then 3 to 4 weekly, we were doing an ultrasound. And depending on that, what it would be. Now, moving across from here, we also had to standardize fundal height measurements. I am sorry about my slide. It has suddenly changed its color. But then this was no longer applicable to use the hand. We started using the tape. We were not using the tape prior to it. So we have to train people. Now, the most important one is that 70% have no risk factors for SGA, and using both your hands, like we do for fundal grip, and identifying where is the peak of the fundus is the best possible way. Holding your tape down and pulling it to the symphysis pubis would be the best possible way to do it uniformly and have less of variation from one to another. Now, moving across to the chart that we were given, the chart has symphysis fundal height, estimated fetal weight on the other side, and it is done based on the height and weight of a woman, ethnic origin, parity, and the expected date of delivery would be coming over here. These are the points that you need to check. The chart has to be plotted, and the trend is very important. If the trend is going on very smoothly and suddenly you find a static or a falling weight, then that is the time you will ask for an ultrasound. Maybe it is oligohydramnios, or maybe the baby has. Slow or falling of the curve also can be an indication for you to call for, or a cross which is coming way below the 10th centile for that mother and the baby. You have to do an ultrasound. I'm just putting up an image. This is a young woman, first time, but she's 140 centimeters. And every time we did an ultrasound for her, we would get a fetal growth restriction. But the minute we would put it up on customized chart, she would always come absolutely normal, and we could deliver her at 40 weeks without any problem. No Doppler abnormality. The two questions that you ask when they come for delivery is, did you suspect FGR? Like, for example, here we did suspect. Was it detected? This is detected. Then we are going to answer the question as yes to both. So this is something which became an auditing mechanism. And for the remaining 30% of the high-risk population, we would do a serial ultrasound assessment, and we would plot it up and to say that for this woman, okay, this baby is not appropriately grown. We had to put in protocols, we had to get in charts, sometimes we had to put in checklists in each of the outpatient department, but the results came in pretty soon. Now the SGA detection rates after April 2015, we started at 50%, and the topmost line is the high risk unit. They are always better at detecting SGA, whereas the low risk unit is not very good because they think everything will go on fine, and they are poor at detecting any abnormality. So we did pick up pretty well. And if you take a look from 50%, we have right now at around 65% detection rates. And our stillbirth criteria is more than 24 weeks, Dr. Priya, and then more than 28 weeks for international comparison. The minute we introduced GROW, then we did have a fall, and we went down to 2.5 per 1,000 stillbirths for more than 28 weeks, and that was a kind of an achievement. If we take a look at the reduction at every gestational age, we found that the reduction at almost every gestational age, including the term ones. If you take a look at 1.7 to 0.4, 1 to 0.7, 2.9 to 0.6, and it was a reduction, which was significant at term. When we took a look at all non-anomalous baby, where we could put it up together, we found that 50% of all the stillbirths that we had in our cohort belonged to FGR. That would mean that amenable to a detection in the antenatal period. It was also very essential that we understand that detecting a SGA baby in the antenatal period would also help you in lowering your adverse outcomes, like, for example, low Apgar, meconium staining of amniotic fluid, metabolic acidosis, because when we suspect an FGR, our response or monitoring or watch will be different, and when we don't, it is going to be very different. Now, if we take a look way back to 2020 and take a look, or 2018, I think I've written over here. So what has happened is the unexplained thing chunk reduced a little bit, and our FGR group, okay, which became much more better. But that is what we want, a cause which we can act on and prevent in the antenatal period. If we ask ourselves, where do we fail? We fail terribly bad at term gestational ages. This is the time where nothing can be done, and that's why we leave it, because we don't try saving the babies at this point. But this is the point where we fail, and that's why we deliver them at 40 and 41 weeks, because we did not think that this baby was small. The reasons for not detecting is an ultrasound error, failure to use the growth chart, they were not doing the symphysis fundal heights, or failure to identify risk factors. So we wanted to attack the system and then edit it wherever the system error or a system can, watch over the error and prevent that insult to the mother and the baby. So over a period of time, it has been a kind of team effort. It cannot be just gap, or it cannot be only ultrasound, but it has been a huge kind of an effort from every aspect of the hospital teams, whether it's Astria software, whether it's Barcelona calculators, or whether it's a change in fetal growth restriction, or the Perinatal Institute, which do an analysis of our SGA detection rates and give it to you. So today we stand at 2.5 has gone up to 3.5 in 2020. And the COVID has moved our stillbirth rates up. It was very difficult for almost 3 months to carry on antenatal care during this point. We have had an increase in our term stillbirths, but we do analyze each unit with the number at what gestational age, and we introspect every baby if there could have been a possibility of avoiding this stillbirth. So in conclusion, GAP, it gives us an incidence of SGA as 9.9, which is what we want, 10% of our population. It definitely increased our SGA detection rate, decreased our stillbirth, and it has had a major impact on more than 32 weeks SGA. And it also led to errors, being picked up, and promoted better training for fetal growth. So we acknowledge the support of Perinatal Institute for all the help. The scope of success, as my speakers before have pointed out, is tremendous. If each one of us, the way we are working today, continues to work maybe a year more, we will see a huge number of reduction. So I would like to end by saying that to be able to prevent just one stillbirth has been a hope and a calling and a mission, and no matter what it takes, it has to be done, and it has to be taken care by each one of us. Thank you so much for this time and this opportunity, the invitation to present our data to you. Thank you so much.
Thank you very much. Dr. Rachna for the questions. Over to Dr. Rachna.
Great talk as always, Dr. Nuzhat. And I don't see any questions in the chat box.
Can I ask one?
Yeah, sure.
Can I?
Yes.
I always had this, I read in one article that NHS, UK service, like the health NICE, and they had stopped taking weight of the patient at every antenatal visit, and later on they realized that if they didn't take the maternal weight, they missed IUGR. So can you tell me how weight plays a role in your charts and all that? Maternal weight gain in pregnancy related to fetal growth restriction.
The only way, I don't have evidence to say, there was a study which I had done long time back, a zero weight gain in pregnancy. I had done a big chunk of population wherein they never put on any weight, but I haven't done 2 kgs or 3 kgs, but zero weight gain or minus weight gain in pregnancy. And we had find a lot of diseases, and especially like tuberculosis or, fetal growth restriction was very high in them. But in our protocol, COVID has really reduced the emphasis on weight, but we do check. And if we find that there has been a very poor weight gain during the pregnancy, we do ask for an ultrasound if we are missing it up. But we hold on to our protocol, and it allows us to do it with a tape, and we are pretty confident with that. The mother gets really worried with poor weight gain. They have a weighing machine at home.
Yes.
Thank you so much, ma'am. It was wonderful to have you here on screen. So we should move to the next talk, please.
Thank you so much.
So I invite the chairpersons for the next talk, Dr. Pratima Mittal, Professor of Department of Obs-Gynae at VMMC and Safdarjung Hospital, New Delhi. She is President AOGD 2015 to 16 and President in FOGSI 2018. Dr. Kiran Pandey, Professor and Head of Department of Obs-Gynae at GSVM Medical College, Kanpur. She is President of Kanpur Menopause Society and ICOG Governing Council member 2021 to 2022. Dr. Sujata Sharma, Director Medical Education and Research and Professor and Head of Department of Obs-Gynae at GMC Amritsar. Madam is President of Amritsar Obs-Gynae Society. Dr. Richa Kansal, Professor and Head of Obs-Gynae, Kalpana Chawla Medical College, Haryana. I request Dr. Pratima Mittal to kindly invite Dr. Rakhi Dandona for the talk. And I request Dr. Kiran Pandey, Dr. Sujata Sharma, and Dr. Richa Kansal to kindly take the questions. Thank you.
Thank you, everybody. And good evening, everybody. First of all, I would like to thank Dr. Vinita Suri and Dr. Neelam Agrawal Bharti for inviting me to this, conference. And secondly, I'm really happy that the stillbirth, which are a neglected, often neglected entity, has been given such an important session here. And talking of stillbirth, before I introduce the speaker, I would just like to highlight that we at Safdarjung Hospital, with the 7 hospitals of Delhi, are doing a stillbirth registry since 2015. And before that, even we were doing the work with PGI Chandigarh. PGI Chandigarh is doing a stillbirth registry for about 10 to 11 major hospitals of North India. And our stillbirth rate of more than 28 weeks of pregnancy is about 24.8 per 1,000 births. And if you take 20 weeks as was taken in our study, it is about 29.3. But with the advent of COVID, it has really increased, because most of the patients who are coming to us are, not having any antenatal checkup. And so dealing with this situation, the understanding the burden of stillbirth in India, that will be the topic of talk of Professor Seema Dandona. I would just like to introduce her. She's got a very impressive CV, I must say. She is a professor of public health and professor of health metrics. And she is a public health, associated with the Public Health Foundation of India at Gurugram, and also associated with Institute for Health Metrics and Evaluation at University of Washington, Seattle, USA. Her major achievements are too many. She's been listed in the Stanford Mendeley database of the global scientists of 2017, 18, and 19. She is a leading population epidemiologist researcher in India, for over 20 years with grants from NIH, USA, and Wellcome Trust UK. She has got a lot of work done on, blindness and HIV/AIDS, and she is associated with the editor for injury prevention and on the editorial board of the Lancet Psychiatry and Lancet Public Health. Also, she has got she's member of many technical advisory groups, especially of WHO and the Government of India. She has more than 250 publications, including the publications in the Lancet, JAMA, and PLOS Medicines. And her field of interest is definitely newborn health, stillbirths, suicide, mental health, and health system equity. So over to Professor Rakhi Randona, who will be talking on understanding the burden of stillbirth in India. Professor Rakhi, please. Professor Rakhi?
Just what is, I think some network issue. She's joining soon.
Hello?
Someone from the organizers, please contact her.
Ma'am, I'm on call with her. Just a minute.
Till she joins, we can really talk. I really want to thank Nusrat, who has really brought out many, many important points in her previous talk, and Priya Kanan also. She talked a lot about the global, statistics, which are very, very important. And our stillbirth rate is also, we are planning to, introduce the preventive strategies, and definitely it is going to work very hard. We are going to bring the stillbirth rate to less than 12 by 2030.
And she's online.
Okay. Good.
Good evening, everyone. There was some issue. They had to promote me as a panelist. Thank you so much, Dr. Mittal, for that introduction. Those were very kind words. Thank you so much. Thank you to the organizers for inviting me, especially Dr. Neelam Agarwal. Thank you so much for bringing this attention to stillbirths. I will share my screen now. Can you confirm you can see my screen, please?
Yes, we can see, yes.
Awesome. Thank you so much. I'm going to talk about understanding the burden of stillbirths in India. And as you would see, I've heard some other presentations where a burden was talked about in terms of numbers. And I'm hoping to expand the definition of burden a bit from taking from the numbers, the rate, and then to the parents, the emotional burden that parents have with stillbirths. Stillbirths, many of us know, can be classified differently, but more often, given the global comparisons that we make, it's 28 weeks and later. So it's a late gestation stillbirth is what we talk about, and that's what I will deal with also today. Unfortunately, in India, like many other developing countries, this is more or less provided by verbal autopsies because our stillbirth documentation in facilities is not very good. I'm not talking about big centers like AIIMS or PGI, but these are the public sector facilities where many of the deliveries happen. And much of our stillbirth data at population level comes from verbal autopsy studies, which basically define a stillbirth as a baby that did not cry and did not breathe and did not move at birth. And as you can imagine, there's always some misclassification between early neonatal death and stillbirth. As I mentioned when I started this conversation, that we hope that stillbirths are not many, but as many of the speakers have already mentioned, it's a big burden for India to take care of. Unfortunately, they are not rare, but they still get missed. This was the report, recent report published on the global burden of stillbirths, one of the many, few ones actually that talk about stillbirths, a global comparison across the variety of countries, including India. And not surprisingly, there are 6 countries that have the entire burden of the global stillbirths, and India, unfortunately, is one of those countries. Not surprising, but yet unfortunate. I will talk about the burden of stillbirths now across the different data sources that allow us to identify stillbirths, report of these stillbirths, how we review the stillbirths to understand how do we make sure that a next stillbirth does not happen in terms of figuring out the actions. What's the magnitude of stillbirths in India? India, the Indian policymakers, the Indian program planners use SRS estimates, the child mortality estimates, to plan programs. If you look at the SRS data from 2000 to 2019, the SRS reports the stillbirth rate at 8, which is now up to 4. In comparison to the UN report that was released last year, the rate in India was 30 in 2000 as compared with 8 reported by SRS, and 14 in 2019 as compared with 4 in SRS. So clearly there is an extent of underreporting that is unimaginable. In 2014, in fact, after the Every Newborn Action Plan was rolled out, India rolled out the India Newborn Action Plan, and this has been very futuristic plan, long-term looking plan, and it actually had an SBR target for 2030, less than 10. So despite of MDGs and SDGs not talking about stillbirth as a target, the India Action Plan actually has a stillbirth target, which unfortunately gets overshadowed because people simply look at the NMR reduction target. And very interestingly, to achieve this target, even for this report, the organizers and the researchers who took part in this work to develop this report had actually assumed the stillbirth rate of 22 in 2009 and said that they would want this 22 to become 10 by 2030. The point I want to make here is even within the ministry, within the researchers that developed this report, SRS data were not considered. They considered model data because there was acute realization that the SRS was underreporting stillbirths by a huge margin. If you look at the UN estimates, the decline from 2000 to 2019 has been impressive in India, 53% decline. Now, if I compare this decline with neonatal mortality rate decline over the same period, which was actually only 40%. So in fact, India has done better in stillbirth decline as compared with neonatal mortality rate decline over the same period. The current rate is 13.9, which is 14 stillbirths per 1,000 births. And as you can see, there is a 95% range, which ranges from 11 to 17. It is anywhere in between those. And because India, as we know, is such a large country, the states are so different. Kerala would have a very different rate than, let's say, UP or Tamil Nadu. So this is the national average rate, which does not reflect the wide variety that we are likely to have at the state level. If we translate this rate into using the birth rate into what's likely to happen in India every day, for the 74,000 births in India that occur every day, 1,000 parents do not take a live baby home. So these are the stillbirths that we talk about every single day. I've already talked about the significant underreporting in SRS. Unfortunately, in the CRVS, which is a vital statistics where the stillbirths have to be registered by the health provider, and then there's a registration certificate that the family is supposed to take. Even in that, only 45% of all the expected stillbirths were actually registered in 2019. So there's underreporting in SRS and there's undercount in CRVS. Which is why we are unable to figure out the actual burden of stillbirth in terms of either rate or numbers. So if you imagine these are all the babies that are born in India, some of them disappear in SRS because we never document them. Some of them disappear in CRVS, And these are the only babies, stillbirths that you see. And this seems like a small number. And hence, they are invisible. We need to count them to make it visible and to talk about stillbirths as a burden. If you look at the data around risk factors or even the demographic data, we need those data to understand what went wrong. And these data are of two types. One is clinical. Many of you have talked about clinical risk factors and what you do in your clinical practice. But to understand what went wrong at population level, we have very less clinical epidemiology understanding at that level. Even the NFHS, which is used by the government to monitor the coverage indicators for the service delivery, the pregnancy details are documented only for live births. If a mother reports she's had a stillbirth, NFHS does not document anything. So there's a wall. As soon as someone says she's had stillbirth, there's no other documentation. So clearly her pregnancy is considered less important for documentation just because she's had stillbirth. Then we have the audits of perinatal mortality audits. And just to understand, what went wrong and what can we do so that that doesn't go wrong again. Many of us who work within the system, and I'm not talking about hospitals like PGI or AIMS, but many of us who have exposure to systems that are far remote, we understand that this audit system really doesn't work as well because of the accountability issues and because of the punitive nature of the way the audit works. And which is why we fully do not understand how can we prevent these stillbirths. Unfortunately, to add to that is also that many times neonatal deaths are also shown as stillbirths because the logic for the health manager, for the facility manager is fairly straightforward. If it's a stillbirth, you couldn't have done anything to prevent it. And that's the mindset that we work with. And hence the audit stops there. There is no punitive action. So when you look at some of these data that come from HMIS, it's very difficult to understand the extent of misclassification of neonatal deaths as stillbirths. Classification of stillbirths as intrapartum and antepartum, clearly an important area to understand if we need to prevent and have actions around it. One of the previous speakers did highlight how India has a larger chunk of intrapartum stillbirths than expected around in the same region. But very interestingly, again, most of this data, the clinical data is really less, and much of this data actually comes from a variety of studies that are based on what the mothers have informed, because we really do not have a tracking system and good clinical records to understand what actually went wrong. So this was a study undertaken by us in Bihar a few years ago now, where we showed that if you were to take information from the mothers and give priority to the movement feeling by the mothers, as compared with the appearance of the babies, this is how the distribution of antepartum and intrapartum deaths would look like. However, if you give preference to the description of how the baby looked over the baby's movement, see how the change happens. And we were not the first ones to demonstrate it. This has been demonstrated in other developing countries, mostly in Africa, clearly highlighting that we need to have a system in place that actually documents all deliveries, irrespective of the outcome, well enough so we understand clinically, we classify them clinically robust enough to understand the proportion of intrapartum and antepartum so that we can actually make a difference in terms of action. These are the risk factors for stillbirths, again, coming from a very large population-based assessment in Bihar. And for the first time, two types of risk factors were highlighted, which were not clinical to begin with. These were the deferred deliveries and the referred deliveries. This basically meant that women went to the hospital or the facility or to a health provider saying that she's ready to deliver. And she was sent back by the health provider saying, no, go back this time for delivery. And many of these women had a higher chance of having a stillborn baby later. We called it deferred deliveries. And the other one was referred deliveries. In fact, the proportion of women who were referred, so she went to one facility or provider for delivery, but she was referred to go elsewhere for delivery. So there's a time lapse between when she went first and where she went for referral. nearly 30% of the women who had a stillbirth actually were referred, as compared with only 6% overall referral. So clearly, the time gap between referral from one place to another also made a difference, which is similar to deferred deliveries, where the time gap when the woman should deliver and when she actually delivers actually makes that the golden period where stillbirth actually happens. What was unfortunate in this study also, what we documented, was that some of the health providers actually refused to deliver a dead baby. Once they figured out there was a dead baby in the womb, they wanted the mother to go elsewhere to deliver, which was very unfortunate to know, but that's a reality out there that we have to be wary of. All of us know there are COVID-19 implications on maternal and child health, clearly on child mortality and maternal mortality. And there's already a concern that the stillbirth rate is likely to have gone up with COVID-19. And if yes, if women are being referred more, if women are deferring more, it's likely. Now we actually have some evidence, global evidence. This paper was published in Lancet Global Health last week, which looked at all the studies on maternal and child health that were published between 2020 and 2021, January to January, all variety of studies across the globe. And they did a systematic review. They found an increase in stillbirth risk by 30% in 2020 from the studies that they discovered. Of course, the studies were variety. They were less population-based, more facility-based, but there's a clear indication. We knew the stillbirths would go up, and now there's clear indication that yes, at least 30% have gone up. We have to now wait for population-based assessments to understand if this 30% is more or less if you look at it at a population level. The risk factors for stillbirths and the interventions that are needed are more or less similar for early neonatal deaths. The population-based assessments have actually shown that the risk factors for stillbirths and 0 to 2 days neonatal deaths are more or less similar, which means that what you do to prevent neonatal deaths is actually working to prevent stillbirths as well, especially the intrapartum stillbirths, which is what's reflected in the decline that you see. So even though India wasn't really focusing on reducing stillbirths, it still did, because we focused so much on reduction of neonatal mortality. In fact, we've done better in stillbirth reduction than neonatal mortality reduction. What's needed is the mindset. It's that we need to start talking about stillbirths. We need to start documenting stillbirths. We need to start counting stillbirths. We need to understand that these pregnancies are real and the women who deliver these babies are real. Otherwise, there's not much that we actually need to do very differently until we get to the antepartum ones, which again goes back to antenatal care and high-risk pregnancy detection, which is also not very different from what you would do for any woman that walks into an ANC clinic. Parents, we do not really understand much also around what happens to the parents. What's the burden on parents? What happens to the lady who comes to deliver a live baby, but is told that her baby is dead? There are some global studies done here, which you can see the red ones, where it highlights that many times we kind of tell the women to forget and get pregnant again. There's taboo on discussing stillborn babies. There's taboo on telling the mother that she's had a stillborn baby. So there's variety, but unfortunately in India, we still do not understand very well what's the burden on mothers, what's the burden on fathers, what's the burden on siblings who are excitedly waiting for a brother or a sister to show up and who does not. In most of the work that we've done, and we've interacted with many others in India, almost no stillborn baby is actually shown to parents. Baby is not held in arms. We don't understand much about the last rites, what actually happens with these babies. And that's the understanding that we need much more to understand how do we deal with this burden that parents go through when they have a stillborn baby. So clearly we need to move beyond telling the mother that she needs to get pregnant again or forget the baby, but actually get more data to understand how do we make parents involved in this so that they talk about the babies, we talk about the babies, so policymakers actually listen and take action for these babies. So I will end my presentation to kind of put this perspective that we understand enough about stillbirths, but yet we need more and better data to make sure that how do we prevent them. We need better numbers, we need better counting. So we start with the magnitude. We need to count these babies. We can't simply just ignore these babies just because they were born dead. So report them, count them. Risk factors and causes, we need to improve our clinical data. We need to consider stillborn babies when we do our perinatal mortality. We need to get back to our accountability issues and actually take stillbirth seriously so we understand clinically more things so we can prevent these stillborn babies later. And of course, the grief. If we are not able to prevent it, there will still be parents, maybe not 1,000, maybe less than 1,000, but they will still be parents. And we need to try to now understand how do we make them help to deal with their grief. Thank you. Thank you for your time.
Thank you, Dr. Rakhi. It was a really wonderful presentation. I do not find any question that has been posted in question answer box. But I'd like to comment upon that this is a very important topic and that needs to be brought up and thought upon, as you very well emphasized.
Thank you so much for that.
Dr. Rakhi,
And
organizing, can I make one comment and a question also?
Dr. Pandey, I can hear you, but very, very feebly, please. Can you speak a little louder? Thank you.
Yeah. Are you able to hear me now better?
Slightly better, yes. Thank you.
Okay. Actually, I just wanted to ask one question, but before that, I would like to congratulate Dr. Rakhi. She has given a really wonderful talk, very informative, and many questions which she has raised, unresolved questions, and specifically the last part, the grief, etc., is a very, very important things which we should all take care of it. And she's very right in pointing out that as soon as one hears that it is a stillbirth, we give less importance, which otherwise we should have done. We should have given more importance because this is the need of the time, and the documentation part is also very good. Well, I just wanted to ask one question because I'm in a medical college and many times these problems do come across. That what happens, what do you think officially is that these babies should be given a death certificate or not? Because when the babies are being handed over to parents, many a time when they are going to do the last rites or something, they need some certificate. And actually, we are not able to understand the causes and many things unresolved. So I just wanted to have what is the official thing about it? That should they be given a medical death certificate or not?
Thank you so much for asking that. And that's so important because it ties to the undercounting that I was talking about. So with the CRVS now, which is the government system of registering a birth and a death, the portal itself, so the facility is meant to register, like the birth registration happens, there is a stillbirth registration option also on the CRVS portal. But unfortunately, irrespective of the facility that you see, stillbirths are not registered in the portal. So the government is unable to capture the numbers, and that's why you see only 45% are registered. That's one bit on the portal. But then the parents are also meant to get a certificate, which is a stillbirth certificate, which is different than a death certificate. So there's a special certificate by Registrar General of India for stillbirths. But because these babies are not put on the portal, that certificate is not generated for families to be given. So the undercounting continues. And you also raised a very important point about last rites. I didn't mention much about it here because we fully don't understand, but our recent work in UP showed us, we asked many women, how did you cremate the babies? What was very interesting, and I don't fully understand it myself when we're trying to get into details, is we were informed that according to Hindu culture, Hindu religion, unless the baby is 1 month old, you do not do the usual rites as you would do for a baby who died after a month. Maybe these are coming from way far time when our infant mortality rate was really high. So many of these babies are actually not cremated as one would expect. Most of what we heard was if the baby is quite macerated, the doctor or the health provider does not hand over the baby. Sometimes because the taboo, they don't want to take a dead baby home. If there's a river on the way, a water body, they just leave the baby's body in that. We've heard people to talk about they dig a hole in their compound field usually and just bury the baby there. So there's a variety that we've heard, and we are getting into more details with it in Bihar to understand exactly how can we make a difference in registering these babies and understanding how the babies are dealt with by the community. But thank you for asking. Very important question.
Regarding the last rites of these stillbirths, even in our part, I'm from Punjab. The ritual is the same, that babies who are not less than 1 month old, they are not cremated, but they are buried. They are buried. So probably that is the ritual across India and in other parts also. But Dr. Dandana, you have brought out very beautifully with emphasis on a very tragic situation which is faced by the parents, and equally tragic it is for the obstetrician to tell the parents the outcome of her pregnancy, because all these 9 months the mother is waiting with excitement, with anxiety, and waiting for that final bundle of joy to be with her. And when it doesn't happen, the psychological effect that it happens on the mother, the parents, and the other members of the family is really enormous. We may not understand, the society in general may not understand by saying different things, but of course this is a topic which needs to be highlighted, and every stillbirth needs to be registered. Although in institutions, since we are from institutions, stillbirths are uploaded on the portal, or they are reported to the government, and the government in turn then puts it on the portals. But in general, I don't think that many people from the private sector, from a smaller areas, they must be doing that, and that's the reason for the stats which are not up to date, which they should be. Because unless we have proper stats about stillbirth, we cannot emphasize on the society how important the intranatal, antenatal care is, and to prevent or to reduce the burden of stillbirth. So very beautifully brought out, and the emphasis that you have made, it's really good, really good.
Thank you, Dr. Sharma. Yes, Dr. Mittal.
Actually, I just wanted to say that with WHO, the PGI Chandigarh and Safdarjung Hospital, they are all working for it, and they are now introducing this stillbirth performa in the HMIS system, and it will be made mandatory for every body to enter these data. And this data, which the form which we have made, highlights the antepartum and intrapartum complication, and we are going to be teaching most of the government sector people about the ICD-PM classification, how to do it, and universal universal classification of stillbirth, and universal classification of cause of death, and antepartum and intrapartum. All these will be included. So I think that government is going to do it very shortly here.
Very, very nice to hear that.
That should be, PGI is conducting this study with 10 institutions from north of India.
Yeah.
And part of it, Dr. Neelam Agarwal is the person.
Neelam is there, and Neelam
and I think this should apply.
10 people, 10 hospitals, 7 hospitals.
It should apply to the rest of India also, to have a actual picture of the number of stillbirths.
That's correct.
Neelam, your comments, please.
Yeah. See, Ministry of Health now is introducing in 3 states, right, Dr. Pratima?
Yes.
Yeah, and we have been asked to train those people in those 2 states because they are starting this HMIS system as MPDSR, right? Yes. So in those 2 systems, they will first pilot the data collection, and after that they will introduce all over India.
And the form is almost finalized.
Form is finalized, and it's a very simple form. And I think in the HMIS system, there should not be problem of data. At least it might take just 1 to 2 years to.
So in the last, I think 5 years, we have analyzed about 450,000 births. And in that, the data which I had given was 24.5 per thousand births. That was the stillbirth rate of our over 28 weeks. And in COVID, it has really increased, 32. It has become 32.
I just wanted to mention that both these points are very important, what Dr. Sharma said and what Dr. Mittal. And this is why if you look at the 45% reporting that happens in the CRBS, that mostly comes from urban areas and large institutions. because as you know, private sector and smaller public sector facilities are actually not uploading as much stillbirth. So clearly the surveillance activities that are happening in the large institutes need to be upscaled elsewhere as well for us to get a better picture of what's happening in stillbirths. And to Dr. Sharma, and thank you for raising this point about the health providers themselves find it difficult to deal with stillbirth, given that they've also taken care of the mother and the baby for 9 months. And sometimes we hesitate we don't know how to talk about it, how to break that news. In fact, on 11th of April with PGI, and there's a effort called the Parent Voices, which is funded by PMNCH in collaboration with International Stillbirth Alliance and London School. It's a very interesting concept where we are trying to understand and talk with health workers, health providers, doctors, nurses, psychiatrists. How do you break this news? What kind of conversation we can have with the parents to make it easier for them and also for the health provider to kind of deal with what's happened. It's on 11th of April, a virtual program. I request Dr. Neelam to share the details. That toolkit is being developed and we are testing it out. So we would really welcome your participation and comments in that.
Can I come in here? For the last 5 years, we have been doing population-based surveillance, recording all birth outcomes. And the findings during the last 5 years, stillbirth rate has varied between 18 to 20 per thousand. Let me point out that only 5% of the deliveries from the area take place either in PGI or in government medical college hospital.
Yes, sir, your contribution to this stillbirth area is tremendous, especially from the community health perspective. Sir is doing very good work at Swachh, and Swachh is capturing, in fact, the real India data. And sir, we look forward to your participation in our workshop on 11th of April also. I will be giving the slide in the end so that everybody can see and participate and register with us.
Neelam, I just want to quickly make one last comment on NFHS. I see something in the chat box. So NFHS has always included documentation of stillbirth as an outcome, but only for the last pregnancy. So a woman could have had more than 2 stillbirths, but only 1 gets reported. And once a stillbirth is reported, that woman is not asked any pregnancy details. So unfortunately, NFHS still continues to ignore stillbirth, and I'm hoping that they change that attitude soon.
Yeah.
Thank you everyone, the organizers, the speaker.
Thank you so much, ma'am. That was a wonderful talk, and I thank everybody else also for the wonderful discussion. So now next we move on to panel discussion on evaluation and management of intrauterine fetal death. And first of all, I would like to invite the mentors, Dr. Neelam Agarwal, Professor, Department of Obs Gynae, PGI, Chandigarh. She is National President, Indian Menopause Society 2019 to 20, and she is Regional Coordinator for Asia for Stillbirth Surveillance under aegis of International Stillbirth Alliance. Dr. Sujata Siwach, Associate Professor of Obs and Gynae, PGI, Chandigarh. She has keen interest in stillbirth and high-risk pregnancy beside her achievements. Now I request Dr. Sujata to kindly introduce the panelists and speakers for the session. Thank you.
Thank you, Tanvi. I welcome you all to the panel, our young moderators, experienced panelists, Dr. Neelam Agarwal, and all our listeners. Today we have 4 Yuva moderators who have worked hard to make this forum good for discussion and learning. Our moderators are, next slide please, Dr. Surabhi Gupta, Consultant CD Hospital, Kalka, Dr. Sushruti, Assistant Professor, AIMS, Bilaspur, Himachal Pradesh, Dr. Amanjot Kaur, Assistant Professor, Department of Obs and Gynae, GMC, Patiala, and Dr. Monica Thakur, Assistant Professor, Dr. Radhakrishnan, Government Medical Institute in Hamirpur. Previous slide. Previous slide, please. It is my proud privilege to introduce to you our eminent panelists,
who are known for their pioneering efforts to reduce the stillbirth and its suffering in India. First and foremost, we have Dr. Tarakeshwari, Medical Director and Head, Obstetrics Medical Unit, Fernandez Hospital, Hyderabad. Dr. Tamkin Khan, Professor, JNMC, AMU, Aligarh. Dr. Richa Agarwal, Associate Professor, UCMS and Guru Tegh Bahadur Hospital, New Delhi. Our efforts to control stillbirths would never be complete without the inputs of our fellow disciplines. So to help and guide us, we have none other than Dr. Praveen Kumar, Professor and Head, Department of Neonatology, PGI Chandigarh, Dr. Inusha Panigrahi, Professor Genetics Metabolic Unit, Pediatrics, PGI Chandigarh, and Dr. Nandita Kakkar, Professor Histopathology, PGI Chandigarh. Madam is a keen researcher and excellent teacher and is collaborating with us in various projects in stillbirth. I welcome you all, madams and sir. I hope you'll enjoy the panel. We hope to cover all aspects of clinical decision-making and the unheard social emotional needs related to stillbirths. Not taking any more time, I invite Dr. Surbhi to start with the first case.
Thank you, ma'am. Is the screen visible?
No, ma'am.
Yes, Surbhi. Hi. No, you need to share the screen. Only timer is seen.
Yeah. You share from the bottom of your screen. There is a.
Yeah, sure, ma'am, sure.
Yeah, now I think.
Okay. Yeah, so we'll start with the session. I hope the screen is visible.
Make it full slide. Yeah, yeah, that's fine. Fine, fine.
So thank you, ma'am, for this opportunity. A very good afternoon, a very good evening to all of you. So let's start with our case discussion. We'll start with unexplained intrauterine fetal demise. So the case scenario we have is a 23-year-old primary gravida. She's a healthcare worker by profession. She was booked and supervised with us from the 6th week of her pregnancy, a low-risk mother, uncomplicated pregnancy. She had her last visit at 36 weeks, around 3 days back. So she comes to our emergency with a complaint of loss of fetal movements for past 1 day. So to start with this session, I would like to put forth my first question to my mentor and yes, an inspiration for all, Dr. Tarakeshwari ma'am. Ma'am, what do we do next in this case? And particularly, what all points do we need to ask in her history?
Thank you, Surbhi. The first thing is I would like to make her not guilty and feel. I'll just hold her hand and would like to talk to her. Sometimes they would like to ask us again, can you again show me the heartbeat on the ultrasound? Okay, by the time as a consultant you walk in, you can see that area is under tremendous stress. First thing I would like to do is I'll hold her hand, I'll talk to her, and then slowly, when I start talking to her, I cannot take the history then and there itself. I would like to understand her situation. So hopefully all this is done. And when she's able to accept that, then I bring in the relevant points to talk to her. So to cut short, first thing is just talk to the mother, hold her hand, let her cry. Then the other things will come into picture. As you, one of the most important things is a sudden loss of fetal movements, a minor headache, just a rise in blood pressure. I felt giddy. Then I was okay. This is what the real life scenario we had. The next day she comes because she has an appointment and it was an IUFD and it was a abruptio. And her pressures were 140, 90, 150, 100. So that is one of the important things of a sudden unexplained fetal death. Second, not realizing the leakage of the amniotic fluid, and probably it's excessive urination or she has not understood a young mother, the first pregnancy, along with it, whether there is any cord prolapse. Third thing is a trauma, which is increasing these days. We never had earlier the road traffic accidents or just a slippery bathroom, fell down and had a severe pain. I would not consider this later on, probably if she tells me itching in the palms and soles, then that history comes relevant. So this is what it is, Surbhi. Thank you.
Thank you, ma'am. Very well explained. So moving ahead, my next question for Dr. Tamkin Khan, ma'am. Ma'am, how will we examine this mother and how do we confirm our diagnosis?
You have to unmute, Dr. Tamkin. We are not able to hear you.
Okay, sorry. So thank you for that question. I would like to, after the history, I would like to examine the patient. And while examining, I would like to know the fundal height, whether it is more or less than the period of gestation, whether it is tense, tender abdomen, whether the uterine contour is maintained or not. And at the same time, I would like to auscultate, and preferably auscultate with a Doppler, so that the patient also hears or does not hear, and then confirm the ultrasound. And sometimes if the patient insists or is in the denial mode, maybe, and she requests for another ultrasound, I will agree to that. Because sometimes they do have, passive movements. She might feel sometimes that movement is there, and she might not be ready to believe that the intrauterine death has occurred.
Thank you, ma'am. So yes, we did the ultrasound for the patient and the ultrasonography revealed an intrauterine fetal demise. There were no evidence of abruption or rupture in this case. So the next point is actually very important for our discussion, especially in government hospitals with busy OPDs. My next question is for Dr. Inusha, ma'am. How will we break the bad news to the patient?
So you have a spikes protocol, which is usually used for dealing with the cancer patients. However, the same steps can be used in counseling the patients coming with this unexpected fetal demise. So there are 6 steps in this. One is setting up the interview, assessing the patient's perception, obtaining the patient's invitation, giving knowledge and information to the patient, addressing patient's emotions with empathetic responses, and then finally the strategy and plan of action. So in the first step, that is setting up the interview, we should have the patient. The patient should be fully relaxed. All the relevant information with the patient should be collected, and steps should be taken to ensure maximum privacy for the patient. So in the second step, you assess the patient's perception. That is, find out what the patient or couple has been informed earlier, what are their expectations, their understanding of the facts, and accordingly proceed further. So whether they know that what has happened, or whether they don't know, and what do they expect from the doctor. So third step is obtaining the invitation. So we should respect the patient's autonomy, find out what the couple wants to know regarding the pregnancy, and do they want to know what is the diagnosis, why this has happened, do they want to know the diagnosis. So when we do counseling, actually the person who comes for counseling is called a consultant. So in genetic counseling terminology, the patient is, or the female or the couple, they come for the counseling. So the female will be the consultant. So we should use in the fourth step, that is giving the knowledge or information, we should use simple language, allow cross questioning, give time for facts to go in, and then once they understand the facts, then we address the patient's emotions. That is the fifth step. So like how they are feeling after the information. If you think there is a problem, the patient, female has started crying, or some unexplained reaction occurs, then one should give a break, and then later again call them and talk to them. And then in the sixth step, once you are ready, everything is set, then we plan the further course of action. They can be called for follow-up visits. And in addition, if there is a significant anxiety or guilt, the coping strategies should be addressed, and accordingly the specialist concerned can be, we can take help from. So these are the 6 steps, very nicely given by Bale et al. for breaking any bad news to the family.
Thank you for such a good elaboration, ma'am. So yes, we should follow the spikes protocol because it's a very difficult task for the doctor as well, because we somehow feel the burden of the responsibility for this bad news, and yes, equally stressful for the patient as well. So moving ahead with our case. So yes, we have told the couple that it's a intrauterine fetal demise. So next is for Dr. Tamkeen Khan, ma'am. Ma'am, how do we manage this pregnancy? Particularly, what all investigations would you like to order for this case?
So the investigations that I would like to order would be directed at three main aims. Number one is to manage the current pregnancy and aim at a safe delivery for the patient. To find a cause, because now is the right time to look into the cause, and then some investigations would be for planning the next pregnancy. So for the current pregnancy, CBC and ruling out DIC through a platelet count, a PT and a fibrinogen. Then if you suspect infection as one of the causes, vaginal culture, cervical culture, urine culture, blood culture, ruling out malaria if she has come with fever, and parvovirus infection and syphilis, of course. Then ruling out a fetal-maternal hemorrhage by a Kleihorler test. And then again, the placental histopathology, the cord, the membranes, and cultures from the membranes and the cord. Then if we are again suspecting infection, then amniotic fluid cultures before the membranes are ruptured, and also karyotyping. If we want to do, the best lead would be through amniocentesis. Apart from that, thyroid stimulation, TSH, and blood sugar fasting PP, and APLA profile. And if we suspect some drug abuse, then maybe toxicology. Or if she's come with the complaint of itching, then bile salts.
Thank you, ma'am. Yeah, we generally direct our investigations to know for the maternal well-being. And yes, based on that, we tend to give her immediate delivery, or we can counsel her for expected management as well. So next, again for Dr. Tarakeswari, ma'am. Ma'am, do you ask the mother's preference for labor and birth?
Yes, Surabhi. First thing is whether they would like to get immediately admitted and then come back, or they would like to give the bloods and then come back. And also immediately, if they may get worried and they say immediately take this baby out. But over the time, when you continue your counseling sessions, almost everybody, majority will agree for a normal vaginal birth. So we do listen to the mother preferences. And only one suggestion I would like to say is whether we are in the government or in the private, probably we struggle to have a space. I think the first thing we would like to do is take her to an area. I'm sure we'll find some room, even it's a doctor's room, and first listen to her, let her cry. Even we are guilty and they are guilty. As you said, the obstetrician also takes the burden, isn't it? That is one suggestion I wanted to say.
Okay. Thank you, ma'am. Yes, we can give them expectant management for around 3 or 4 weeks if all the lab parameters have turned out to be normal and the membranes are intact. Just making sure that we repeat her program twice weekly. But in case of sepsis, preeclampsia, abruption, or leaking, we tend to go for immediate delivery. So next, Dr. Richa Agarwal, ma'am. Ma'am, do you think that the couple needs emotional support and clinical counseling?
Yeah, thank you, Dr. Sobi. Yes, definitely. This part of stillbirth care is the most important, but unfortunately, it is the most ignored one also. Bereavement is the condition of loss, basically, resulting from a death. And bereavement care in the setting of stillbirth includes both formal and informal care and support, which is given to the bereaved parents and their families to help them through the grieving process, basically. So this care ideally should begin in the immediate period following the diagnosis of stillbirth, as ma'am has pointed out, and it should continue throughout the postnatal period within the hospital and community settings also. So the mother, partner, and children all are at risk of prolonged psychological reactions. So it may include basically anxiety, there may be depressive symptoms, post-traumatic stress, suicidal ideation, panic, phobia, and all. And so basically, all the communication with the people, those who are closely affected by stillbirth, it should be done in a very sensitive way. It should be clearly, easily understandable. We should give acknowledgement of the fact that the patient is having a stillbirth, and a little prioritization of their situation by healthcare staff goes a long way in helping the bereaved family. It should be an inclusive approach where the parents should be involved in the decision-making process. So apart from the psychological counseling, and clinical counseling definitely is equally important. Patients should be offered full autopsy of the fetus to help them explain the cause of stillbirth. In fact, in one study, more than 30% of the parents who declined fetal autopsy in the first go, they subsequently regretted their decision. So therefore, it is very necessary to explain the family the importance of getting the autopsy done, the additional value it is going to add, including the value of negative findings also for future discussion. And to help the parents with their decision about fetal autopsy, it is very important to provide clear and consistent user-friendly information to the parents in a respectful way, including a brief description of the procedure also. And then an abnormal karyotype can be found in approximately 8 to 13% of stillbirths. So that should also be offered to the parents. And in fact, if the specific abnormalities are there, neonatal malformations are there, a referral to a fetal medicine specialist may be considered. Then, as already pointed out in the previous lecture, also funeral options, including burial and cremation, should be discussed in a sensitive way with the parents, taking in account their cultural and religious considerations. And prior to discharge, also parents should be informed about what to expect in their postnatal period, and then they should be told regarding the follow-up visit.
Thank you for the wonderful explanation, ma'am. So this couple had normal lab parameters, but even though the couple decided to get admitted and go for immediate delivery since they were very anxious, so we admitted them in the labor ward for induction of labor. So next for Tarakeswari ma'am, do we have special wards for such mothers?
We try to put them in a corner or labor ward cubicle, Surabhi. We have 4 rooms, and the last rooms are little far away. So we choose those rooms. We particularly put the mothers in those rooms. And we understand when the other mother delivers and the baby cries, and when she has a birth, automatically that becomes little difficult for them. Unless until they are into active labor, we don't bring them into the labor room, provided this mother, all lab parameters were normal. So she would be monitored in the room. She would be comfortable doing the exercises in the initial part. We don't bring them in early unless she needs a pain relief. If she is not able to accept the pain and we have to give her epidural, we give liberal epidurals for them. They shouldn't go through the pain because they already lost the baby. Then we bring them into that, and we have a separate in the 5th and 6th cubicles are neither corner of the labor ward. So we try to take those rooms.
Thank you, ma'am. And yes, we can have a companion along with them since we deal with respectful maternity care as well.
Sure.
So next, Tamkeen ma'am, is there a role of antibiotic prophylaxis in this case?
So there's no role with intact membranes of antibiotic prophylaxis, and it is not recommended by any guideline, even in the presence of documented infection of the streptococcal infection. Only when there is chorioamnitis or risk of sepsis, then you start the antibiotics. And the baby can serve as a septic focus and lead to septicemia and Clostridium infection and DIC. So only in that case, we require antibiotics.
Thank you, ma'am. Richa Agarwal ma'am, do we give options for pain relief for these mothers?
Yes, analgesia is very important, especially in stillbirth women, because they experience somehow more pain. All the usual modalities, they should be available, including regional anesthesia and patient-controlled anesthesia. So, however, an assessment of DIC to rule out any possibility of subdural or epidural hematoma formation during epidural anesthesia, and sepsis should also be ruled out to prevent any formation of epidural abscess. Then diamorphine and morphine are preferable in case of pathogen because of their better pain relief qualities and a longer duration of action. So yes, pain relief should be given adequately in stillbirth women.
Thank you, ma'am. So she delivered a stillborn baby boy vaginally, 2.6 kg. There were no gross congenital malformations. From here, the discussion will be taken by Dr. Sushruti. Over to you, Dr. Sushruti.
Thank you, Dr. Surabhi. Continuing from where Dr. Surabhi left, our patient has now delivered a fetus weighing 2.6 kg or after opting for immediate delivery in considerate surroundings and with proper bereavement care. My first question is for our neonatologist, Dr. Praveen sir. So how should we proceed about the immediate examination of this fetus after delivery, and what is the role of a neonatologist in this scenario?
Thank you, Dr. Sushruti. I think first thing we have to remember that in the usual variety of labor rooms with a lot of rush and patients walking in, often we may not know the timing of the so-called stillbirth. So I think the neonatologist has to go prepared that what is being labeled as stillbirth might turn out to be live birth also. So one has to be prepared for resuscitation if required. Once we know definitely it's a stillbirth, then obviously we need to examine this fetus or the newborn. I think the examination principles remain the same as one would examine a neonate, except that now you're not looking for signs of life. So I can categorize these items under maybe 3 or 4 headings. So first will be measurements. The core measurements will obviously be the weight, the length, and the head circumference. However, if on examination or antenatally we have some suspicion of a skeletal dysplasia, then more detailed anthropometry can be done using some calipers and trying to measure the upper segment, lower segment, and all those details can be done. In very small fetus, less than 23 weeks, it is said that foot length can be done to have an accurate idea of the gestation. Other than the measurements, the next category will be looking for dysmorphism and malformations. And one can do a head-to-toe examination for malformation starting in midlines, either anteriorly or posteriorly, and go around a full circle so that you do not miss any malformations. For dysmorphism, we pay special attention to the face. So basically the eyes, the ears, the nose, the mouth, the head, and any kind of dysmorphism if it's visible. We specifically look at the palms, the palmar creases, the digits, the limbs. And then we also need to look for any signs of a systemic disease. So we can look at the chest, the abdomen, palpate the abdomen for any organomegaly, any masses, any lumps, and look at the skin for any rashes or any pigmentation or any bullae. So it has to be very systematic, structured examination for which we must have a structured case form available to us so that we do not miss. And simultaneously, we must think of documenting it photographically. So one can look at taking certain photographs from anterior, posterior, lateral, and different views, so that whatever findings are being described are also documented for a subsequent review. Thank you.
Thank you, sir. Supposing on general examination, dysmorphic features are noted, and it is now decided to get a genetic consultation for this patient. Dr. Inusha ma'am, what documentation from this initial examination would you require from this initial examination? And if there is anything you would like to add on to what sir has already explained in detail? Dr. Inusha ma'am, you're not audible, ma'am.
So in skeletal dysplasias, you can get flat faces, and in the photograph also you can see if the child has not been seen earlier, and then extremities, whether the limbs are short, whether there is any bowing, whether there are any shortening of the digits or shortening of any segment of the limb. So that is important. Then if suppose there are any contractures, arthrogryposis, so that should be noted. So in some skeletal disorders, you can get arthrogryposis. Then in storage disorders, you can also get like edema, hydrops, features suggestive of hydrops might be there in case of some storage disorders. Then you can see the posterior part of the neck, whether there is a short neck or whether there is a cyst or some swelling on the back of the neck, which can again point towards, suppose if there is a cystic hygroma, it can point towards a chromosomal disorder. If there is just short neck and some thickened neck, it may point towards some storage disorder or some skeletal dysplasia. So these are the features So we do a head-to-toe examination so that nothing is missed.
Thank you, ma'am.
Even turn the child, see the back for any, say, Mongolian spots on the spine. You can see any abnormalities over the spine. You can see. So full examination of the baby is essential.
Thank you, ma'am. Now coming to placenta from this, Dr. Nandita, ma'am, can you explain on the role of gross and microscopic examination, placenta, cord, and membrane in investigating the cause of this stillbirth? Ma'am, Dr. Nandita, ma'am. Please unmute yourself, ma'am.
I'm unmuted. You can't hear me?
Yes, ma'am. Now we can hear. Yes, ma'am.
Yeah. So ideally, I said that we should have a complete autopsy, but then if the parents don't agree to it, then the best is to examine the placenta, the cord, and the membranes. So of course, the placenta has to be seen. Where is the as regards any hemorrhage, any abruptio present, any what is the length of the cord, what is the weight of the placenta, the color of the membranes, and any hemorrhage on either sides, and then any cord, if they are all the developmental insertion of the cord. If there are infections, obviously we'll see some kind of greenish discoloration or some grayish discoloration there, and these are the things that we have to see. And then of course take sections. When we take sections, we normally take sections from the cord, from the membranes, and also from the placenta. So we take the peripheral part of the placenta also, as well as the central part of the placenta. And then when we give our sections to the placenta, we look for the areas of infarction and measure the percentage of infarction that is present, and then take about 3 sections from the placenta, 1 from the membranes and 2 from the cord. So that's how we do it.
Thank you, ma'am. Now I would like to emphasize again that histopathology of placenta, cord, and membrane remains the single most important investigation, and that alone can give us the cause of stillbirth in up to 67 to 93% of the cases. Now we discussed fetal autopsy with the parents, and they are not willing for a complete fetal autopsy. Especially, they do not want the face and head and neck to be distorted. They want the face to remain intact. So, Dr. Tamkeen Khan, ma'am, can you tell us how to counsel these parents? What are the options we can provide them if not for a complete fetal autopsy?
So I would like to again re-emphasize that the best time to find a cause is now, with a detailed history and examination of the mother, the examination of the baby like Dr. Kumar told us in detail, and of course the placenta like Dr. Kakkar told us. It's the best record of all the intrauterine events that have occurred. So the placenta, the membranes, and the cord. And if the parents are not agreeing to an autopsy because of some ethical or religious concerns, then we can offer them an imaging autopsy with an X-ray or MRI or a needle, biopsies from various organs directed under some imaging modality. So that is another option we can give them.
Thank you, ma'am.
Partial or a limited autopsy.
Yes, ma'am. Partial or limited autopsy is what we can do. And we can even enter some of the body cavities and leave some of these cavities intact as desired by parents. So if they want, we can open up the abdomen but not CNS, we can go ahead with that, in addition to all the other things that you've already elaborated on. Thank you, ma'am.
So Shruti, may I add a point about this here?
Yes, sir.
I'm sure all of you must be aware about the use of MITS or MIA, the minimally invasive tissue sampling techniques, which is now being used for stillbirths and neonatal deaths, and have been shown to be almost as reliable as the standard autopsy. So maybe that would be something which will come up.
Yes, sir.
Thank you.
And another thing, can I add one more point here?
Yes, ma'am.
Like you said, the parents don't want the head and the face to be disfigured. So what we can also do is do a thoracic autopsy, wherein we just give a nick to the thorax and we put in our we give a cut there, and we can go into the deeper we can cut the diaphragm from there, and we can take out the abdominal organs as well. So we do a thoracic autopsy. It's very easy in these children to do those. So we can thoracic incision, and we can do a complete autopsy, except for the brain, of course.
Thank you. Now, my next question is for Dr. Inusha, ma'am. Ma'am, how helpful is post-delivery radiological imaging in investigating this patient now?
Yes, X-rays are important, especially when we are thinking of, say, skeletal dysplasias or some paroxysmal disorders like Zellweger syndrome. And MRI can also be done in selected cases. Nowadays, there is option for virtual autopsy. Virtual autopsy means you need not cut the baby, but still you can obtain sufficient information by using artificial intelligence techniques. And like we use for spiral CT or MRI, so similar techniques can be used to do a virtual autopsy of that baby. And ultrasound can be done, but ultrasound is usually which we rely is the level 2 ultrasound or a 3D ultrasound or a 4D ultrasound, which is done before the delivery. And in that 3D, 4D ultrasound, you can also identify many abnormalities which may not be identified by a routine ultrasound. So that is level 2 or a 3D or 4D ultrasound is important. And especially if you want to see the CNS, sometimes ultrasound cranium may help. But most of the time, X-rays are important. And we do a full phytogram and X-ray of the dorsolumbar spine. This is important because in that we can see for dysostosis. In the X-ray dorsolumbar spine, we can see for dysostosis, which otherwise may not be possible to pick up if we are doing only a single phytogram like we do in femtogram.
Thank you, ma'am.
Shruti, can I just add one point? A very important point that we've all missed out is meconium. Meconium has to be looked for, and meconium aspiration is a very common cause of term fetal death. That's what we find in autopsy. That's what I have found in a large number of my autopsies that we do. So meconium can sometimes be seen even on the this placenta membranes and the cord. So meconium is one thing that we have to all consider here.
Yes, ma'am. Thank you. Now coming to cytogenetics, which is a rapidly advancing area and can give us the diagnosis or the cause of stillbirth in about 15% of the cases. Dr. Inusha, ma'am, what are the appropriate samples for cytogenetic studies that you would require to be collected, and what are the precautions that should be taken in collection and transport of these samples?
Actually, cytogenetic, traditionally, we rely on karyotyping. Heparinase sample is needed for karyotyping. But nowadays, many other tests are also available, like chromosomal microarray, and we can also do MLPA for chromosomal abnormalities in selected cases. And usually the common cause in many cases of this will be trisomy 21 or a Turner syndrome, which accounts for around 23% of all chromosomal disorders. Like T21 accounts for almost 23% and Turner for 23%. But apart from that, we also need to remember that there are other causes, single gene disorders, which can contribute to the cause. And so for these disorders, one has to do a separate test, different test, which can be like lysosomal enzyme analysis. We do a panel of lysosomal enzymes in suspected stillbirths or hydrops cases, in addition to X-rays. And then if there are some disorders in which the cardiac involvement is there, in some disorders in which multiple malformations are there, So if multiple malformations or cardiac involvement is there in those cases, even there can be conditions like rasopathies. And rasopathies are important, especially in these antenatal deaths cases. And these include a spectrum of disorders like Noonan syndrome, Costello syndrome. And if we don't do this NGS testing, then we are likely to miss these cases. And sometimes it may be a condition like cardiac defect or cardiac rhythm abnormality causing fetal death. But if we don't do NGS, we may not be able to pick up these conditions, and these may be autosomal recessive or autosomal dominant in inheritance. So like many rasopathies will be dominant, a single mutation will be causing the disease. And many cases they may be de novo. So if we want to take tissue samples, then we can keep a urine sample, we can take a liver biopsy sample, then blood sample, of course, we collect every time. And then CNS samples usually are not taken, but skin biopsy may be helpful in many cases. Sometimes we may need to do karyotyping from skin fibroblasts, or if it is a skin disorder, then it may be helpful. So if there are no clues on ultrasound prior to the delivery or the this stillbirth, so if no clues are there, then it becomes more important than that we have maximum number of tissues so that we can process them gradually and find out what is the likely cause.
Thank you so much, ma'am, for this informative answer. Coming to the topic of bereavement care, we all know stillbirth produces intense grief in parents, and it may not be socially validated. And so it remains a largely neglected area, especially in busy hospitals or busy government hospitals. My question is for Dr. Tara Keswari, ma'am. Are we following bereavement care protocols in your hospital, and how do we go about it?
Thank you. We do have bereavement sessions done by the senior consultants. Actually, Dr. Evita takes us every once in 3 months for all the newcomers. And when such an incident happens, it's a senior consultant or the consultant who's already involved in the bereavement counseling does it in front of your resident so that they become more sensitive. The first, one of the most important support systems, is reaching out to the consultant, particularly when you are in a team work and I'm not able to reach my consultant, should not be there. So access to the consultant, either an email or a phone, and bereavement counseling to be done every 3 to 6 months, because we get residents from all over and they must attend a bereavement counseling session, which we do it. And the third one is we do it as a live session, like a mock drill, like how, and then we again recheck like where we did not find the person sensitive. That is from the doctor's point of view. Fourth is, I think even the doctors need counseling sessions because they're completely devastated. Yes, we understand the couple lost the baby. At the same time, we need to take care of the labor ward teams. Particularly when they're on long hours, and which happened last year in COVID, doing 2 duties and continuously a week and then taking 4 days break. So the support systems are in place. We have a committee. We take care of the doctors and the mothers, the couples who lost the babies. We consultants share the care, and 2 or 3 senior consultants. When other person is not there, we fit into the role. And we should not forget the father. We always talk about the mom losing the baby. We have seen the fathers left alone without much of support. So the counseling is for the couple together, and then they come back after a week to talk to you. They may ask you so many questions. So the continuity of care continues for quite some time, and they become your friends. Even if they have 2 babies born in your hospital, they can never forget the first baby. And we always name the child. We make a card, and we give the baby to the mother to hold and give that privacy to them to cry. So the first and foremost, immediately they may get worried, but we ourselves, the person who's doing the counseling, the doctor herself carries the baby. So respect to the baby, covered, cleaned in a clean white cloth in a basket, go to them, give the privacy, let them cry, hold the baby. They may not hold immediately. The father may hold, mother may take after 6 hours, maybe after 8 hours, because even we do face the problems with the autopsy. You cannot push your decision onto them. And feel free to take the pictures. And you should ask them whether they would like to take. If they don't want, we take the pictures, and then they come after the 1 week, 2 weeks. We make a small memoir. Dr. Nuzhat and Dr. Revita together, they have put a small card almost 25 years back when I joined the organization. We still have that. And the card automatically goes to the primary consultant. When they come for bereavement counseling, then we would like to ask them a picture of the baby footprint, or the hand, or the picture of the baby face, and a nice written words just to comfort them. And if, or sharing that on email one-on-one basis to them, that is extremely important, and it really helped us in a long way to counsel these couples, particularly unexplained fetal demise with reduced fetal movements, where you think you have done everything and everything is normal.
Do you think the gynecologist or the obstetrician should be doing the counseling herself or himself? Are we the appropriate people to do, or should we take help from a counselor? Or
here in our organization, we have consultants with the junior consultants and residents, and when they are not able to face alone, we are there with them. Like, the choice is to that particular person who is taking care of the couple. And if she feels like she wants the support, we are there always. And we doctors do the bereavement counseling. But after that, if the doctors are not able to come out of their own mental status and are still very low and depressed, then we have a psychologist in the hospital team, 4 psychologists. We book an appointment with them, and slowly they come out of it.
Thank you. Dr. Richa Agarwal, ma'am, can you add on something? And ma'am, what are the options for support to these parents after discharge from the hospital or from professional counseling?
Yeah, apart from counselor, now there are various support groups also nowadays, which basically aim to support. They provide awareness of pregnancy loss and of support services. Many of these groups include like SANS, that is stillbirth and neonatal death support, miscarriage, stillbirth and infant loss support group. There's March of Dimes. There's International Stillbirth Alliance. Basically, the website contains a collection of support resources as well as a list of regional support groups also. They also provide information about ongoing research. Plus, there are many other people who are going through the same phase, so they can share their feelings. They feel better by sharing their grief with each other. So that is also there nowadays, apart from counseling from the counselor.
Dr. Praveen, sir?
I think in the government hospitals, obviously, we are, in a very, very, very dismal state. We don't even do bereavement counseling for, somebody who lived and died. Forget about stillbirths. And obviously, we don't do any counseling or support for the health workers, which Dr. Tarakeshwari is mentioning. There can be several reasons. I think because of the number of deaths which take place in these places, people get desensitized, the amount of work they have. Of course, I don't think this should be an excuse to not do this. And I fully agree that a stillborn baby should be given the same respect as one would give to a baby who lived in the NICU and then died. After all, this fetus was also living in the most advanced incubator in the mother's womb, was living. And so same respect, same dignity, same everything has to be given. The only additional point I can say is that I'm sure it's true for the obstetricians also, that at the time of death, soon after death, the family may not be obviously very receptive, may not be very forthcoming. And whereas later on, after discharge, they may want to wish to sit with us and talk. And that is the time when they often seek the neonatologist, because the obstetrician said, please go to them and take advice for future pregnancy. And then they are roaming around with the card searching for the neonatologist. So I think that could be organized in a better way, more respectful way. And the access to pediatrician should be available like the obstetrician, and maybe a joint counseling can be done. Thank you.
Can I make a point here?
Yes, ma'am.
Yeah, I totally agree with Dr. Praveen. We really need to do these measures. We have to take up these measures because even the students have to actually be taught how to give the bereavement, how to deal with these kind of patients. Sometimes they become very harsh with the patients because of the excess load that our residents are actually facing. So things become very, very difficult. And since the autopsy is with me and they come and get their reports from me, so I get to hear, many things that have happened on the other side as well. So I think that the residents should be taught how to deal with these patients in a very different manner and in a very, compassionate way.
Yes, ma'am. That is very important, ma'am.
I would like to come in for a very brief intervention and request the expert panelists to kindly deal with the issue that after the bereavement process is somewhat over, how do we get the couple in optimum health so that the story, a sad story of stillbirth or a neonatal death does not repeat? I'm very concerned about the fact, yes, we provide a lot of service. Some of us do, some of us don't, during the immediate period of bereavement. But what about the challenge of bringing the woman back to normal health so that it does not repeat itself? Thank you.
Thank you, sir. Can I add on to that? Our journey continues, sir. It doesn't stop there. And over the last 25 years, I think I have seen who were upset with us, but came back after 6 months, after a year, after 2 years, even then. Believe me, sir, when we are honest, open, and we say that we don't know the cause, but we are here to help you with the next pregnancy, who lost babies with us, they 100% they come back to us when we are honest, without cooking any stories. If something has happened intrapartum event, which is uncontrollable. So we do continue our support, sir, on email. Sometimes they write long mails. We take opportunity to arrange for a meeting. We talk to them, their parents, their families, and it continues for the next pregnancy too, and it has continued so far. So honesty and reaching out to the parents, and along with the reports, whether it's a placenta, autopsy, as you said, with the neonatologist, we sit and talk to them. We sit and talk to them. We give them time, even if it is an hour or 1 hour away from our working hours. But we need to give that dedicated time and space to them. And they continue the next pregnancy, the journey with us. This is what my observation is and my input, sir.
Thank you, ma'am. Ma'am, Dr. Tara Kesri, ma'am, do we need to suppress lactation in all these mothers, or is there any other alternative that we can suggest to them?
Since initially there will be a bit of colostrum and then the breast engorgement and lactation starts, one thing we ask them is, we do have a milk bank, Shushruti, if they would like to donate, is what we ask them. But when the pregnancy is around 24, 26 weeks, much earlier, and then they wish to have the suppressant, then we do use cabergoline, and if it is a hypertensive mother, we still use B-long. We don't use B-crib. So the support to the breast by wearing the sports bra really helps, and then the hot towels to reduce the engorgement and analgesics. But we do talk about a milk donation, but Shushruti, it doesn't come just like step 1, step 2, step 3. It
Yes,
takes
ma'am.
time and how the couple feel, and then that's how we take it. But my suggestion is to design a stillbirth evaluation form for your own hospitals where you work, the maternal investigations, the the picture of the baby, and then any test done of the chromosomal, And then the neonatologist examination, if you put one paper and it goes into the file where the neonatologist does not have time, but later can jot down the height, weight, and all the important examination findings, it becomes a stillbirth evaluation form. So examination, like Klehor-Betke, reduced fetal movements. We had mothers, and third pregnancy, we did a Klehor when she came with reduced movements, and we just had to rush in and deliver her. So one stillbirth evaluation form for your own hospital with the test, what you do. It took years, almost 10 years for us to start Klehor-Betke in our hospital. I don't know how many of our panelists do Klehor-Betke routinely. It in a private setup, I'm saying, but a hospital of 70-year-old, but we could get, it took 10 years for us to do a KB test by our pathologists. I'm honest.
And Dr. Praveen sir, do we have any milk banks in our area? Can we suggest this option to our...
I think the madam has already covered all the points, how the lactation should be managed. But I think this has to be part of the bereavement counseling, because there are so many options and so much variation if you read the literature, how lactation has to be managed after stillbirth. But typically, you know what happens, the obstetrician writes one tablet, okay, please take this, and that's the end of it. And the woman may be suffering because of the ongoing lactation. Of course, she could come and express and donate to the milk bank, but that again needs counseling. She's going there, and mothers are there who are actually having live babies. So, you know, so it has to be a very, I mean, some counseling has to be done, options have to be given. And then whatever the family chooses, I think we respect that and follow that. Yeah.
Sir, to add one thing, we have lactation helpline, sir. Lactation counselors and helpline. And that helpline is 24/7. So that also helps.
Excuse me, ma'am. I'm really sorry to interrupt the session, but the time has been up and I'm really sorry, but we will have to move forward. So kindly please wind up soon. Thank you.
Coming to this issue of memoirs and artifacts, ma'am has already covered it in detail, and we all know it. When the patient comes 6 weeks after delivery, we could not find any cause of stillbirth. We counseled her and emphasized the safekeeping of records and explained to her that a large number of stillbirths remain unexplained, and gave her the prognosis for the next pregnancy, explaining to her that there are less chances of stillbirth in the next pregnancy and the prognosis is good. Now I will pass on the baton to Dr. Amanjot.
Good evening, everyone. As we are already short of time, so we will have to finish off our session over here only. We'll not be able to take up the preconceptional counseling and the management of the re-enrolled pregnancy. We are really very sorry. To conclude, I will say we all aim to reduce the stillbirth rate to the 12/1000 by 2030. And we hope to give every aspiring mother a healthy baby and bring joy in every life of a patient. A moment of unimaginable joy is what a mother feels when a newborn is placed in her arms, a joy every mother should have the right to experience. Thank you.
Thank you, everyone. Thank you all
for
the
the wonderful
panelists.
discussion.
Thank you. Thank you, Surabhi. It's an honor for me to be here. Thank you.
Thank you, everyone.
Thank you.
Yeah, thank you, organizers, for their kind invitation. Thank you all.
Thank you all.
Thank you so much.
Thank you so much.
Now, let us move on to the next session. For this, I invite the chairpersons, Dr. GRV Prasad, Professor and Senior Consultant, Obs Gynae, PGI Chandigarh, Dr. Geetanjali Kaur, Assistant Professor, Obs Gynae, Maulana Medical College, Ambala, Dr. Vandana Bhuria, Professor in Department of Obs Gynae, PGIMS, Rohtak, Dr. Shehla Jamwal, Associate Professor, Obs Gynae, RMRI, Bareilly, Dr. Urmila Singh, Senior Consultant, Obs Gynae, Midland Healthcare and Research Center, Lucknow, the winner of Doctor of Millennium Award 2000. Now I please request Dr. Geetanjali to introduce Dr. Bharti Sharma for the talk. Thank you.
Good evening, everyone.
Geetanjali, ma'am.
Yeah, good evening, everyone. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. It is my great pleasure to introduce Dr. Bharti Sharma, who is an assistant professor in the Department of Obs and Gynae, PGI Chandigarh. She has been a trainer for birth defects and stillbirth surveillance in Southeast region, and also has revised technical documents for WHO to adapt to the ICD-PM classification. She also gives the bereavement care and is also running a postpartum clinic just for this. She has also received many awards. The first runner-up of FOGSI, Dr. Usha Krishna Quiz in 2009, 2010. She has also received prizes for her posters in stillbirth care, and also received Mrs. Utpal Lakshmi Nair Gold Medal for Best Graduate Award in 2010. And she has around 28 publications to her name, and her field of interest is high-risk obstetrics and perinatology. I welcome Dr. Bharti Sharma to start the topic.
Thank you so much for that kind introduction. So I'll start my presentation. So I'm talking about the ICD-PM system of classification. That is a newer system to classify stillbirth. So if we go by the history, stillbirths were first notified in Scotland in 1940. First classification system was developed by Barrett et al. In 1954 for audit and surveillance. And since this time, clinicians, researchers, and epidemiologists have developed a large number of classification systems. We have around almost 80 classification systems to classify stillbirth, leading to various contexts, various settings, low middle income country, high middle income countries. Now, first of all, why to classify stillbirths? Basically, the purpose of any classification system is to identify deficiencies in the provision of care, to focus attention where improvements are already possible, and to indicate where development or knowledge may be expected to lead to further advances. However, until, as I told you earlier, there is no uniform classification system was developed specifically with the aim to be able to apply both in high-income country group, where we have complete workup for stillbirths, and low middle income country, where is the incomplete documentation, incomplete workup. Ideally, a global system of classification should have 5 characteristics. Number 1, it is easy to use and produce data. There should be clear guidelines. It should be able to work with all levels. It ensures causes of death categories are relevant in all settings and produce data for preventive strategy, because the main motive of any classification system is to prevention of stillbirths, right? So what is ICD? Basically, ICD is the International Classification of Disease Codes, and it is the only global system for classifying any death, like adult or neonate. The problem is that in ICD-10, they included the extensive coding of newborn, but that classification was not consistent with the fetus, because fetus has their own characteristics like placenta, cord. So you cannot apply the normal ICD-10 coding to a fetus. That's why WHO and collaborating partner developed the WHO application of ICD-10 to perinatal death, that is called ICD perinatal mortality, ICD-PM system of classification system. It is for stillbirth as well as for neonates. So I'll be dealing with stillbirths. So now, what is the problem with stillbirth? Because it is most difficult to assign the cause of stillbirth, because we don't witness the baby, fetus, right? It is inside the mother's womb. The causes, risk factor, and associated factors are overlapping. For example, hypertensive diseases of pregnancy. It can be a cause for stillbirth, it can be a risk factor, or it can be an associated factor for a stillbirth. And the problem with our setting is incomplete workup, unbooked patients, no antenatal care. So I am just sharing the case scenario. Suppose a 26-year-old woman, chronic hypertension at 32 weeks of gestation, comes to you with the eclampsia with IUFD, right? So in this case, the cause of stillbirth will be acute hypoxia because of eclampsia. But this mother can have IUFD because of abruption also. She can also have a FGR because she's a hypertensive, right? This mother can go into preterm labor and she can have stillbirth because of prematurity, right? And this mother can also have suppose she have a neural tube defect baby, she has an anencephaly. The stillbirth will be attributed to birth defect, not to hypertension, right? And she can also have because of mismanagement of labor, any hypertensive mother can have intrapartum loss. So it is very important to identify. We can't just say that the mother was hypertensive, so the cause of stillbirth is hypertension. So it is very important. That's why ICD-PM classification, that is International Classification for Disease, Perinatal Mortality Classification, it has got 3 components. Number one, capture the time of perinatal death, whether it is an antepartum, intrapartum, or neonatal. It has got a multi-layered approach to identify the single cause of death. And third is they are linking the perinatal death with maternal condition. So the first component of ICD-PM is type of stillbirth. That is timing of stillbirth. Why we are so worried about the timing of stillbirth? Because antepartum stillbirth means the death occurring before the onset of labor. What does it mean? It means that that mother require better antenatal care at grassroots level. If a mother is having intrapartum stillbirth, that is the death of the fetus occurring after the onset of labor and during the labor. That means that mother require a better quality healthcare services. So we have to improve the quality of healthcare or healthcare facilities, right? So what were we using till now? What we have learned. Yes, ma'am. It's like a FSB, fresh stillbirth, or macerated stillbirth. What we were using is we were using as an appearance of the fetus as a proxy to mark. If it is a FSB, we used to call that intrapartum stillbirth. Whereas if it is a macerated, we call that antepartum stillbirth. However, the signs and of skin macerations begins only after 6 hours of death. Suppose a mother comes in an obstructed labor case and she reaches a health center after 24 hours of her labor, she's definitely going to deliver a macerated stillbirth. So we can't assign that cause as an antepartum stillbirth. So that's why it is very important to document everywhere whether you have heard the FHS or not, because it will help us to identify whether it was an antepartum stillbirth or intrapartum stillbirth. And if there is no fetal heart sound, we have to rely on the mother's maternal history, whether she's saying whether she was feeling the fetal movements or not. So the second component of ICD-PM, as I told you, it is a multi-layered approach. One is time of death, then is maternal condition, and third is fetus condition of the fetus. So let's go for the maternal condition. The maternal condition has been divided into, as per ICD-10, it has got a 5 component. M1 to M5. M1 is the complication of placenta, cord, and membrane, which include placenta previa, abruption, cord prolapse. M2 is the maternal complication of pregnancy. It is the incompetent cervix, multiple pregnancy, maternal death, or pre-labor rupture of membrane. Whereas M3 is the complication of labor and delivery, which include all the suppose breech extraction, forceps ventouse, or cesarean delivery. Whereas M4 is the medico-surgical conditions. It includes everything: hypertensive diseases, preeclampsia, eclampsia, gestational hypertension, diabetes. And M5 is the healthy mother. In the similar manner, antepartum and intrapartum stillbirths are further divided into 6 subgroups. Antepartum is divided into 6 subgroups, which include malformation, infection, antepartum hypoxia, other specified antepartum disorder, which include isoimmunized pregnancy, non-immune hydrops. And A5 is disorder related to fetal growth, FGR babies, small for gestational age babies. And A6 is unspecified. In the similar manner, intrapartum is also divided into 7 subgroups, which are almost similar to antepartum. The extra part is birth trauma, right? So let's go to a case scenario, how we are going to do it. It's very simple. It looks complicated, but I tell you, it is actually very simple. So let's go to a case history. There is a primea gravida, 23-year-old, uncomplicated, adequately booked, supervised at civil hospital at 37 weeks, had bleeding PV at 2 a.m. in the morning. She reached a civil hospital after 45 minutes of her. And on examination, her tone was increased, pulse was closed, uneffaced, and she was diagnosed to have abruption with fetal distress. It was documented on the referral. Due to non-availability of anesthetic, she was referred to higher center for cesarean section. So she reached her center at 3:30 a.m., where she was found diagnosed to have IUFD, and she delivered after 12 hours of induction a fresh stillborn. So let's classify this stillbirth, right? So if you go by the history, she was not in the labor, so it was a antepartum stillbirth, right? And antepartum stillbirth, what happened? There was a sudden antepartum hypoxia. There was no fetal growth retardation, so it was A3, right? And what was the maternal condition? Mother was having abruptio placenta, so it was M1, that is complication of placenta, cord, and membrane. So as per ICD-PM, my stillbirth was antepartum stillbirth. It was A3, sudden antepartum hypoxia, and M1, that is complications of placenta, cord, and membranes, right? So next, let's move to another case scenario. There was a second gravida, para-1 living one, uncomplicated, booked and supervised at CHC, previous uncomplicated delivery at community health center, CHC, 3 years back. At 38 weeks of gestation, she went into labor. She reached at 4 p.m. Her fetal heart, as per documentation, she was 3 centimeter, 50% effaced. As per record, intrapartum fetal monitoring was done by intermittent auscultation, right? At 7 p.m., she delivered a stillborn baby of 2.9 kg and like was meconium. So how we are going to classify this stillbirth, right? So if I go by the history, she was in labor, so it was a intrapartum stillbirth. So my patient was intrapartum stillbirth and there was a sudden acute intrapartum event, right? So it was I3. And what was the maternal condition? My mother was healthy. There was no complication, so it was M5. So ICD-PM for my case was, it was an intrapartum stillbirth. She had an acute intrapartum event and my mother was healthy mother. And how we are going to prevent this stillbirth? By improving the intrapartum care and proper fetal monitoring, right? So let's go to a last case scenario. That is second gravida, 36 weeks pregnancy with previous cesarean, adequately booked supervised, developed pain abdomen at 6 a.m. As no one was there at home, so she reached hospital after almost 14 hours of labor in the night, and where she was diagnosed to have ruptured uterus with IUFD. Emergency laparotomy was done and she delivered a fresh stillborn of 2.5 kg. So let's categorize this stillbirth, right? She was in labor, so it was a intrapartum stillbirth and there was an acute intrapartum event which occurred, right? And what was the maternal condition? It was a complication of labor and delivery. She had a ruptured uterus. I hope I have made it clear how to classify stillbirth. So what is the benefit of stillbirth if you work in an institute or in your hospital? Let's see. So suppose this is our institute data for 3 months, right? January, February, March. Suppose in 3 months we had a 1,416 deliveries, out of which I know with ICD-PM that in my institute 83% were antepartum stillbirth and 17% were intrapartum stillbirth. So let's move ahead. Let's divide it again. So if you go by the tabulated form of ICD-PM classification, you can very well clearly see that out of 71 stillbirths, only 12.6% mothers were healthy mothers and 46.64% were having any medico-surgical disorder at the time of stillbirth. And only 4.2% of mothers had intrapartum complications of labor. And out of fetal condition, maximum stillbirths attributed to fetal growth retardation, that is 40%. So the benefit of ICD-PM is it is not just for international comparison, it is for ourselves also. We can have a robust data of our institute. We can know where to act and when to act and how to act, right? So conclusion is ICD-PM classification system clearly defines the time of stillbirth and correlate feto-maternal diet together. And it is feasible to adapt ICD-PM system even in existing setting, because this was the first publication by Alanson where it was a result from pilot database testing from South Africa, that is low middle income country, and United Kingdom. And they found that although a global classification system will never be perfect, but for every setting and eventually, but the 3-step approach for ICD-PM, right? It facilitates standardized comparison of data internationally. And we also have the publication from our institute where we also found that the ICD-PM system of classification seems feasible and would facilitate the uniform and consistent stillbirth data even from LMICs for global comparison, although we need more number of studies for any conclusion. Thank you so much.
Thank you, Dr. Bharti, for your wonderful presentation. You gave the ICD-PM classification in a very clear and lucid manner. All the concept was explained very clearly with all the cases, which made it very easy for all of us to understand. And we also in private practice can have a handout or a printout of this, which will help us also to improve our quality of care, not only for an institute where all the residents learn, even in a private setup, it can do wonders if we know at what stage things have gone wrong and how we can improve upon it. And yes, it was very good to know that you had your own publications also according for that and your own data also.
Thank you so much, ma'am. Thank you.
Because in stillbirth, we all know that we have to be like Sherlock Holmes to try to find the cause, otherwise we'll never be able to find it.
Thank you so much, ma'am. A very elaborative talk it was. Now I request Dr. Urmila Singh to invite Dr. Vicky Flannery for the talk. Thank you.
Thank you very much. A very good evening to all of you. At the outset, I would like to thank organizer to giving this opportunity. And it's my great honor to me to introduce Professor Vicky Flannery. And she is a director Center for Research Excellence in Stillbirth MRI PUQ. And she is an honorary professor Matter Research Institute, University of Queensland, honorary research leader, Australian Research Centre for Health of Women and Babies, honorary professor, South Australian Health and Medical Research Institute. She established a national committee to inform the development of National Stillbirth Research Program, including Stillbirth Foundation Australia. She established partnership with the Stillbirth Foundation Australia and is still aware of the collaboration with NHMRC partnership grant. So as we know, the prevention of stillbirth remains one of the greatest challenges to the modern maternity care. Professor Vicky Flannery is giving to talk on Safe Baby Bundle initiative to reduce stillbirth. Now over to Professor Vicky Flannery for the talk.
Hello, I'm very pleased to be here today to present the Australian National Initiative to Reduce Stillbirths, the Safer Baby Bundle. And I'd like to thank the Conference Organising Committee for the opportunity of being here today. Before moving to the Safer Baby Bundle, I wanted to just reflect on where we've come from and how we got to the point of implementing this national initiative. Well, the beginning of local advocacy was really the Lancet Stillbirth series of 2011 and 2016, and I was very fortunate to be a member of the International Steering Committee for these series in my role then as the chair of the International Stillbirth Alliance. These series showed that stillbirth was a neglected tragedy, that almost 3 million women would suffer the tragedy of a stillbirth every year, and that many could be prevented with implementing best practice care. And while 98% occur in low and middle income countries, we made the point in this series that there were many preventable deaths in high income countries, such as Australia. Australia's stillbirth rate has remained unchanged for almost 2 decades. While there's been some reduction in late gestation stillbirths over this period, there are still, every day, 6 women in Australia will have a stillborn baby. And for some groups, such as Aboriginal and Torres Strait Islander women and migrant and refugee women, the risk is almost double. Most stillbirths occur in the antepartum period, and we know with the wide variation across high-income countries in the stillbirth rates after 28 weeks, this shows that we can further reduce stillbirth rates in these settings. So this statistic, Australia was 35% higher than the best performing country in the Lancet Stillbirth series, was really the driving force behind the National Health and Medical Research Council setting up the National Centre for Research Excellence in 2017 to address stillbirth by improving care and outcomes for women with risk factors for stillbirth, developing innovative approaches to further reduce the stillbirth rate, such as biomarkers for prediction, implementing best practice care after stillbirth and in subsequent pregnancy, and improving data quality. Even with the efforts that we've undertaken in Australia, there are still many stillbirths not appropriately investigated, and at term, up to 40% of stillbirths are unexplained. We continue to work with researchers and advocacy groups calling for a national inquiry, which happened. A report was produced and the government accepted that report. And subsequent to that, a national stillbirth action and implementation plan has been developed and endorsed by all governments across Australia. such exciting times. So the Australian Safer Baby Bundle is one of the main initiatives in the National Action Plan. It has 5 evidence-based elements where to address key practice evidence gaps, with a goal of reducing stillbirths from 28 weeks gestation by 20% by 2023. The 5 elements are helping women to stop smoking in pregnancy, providing them with the support that they need. In some communities in Australia, smoking rates are very high, up to 40%. To improve the detection and management of women with fetal growth restriction with decreased fetal movements, to ensure women have the information they need around side sleeping and for them to understand the importance of side sleeping in late pregnancy. And the whole area of appropriate timing of birth for women with risk factors. We know the mainstay of prevention of stillbirth is induction or birth. And to make sure that we get that timing right, taking into account the woman's risk factors, so we're not delivering women too early and increasing unnecessary interventions. So all these resources for the Safer Baby Bundle can be accessed from the Stillbirth CRE website freely. So what do they include? A handbook and resource guide for clinicians, your care pathways. You see this one on decreased fetal movements. We have others on a care pathway on fetal growth restriction, for an example. And we've developed key performance indicators to help maternity services and jurisdictions, health departments across the country to implement this bundle of care. And you can see this one here for fetal growth restriction is the proportion of term births with undetected growth restriction defined as birth weight less than 3rd centile at 40 weeks gestation. And there are many other process indicators as well. So for resources for women includes information brochures now on each element. We're still working on the timing of birth resources, and I'll come back to that shortly. And they've been translated into multiple different languages. We've developed a video for antenatal clinics that cover the key messages for women around how they can reduce their risks around the 5 elements. And with any intervention to address stillbirth, as delivery is really the only way to avoid a stillbirth happening, then we must look at our unintended consequences. We're launching the Safer Baby Bundle in a background of increased induction rates in Australia, and earlier births. And this slide shows a shift, the left shift here, and gestation at birth from 40 weeks in around 2000 to just below 39 weeks now. And we know that babies born at 37 and 38 weeks, even though term, don't do as well, even in the longer term with additional educational needs, than babies born at 39 and 40 weeks. So we need to weigh up the benefit of delivery at each gestation against the potential consequences, which at a population level for earlier birth could be quite significant. So to do that, we need to have conversations about stillbirth risk with women. And we asked women in this survey, had they had any information about their risks of stillbirth in the antenatal clinic, and a third of them only said yes. So there's some room for improvement there. And when we asked them how satisfied they are with information being provided, there were about half who weren't satisfied with the information they received about their risk factors for stillbirth. And we've interviewed women, we've done lots of focus groups about what they would like to know. And basically, as a pregnant woman, they want information. They want the information to be able to protect their baby and to reduce their risk. And you see this quote here, particularly relevant. No need to sugarcoat it or keep it away from us. Just tell us how we can reduce our risk of stillbirth. So clinicians shouldn't be worried about increasing anxiety, and have a conversation with women. Their risks, the risk of stillbirth is low in Australia, about 1 in 1,000 at term. but there are ways they can reduce their risk even further. But unfortunately, the clinician survey did show that many clinicians felt that talking to women about these individual elements and how they could reduce their risk of stillbirth through best practice in these elements would cause anxiety. So we've developed a number of videos about how to have those conversations, and they're embedded online in our e-learning program. So the areas where clinicians were most concerned were smoking, talking about risk factors for having a small baby, and about the general individualised risk. They felt that that would cause concern, less so with decreased fetal movements and maternal sleep position. And this is a decision support tool from the Australian Preterm Birth Alliance to help the conversation towards the end of pregnancy in what's the appropriate timing of birth for individual women, and just making the point that every week does count towards term and the risk of stillbirth is very low. And we're adapting this tool to better meet the needs of the Safer Baby bundle with further information about individualised risk. Another area that's really important that isn't part of the bundle but we're implementing it alongside the bundle is high quality perinatal mortality audit, and not only just to make sure that they're, we're closing the audit loop and we're ensuring that all stillbirths and neonatal deaths are fully audited to see where we can improve practice, but also to ensure respectful supportive care for families. So we have e-learning modules around both the bundle and perinatal mortality audit freely available. We welcome you to come on board and have a look at those and provide feedback. For perinatal mortality audit, we have the Improve program that covers each area of care, including investigation and supported care, based on our national guidelines, and binational actually for Australia and New Zealand. COVID has changed the face of pregnancy care across the globe, and we've made some adjustments to our bundle and advice to women on the basis of that, but it's mainly around making sure that women attend for care if they are concerned, and to keep as many antenatal clinic appointments as they can, even if they are telehealth, to monitor the baby and reduce their risk of stillbirth. There's some good news. The Safer Baby Collaborative in Victoria that implemented the Safer Baby bundle has shown practice improvement around the elements of the bundle. They've been working on implementing the bundle now for 1.5 years, and they've shown a 27% reduction in stillbirths across the participating maternity services in this first rollout. So that's preliminary data, but it gives us some really good encouragement that we're on the right track. I'd just like to finish by acknowledging the International Stillbirth Alliance Board, a wonderful bunch of people from around the world, including Raki from India, and to encourage you to join this a wonderful alliance that really is a global initiative with parents at the heart of the alliance to create change and to reduce stillbirths and improve care. And my final slide is an invitation for you to join our International Stillbirth Alliance Conference in 2021, Driving Change. Unfortunately, now a virtual conference, but still it will be a worthwhile conference, and we hope you will submit abstracts to present and attend. So thank you very much for your attention.
Questions and comments are welcome. Okay. So that was a brilliant talk by Professor Vicky Flaherty. Now let's move on to the next talk, and I would like to invite the chairpersons for the same. Dr. Sandeep Grover, Professor and Consultant Clinical Psychology, Department of Psychiatry and PGI Chandigarh, and awarded thrice by ICMR besides his multiple achievements and publications. Dr. Ritu Nehra, Professor Clinical Psychology, Department of Psychiatry, PGI Chandigarh, and Dr. Vani Aditya, Professor and Head of Department Obs Gynae, Baba Raghav Das Medical College, Gorakhpur, recipient of R.D. Pandit Award. In this talk, Ms. Claire would not attend the conference due to personal reasons. So the talk will be delivered by Dr. Neelam Agarwal. I request Dr. Ritu Nehra to kindly invite Dr. Neelam Agarwal for the same. Thank you.
Thank you, Dr. Tanvi. And I would like to thank all the organizers for inviting me to chair this session. It's a privilege to introduce Dr. Neelam Agarwal, who is Professor of Obs and Gynae at PGMR Chandigarh and has about 160 and more than that publications. And she's National President of Indian Menopause Society and Regional Coordinator for Asia for SB Surveillance under aegis of International Stillbirth Alliance. And her field of interest is perinatal health, pregnancy with cardiac and other medico-surgical disorders, and menopause. And with this, I invite Dr. Neelam Agarwal to present her talk on bereavement care following stillbirth, unfulfilled needs. I think Dr. Neelam Agarwal.
Good evening, everybody. So two things. One, this is the worst part in a conference time, being the last speaker on the dais. And second thing is that I have prepared this in less than 20 hours because at this time yesterday, Claire finally said that her mother is actually not well. In fact, Claire is one of the people who has been involved in the Lancet Stillbirth series from the beginning only. And she is the one who is in bereavement care by the ISA and all others. But she could not come, so I am filling up for her, right? So if we look at the world maternal mental health statistics, we know that 10% of the pregnant women and 30% of immediately postpartum women, they suffer from primary depression. And in developing countries, this incidence is even higher by 1.5 times. So this is the state of affairs with those mothers who have a live baby, who are nursing their baby. Then what would be the status of those mothers who have a stillborn with nothing to hold upon, right? So why stillbirths matter? Because there is a huge burden of stillbirths and with impact on people and families, those who are who have experienced stillbirth, then on the healthcare system and on the governments as a whole. So on the mothers following stillbirths, there are a broad range of manifestations of grief, which may not be recognized by health workers or even the communities. And this may exacerbate negative experiences and stigmas, blame, blame and devaluation and loss of social status. And long-term psychological outcomes may include complicated grief, significant depression and anxiety even after 1 year of stillbirth, leading to 20% of post-traumatic stress disorder in a subsequent pregnancy, according to a study in 2013. So if we trace the historical background for the bereavement care, for decades it has been believed that grief could be prevented. That is the escapist attitude, that if no attachments are formed, so grief may be prevented if you show the baby to the mother, or if you keep on talking about the stillbirth to the mother, she might feel more aggrieved. So the parents were kept separated from their stillborn baby. But recent studies have brought out that grief process might in fact be facilitated by parents if you talk about that, and if you bring that baby to the mother, and so that they can create some memories and may be better off. So there have been not many studies till 2013 where they have shown that perinatal grief counseling may affect the mothers. But recently there has been a lot of global work on bereavement care, especially in the last 5 years. So much so that just recently, a week back, New Zealand has passed a bereavement leave for pregnancy, loss and stillbirth. And this will be a great evolution in the bereavement care and bereavement benefits. If this is passed, maybe other countries may follow. So how can bereavement care help? It can help in bringing relief both from the immediate and the long-term effects of grief. There are national guidelines from some high income countries, but from the low middle income countries where in fact the burden is greatest, paradoxically there is a very limited data, and the very fact which has plagued the topic of stillbirth, that only impedes the bereavement care also, because there is no talking about stillbirths, so there is no talking about the bereavement care. So bereavement care starts from the diagnosis of the stillbirth, IUFT or stillbirth after delivery, then how to break bad news, taking care of the birth and after birth time, leading on to subsequent pregnancy following the stillbirth. Since till the mother doesn't have another live born, this whole circle continues, and this constitutes the bereavement care. So according to a systematic review from the lower and middle income countries, it was seen that there are various reactions of the healthcare workers and various reactions of the women from the low middle income countries, which are much more different than the high income countries. So these are different in globally, they are different, and so they have to be adapted according to your own setup. And what are the barriers for us to implement bereavement care, if at all we start? Till now there has been no concept of bereavement care. We are trying to start bereavement care and learn how to give bereavement care. So barriers may be lack of supervision of healthcare workers, because there are no rigid guidelines or proper structured care. Then shortage of resources, funding, lack of skills, there is no proper training to be given to these. So all these may be facilitated by educating women on stillbirth via social media, training of all healthcare workers, development of care pathways or flowcharts for easy references for giving these bereavement care guidelines, and inclusion of these bereavement care services in minimum service delivery standards for maternal and neonatal care, or even in audits, and women's support groups for emotional support. So there has been a global consensus on principles for bereavement care and published under as RESPECT study, and there have been a consensus on 8 principles for the bereavement care globally, and this has included most 236 countries were surveyed by Delphi survey for this thing for before finalizing these principles. And out of these countries, 1 or 2 low income countries were also included in this study. And the final 8 principles, they work around reducing stigma experienced by bereaved women and families, to provide respectful maternity care even to the bereaved women, like we expect to give respectful maternity care to any birthing mother, support women and families to make shared informed decisions, and make every effort to investigate and identify contributory factors, so that one, that you can offer a proper explanation to the mother, and secondly, you can try to prevent the subsequent stillbirth. Then normal grief responses need to be acknowledged and seen, and other postnatal care to address physical and psychological needs, provide information about the future pregnancy, and enable highest quality bereavement care by continuous, comprehensive, ongoing training and support to the whole healthcare team. So these are the 8 principles which have been finalized by RESPECT study and globally applicable. And global efforts and vision, they want to keep bereavement care on the agenda always. So acknowledging the partners for global efforts and vision, and from where I have taken my resources. This is the ISA, ISPID, and Partners for Maternal and Child Health. So take-home messages are the impact of stillborn birth on women and families is tremendous, and still women continue to experience stillbirths every day in a huge number, and needs to have multidisciplinary working, especially putting patient at the heart of the problem. So there needs to be a paradigm shift from healthcare workers to the patient being the center of attention for the bereavement care. And there is need of evidence-based and readily available training. Consensus is already established globally. We need to involve parents and families. So it is high time to recognize the need for basic bereavement care and to ensure equal, high quality, individualized, safe and sensitive care, even in low middle income countries, and to raise parents' voices. And I'm happy to announce that we are trying to keep this basic need, and we are trying to establish the bereavement care. So there will be, this is not one day, this will be 3-hour virtual workshop for piloting and adapting raising parents' voices advocacy toolkit. This is basically to increase the sensitization of the healthcare workers and to see how we can adapt this toolkit in Indian settings. So I would like maximum people from this expert group to please volunteer for this workshop and give your valuable inputs. This workshop is on 11th of April, next Sunday, from 10:30 to 1:30, and it will be a virtual workshop. We will be very happy. These are the phone numbers which we have shared at the bottom. You can contact this person. Abhishek is the concerned person, and register yourself, and please be with us on that. Thank you so much.
Thank you, Dr. Neelam, for a very informative talk. Working with Dr. Neelam, Dr. Sandeep and me do get referrals, and Dr. Sandeep looks after the anxiety depression part, and sometimes I'm doing the counseling. I would ask Dr. Sandeep to contribute some of his experiences.
Yeah, and just one thing, Ritu, I would just like to share with all our panelists and the delegates that both Dr. Sandeep and Dr. Ritu, both of them are a part of this PVI project, and they are a very important part of this project. Yeah. Thank you.
Thank you, Dr. Neelam and Dr. Ritu, for having me here in this important talk. I think what we need to understand that we are talking about bereavement here. Often, unlike other conditions here, way we doctors behave, if there is a stillbirth or something which we are anticipating, where our behaviors reflect that something is wrong with the child, actually goes to the mother itself before we talk about it, that there is something wrong with the child. So when you're talking about bereavement care, breaking the bad news, I think the most important fact which comes into the mind is always to ask, what do they understand and what do they know? Rather than ourselves going and just breaking what happens in normal government setup or something is just one liner, breaking the bad news, and then what is to be done. So that is one thing which we need to learn, how to break the bad news. We need to have proper training for that. The number two is bereavement care. When we're talking about, it cannot be one session activity. It is a process. It's not just one session that you can do the bereavement care. It's a process which requires longitudinal follow-up of the family, not just the female who is given birth to a stillbirth child, but the whole family, because everybody gets affected. And that is where it's very, very important that we need to keep on continually evaluating their mental health status, and as required, they can undergo the counseling or so-called pharmacological management if that is required, and nothing should be delayed. And as Dr. Neelam has pointed out, one of the major issues is stigma, because in Indian culture, everything is blamed to the mother. So as doctors, we should be very, very careful at the bedside. What happens at times that we end up passing such remarks in front of the husband or mother-in-law that which puts the patient later on into trouble. कि आपने अपना ध्यान नहीं रखा. As doctors, many times we want to reflect back our inefficiency, or what I would say that we don't want to get the blame to ourselves. That is uncomfortable to us. So we end up saying certain things to the mother which is heard by the husband or the mother-in-law, and they bear the brunt of those, our behavior, maybe throughout their life. So we need to be very, very careful how we behave with the patients. I think I will stop here. Thank you.
Thank you, Dr. Sandeep. And I think now it's open for comments, suggestions, or questions to Dr. Neelam in case there are any.
Excuse me. I just want to add, ma'am, Dr. Urmila Singh is also there, my teacher. Ma'am,
Yeah,
would you like to
please.
say something, ma'am, to add on? Dr. Urmila Singh.
Dr. Urmila Singh? Yeah, she's
Yeah, she has to unmute herself, Bharti. Just
ma'am, please unmute yourself. Hanji, ma'am.
Hello, Bharti.
Hello, ma'am. Ma'am, would you please add something regarding bereavement care and
Everything is explained by the Neelam. Dr. Neelam has explained very well. Okay. Thank you very much.
So much, ma'am.
Thank you so much. That was a very informative and enlightening session of 3 hours. And I hope and I'm glad that the forgotten and unfulfilled will not remain the same. I would like to end the session with these lines. You are unsure which pain is worse, the shock of what happened or the ache of what never will. So let's all pledge to keep the generosity high, the vigilance to investigate, and never ever lose the touch of humanity. Thank you so much. Thank you.
Thank you.
thank you, Tanvi. Thank you so much.
Thank you.